A very warm good morning for everyone over here. Today is the second day of ACP India Chapter 6th Annual Hybrid Meeting of the IM ACP India 2021. I would like to call upon the Scientific Chair, Dr. Jayant Panda, to please come upon the stage and formally start the session for today.
Thank you, Pragya. Welcome to day two of the fifth, sixth annual hybrid meeting of the IM SCP India 21. It's a pleasure inviting you all for the scientific feast. We have a packed program of all physical lectures as well as virtual lectures. We have prestigious Dr. A. Muruganathan oration and ACP India oration. And also we have a insulin symposium, which is titled as 100 Years of Insulin Symposia today. To start with, in the Hall B, the William Osler Hall, we have the pre-paper presentation by the residents, by the students and consultants, followed by a doctor's dilemma, and then we have virtual presentations post-lunch. In the VC Roy Hall, we are starting with physical presentations of who's who of medicine in the country. So I welcome all of you for this scientific feast. Keep watching and enjoy the academics. Thank you.
Thank you so much, sir. Let's start with the session from the very first talk. But before that, let me introduce the program director for day 2, Professor L. Srinivas Murthy. Sir, you're welcome and good morning to you. The chairperson for the first talk is Dr. Narsingh Verma and Dr. Sangeeta Singh. The presenter is Dr. Preetam Gupta. I request the chairperson to please introduce the presenter.
Thank you, Pragya.
Thank you, sir.
And we are going to start the first lecture, and that lecture will be by Dr. Preetam Gupta. I think Dr. Preetam Gupta is well known. And I request, sir.
Good morning, friends. It's my pleasure to be here in ACP India annual meeting, which is organized by our governor, Dr. Maheshwari, under the chairmanship of Dr. Jayant Panda. I'm thankful to scientific chairman and the organizing team for inviting me to deliver this important talk, that is orthostatic hypotension. Why we are concerned about it? This is one of the entity which can lead to sometimes fatalities related to autonomic dysfunction. But by the intervention of pharmacological and non-pharmacological maneuvers, we can improve the symptoms and the quality of the life of a person. It can lead to falls, fractures, syncope, acute coronary syndromes, heart failures, stroke, depression, limitation of physical activity, weakness, and exhaustion. As far as the prevalence is concerned, it increases with the age. But if the people who are having high blood pressure, systolic more than 160, the prevalence increases irrespective of age. Between the age of 65 to 69 years, it is 14.8%, and more than 85 years of age, it is 26%. But interestingly, only 2% patients are symptomatic. What is orthostatic hypotension or postural hypotension? A drop of systolic blood pressure of 20 millimeter or more, or diastolic of 10 millimeter or more, while assuming the upright posture. It could be initial or immediate, classic, delayed, or neurogenic. What is immediate? There is a transient fall of blood pressure which occurs within 15 seconds. It is associated with syncope or pre-syncope. Classic orthostatic hypotension is systolic fall of blood pressure 20 millimeter or more, or 10 millimeter or more within 3 minutes of assuming upright posture. Delayed, there could be delay that it can occur after 3 minutes, and it may take about 20 minutes, 25 minutes, up to 45 minutes also to develop the symptoms. There is a fall of blood pressure of 20 millimeter of systolic, or 30 millimeter in patients who are having supine hypotension, or 10 millimeter of diastolic. Now, what is neurogenic, which is a great concern today? It is subtype of orthostatic hypotension. It could be classic or delayed one, but the dysfunction is related specifically to the autonomic nervous system, not aggravated or precipitated by any environmental factors like dehydration or the drugs. Now, what is the pathophysiology? When we assume standing posture, there is a drop of pooling of circulation, pooling of blood about 500 cc to 1000 cc in the leg areas and flanking area, which leads to less venous return, less cardiac output, which in turn activates the carotid body and the baroreceptors, which are located around the large vessel, the aorta. The afferent goes to the hypothalamus, and then the efferent comes, which in turn increases the sympathetic activity and depresses the parasympathetic activity, which produces increased cardiac contractility, increase in heart rate, increase in venous return, thereby increase the blood pressure and vascular resistance. So this is the mechanism which prevents the orthostatic fall of blood pressure. Out of them, it is the peripheral vascular resistance which is most important. Now, what are the causes of autonomic neurogenic orthostatic hypotension? It could be at the central level, brain, synucleinopathies, multiple system atrophy, Lewy body dementia, Parkinson's disease, Wernicke-Korsakoff syndrome, bar receptor failure, oligopontine degeneration. At the level of the spinal cord, it could be due to trauma or syringomyelia. And peripherally, autonomic neuropathies could be acute or chronic. Most important one are acute Guillain-Barré syndrome, which we clinically see most of time, acute paraneoplastic autonomic neuropathies, autonomic neuropathy, botulism, porphyria, heavy metals, and drugs. Out of the chronic neuropathies, diabetes, amyloidosis, autoimmune autonomic ganglionopathy, pure autonomic failure, familial dysautonomia, HIV-related autonomic neuropathies, these are the most common. Now, coming to the drugs, there is a huge list of the drugs, but worth mentioning are the antihypertensive drugs. Practically all antihypertensive drugs, they produce postural drop of blood pressure. But alpha blockers, alpha-2 agonistic, that is clonidine, methyl dopa, vasodilators, hydralazine, and minoxidil, and diuretics, which are very commonly used, they produce orthostatic fall of blood pressure. Vasoactive drugs, nitrates, and phosphodiesterase 5 inhibitors, which are used for erectile dysfunction, antidepressants, and antipsychotic drugs, drugs which are used for Parkinsonism, dopaminergic agents, levodopa, dopamine agnostic, anticholinergic drugs, they all can produce orthostatic fall of blood pressure. Now coming to the dehydration, it could be due to loss of blood, due to any reason, or loss of fluid. Loss of fluid could be because of vomiting, loose motions, excessive sweating, heat pyrexia and stroke, drugs, burns, and another interesting, working in the hot weather, exercise in the hot weather, they all produce loss of sweating and loss of fluid. Now, what are the clinical presentation? The most important, dizziness, vertigo, lightheadedness. Patient feels that something is being drained out. He feels sinking sensation, shortness of breath, chest pain as a result of myocardial hypoperfusion, neck cramping and standing. That is a coat hanger type of headache. It is as a result of hypoperfusion of the trapezius muscle and the shoulder girdle muscles. Retinal ischemia leading to visual blurring and loss of consciousness. Now, how to deal with these patients, how to approach? The most important is the history taking. Review all the medications which can produce orthostatic fall of blood pressure, relationship with the meals, relationship with the standing, working in the hot weather, and working in the exercise during the hot weather. Now coming to the physical examination, most important, the active standing test. This is a practical test, bedside test. Patient is advised to lie down for 5 minutes. His basal blood pressure and heart rate is recorded. Why heart rate? Because heart rate is very important. During autonomic dysfunction, there is a blunting of the chronotropic compensatory response. Usually, when the person stands, there is an increase in heart rate by 10 to 15 beats per minute, which is not there, and it signifies autonomic dysfunction. Ambulatory blood pressure monitoring is another tool. It can detect orthostatic hypotension, white coat hypertension, nocturnal hypertension, and mask hypertension. And the head up tilt test, this HUT test, which is being done. When we think that patient is having orthostatic hypertension and we are not able to diagnose by other methods, then this test is being performed. There are special tables, HUT tables, which are lying in the air-conditioned room and available in the tertiary hospitals, not everywhere. Patient is made lie down for 5 minutes. He is connected to the cardiac monitor. He is strapped on the leg as well as on the waist. That table is tilted to 60 to 70 degree, and the blood pressure and heart rate is recorded till the symptoms develop. Now, you can see this is vasovagal syncope, which is the initial orthostatic hypotension, and another is delayed one. Now, what are the guidelines? As per American Heart Association, neurogenic hypotension, acute water ingestion is class 1 indication. Compression garments, counter pressure maneuvers, midodrine and doxydopa, these are class 2A indication. Increased salt and fluid, octreotides and parastamine, these are class 2B indication. If the drugs are the culprit, withdrawal or modification of the drugs is class 2A indication. Dehydration is the cause, then acute water ingestion is class 1 indication, and reduce or withdrawal of the drugs class 2A, and increased salt and fluid intake class 2A indication. Now, what is the treatment? Removal of the reversible cause. The most important, the lifestyle change, the non-pharmacological measures are there. Education the patient regarding the aggravative factors which precipitate orthostatic hypotension. They should be removed, avoided, like warm ambient temperatures, hot baths, hot showers, straining, especially breath holding, that is Valsalva maneuver. These should be avoided. At the same time, when the person changes the posture from supine to standing or sit to stand, he should be advised to have a pause. He should be cautious about it. The hot meals, especially carbohydrates associated with alcohol, they should be avoided for postprandial hypertension. Now coming to the physical maneuvers. Leg crossing, stooping, forward, squatting, straining of the muscles of the leg, thigh, up to the pelvic girdle, they all decrease venous cooling and increase cerebral flow and avoid the development of symptoms of postural hypotension. Now, physical activity is advised to all the people. Since it occurs mostly to aged man, the best is the morning walk and the light exercises. Now, another is the compressive garments. The use of custom fitted elastic stockings, which are applied from the legs to the pelvic girdle. They minimize the peripheral blood pooling in the lower extremities and thereby reduce the symptoms of orthostatic hypotension. Postprandial hypertension. When there is a fall 20 millimeter of systolic of blood pressure, or person who is having basal blood pressure 100 millimeter systolic, and his blood pressure comes 90 millimeter or lower than that 2 hours after meals, this is postprandial hypotension. So it can be avoided by using large amount of meals, especially in carbohydrates, hot meals, and avoiding of alcohol. Patient should be advised to stand cautiously after taking meals. Now coming to the volume expansion. Patient is advised 2 to 3 grams of salt per day. Up to 10 grams of salt has been advised by in some reports, but we have to be very cautious, especially in patients of chronic kidney disease and heart failure. Fluid intake should be 2 to 2.5 liter per day. Urinary output should be more than 1.5 liter per day, and urinary sodium excretion should be more than 170 milliequivalent per 24 hours. Now, sleeping with raised head. Patient is advised to sleep with 10 to 20 degree raised head. He can apply pillows, or 2 bricks can be put on either side of the head to raise the head. That helps in prevention of orthostatic fall of blood pressure. Now, the most important and class 1 indication, irrespective of the cause, is the acute water ingestion. Patient is advised to take 2 glasses full of water within 3 to 4 minutes. It increases the pressure response and sympathetic activity, and thereby controls the blood pressure, thereby avoids the orthostatic fall of blood pressure. But there is a caution here. Person should not consume salt or sugar. कहते हैं ग्लूकोज का पानी पिला दिया. No, that reduces the pressure response and increase the flow in the splanchnic area, thereby may produce further fall of blood pressure. Now coming to the drugs, the most important is the fluorocortisone. It is a mineral corticoid drug which helps reabsorption of sodium at the renal tubules and excretion of sodium, hydrogen and potassium. So the side effects are the hypokalemia, edema, supine hypertension, and headache. But the most important and the worst reaction is the adrenal suppression as a result of immunosuppression. Dose is 0.1 milligram per day, and the effect may last for a few weeks. It is the most commonly used drug. Now coming to the vasopressin, and they are antidiuretic hormone. Vasopressin is available in the form of nasal spray and the oral tablets. It is given at bedtime for the patients of nocturnal hypertension and who are having the morning symptoms. Now midodrine. Now it is available in our country. The active ingredient is desmogledomidodrine, which constricts the peripheral vessels and increase the peripheral vascular resistance. The side effects are supine hypertension, itching due to pilomotor activation, a goosebump phenomena. रोंगटे खड़े हो जाते हैं. It is because of pilomotor activation. Urinary retention and headache. Dose is 2.5 to 10 milligram 8 hourly. Another drug is doxidopa, which is metabolized by dopa carboxylase. It yields norepinephrine. Side effects are supine hypertension. Dose 100 milligram 3 times a day. Other drugs are parastomine, which is a reversible cholinesterase inhibitor. It improves orthostatic tolerance by increase in peripheral vascular resistance. Side effects are nausea, vomiting, abdominal cramp, sweating, salivation, and urinary retention. Octreotide, it is used in patient of postprandial hypotension. It constricts the splanchnic circulation by 20%. So to conclude my talk, ladies and gentlemen, orthostatic hypotension is associated with increased mortality and morbidity independent of underlying etiology. It increases the incidence of fall, fracture, syncope, especially in the elder population. Initial orthostatic hypotension, which is associated with syncope, should be taken care of. The drugs, which are the causative agents, they should be modified, removed, or stopped and changed, replaced. When supine to standing test is not possible, then sit to stand test is to be done. Education of the patients regarding lifestyle changes is very important. And water ingestion, 500 cc of water, 2 glass full of water is a remedy for all type of orthostatic hypotension, which improves the symptoms immediately, irrespective of the cause. Thanking you very much for your patience hearing.
Thank you, sir, for such a good talk regarding very important orthostatic hypotension. The time does not permit me to invite questions. I know that most of the questions are there, but you can ask Dr. Pritam Gupta, sir, individually, and I close the session.
Thank you, sir. Now I would like to say thanks to the chairperson for this session, Dr. Narsingh Verma and Dr. Sangeeta Singh, and also to the presenter, Dr. Pritam Gupta. With this, I would like to invite Dr. Anuj Maheshwari and Dr. Ashish Kumar as a chairperson for the next talk. And the presentation of talk will be by Dr. Rajesh Upadhyay. Sir, please come up on the stage.
So welcome you all on this pleasant morning. First session has already been completed within time by Dr. Narsingh Verma. Now we are heading towards a very important session. Now, this is a problem of nowadays conferences, that most of the conferences are over-occupied by the metabolic diseases. So sometimes it is very difficult to get the other specialists and other experts like gastroenterologists, very difficult to get on the physician forum. But I'm very lucky Dr. Rajesh Upadhyay has accepted this invitation and he is with us here. And my co-chair, Dr. Ashish Kumar, he is also gastroenterologist and he is also accepted to be here. So, and he is also our advisory council member. So not wasting much time, although it is a very big CV of Dr. Rajesh Upadhyay, but I shall say that the people doesn't need any introduction for Dr. Rajesh Upadhyay. The biggest introduction is he is Dean of Indian College of Physicians, and he has got a lot of awards, a lot of accolades in his credit, a lot of publications, and he is a person whom you can see that the real scientific person in the gastroenterology who is disseminating the knowledge of gastroenterology to the physicians in the real sense. Over to Dr. Rajesh Upadhyay. The topic is chronic diarrhea, clinical approach.
Thank you, Anuj, for a very kind introduction. I normally keep the first slide as my introduction because, but that's a habit. So you've already gone through what? How do I change? So, yes, you've just heard that the conferences are loaded with metabolic diseases and gastroenterology finds a smaller section in there. But I think we must believe in the old Ayurvedic wisdom that all the diseases of the body arise from the abdomen. So I think gastroenterology is a very special place, and I keep talking about another issue is that things like diabetes originate from the liver. So that is another issue. Uh, so today I'm talking about a very clinical issue, a chronic diarrhea, which is seen by one and all. And I think we need to have a very clear concepts about it. So let me start with the definitions. Acute diarrhea, less than 2 weeks. Persistent diarrhea, 2 to 4 weeks. And a chronic diarrhea is defined as those diarrhea which persist for more than 4 weeks. So what are the common causes and how common is it? Well, at any given time, it may be affecting about 1 to 5% of the population. And the common causes, certainly in clinical practice, we see a lot of functional diarrhea, irritable bowel syndrome of diarrhea type. And then there are a variety of other causes, the celiac disease, lactose intolerance, which is very common in our country, the metabolic causes, inflammatory bowel disease, tuberculosis, and conditions like small intestinal bacterial overgrowth. But I think the most important thing in evaluation of a patient with chronic diarrhea is a good history. And a history of medication is very important because often you find that it is the medication causing the diarrhea and you just stop the medication, the diarrhea improves. And there are other issues, and we'll come to that gradually. So broadly speaking, when you have a patient in your clinic with diarrhea, you try and decide what type of diarrhea the patient has. And if the patient describes a diarrhea which is oily in type, it is loose, it is frothy, etc., you know that he's talking about malabsorption. And when you're talking about malabsorption, you immediately think of it is either the small intestine or the pancreas. Chronic inflammatory diarrheas and inflammatory bowel disease and tuberculosis, etc., are common causes. So they are usually the ones who present more with a large bowel type of diarrhea, with feeling of incomplete defecation, presence of blood, mucus, etc., is a very important feature there. And then you have those patients with chronic watery diarrhea who may have secretory diarrhea, osmotic diarrhea, drug-induced diarrhea. Infectious diarrhea remains an important entity in our context. And never forget, and this happens not uncommonly in a gastroenterology clinic, that you look at all the aspects of the diarrhea, but forget that thyrotoxicosis and diabetes are themselves very common causes of chronic diarrhea. So I think the first thing one has to decide when you have a patient with diarrhea, is the diarrhea coming from the small intestine? Is it the large intestine? Or is it pancreatic? So these are the areas through which you get the chronic diarrhea. So the diagnostic approach is very simple. Just try to answer the following question. Is it a functional diarrhea or an organic type of diarrhea? Is it a small bowel diarrhea or a large bowel diarrhea? Is the diarrhea associated with malabsorption, in which case there will be specific features and we'll come to that. Diarrhea associated with abdominal pain or no? Associated with bleeding? Are there features of inflammation? So all these are questions which need to be answered. So let me start with the first one. Is the diarrhea functional or organic? Now, classically, if you have a patient, let's say, presenting with a diarrhea for the last 3 years, and there are no constitutional symptoms, there is no weight loss, the appetite is normal, and interestingly, all the diarrhea is happening during the daytime. There is no nocturnal diarrhea. And there are features of gastrocolic reflex, which means every time I eat, I have to go to the toilet. So there is an exaggerated gastrocolic reflex. And the patient has anxiety symptoms. So these are classical or functional type of diarrhea. There is nothing to suggest that the patient has an organic disease, whereby he must have developed other features by now, including constitutional features, weight loss, etc. On the other hand, organic cause will have a shorter history. So you don't have patients with tuberculosis or ulcerative colitis or Crohn's disease, staying like that for years on. They usually present to you within weeks or months. And they have marked constitutional symptoms. There may be weight loss. There may be a decrease in appetite, and the diarrhea is also present during the night. So that is a very important distinction. Nocturnal diarrhea is usually suggestive of organic disease. There is no exaggeration of gastrocolic reflex, but tenesmus may be there. And anxiety symptoms are less common, but you can have a mix of the two as well. So these are the broad features differentiating. What are the risk factors? Where should we be cautious that we do further investigations if there is a family history, if there is a history of previous surgery, previous pancreatic disease, history of thyroid disease, diabetes, history of alcohol, and as I said, always take a meticulous history regarding the medication. And also remember that antibiotic associated diarrhea, the patient may have had his antibiotics 2 or 3 weeks ago and yet presented with diarrhea which persisted after that. So that is also another important issue. So now I come to the next question. Is it a small bowel diarrhea or a large bowel diarrhea? Now, small bowel diarrheas, the number of stools are lesser, but the volume is larger. So large, bulky stools, which may be frothy or greasy if there is malabsorption. There is no blood, no mucus, no pus, and no tenesmus. So these are features of small bowel diarrhea. On the other hand, large bowel diarrhea, patients keep on passing small amount of stools, but very frequently. And this usually happens in patients with proctitis, in ulcerative colitis, let's say. So small volume stools frequently passed, associated with blood, mucus, pus, and there is a history of tenesmus. So it is a clear distinction. I think if you take a history properly, you can understand whether it is small bowel or large bowel diarrhea. And if you have a patient with small bowel diarrhea, you have to decide two things: whether there is malabsorption or is it a small bowel diarrhea without malabsorption. So malabsorption, you will have a clear history of the oily stools, frothy stools, bulky stools. Anemia may be present, and there will be features of nutritional deficiencies. And you have to immediately think of conditions like celiac disease, tropical sprue, parasitic infections, etc. But one entity I would like to point out specifically is, don't forget small intestinal bacterial overgrowth, which is very common in diabetics. Now, these are the features of malabsorption. If there is no malabsorption, then usually it is a secretory type of diarrhea, large volume diarrhea. And the distinction between secretory diarrhea and osmotic diarrhea is very simple. Osmotic diarrhea, if you ask the patient to stop eating, the diarrhea stops. On the other hand, in a secretory diarrhea, even if the patient stops eating, the diarrhea continues. So large bowel diarrhea, again, you have to make two distinctions: functional diarrhea, which is the commonest one, irritable bowel syndrome of diarrhea type, or functional diarrhea. But organic diarrheas must always be remembered, and it is easier to diagnose if there is presence of blood, mucus, etc., where you think of inflammatory bowel disease, tuberculosis, solitary rectal ulcer syndrome, tumors, etc. But there will be a category of patients, and again I say you all are primarily physicians, that in those who have no blood, have got large bowel diarrhea, always remember this entity called microscopic colitis, which I think is underdiagnosed. And talk about drugs as well. Well, the next question was painful or painless diarrhea, and painless diarrhea in all the malabsorptive conditions, but painful diarrhea in all the inflammatory type of conditions. So tuberculosis, Crohn's disease, Whipple's disease, etc. And if the patient has got inflammatory type of diarrhea, there might be presence of fever, constitutional symptoms, joint symptoms, etc. So if you have a patient where you've identified has got a chronic inflammatory diarrhea, you must try and differentiate: is it due to inflammatory bowel disease? Is it due to infection, particularly tuberculosis in India, pseudomembranous colitis, ischemia, radiation, and neoplasia? And on the other hand, remember, there can be sometimes chronic infective type of diarrhea, and don't forget pseudomembranous colitis, the C. difficile, and tests for that are available in most places now. In patients, particularly those who are immunosuppressed, cytomegalovirus, Entamoeba histolytica, these days not very common. Many a times previously, all these patients with ulcerative colitis were called amoebic colitis. But nowadays we can make a very simple, clear distinction. Mycobacterium tuberculosis remains an important cause. And in this slide, I've just pointed out some of the drugs, and you all know about it. But I think the important thing is to take a history. And many a times, you find that patients using olmesartan, which is a very common drug used in clinical practice now, they will have diarrhea. So olmesartan, etc., must be remembered. And I will not go into each and every drug because I think you know it already. And if you do not know, for our youngsters, the graduate and the postgraduates, I would suggest that you always look up and check the Google or your book for all the different drugs which can cause. So when you are evaluating now a chronic diarrhea, the history should also include what is the relationship to food. And every time the patient eats and has to go to the toilet but has no other constitutional features, always think of irritable bowel syndrome. As I said, if the diarrhea stops with fasting, think of osmotic diarrhea. If it occurs in spite of fasting and even during sleep, it is secretory type of diarrhea. And I think we talk about measurement of stool electrolytes, calculate the osmolality. Hardly anybody does that, except in a research setting. So I think we have to hear a condition where just by clinical acumen, history taking, physical examination, you can make a very simple diagnosis. Abdominal pain and diarrhea. If the pain is in the left lower quadrant in particular, and in Indians sometimes even in the upper abdomen, IBS must be considered. On the other hand, Crohn's disease is usually pain presentation which is periumbilical or in the right lower quadrant because it is ileocecal disease is more common. And then you have the gastrinomas, peptic ulcers, which are responsible for the upper abdominal pain, and clearly they would have epigastric pain. And for those with malabsorption, you must look for nutritional deficiency features. And on the right-hand side, I've shown a number of things, neuropathy, glossitis, angular stomatitis, because of nutritional deficiencies. So this is what, when you're doing a clinical examination, you must look for. So I will just come to the primary assessment of these patients. Always do some basic investigation, CBC, C-reactive protein, to look for any evidence of inflammation. Thyroid function and blood sugar, I think, should always be done. And since celiac serology, we are doing very commonly now. It is common even in southern part of India, and north it is very common. Stool examination has always been contentious. Are we doing the stool examinations properly? And in most centers, it is not being done properly, but always in clinical, depending on the clinical scenario, try to look for the C. difficile versus parasites. And these days we have a very interesting and a very non-invasive fecal cal-protecting test, where if you cannot differentiate between inflammatory bowel and irritable bowel, you can just do the fecal cal-protecting level. If it is low, it favors irritable bowel syndrome. If it is high, it shows that there is inflammation or ulceration in the gut, and therefore the patient requires further investigation. And if the cancers or inflammation are suspected, then we as gastroenterologists go on with colonoscopies, ileoscopies, biopsy, etc. Celiac disease, simple is upper GI endoscopy and biopsy, but always do the TTG, which is a screening test, anti-TTG IgA. And if you are suspecting disease of the small bowel, I think wherever possible, I would say, because barium meal follow-throughs are not good at all. And you now have CT or MR enterography in most places. So go for CT enterography or MR enterography, and you can do a capsule endoscopy. Malabsorption, again, if you suspect a pancreatic problem, then you can go for CT MRI for structural definition of the pancreas and do a test which is very commonly available now, fecal elastase. And if it is low, then certainly it points towards malabsorption. And then if you suspect the other variety of conditions, then you must do enterography, upper GI, biopsies, etc. And where surgical conditions like diverticulosis, etc., is suspected, MRI or CT will be again useful. So I will just come to just few common problems. Lactose intolerance must always be recognized. Almost 60% of the Indian population are lactose intolerant. Suspect if milk intake causes bloating, borborygmi, diarrhea. And a simple glucose or lactose challenge test. एक गिलास दूध बड़े वाले ग्लास में पिला दो and see if the patient develops symptoms after that. But if you are a science purist, go for the hydrogen breath test. And simple thing is avoid milk intake. So if you made a diagnosis, treatment is always very simple. And this condition I would certainly like to point out because I think it is often missed and underdiagnosed. And it is almost present in 1 to 2% of the population. And many of the patients who we diagnose as irritable bowel syndrome of diarrhea type have actually got bile acid diarrhea. And it is said that 50% of the patients with functional diarrhea have bile acid diarrhea. So just to give a word of caution, always think of this condition. Usually in those who have undergone cholecystectomy or those who have undergone ileal surgery, it can be idiopathic. It is usually a painless osmotic type of diarrhea, non-inflammatory. And the diagnosis, very difficult. CCAT test, the only time I've done it is when I was in UK. Not easily available. And fecal bile acid again is something which can be done, but it requires 2-day collection and measurements, which is not easily available everywhere. So if you suspect, just give a therapeutic trial of cholestyramine, which is a bile sequestrant. It will bind the bile and thereby improve the diarrhea. So before, if you're getting frustrated with what is the cause, and if you suspect this condition, give a trial of cholestyramine. There's nothing wrong with it. Microscopic colitis, as I said, is a condition you must be aware of. Painless, watery diarrhea, particularly in those who are above 45 years, females more than males. Those who are diabetics, taking non-steroidals, those who have rheumatoid arthritis and celiac disease are more susceptible. And the diagnosis is made. And interestingly, when we do the colonoscopy, you don't find any lesion. It is only on the biopsy. So it is important that when we are doing the colonoscopy in a patient with suspected microscopic colitis, we take multiple biopsy from multiple sites in the colon. Pancreatic diarrhea will be relatively easier. It's a steatoric diarrhea, malabsorption associated with chronic pancreatitis. Imaging is important, and fecal elastase test will be useful. Treat with pancreatic supplement. So once you've made the diagnosis, the treatment becomes easy. But this condition, as I said, is a hot favorite of gastroenterologists these days. SIBO, presenting as diarrhea, small intestinal bacterial overgrowth. When to suspect? Predominant symptom is diarrhea, milk intolerance is marked, older age, longer duration, marked abdominal bloating and flatulence associated. And remember, patients who's been on years of PPI therapy, they are more likely to have small intestinal bacterial overgrowth. History of response to antibiotics and probiotics will be there. That was a very gastrointestinal type of sound I heard. I will limit my role of imaging. All I want to see is that imaging should be confined to patients where you suspect pancreatic disorders or in patients who are predisposed to bacterial overgrowth, such to locate diverticulas, blind loops, intestinal hypomotility, dilatations, fistulas, tumors. But routine use of barium meal follow-through is discouraged. Always go for MR and CT enterography. And once you've made the diagnosis, I think there is no point in talking about treatment. Celiac disease, you all know, tropical sprue. Again, simple antibiotics, folic acid, tuberculosis, anti-ATT, and Crohn's disease, you all know, pancreatic diarrhea as supplements. So approach to a patient with chronic diarrhea needs a detailed history and a clinical examination. Achieve a specific diagnosis using a minimum number of tests. And I think that is important. Otherwise, you'll end up doing all the tests in everyone. Individualize investigations. And if a disease seems more likely, directly proceed to confirm it. not necessary to do all the tests in everyone. Now, if you have 2 minutes, then I can just show a few history if you have postgraduates in the listeners there. Now, this is, in fact, normally I ask this question, but young boy with 7 years history of diarrhea, 3 to 5 undigested food, there is no blood, no pain, no fever, no joint pain. Examination show low body weight and anemia, and there are features of vitamin deficiency. So clearly we are talking about small bowel malabsorption. Young boy, long history. What is the diagnosis? Well, clearly celiac is the most likely diagnosis. What test would you do? I think you can just go for anti-TTG antibody and do a duodenal biopsy over there. And if you really, because sometimes giardiasis can mimic, so you can look for stool for parasites as well. This is the next case, 36-year-old male presented with diarrhea, occasional blood for 3 months. Now, blood is present here with a history of right-sided abdominal pain. And I've already said if you have blood and right-sided abdominal pain with anorexia, recent fever for 2 weeks, I think immediately you start thinking of inflammatory bowel disease or tuberculosis. And in this particular patient, when we did the colonoscopy, we found a typical cobblestone pattern, which is suggestive of inflammatory bowel disease, and the biopsy confirmed it. And this is probably the last case. And this I'm showing because this is something which you find in clinical practice physicians, in particular, 65-year-old, long-standing diabetes with polyarthropathy, has watery diarrhea with gas and bloating for 6 weeks now. So diabetes, polyarthropathy, so drug intake we have to think. So what are the differentials we'll think of in this sort of a situation? And you have to think of, first of all, long-standing diabetic, could it be diabetic diarrhea? Or could it be drug related? The patient has been taking probably metformin for a long time, or maybe non-steroidals. Small intestinal bacterial overgrowth, microscopic colitis is something again, because this is a highly high risk group, and pancreatic diarrhea. So these are simple cases I have shown where you don't need to do a huge number of investigations. Do a good clinical meticulous history, clinical examination, come to some, narrow down your differentials and do the appropriate tests and come to a diagnosis. Life will be simple in primary health care. Thank you.
Thank you, Dr. Rajesh Upadhyay. That was an excellent deliberation on chronic diarrhea. I think there would have been lots of questions, but due to shortage of time, we cannot permit them now. I would just like to summarize that, as you have elegantly pointed out, that chronic diarrhea in history taking is the most important thing, and we should not rush to giving antibiotics or doing lots of investigations. A good history taking would actually point out to the cause, and we should avoid over investigating these patients. So with this, I would like to conclude this session. Thank you, Dr. Rajesh. Thank you, my co-chair, Dr. Anuj.
Thank you to the chairperson for chairing the session, Dr. Anuj Maheshwari and Dr. Ashish Kumar. I extend my thanks to Dr. Rajesh Upadhyay for such a wonderful talk. With this, we'll proceed to the next talk. The chairperson for this talk will be Dr. Sunil Kumar Srivastav and Dr. Rajiv Ratan Mishra. I request them to please come up on the stage and take their seats. The presenter for this talk will be Dr. K.K. Parekh. So the chairperson for this session will be Dr. Devendu Bhushan and Dr. Anuj Maheshwari. I request them to please come up on the stage, and the podium is all yours, Dr. K.K. Parekh.
Very good morning, everybody. Respected chairpersons, important members of API and delegates sitting in front of me. At the outset, I would like to extend my sincere thanks and gratitude to Dr. Anuj Maheshwari, Dr. Jayant Panda, and Dr. Srinivas Murthy and the organizing team for giving me the opportunity to be a part of this very prestigious conference of American College of Physicians. The topic which has been allotted to me when I fail to control blood pressure, that is approach to resistant hypertension. The flow presentation of my talk will be prevalence of hypertension, what is resistant hypertension, approach to resistant hypertension, and then management of resistant hypertension. We all know that hypertension is a global health crisis. More than 1 million of people are affected all over the world because of hypertension, and 1 out of 4 men and 1 out of 5 women are suffering from hypertension. And there is an unmet need is extensive because there is a decrease in level of awareness, level of diagnosis, treatment, and control remains very low. Less than 20% of people who are taking antihypertensive medication can control blood pressure at a target level. And hypertension is the #1 risk factor for death. 12.8% of all deaths globally is because of hypertension. Hypertension is a big risk for CAD, stroke, heart failure, and kidney disease. And just reducing 10 millimeter of systolic blood pressure can reduce major events of cardiovascular by 20%, stroke by 27%, CAD by 17%, heart failure by 28%, and mortality by 13%. So hypertension, which is being taken very simply, is a really, if it is uncontrolled, a big problem. Overall prevalence in India, from National Family Health Survey 4, there is a significant increase in national and regional prevalence of hypertension according to the 2017 ACC-AHA guidelines, and there is an increase by 2.3 times, that is from 18.5% to 43% with the new guidelines of American Heart Association. So when I fail to control BP, that is difficult to treat hypertension. What is difficult to treat hypertension? It is refractory hypertension, has often been used interchangeably with resistant hypertension. According to the number of PubMed citations, resistant hypertension has been used much more commonly with refractory hypertension to say that the patient is have hypertension resistant to pharmacotherapy or difficult to treat hypertension. So commonly used word is difficult to treat hypertension for resistant hypertension. So what is resistant hypertension? Resistant hypertension can be defined as blood pressure that remains above goal. Above goal, in spite of concurrent use of 3 antihypertensive agents of different classes. You have to think 3 antihypertensive agents of different classes and blood pressure remaining above goal, and one of the 3 agents should be diuretic, one of them should be a diuretic, and all agents should be prescribed in an optimal dose amount. This was the statement of AHA in 2008. And what is controlled resistant hypertension? When you can control blood pressure with more than 3 antihypertensive agents. But then there was some change in the AHA guidelines in 2018, and what they say that resistant hypertension, when they need 3 or more medications to treat blood pressure, but still have blood pressure that exceeds the goal for hypertension. Goal for hypertension, what is goal for hypertension? I'll let you know. According to the 2017 AHA-ACC guidelines for hypertension. And what they have changed then, from optimum, the antihypertensive drug should be administered at a maximum or maximally tolerated daily doses. So what is the goal? 2017 AHA, hypertension diagnosed when systolic blood pressure between 130 to 139 and diastolic blood pressure 80 to 89. And if you go with the threshold for diagnosing hypertension by home BP monitoring or ambulatory BP monitoring, the American guidelines says 130/80 for clinic. European guidelines says 140/90, and then International Society of Hypertension says 140/90, and the same with the Asian guidelines. So any blood pressure which is 130/80 is the targeted to keep the blood pressure to normal range. The hypertension classification, with the number of antihypertensive medication, controlled hypertension when patient is taking 2 tablets, 2 antihypertensive drugs. When he is taking 3 antihypertensives, then it is resistant, not controlled, then it is resistant hypertension. And when he is taking 4 tablets antihypertensive drugs, it is controlled resistant hypertension. And if the blood pressure is not controlled with more than 4 or 5 medications, it is refractory hypertension. What is the prevalence? It is between 12 to 15% of patients treated with high blood pressure. Those who are taking treatment for hypertension, among them it is 12 to 15%. Then who is at risk of resistant hypertension? Those who are having older age, female sex, excessive dietary salt ingestion, having evidence of left ventricular hypertrophy, and those who have got a high blood pressure at baseline, obesity, diabetes, chronic kidney disease, and plaque. And what are the comorbidities? Obesity, diabetes, and CKD. All these are present. If they are present, they add to unfavorable and adverse prognosis if blood pressure is not kept at a targeted level. And all population-based studies of hypertension, if there is a target organ damage, then the risk of MI, stroke, heart failure, and end-stage kidney disease are directly related to the level of high blood pressure. So now this is a population of uncontrolled hypertension. Which of these patients have treatment-resistant hypertension? Not all patients with uncontrolled hypertension are treatment-resistant, because majority of the patients who are diagnosed as resistant hypertension are pseudo-resistant hypertension, and very less number of patients who are diagnosed as a resistant hypertension are really the resistant hypertension or true resistant hypertension. A very interesting study research article which included 69 patients of resistant hypertension. The 30% were non-adherent to the medicines, 20% were white coat resistant. So overall 50% with pseudo-resistant hypertension, those who were diagnosed as resistant hypertension. And most of were undertreated with none receiving chlorthalidone or spironolactone, only 40% receiving maximum doses of ACE inhibitors or ARBs, and only 15% receiving maximum doses of calcium channel blockers. So most of the patients who are diagnosed as resistant hypertension are, big number is pseudo-resistance. What is pseudo-resistance? They include suboptimal BP measurement, white coat effect, poor adherence to drug therapy, clinical inertia, an important factor for pseudo-resistant, not titrating antihypertensive medication to control blood pressure target level. And lastly, not adopting lifestyle modification. So this is a common practice among physicians to not to take blood pressure as been advised or as been dictated. This is the slide which tells the right position and right way of taking blood pressure. Feet flat on floor, arm bare and resting mid-arm at heart level. You should take 3 readings at a 1-minute interval, discard the first reading, and then take the average of second and third reading. That will be the real actual measurement of right way of taking blood pressure. White coat hypertension. What is white coat hypertension? The blood pressure which is more at doctor's clinic than at home, common in patients whom we think that they are suffering from resistant hypertension. 20% of such patients achieve, when they are treated with the right medicines, less target organ damage in patients with pseudo-resistant hypertension. more target organ damage in pseudo-resistant hypertension. That's how you can detect who is at pseudo-resistance, detected by home or ambulatory BP monitoring. So when we want to rule out white coat hypertension, the best thing is ambulatory BP measurement. But even at home BP monitoring, you can detect, you can rule out white coat hypertension by taking 6 readings in 6 measurements in the day, morning, evening, afternoon, and night. So non-compliance is the most common cause of pseudo-resistance. It is because of side effects of the drugs, complexity of the regime, treatment failure, issue of cost, patient level of literacy and education. 56% patients take less than 25% of targeted dose during discharge, and 76.4% patients had no titration even after 3 weeks. This is what is clinical inertia. So it has been rightly said, drugs don't work in patients who don't take them. Then poor adherence. Poor adherence is also a very important cause of pseudo-resistant. 40% of newly diagnosed hypertensive discontinue drug within 1 year, and 40% of the remaining patients continue therapy or next 10 years thinking that they have controlled their blood pressure and they are cured of blood pressure. So education from the physician is very important, that they have to take lifelong treatment until they have normal blood pressure. And adherence can improve if using drugs with low side effects such as ACE inhibitors and ARB. Drugs with once daily doses in combination of multiple drugs, pill box, family support is always needed, and improved patient education by any way is very, very important. The clinical inertia, an important factor for pseudo-resistance. Conscious decision by a physician or a clinician not adequately treat or titrate drug, a condition in spite of knowing that it is present. Not adopting lifestyle modification, they are the most, as already been told by the previous speakers, that lifestyle modification are very, very important, and it should be the first line on your prescription about lifestyle modification, because weight reduction, dash diet eating, sodium restriction, physical activity, alcohol abstinence, and all put together can reduce systolic blood pressure by 20 to 50 millimeters of mercury. So there is a great importance of lifestyle modification, weight reduction, and the diet control is most important. Then very important thing that we must rule out secondary hypertension, because 5 to 10% of patients with resistant hypertension have an identifiable cause for hypertension. Most common are parenchymal disease, renal arterial disease, primary aldosteronism, and obstructive sleep apnea are common causes of secondary hypertension. The incidence increases with the increasing age. Renal disease, sleep apnea, and possibly primary aldosteronism are more prevalent among older patients. Drugs and blood pressure control. Many drugs are responsible for increased blood pressure. NSAIDs, COX inhibitors, oral contraceptives, corticosteroids. Then careful about black licorice and herbal products or Ayurvedic products that the patient is taking, and careful about ruling out illicit drugs like cocaine, alcohol, and caffeine. So drugs have got very important role in increasing blood pressure. So what is the etiology of resistant hypertension? The most important is elevated levels of aldosterone and excessive volume are the most common and most important cause of resistant hypertension. Endothelial dysfunction, insulin resistance, genes, and sympathetic overactivation are other causes. So excess volume because of dietary sodium reduction of reduced GFR, aldosterone excess, and then vascular resistance by RAS activation, SNS activation, and arterial remodeling are important causes, and they combine together to produce resistant hypertension. So the persistent intravascular fluid retention is a multifactorial: hyperaldosteronism, obesity, African American race, chronic kidney disease, high dietary intake, heightened sodium sensitivity, for which we Indians are very prone. These are the causes for excessive fluid retention, and a very important study for fluid retention which justifies the fluid retention is the cause for resistant hypertension pathway 2 study, which which said that after titrating spironolactone to 50 milligram from 25 milligram at 12 weeks had much more BP reduction as compared to titrating high doses of doxycycline, bisoprolol, and placebo. And the magnitude of BP reduction in patients with the lowest renal levels had an average of 20 millimeter reduction in home systolic blood pressure. So spironolactone is one of the most important drugs for resistant hypertension, and you can go to increase the doses by 50 milligram from 25 milligram, and you can reduce blood pressure to great extent. Then prognosis is not known. No study specifically powered to address this issue, but those who are having a resistant hypertension, naturally the risk of MI, stroke, heart failure, and renal failure are directly related to the level of blood pressure. Investigations, ABPM is the best to rule out 12-lead ECG, echo, CBC, blood sugar, renal function test, 24 hours, urine sodium, albumin, aldosterone, plasma aldosterone, renin ratio, and Doppler to exclude secondary hypertension. Just a minute. Treatment pharmacologic therapy, including administration of at least 3 antihypertensive substances, usually ARBs, ACE inhibitors, and a diuretic. And since the non-dipper pattern is the most common for resistant hypertension, one of the antihypertensive medications should be given at bedtime to control night blood pressure. The combination of drugs, you can use diuretics with ARBs, diuretics with calcium channel blockers, ARBs with calcium channel blockers, ARBs with diuretic or beta blockers, but you cannot use ARBs and AC inhibitors. They are contraindicated. The device therapy, carotid baroreceptors, they cause stimulation of these receptors, and there is a sympathetic discharge to the heart, peripheral vasculature, and the kidneys, and reduces blood pressure. And the New Hope trial, Firibistate, an oral brain penetrating prodrug, a selective and specific inhibitor of APA, blocks formation of angiotensin III from angiotensin II and decreases blood pressure. This is also being tried and being used. But the most important, renal denervation was the most important, and the Simplicity 1 trial and second trial showed very encouraging results for decrease in the blood pressure in patients with resistant hypertension. But then Simplicity 3 trial failed, and then it was stopped, and it was found that it is not working. So then came the recent renal denervation shame control RCTs, the spiral hypertension on med, spiral hypertension off med, and radiance hypertension solo. And they showed that the blood pressure, systolic blood pressure, can be reduced to 9 millimeter of mercury, and diastolic blood pressure can be reduced to 6 millimeter of mercury. And then very recently in 2021, ACC, there was a paper that ultrasound renal denervation for hypertension resistant to a triple medication pill, that is a radiance hypertension trial, a randomized multicentric single blind shame control trial showed that there is a reduction of blood pressure by 9 millimeter of mercury systolic blood pressure, even in the office BP or home BP. So it was found that this will work as a renal denervation therapy, and is a promising. Then the future of the antihypertensive treatment is the precision medicine. In future is the precision medicine has come, time of precision medicine has come. What is precision medicine? Classifying patients into subgroups that differ in susceptibility of disease, biology, prognosis of disease, and response to treatment. So this traditional medicine is the same therapy which we are giving. It benefits to someone, then someone are not benefited, and then someone are, a group of patients are have adverse side effects. But in precision medicine, after DNA testing, we tailored therapy, and every group of patients are benefited. So there is a future for precision medicine, and advances in genomics and informative technology will allow for more precise treatment of high blood pressure. Till then, current management of hypertension should continue to focus. And we know that genomics of hypertension,
Sir, please
there will be a road
summarize it.
to precision medicine.
Sir, we are running short of
Okay,
time.
okay, last. Take home message. The most important effective management needs careful evaluation, exclusion of pseudo resistance, identification and modifying factors related to true BP rise. RND therapy as a device-based intervention could potentially simulate a paradigm shift in the management of resistant hypertension. So I conclude my talk here and thank you everybody for listening. And it is my proud privilege to invite all of you to EPICON 2022 in Jaipur between 11th March and 14th March. You are all welcome. We are eager to welcome all of you. Thank you very much.
Thank you, sir, for such a elaborate description of the resistant hypertension. And as you truly said that it is the pseudo resistance which is the most common cause of resistant hypertension. So thank you, sir.
I extend my heartfelt thanks to Dr. Devendra Bhushan and Dr. Anuj Maheshwari for chairing this session, and to Dr. K.K. Parekh for this wonderful talk. For the next talk, I would like to invite Dr. Nishant Kanodia and Dr. Sajid Ansari as a chairperson. Sir, please come up on the stage and take your seats. The presenter of the next talk is Dr. Girish Mathur. Sir, please come up on the stage. Dr. Girish Mathur.
Thank you, sir. Welcome you on this dais, and I think the wonderful topics looks like overcoming therapeutic inertia and diabetes. We know there is inertia from both doctors and patient side, so we should counter our side, and on the same time we should be explain the patient and educate the patient. Thank you, sir. You have a very vast CV. I mean, not very good to read CV and waste time, sir. Please, over to you and welcome for wonderful deliberation, sir. Hoping. Thank you.
Thank you, Chairperson. Very good morning to everybody. At the outset, I express my sincere thanks to Dr. Anuj Maheshwari, Dr. Jayant Panda, Dr. Murthy, Dr. Narsingh Verma for inviting me to this prestigious event and giving me the opportunity to talk this morning. I'll be talking on overcoming therapeutic inertia in diabetes. For the last 2 years, world is grappling with a COVID pandemic, which is now showing some signs of abatement. But there is another pandemic which is rising gradually, and there's diabetes. According to the latest IDF Atlas published only a few days back, we have around 534 million diabetics worldwide, and the number is rising at alarming pace. In spite of all the technologies and the latest agents available at our command, so what's the reason of not achieving this diabetes control? And therapeutic inertia is one of the most important factor in diabetes management. I'll be discussing in next 20 minutes or so. I think this is not moving. Type 2 diabetes is characterized by a continuous decline in beta cell function with the resultant progressive loss of glycemic control over time. The hyperglycemic burden is associated with long-term microvascular and macrovascular complications, and early diagnosis and intensive glycemic control has shown beneficial effects. A very high proportion of patients fail to reach the recommended glycemic targets for a considerable period of time after the diagnosis of diabetes, thus leading to the complications. Guidelines for the treatment of patients with type 2 diabetes suggest that tight glycemic control, as revealed by HbA1c below 7%, should be maintained from diagnosis through active titration of combinations of anti-hyperglycemic medicines and lifestyle modification. If you take a look at the glycemic control in Indian diabetic population, scenario is very dismal. According to a diabetic care study done in 2011, the average HbA1c in India was 8.9. And one study done by ICMR in India Diabetes, which estimated the levels of glycemic control among subjects with self-reported diabetes in urban and rural areas, showed that only 1/3 of patients had good glycemic control, with 31.3% in urban and 30.8% in rural population had HbA1c less than 7. Rest 2/3 were in the category of fair or poor control. And with poor glycemic control, HbA1c and the risk complications arises exponentially. With the rise in the uncontrolled diabetes, burden of diabetes complications rises at a steep rise. According to a study, there were about 11.5 million cases of CAD, 4.4 million cases of peripheral vascular disease, 11.1 million cases of retinopathy, 16.8 million cases of nephropathy, and 17.3% cases in neuropathy. By a study done by 2011, we can imagine what would be scenario now after about 10 years. Failure to initiate or advance appropriate measures leads to accumulation of huge avoidable glycemic burden of uncontrolled diabetes. And the main factor behind this is therapeutic inertia, the tendency to maintain current treatment strategies despite results demanding escalation. The original thought about clinical inertia was highlighted by Phillips et al. In year 2001, who said that failure of healthcare providers to initiate or intensify therapy when indicated is therapeutic inertia. If we see the natural history of diabetes, we find inertia at every stage, whether it is general population with normal glucose, whether in pre-diabetes states, clinical diabetes, or with complications. And we can employ preventive measures at all stages to overcome therapeutic inertia. At population level, this inertia is in the form of not taking steps to improve physical activity or encouraging healthy eating and reducing obesity rates, leading to increased rates of type 2 diabetes in the population. In pre-diabetes, it is in the form of not doing community-based screening to identify pre-diabetes and altering a lifestyle in those with pre-diabetes, leading to losing the opportunity to prevent diabetes. In those with new onset diabetes, there is not identifying diabetes early, leading to delay in diagnosis, which increases the risk of developing complications. In those with established diabetes, inertia is in the form of not treating diabetes aggressively in early stages, leading to bad metabolic memory or legacy effect, increasing the chances of developing complications of diabetes. In those with a long duration of diabetes, it is in the form of not screening for complications on an annual basis, thereby missing the opportunity to identify complications of diabetes in an early stage. And in those with early complications, not aggressively treating the complications leading to end stage complications like renal failure, amputation, heart attack, and stroke. Over the years, a lot of suggestions and discussions were there about clinical inertia, and was thought that this term is too narrow because it uh, accounts only with the initiation and advancement of therapy, whereas there is also a potential for over treatment, especially in elderly diabetes, where tight glycemic control leads to more harm than benefit. A new term came, therapeutic inertia. Clinical inertia should be reserved for lack of adherence to guidance recommendations when appropriate to do so, whereas therapeutic inertia was suggested as providers' failure to increase therapy when treatment goals are not met, and importantly, to de-intensifying therapy when appropriate to do so. For example, when a low HbA1c or BP target is inappropriate for a patient, this may lead to worse outcomes, like in elderly diabetics who are over-treated, like in frail diabetes phenotypes, patients older age with very long duration diabetes, underweight, underlying heart disease or stroke, or with renal insufficiency. Uh, by paper by Kunti and Davis, about 200 potential barriers were identified. Out of them, 50% were physician related, and 30% were patient related, and 20% were the structural system level factors. The ADA recommends an A1C target of less than 7% for most people with diabetes. This goal can be set higher or lower based on each patient's need. However, fewer than 2/3 of people with type 2 diabetes get to their A1C goal, and only about half get to an A1C of less than 7%, despite a wealth of new medicines, treatment tools, and best practice guidelines. This number dropped over the past 10 years, while the number of patients with an A1C more than 9% went up. Delays happen at all stages of diabetes treatment, from starting the first drug, adding more medications, and then to intensifying insulin therapy. The ADA advises clinicians to advance therapy if a patient doesn't get to a goal within 3 to 6 months. However, the studies have shown that it often takes more than a year and even take up to 7 years to intensify a patient's treatment. And likewise, elderly diabetes often remain in danger from over-treatment for so long. In a study of more than 1 lakh patients, mean HbA1c at 8.1% at diagnosis, 22% remained under poor glycemic control over 2 years, and 26% never received intensive treatment. A delay in intensive treatment by 1 year in conjunction with poor glycemic control significantly increases the risk of MI, heart failure, stroke, and composite cardiovascular events. A lot has happened in diabetes management after 1990. Last 2 to 3 decades have seen arrival of many agents. Before 1990, we only insulin and sulfonylureas were available. Then came metformin, alpha glucosidase inhibitors, rapid acting insulin, basal insulins, GLP-1, DPP-4, SGLT2 inhibitors. But in spite of all these new diabetic medications and technologies, the percentage with HbA1c more than 9% is increasing from 12.6% to 15.5%. At the root of problem is therapeutic inertia. The clinician related factors are: we don't give sufficient time to patient. We fail to set clear goals. There is a failure to initiate treatment, failure to titrate treatment, failure to identify and manage comorbidities. Sometimes patient hijacks the clinical encounter. Our approach is reactive rather than proactive. At the patient level, There's a denial of having the disease, denial that disease is serious. There's low health literacy. Sometimes cost of medication is very high. Sometimes there is too many medications, medication side effects, poor communication, and lack of trust between patient and physician. There are system-related factors also, like there is no clinical guidelines sometimes, no disease registry, no visit planning, no active outreach to patients, no decision support, no team approach, poor communication between physician and staff. So pillars of overcoming therapeutic inertia are research, education and awareness, and collaborative barrier busting. What else is important to know about therapeutic inertia? Early tight control leads to longer term maintenance of glycemic control. We all know a legacy effect. Therapeutic inertia leads to a reduced likelihood of achieving target levels later in the disease trajectory. An early intensification of treatment in appropriate patients associated with a shorter time to subsequently achieving glycemic control. Therapeutic inertia has been associated with a reduced quality of life for the patient, along with increased risk of morbidity and mortality. There is clinical inertia, the diabetes management at every stage, but when it comes to insulin, things are even worse. According to a landmark trial, which is a first a large-scale, a longitudinal prospective observational study to investigate management and complications, it found that 4 out of 5 people with type 2 diabetes are uncontrolled in India. And less than 1 in 4 Indians with established type 2 diabetes receive insulin. And at average A1C at which insulin is started is around 9%. And even after starting insulin, we fail to titrate or intensify the doses of insulin. The average optimizing dose of basal insulin remains 18 units in Asian countries, whereas maximum dose up to which basal insulin should be titrated is 0.5 units per kg per day. The various patient-related factors when giving insulin. There is misconception regarding insulin risk. There is injection phobia, fear of weight gain. There is hypoglycemia concern. There's negative impact on social life and job, poor health literacy. There are physician-related factors also, like concerns about the efficacy and flexibility of insulin therapy. There's concerns of hypoglycemia. There's lack of faith in patients' competence for self-management, which all leads to limited access to diabetes care and medications in rural area also. What is the benefit of giving intensive insulin therapy at the initiation? We can preserve beta cell by giving early intensive insulin therapy because it decreases the decay of beta cell in the pancreas. According to a case study, a 41-year-old male had 7 days duration of diabetes with BMI 25, with family history of diabetes, on sulfonylurea and metformin, with uncontrolled diabetes, fasting sugar 299, postprandial 374, HbA1c 12.6. I started insulin with sulfonylurea and metformin. After 4 weeks, insulin was stopped and oral anti-diabetics were continued. And there was a reduction of HbA1c from 12.6 to 6.2 in 4 weeks. And there was an increase in C-peptide from 1.6, stimulated C-peptide from 1.6 to 4.2. Another paper by Dr. Mokta and Dr. V. Mohan showed that early intensified insulin therapy in newly diagnosed type 2 patients led to sustained improvement in glycemic control and improved beta cell function. There was a change in fasting plasma glucose from 267 to 102 in 6 months, and in postprandial glucose from 408 to 153 in 36 months. HbA1c came down from 11.4 to 7.1. So to conclude, we can say when a patient comes to us, we take a decision without taking into account the patient's history or discussing with him his problems. We prescribe in the medicine, patient fails to comply, and there is no improvement. But if we take a trust-based shared decision, there are more chances of adherence and taking treatment by the patient. To conclude, you can say that clinical inertia has to be prevented at every stage of the natural history of diabetes. It is possible to prevent diabetes in those with pre-diabetes. Once diagnosed with diabetes, good control of diabetes can prevent complications. Suboptimal control of hyperglycemia due to delayed intensification of therapy leads to diabetic complications and doubles the risk of cardiovascular events to type 2 diabetes. The strategies for overcoming therapeutic inertia must aim to improve the physician's knowledge and training and a structured education program for patients with improved communication and collaboration. So it's not about working harder, it is about working better. So take the time to develop a system to tackle inertia in your practice. Otherwise, if you don't deal with inertia, it will deal with you sometime. Thank you so much.
Thank you, sir. I must compliment that you finished by time, before time, even 2 minutes. So we have time for discussion. So if any comment and question from audience, welcome.
Thank you, Dr. Girish Mathur, for such a wonderful talk. And thank you to the chairpersons, Dr. Nishant Kanodia and Dr. Sajid Ansari. With this, we'll proceed to the next talk. The chairperson for the next talk will be Dr. Bijay Patni and Dr. Mukesh Sarna. Sir, please come up on the stage and take your seat. The presenter for this talk will be Dr. Mukhi Pran Prabhu. Sir, the stage is all yours.
Good morning. So we are going to the next topic, and this is extremely important from the primary healthcare point of view. Bolt from the blue, syncope, the approach and the management. And we have Dr. Mukhya Prana Prabhu to give us the deliberation. Syncope, as you are aware of it, it is definitely bolt from the blue for the, at least for the family. And later, obviously, the physician, when the patient realizes it, it definitely is out of the world for him. So to give talk on this such an important topic, I'll request you to go ahead with it. Dr. Prabhu, please.
Chairperson. At the outset, I would like to thank Professor Anuj Maheshwari, Professor Srinivas Murthy, Jayant Panda sir, and all the respected seniors in this podium for giving me opportunity to talk on such an important topic, bolt from blue, syncope, and how to approach. This is a vast topic. I will try to cover it in next 15 to 20 minutes. My previous esteemed speaker, Preetham Gupta sir, has already covered some of the topic orthostatic hypotension, tilt test and all. So beating from KMC Manipal where I come, what is bolt from blue? If you see that Greek god, Zeus, who was considered as a rain and thunder god, and that term was used by English sociologist, bolt from blue for a surprise. So as chairperson told, syncope is always surprising and bolt from blue. My outline of talk, I will be talking on brief introduction, some of the causes and differential diagnosis and pathophysiology, and how to approach syncope clinically. As I told that the theme is primary care. Syncope is diagnosed based on the history, simple investigation, ECG and clinical examination. Some diagnostic testing and management and summary. See this lady, all in a room. What is syncope? It is defined as transient loss of consciousness due to, most important term is cerebral hypoperfusion, with inability to maintain postural tone that is followed by spontaneous recovery. There is no time. And syncope excludes seizures, vertigo, coma, shock, or other state of alteration. You see that there is a circle, there are so many times. Patient comes, I feel giddy, I feel dizzy. And in yours, they say, I passed out, I fainted. So syncope is not a symptom. It's a symptom, not a diagnosis. Again, self-limited loss of consciousness, short duration, variable waning symptom, spontaneous and complete recovery. But complete loss of consciousness occurs within 20 seconds. So patient will be completely all right. What is the impact of syncope? If you see, 40% will experience syncope at one point of time. Common medical problems, 3% of emergency visits and 1 to 6% of hospital admissions. Major mortality is with fall, which cause fractures, motor vehicle accidents, minor injuries. You can see that there is a term called pre-syncope. When the patient feels initially feels of giddiness, then there is a syncope is imminent. Patient person sits, he will recover it. It's also called lightheadedness. If you see the differential diagnosis, syncope there should be transient loss of consciousness, whereas syncope is can be neurally mediated like vasovagal attack or neurocardiogenetic. Orthostatic hypotension, sir, Preetham sir has deliberated in detail. Cardiac arrhythmia, that's more serious cause of syncope. Structural heart disease like aortic stenosis or massive MI or pulmonary embolism, cerebrovascular, non-syncopal syncope like psychogenic or pseudosyncope. That there is a loss of consciousness. Most important differential diagnosis, seizure disorder, where there is a loss of consciousness, but usually for 5 to 10 minutes. But syncope, there is only transient loss of consciousness. So what there is a complete loss of consciousness without global hypoperfusion, hypoglycemia, hypoxemia, hyperventilation, hypocapnia, that's again psychogenic hyperventilation syndrome, drug overdose, vertebrobacillar TIAs. Disorders without impairment of consciousness, psychiatric illness like cataplexy, drop attacks, functional psychogenic, TIA of carotid origin. This is a major circle. What are the bases? Asserted hypotension related, either primary or secondary, reflex syncope, either vasodepressor, cardioinhibitory, or cardiac syncope, where there is obstruction or arrhythmia, or can be both. So if you see that by etiology, reflex, what is the most common cause? Situational cough syncope, micturition syncope, carotid sinus hypersensitivity. The patient can, tight collar can cause, turning the neck can cause. Atypical, which is a tilt positive. Orthostatic hypotension has been dealt in detail. Autonomic failure, either primary or secondary or drug induced. Cardiac arrhythmia, most important is heart blocks, tachycardia, particularly serious, ventricular tachycardia or drug induced, structural endocarditis, aortic stenosis, created myxoma. If you see the mechanism wise, bradyarrhythmia, tachyarrhythmia, no or slight rhythm of blood, this is hypotension. So evaluation, what is the EM? Identify the etiology of syncope, then decide what is the risk factor. As I already told, either neurally mediated, orthostatic or cardiac arrhythmia related or structural heart disease or cerebrovascular. So you have to decide whether the patient has lost consciousness, is it transient or is it regular? If it is a prolonged loss of consciousness, is there hint of seizure? Is there a history of fall, coma, altered sudden cardiac death? Other things, non-traumatic, like most important, syncope is the vestibular attack, the differential action, and some rare cause. So classification, I already told it. Most important is neurally mediated, the vasovagal attack, of post-fixation, drug-induced volume depletion, bradyarrhythmia, tachyarrhythmia like VT, rarely SVT. Another important is a long QT syndrome. And myocardial infarction, aortic stenosis, pulmonary embolism is one important cause. Aortic dissection is another important. Cerebrovascular, Thiel syndrome, and ventricularis insufficiency. Unexplained syndrome, 34% of cases. So if you see that most important is vasovagal attack. And if you see that if the person is younger, most important is either it's neurally mediated. If the person becomes older, cardiac and more serious causes become important. So episodes, if you take by causes, sudden attack occurring in an unpleasant environment, prolonged standing, the vasovagal attack, which we see commonly. Most common is long rounds in medical ward rounds or classes, or patient is taking a blood. That is one of the causes of syncope. That is cardiovascular reflexes, vasodilatation, and bradycardia, fall in blood pressure and global cerebral hypoperfusion. This is what is called common heart shower, emotional stress, orthostatic stress, and neurally mediated. This is a pathophysiology. I will not go in detail. Most important is that decreased low cardiac output, baroreceptor impairment can lead to hypotension and cerebrovascular hypoperfusion. There are three types: vasodepressor type, cardioinhibitory type, and vasodepressor type. There is a vasodilatation, hypotension, bradycardia. There may be both parts, like a vasodilatation and bradycardia. One more important part is a turning the neck, wearing a tight collar can lead to the dedifferentiation of neck muscles, increased afferent signals that leads to syncope. This also again can be diagnosed based on the history. Orthostatic hypertension is dealt in detail, classical and initial. Sir has dealt in detail. I will not go in detail. Fall of blood pressure more than 20 minutes within 3 minutes or immediately. If you see that again, history is important. How much loss of consciousness, whether either the fall, either the bowel bladder implantation. Jerks can also occur in syncope, but usually jerks are typically vitals will be normal. Vitals could have low bradycardia and hypotension. Initial evaluation, most important is history. 5 P's: prodromal symptom, precipitating factor, palpitation, posture at what position the syncope occurs, post-event recovery. These are the things if you ask, you can make a diagnosis most of the time. Physical examination, BP, orthostatic hypotension, and also look at the cardiac examination, specifically aortic stenosis murmur, and also any other murmur, and neurological examination to rule out seizure. Is it syncope or not? Data. Was there a loss of consciousness? Quantity have a post. This also is that it is a syncope. Whether the patient has a serious risk factor. Serious risk factor is decided as a cardiovascular, which can lead to sudden cardiac death. So, in syncope, during exertion or syncope, palpitation, prior history of sudden cardiac death in the family, non-sustained pre-excited complex ECG, prolonged QT interval, RPT pattern, then and not there. One is two other important severe anemia, electrolyte. Most important Stanford syncope score. Out of that, abnormal ECG, underlying congestive heart failure, history of shortness of breath, hematocrit, less than 90 millimeters. If you see this is called text acronym. The patient has a syncope, look at the congestive heart failure. hematocrit less than 30%. ECG abnormality is in the form of bradycardia or tachycardia or blocks. Shortness of breath history is there. Systolic blood pressure is less than 90. This is common in all these things. So if you take then you can identify the what are the serious medical conditions. One is cardiac arrhythmia abnormalities, ventricle non-arrhythmic like ischemia, severe aortic stenosis. Non-cardiac condition you have to identify is sudden blood loss, anemia, major traumatic injury, state vital sign of travel. How to evaluate the initial history as I have told, most important, then whether the patient has evaluation is required, you can take it as a vasovagal attack and leave it. If the initial evaluation think of orthostat weight potential, initial suggest CV abnormality, echocardiogram, and MRI and CT of the can be considered suspicion of 124 to identify the arrhythmia. This is what monitoring every you can record the ECG for 24 to 48 hours. These are group recorders where the syncopal episodes are less common. You can use this. Fast test here head tilt test whereas done in detail. Table is tilted at 70 degrees with foot rest. Velcro straps are aortic. There is no major contraindication, but indication obvious repeated syncopal episode. In a single case of unexplained syncope, you should consider. And important to differentiate convulsive syncope and epilepsy. Complication, there is no contraindication. Left ventricular outflow, tract obstruction, I mean, treatment, a simple measure, patient education, reassurance and inspection, avoiding crowded environment, prolonged standing, adequate intake of fluids, cold water intake, salt intake, field train, drug therapy, not an ideal indication. So, associated injury, improve quality of life, education regarding avoiding triggering factors, recognition of head comes down, patient will improve. So, the most important thing is that making the patient prevent attack, maneuver to avoid the episode. So, see, evaluation and treatment may take part. Field training is another thing which can be done. Those who have got a recurrent attack of syncope. So, salt or volume, salt tablet, midodrine, proxetron, beta blocker, midodrine, all these things have been used. So, some of the complex challenging cases which I have seen, but if you have hypertension, RPPB, and the diagnosis of pulmonary embolism. So, patient is now even afraid to stop the anticoagulation to decide surgery. Second is a 35 lady, repeated episode of diplopia. She was brought to the hospital, a refractory hypotension, and they palpated the lower limb BP, pulse was well felt, it's a Takayama syndrome, which ECG diagnosis very simple, it was a complete heart. When walking to the we found the ECG was a fever-induced pagoda, but we wanted electrophysiology. He was not believed. And a repeated episode of diagnosis of aspect. So coming to summary and conclusion, all of you agree syncope is a very common medical problem. Most important, like a primary case, taking a good history. What position it occurred, how many positions, previous history, premonitory symptoms, was there any palpitation, what was the post-recovery, clinical examination. Most important is pulse, blood pressure, cardiac auscultation, neurological examination. Judicious investigation, simple to investigate, hemoglobin, hematocrit, ECG, glucose, electrolytes, and also if required further EEG may be helpful. Most important is syncope or seizure. Always close differential. We always ask the patient, is it syncope or is it seizure? Because both of them are very common. Chest saprophy can by high risk patient who got a cardiac disease or further evaluation needs to be evaluated. Evaluation is syncope, challenge in clinical practice, but in primary care, most important is only history and examination. Thank you for the patient figuring. These are my so I want to end with William Oscar's quote. Medicine is a science of uncertainty, the art of probability. So we know that syncope is a disease, vast number of differential diagnoses, vast number of, it's not a diagnosis. You have to find out the cause. Thank you for the patient listening.
Thank you, Dr. Mukhya Prabhu, for beautifully narrating this vast and very wide topic of syncope. And as you explained us that the basic medicine teaching that taking a wide detailed history and by doing simple tests, we can differentiate and diagnose the cause of syncope and then we can successfully treat. Thank you, Dr. Mukhya Prabhu.
One simple request to you, can you give a clear message to the to us rather, I would say, CT scan as an initial evaluation is very commonly seen whenever a patient has syncope. So what would you recommend? Thank you. Thank you. We can wrap up the, if you have any other questions. Thank you. Thank you. Thanks.
Thank you, Dr. Mukhya Prabhu, for such a wonderful talk, and thank you to the chairpersons, Dr. Vijay Patni and Dr. Mukesh Sharma. With this, let's move to the next talk. For this talk, the chairpersons will be Dr. Dhruvi Hasnani and Dr. Mukesh Gupta. Ma'am and sir, please come up on the stage. Dr. Mukesh Gupta. The talker for this presentation will be Dr. L. Srinivas Murthy. Sir, please come up on the stage.
So I have the honor of introducing someone who doesn't require introduction. Dr. L. Srinivas Murthy. He is the Life Care Hospital and Research Center, Shankar Nagar, Bangalore. He is MD and FRCP Edinburgh, FICP PDCR, former consultant at Fortis Hospital. And he has a lot of national and international publications. He is faculty at various national and international forums. He is going to deliver his talk on mitochondrial modulators, the new age OHAs. Over to you, sir.
Thank you, Dr. Mukesh, and Dhruvi, thanks for being here. And good morning, all. So the topic is going to be something at the molecular level. I'm sure you people had a coffee just now outside, so I assure that you're not going to. We'll get it out, sir. complaints again. We'll get it. We'll get it served here if you are awake after my talk. So the mitochondrial modulation is the heart of the matter, is the title, which is going to be the outline about the global burden, progressive diabetes, cutting the risk of this meta-flexibility is the new terminology what we talk about, and the early intervention, and of course meeting the unmet need with these mitochondrial modulators in our armamentarium for treatment. So we know diabetes and pre-diabetes prevalence in adults with the as high as about 11%, and the current estimate we have about 75 million Indians with diabetes, and we are second to China in this. So we have moved on when it comes to the pathogenesis from the triumvirate to omnious octet. All of us know that we're literally involving whatever the available systems for the pathogenesis of this hyperglycemia. And of course, we have been the glucocentric approach, and the fallacies of this have been shown back in Wikipedia, in the VADT trials, all that, but targeting only the A1C below 7% is not going to help you, is not going to prevent your macrovascular complications. And this clearly talks about the typical thin fat Indian phenotype, where there is high prevalence of micro and macrovascular complications in young diabetics, and also increased burden of CV risk at an early age, at least a decade early, our patients succumb to these complications. So what is the reason? There is a progression in this pathogenesis we are talking about today: adiposity, the adipocytokines, oxidative stress damage, and the higher levels of glucagon and genetic factors. Of course, finally, the mitochondrial dysfunction is what we are proposing as a new mechanism in the pathogenesis. So let us look at this metabolic flexibility. Normally, as you can see here, the hyperplasia of adipocytes results in the chronic inflammation and results in an imbalance between the expression of the pro-inflammatory cytokines, which is one of the typical pathogenesis proposed in Indian context. And this, now we are proposing the mitochondrial dysfunction is one of the key defects in this insulin and beta cell resistance, which ultimately acts upon the various systems, resulting in the endothelial dysfunction, and of course, the RAS activation and the vascular complications. So we know the mitochondria is the kitchen of the cell, which releases ATP molecules. It fires literally, and this dysregulation in the switch therapy, because in the fed state and in the obesity or hyperglycemic state, there is a fuel switching, which is meta-flexibility is deranged, and that is what is the proposed mechanism. And this alternative switching of this metabolic fuel is lost during this chronic fed state and in the metabolic syndrome like obesity. And this happens across the organ systems, as you can very clearly see, the cardiovascular system, the skeletal muscle system, even in the pancreas at the level of pancreas. End of the day, there is a released lesser of ATP molecules, and this pushes the oxidative stress. So the alternative hypothesis, what we are talking about, is the mitochondrial dysfunction, which both in skeletal muscle and at the pancreatic level, there is a defective insulin secretion. And this long-term exposure of glucose and free fatty acids surpasses this adaptive threshold for ensuing the lipo and glucotoxicity, eventually resulting in the vascular complication. So this is what I was talking about, the switch between. Whenever there is a increased fatty entry or the fatty acyl oxidation, the free fatty acid acylation, what we call, it results in the increased acetyl-CoA, and this oxidative stress and acetylation eventually results in the glucotoxicity, and the proposed mechanism is the mitochondrial dysfunction. So this substrate utilization reduces whenever there is a mitochondrial lipid oxidation enhances in the fed state, like in obesity or in metabolic syndrome, and this phosphorylation will result in the increased nitric oxide production, and eventually the macro and microvascular complications are resulted. And this mechanism is also now proposed for the erectile dysfunction, which we see as one of the microvascular complications in diabetes. And of course, this metabolic inflexibility with respect to the mitochondrial dysfunction has been proposed through various genetic factors, environmental factors, and eventually the beta cell function and insulin resistance, and resulting in the complications of diabetes. So let us look at the unmet need now in our treatment. We know this age of this multimorbidity and continuum of cardiorenal metabolic syndrome is now proposed to be instigated by this mitochondrial dysfunction. This is again the lifestyle modification, which has shown that restricting the calories has got little impact on the long-term efficacy of this mitochondrial dysfunction and the advantages of this intermittent fasting. So there are no studies. In fact, there is a small study done which has shown that the persistence of exercise with the intermittent fasting will not reduce the microvascular complications. And the one other class of drug which is there now available is the TZDs, which can counter this to the PPR pathway, where only the glucotoxicity is not taken care, only the lipotoxicity is taken care. Again, there is an unmet need. Similarly, the newer class SGLT2s will accentuate lipolysis and the non-HDLC component is increased, which is one of the markers for this toxicity of the mitochondrial dysfunction. Non-HDL is one of the the markers for this inflexibility. So what are these mitochondrial modulators? They are the drugs which benefit patients by these new mechanisms that would make the system and the organ dysfunction, altering the hemodynamics. So they correct the metabolic dysfunction due to inappropriate or underutilization of the carbs, proteins, and lipid substrates, and they directly correct the metabolism defects in the liver, pancreas, and skeletal muscle to improve this insulin resistance and insulin sensitivity. And mitochondrial modulators directly improve cellular energetics by glucose and lipid disposal while improving the NO-mediated endothelial dysfunction. So basically, we're trying to look at the basic defect pathophysiological mechanisms at the level. And the ideal OAD with the mitochondrial modulator effect, what we want is should correct the mitochondrial dysfunction, the insulin resistance, and the insulin secretion, and eventually resulting in the reduction of the A1C and the CVD risk as a whole. And that is what we look at. Are there anything available now? Of course, there is only one class of drug which is available, and these novel mitochondrial modulators are the which targets and upregulates the mitochondrial energy transport chain, and that is what we look at, and eventually improving the insulin sensitivity and correcting the glucose and improving the lipid profile, and of course the other cardiovascular advantage. So there is one late stage clinical development which is phase 2B, which is going on, and I'm one of the part of this study wherein these mitochondrial modulators we're looking at these endpoints, and of course it's not yet done, where we're looking at the A1C, the blood pressure, and the non-HDLC component, whether it improves or not, and that is what we're looking at. And there is only one group which is there. So finally, the unmet need for thin fat Indians, we know these two classes of drugs are there, the metformin and the SGLT2 for the people with moderate risk and a very high risk. But what about the high risk component, which we see in day in and day out in our OPD, where a diabetic patient more than 10 years without any target organ damage plus any other additional risk factors? For them, we are proposing mitochondrial modulators would try to correct the basic defect in this. And thank you very much for patient hearing. And I'm sure all of you are awake with the tea rather than my lecture. Thank you very much. And I hurried a bit to compensate for the time. We are running about 20 minutes late. So thank you very much for being here. Yes, sir. Yes, sir. There is a class called Glimins. There is a group of drugs which is available. I don't think in India it's available, but that's the only class. But now the Torrent is doing this study. I'm not aware, sir. I think in the US it is available. Yes. Yes. I think Purvi is also. In India, it is not at all. Thank you, sir. Thank you. Thank you.
The next session is none other than by Dr. Y.P. Munjal, and he'll be speaking cardiovascular outcome trials and impact on clinical practice. To chair this prestigious session, I invite Dr. Preetam Gupta and Dr. N.K. Shoni and hand over the session to them. Dr. Munjal will be speaking virtually.
Good morning, dear friends. It's my proud privilege to invite Professor Y.P. Munjal for this next talk. Professor Y.P. Munjal, he doesn't need any introduction. He is our mentor. He is a guide for Association of Physicians of India. He has been at the helm of affairs for the last so many years. He has given a talk at numerous places, not only well known all over the country, but even internationally. I very humbly would like to invite Professor Y.P. Munjal and would ask my co-chairperson, Dr. Preetam Gupta, to introduce the subject and invite Professor Munjal.
Thank you, Dr. Soni. Good morning to everybody. Dr. Y.P. Munjal has already been introduced by my co-speaker, co-chairperson, Dr. Soni. He is going to deliver a very important topic, that is cardiovascular outcome trials and its impact on clinical practice. Over to you, Dr. Munjal, please.
Thank you very much. At the outset, I will like to thank Dr. Anuj Maheshwari and Dr. Jayant Panda for inviting me to talk on this important subject. Can you see my slides?
Sir, we can see you, but the slides are not visible as yet.
It's okay, sir.
Is it all right now? Well, dear friends, you know that we made tremendous strides in the control of cardiovascular disease, but the results have not been up to the level expected by the various methods which we have adopted. And one of the important reasons is that diabetes is the single largest cause for cardiovascular disease all over the globe and especially in our country. This first slide shows you that the cardiovascular risk across all the formats of coronary artery disease and cerebrovascular disease, which we see is at least 2 times than the normal people. The enthusiasm to control glucose level in a very aggressive manner, we had the Accord trial, and then we had the Veterans Administration trial, in which there was marked control of the hyperglycemia, but to our surprise, in the Accord trial, we found that the morbidity and mortality increased. Similarly, a drug which was introduced, that is rosiglitazone, also showed an increased propensity to cardiovascular events. So therefore, the lessons which we learned by them was, it's a major cause of morbidity and mortality in patients with diabetes. Cardiovascular disease management is an expensive proposition, and when treated with intensive control is not associated with reduction in the risk of macrovascular disease over a 3 to 5 year time. While glycemic control early in the disease appears to be associated with decrease in major adverse cardiovascular events, most of the long-term cardiovascular outcome trials are in patients who have either marked risk factor for cardiovascular disease or atherosclerotic cardiovascular disease per se. If these trials, as we will be shortly discussing, are positive, then our focus will change from treating aggressively the hyperglycemia to how to achieve and which drug to use so that the cardiovascular outcomes improve. Since the year 2008, when FDA made it mandatory for conducting the trials on any new group of drugs which was launched, and as you can see here, we have important clinical trials which started bringing results as early as 2013-14, and still some of the results are coming. What are the major cardiovascular events which are looked at in cardiovascular outcome trials? They can be 3-point major adverse cardiovascular events, 4-point major adverse cardiovascular events, and the 5-point MACE. The 3 important points, which are the primary endpoint in most of the trials, consists of the non-fatal myocardial infarction, non-fatal stroke, and cardiovascular disease and death. If you add to that hospitalization for unstable angina and hospitalization for heart failure, then that completes the 5-point major adverse cardiovascular event which are evaluated in most of the trials. How the cardiovascular trials have been conducted, that the new drug is compared with the standard of diabetes care in the established way in which we have been treating hyperglycemia. What were the safety factors and the non-inferiority to the placebo drug? One of the earliest groups which was evaluated are the DPP-4 inhibitors. And as you can see in the major DPP-4 outcomes trials, that is SAVOR, EXAMINE, TCOS, CARMELINA, you find that compared to the placebo, the results are practically similar, and though there is no improvement or superiority of the treatment agent over the placebo treatment, but certainly they are cardiac effect neutral. Let us see what changed that we have a group of drugs which are superior than the placebo group, and you find the first trial which suddenly woke up the medical profession was the EMPA-REG outcome trial with empagliflozin. And the various therapies which were used in this group of patients is highlighted, that is the glucose lowering therapy and the cardiovascular therapy which these patients were receiving. What did it show? Number one, it showed a decrease or improvement in the 3-point MACE outcomes. The other important point which is seen from these Mayer curves is that no sooner the drug is started, the beneficial effect starts manifesting itself, as you can see from the slide, that the diversification starts taking place even within 2 to 3 months of the start of therapy. The other SGLT2 inhibitors also showed a similar beneficial effect with CANVAS program, which involved canagliflozin, and DECLARE TIMI 53, which included the dapagliflozin. Now let us look at patients who had established atherosclerotic cardiovascular disease, and if you look at the events per 1,000 patient years, then you find that with SGLT2 inhibitors, there is a significant reduction in these events. And when you pool all the SGLT2 inhibitors, the beneficial effect still stays. If you look at patients with multiple risk factors, then the 3-point MACE is equal to 1, and that is, it is neutral. The other important group of agents which were tried are the GLP-1 receptor agonists, and we had the exenatide, liraglutide, semaglutide, elbigutide. You find that with Elixa, there was cardio neutral effect, while the liraglutide did show a significant reduction in the 3-point MACE, which was bettered in the semaglutide trial. And now we have semaglutide both in injectable once a week and the daily oral therapy, the major and most startling effect was seen with empagliflozin in the mortality, and again the effect became manifest within the first few months of starting the therapy, and there was a reduction of 68% in patients with cardiovascular events. With all the other agents, a similar effect was seen, while patients with multiple risk factors, the effect was not so pronounced. Similarly, with GLP-1, the best effect was seen with liraglutide, and then with the Excel trial, we also found beneficial effect, while SUSTAIN and ELIXIR trial did not show any significant reduction in the mortality. The all-cause mortality also was reduced to a maximum extent with EMPA-REG studies. The next important thing, which was their hospitalization for heart failure in the presence or absence of atherosclerotic cardiovascular disease. And you can see that again, both in the group with multiple risk factors and established cardiovascular disease, the glyphosins did show a significant reduction. The next important thing which was seen as an observation was the effect on kidney function. The deterioration in the kidney function reduced markedly with the glyphosins. The hospitalization with the DPP-4 inhibitors, you can see increased in cases of saxagliptin, alogliptin, and no change was seen with sitagliptin or linagliptin. Then they thought that let us look at the heart failure in all its different forms, and Emperor preserved was that with the heart failure with preserved ejection fraction, that is more than 40%, and Emperor reduced was where the ejection fraction was less than 40%. Dapagliflozin was also evaluated with dapagliflozin heart failure trial, where the ejection fraction was more than 40%, while dapagliflozin with the reduced ejection fraction, it was less than 40%. The sotagliflozin was seen as a single trial, and you can find out from this that in the large scale patient trials, the primary endpoint with SGLT2 inhibitors showed improvement in chronic kidney disease as well as diabetic kidney disease. We talked about the conditions and the use of drugs in a situation where clinical trials are going on, patients are selected, there are stringent inclusion and exclusion criteria, but let us see what happens in the real world. And in the real world data, which is usually collected outside the controlled constraints of conventional randomized clinical trials, to evaluate what is happening in normal clinical practice. And what we found out was that with the real world data, again, you can see heart failure or death significantly reduced with the SGLT2 or 1 inhibitors. The same point was highlighted in case of empagliflozin by a trial called EMPEROR. How did it change the practice? Well, I think the comprehensive management is to start with metformin and use it as long as it is tolerated and is able to achieve the A1C control along with the lifestyle measures. The patients who are at high risk of established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, the thought process switched over from the conventional therapy to SGLT2 inhibitors, use of GLP-1 agonists, and third in position were the DPP-4 inhibitors. If you get a control in the A1C, you continue with the same treatment, but further increase or improvement in therapy, again, we use either the future generations of sulfonylurea or insulin. Here, if the HbA1c is above target, despite the recommended first-line treatment, and the patient has atherosclerotic cardiovascular disease or CKD, if cardiovascular disease predominates, then you use a GLP-1 receptor agonist with proven benefit or add SGLT2 inhibitor with cardiovascular benefit. And if the glomerular filtration rate is still reasonable, and similarly, if there is heart failure or CKD, first choice will be SGLT2 inhibitor, and if not successful, then GLP-1 receptor agonist with proven benefit are used. So the consensus evolved over a period of time, and now it is said that patients with type 2 diabetes who have established atherosclerotic cardiovascular disease, SGLT2 inhibitors or GLP-1 receptor agonists with proven cardiovascular benefit are recommended as part of the glycemic control. Among patients with heart failure, SGLT2 inhibitors are recommended. For patients with type 2 diabetes and CKD without cardiovascular disease, we may think of SGLT2 inhibitors, and GLP is not the preferred group of drugs. So, has there been a change in the thinking and the treatment? Before the CVOT trials, there was lack of evidence for cardiovascular outcome therapies with different means, and it was mainly focused on controlling the sugar values. Now, with the new drugs, the new data has emerged where cardiovascular outcome trials have been carried out and which has shown that there is a reduction in the cardiovascular outcome trials in patients who have atherosclerotic disease, heart failure, or chronic kidney disease. So with this, I thank you, gentlemen, because now the line of treatment changed from metformin, and the second line, which was the either glitazones or it was sulfonylurea or insulin, is now veering around to the use of SGLT2 inhibitors. Therefore, I think for the benefit of your patients, and if cost is not a major constraint, then SGLT2 inhibitors or GLP-1 receptor agonists may be used to reduce the burden of cardiovascular disease in diabetes. Thank you very much for your patient attention and listening. Thank you so much.
Sir, thank you very much for enlightening us about the cardiovascular outcome trials and the changing scenario of treating type 2 diabetes with comorbidities and where we can provide a better quality of life to our patients. Now, because of the paucity of the time, we would now take any questions and we'll move on to the next session. Thank you very much once again.
Thank you so much, sir, Dr. Y.P. Munjal, for such a wonderful talk. And thank you, the chairpersons, Dr. Preetam Gupta and Dr. N.K. Soni, for chairing the session. With this, we'll move on to the next talk. The presenter for the next talk is Dr. Swati Srivastava, and the session will be chaired by Dr. Mukhya Pran Prabhu and Dr. Mukulesh Gupta. Chairpersons are requested to please come up on the dais and take their seat. And the presenter is requested to please come up and take the podium. Dr. Swati Srivastava.
So now we have another important area in the field of medicine, and that is thyroid disease. We know that thyroid as such affects nearly 4.2 crores people in diabetes, and the equal number is underdiagnosed. To dwell upon this topic, we have a speaker which will be introduced by my co-chair.
Madam Swati, today we got a very important topic, sir has introduced interpretation of thyroid function test. To speak on this topic, we have got an eminent speaker, Madam Swati Srivastava, who is a professor and HOD in Unit 8 in SMS Medical College, Jaipur. She is a gold medalist from Baroda Medical College, topper in medicine, 9 awards and orations, and best paper in Jaipur Epicon. She is a postgraduate teacher and in charge of thyroid clinic in Jaipur. Please give us a talk. Thank you, madam.
Thank you very much. Respected seniors, chairpersons, colleagues, at the outset, I would like to thank the organizers, Dr. Anuj Maheshwari sir, Dr. Jayant Panda, and the entire team of ACP India chapter for giving me this wonderful opportunity to talk on this very important topic and to give me this podium to be present on this very important podium. So I'll be talking on a very primary basic topic, and that will be diagnosis made easy, interpretation of thyroid function tests. Thank you very much. So as we know that the regulation of the thyroid axis involves the hypothalamus, pituitary and thyroid, and the entire hypothalamic pituitary thyroid axis is responsible for the equilibrium of thyroid hormones and the function which we have, which affects the so many metabolism and so many important functions that the thyroid hormones have on the entire body. And that is what we test when we do the thyroid function test. So we have so many tests. Why we talk so much specifically of interpretation of thyroid function tests? That is the question. So what is the significance? So although thyroid disease in its most florid form is easily recognized, it's a very common disorder. We know that, affecting to as much as 2 to 10% of the entire population. And it's easily recognized, but still we see that patients often manifest with symptoms or signs that are many a times non-specific. Many a times they present to clinicians of different specialities. They may go to a gynecologist, they may go to a skin specialist, they may go to a psychiatrist. So we have so many, even in orthopedic surgeons, with so many different manifestations and specialities. And accordingly, we need a high clinical index of suspicion to confirm the diagnosis. And this requires a very accurate measurement and interpretation of the thyroid function test. And then, as we know, that there are some very commonly encountered patterns of abnormal thyroid function, so which we can say as the anomalous or discordant TFTs. Because when we have a thyroid function test, we make a clinical diagnosis. On the basis of the diagnosis, we order a thyroid function test. And sometimes when it comes totally discordant to the diagnosis that we suspect, then that becomes difficult to make out. And that is what I will be discussing in my talk today. So assessment of thyroid status basically assesses the status of the hypothalamic pituitary thyroid axis, estimates the thyroid concentration in serum tests. There are tests for presence of autoimmune diseases, tests that provide information about the thyroid iodine metabolism and assessment of thyroid swellings. But as per the scope and the time for this talk, I will be discussing only for the first two, focusing on them. So when we talk about the thyroid function tests, the thyroid hormones, thyroxine, that is T4, and the triiodothyronine T3, these levels remain relatively constant and reflect the set point of the hypothalamic pituitary thyroid axis. This is what we should remember, that the thyroid hormones remain relatively quite constant and reflect that set point. So if they change a little bit also, then the patient is rendered probably sometimes a little hypo and hyperthyroid, but they remain stable. But along with the changes which are there in the thyroid hormone, there's a concordant changes in the TSH levels. So if we talk about the thyroid hormones, that is a T3 and T4, what happens is that the reference ranges of these thyroid hormones are relatively quite wide. If we see how much change they go through, the reference ranges are quite wide. So suppose there is a minor change in the thyroid hormone level, it is sufficient to render a person hyperthyroid or hypothyroid. But still, numerically, it will remain in the normal reference range. And that is the reason we are not able to diagnose on the basis of only T3, T4 many a times, which we call a subclinical or a mild disease. That the reference ranges being, it relies numerically in that range, but the change is sufficient. Suppose a T4 goes up, it is sufficient for the person to become hyperthyroid. But still, when we see in the reference range, it is within it. What changes? The TSH changes. So the excursion, even a modest change in the thyroid hormone, is associated with marked excursions of the TSH. And that is why TSH is traditionally recommended as a screening test for thyroid dysfunction. Having said all this, we still know that screening exclusively with TSH means that some patients will be misdiagnosed and will be missed altogether. So that alone is also not possible, though TSH is the traditional screening test, and it is definitely a very important test in most cases. So which are the conditions in which alone TSH can be misleading? There can be central hypothyroidism. We know the secondary and the tertiary hypothyroidism, where the TSH does not change. The non-thyroidal illness. This is a very important set of disorders where the non-thyroidal illness leads to different changes, and then alone TSH gives a wrong interpretation. The recent treatment for thyrotoxicosis. Now this becomes very important, because when a person with thyrotoxicosis begins his treatment for a long period, it is only the thyroid hormones which give you a valid interpretation as to the change which is occurring. The TSH remains as such for a long time. So we should not be following up the patient with TSH, but instead the thyroid hormones. And resistance, the last two are relatively quite uncommon. Resistance, after excluding the upper three, we can think of the other two, that is the resistance to thyroid hormone and the TSH secreting TSH HOMAs from the pituitary. So as we know, the test for the hypothalamo-pituitary thyroid axis, TSH is an important test, is a sensitive indicator, and it is a important screening test for most of the cases. We have ultra-sensitive fourth generation assays existing, and they which can detect as very low as 0.004 milliunit per liter. So very sensitive assays. Even for in the previous years, some 2 decades back, we used to rely more on the thyroid hormone and not on TSH. But now with the availability of such advanced assays, even for hyperthyroidism, we have a TSH becomes a valid indicator. We have various tests, the ELISA radioimmunoassay, the chemiluminescent assay, and the fluorescent immunoassay, out of which CLIA being the most preferred in most options, and mostly it is being used. T4 and T3 concentrations, we have to evaluate the free hormones. Also, we have to evaluate, we should remember that thyroid hormone has a very, very significant protein binding. The major part is bound. So sometimes when the binding proteins, that is the thyroid binding globulin, the transthyretin, and the albumin, if there are changes in these, then that leads to changes in the total thyroid hormone levels. And these are the conditions where we require to evaluate the free hormones more. So we can have so many permutation combinations where the thyroid hormone levels and the TSH levels have they are altered, and the various conditions we'll be discussing. So what are the various TFT patterns? This is the commonest pattern that we see, the high TSH and the low FT4. This is a primary hypothyroidism, most common. We all know this very well, the auto causes of this. Autoimmune thyroiditis, post-radioiodine thyroidectomy, hypothyroid phase of subacute thyroiditis. That is initially we know there's a thyrotoxic phase in the hypothyroid phase, and then the euthyroid phase in subacute thyroiditis. So the second phase we can say. Drugs, amiodarone, lithium, tyrosine kinase inhibitors, they have a tendency to suppress the thyroid function. So they lead to hypothyroidism. The antithyroid drugs, of course, iodine deficiency of excess by the Jod-Basedow phenomenon and the Wilf-Chekhov effect. Neck irradiation, renal thyroiditis, thyroid infiltration, and congenital hypothyroidism. Now, this is an important set which we know, high TSH and normal thyroid hormones. So this is an important group. We know that it subclinical hypothyroidism, when the TSH goes high, but the thyroid hormones are still within the normal range, as we just discussed. The subclinical, which was to be called the mild hypothyroidism, we should go in for anti-thyroid, anti-TPO antibodies, which help us in decision making as to what we should do, whether we should institute therapy or not. Confirmation is advised. However, in certain circumstances, for example, in pregnancy or where a pregnancy is being planned, replacement should be instituted without delay. But only subclinical hypothyroidism is not the condition which leads to such picture. We should always remember, probably we attribute to subclinical hypothyroidism in most cases. We should remember there is an assay interference which could lead to such picture. And the second most important point which is there is that in patients where exogenous thyroxine is being given, it may reflect malabsorption, altered metabolism, or poor compliance. This is very important because sometimes a patient is taking levothyroxine and the patient is probably not so compliant, and we get this picture, we keep on increasing the dose of thyroxine, which is probably not very correct. So that now we go to another picture where the thyroid TSH is high or within the normal range, whereas the thyroid hormones are high. This is a picture is not very frequently encountered. This can occur with assay interference of FDH, thyroxine replacement therapy, including poor compliance, drugs, non-thyroid illness, neonatal period where the TSH tends to remain high. The TSH, very rarely, as I said, TSHomas and resistance to thyroid hormones and metabolism and transport of thyroid hormone disorders. So we should try to exclude the first 4 rather, and then the last 3 are relatively unusual. Low TSH and high thyroid hormones is a very common picture, as we know primary hyperthyroidism, Graves' disease, toxic multinodular goiter, toxic adenoma, thyroiditis, drugs, amiodarone, excess thyroxine ingestion, excess iodine intake, congenital hyperthyroidism, pregnancy-related thyrotoxicosis. Again, this is a simple setup which most of us can diagnose very well. Now, TSH reduced and thyroid hormones being in the normal range. This is again very important. This is a subclinical hyperthyroidism. Now, subclinical hyperthyroidism is again an important entity because here we find that the thyroid hormones are okay, the TSH is mildly low. and there is a TSH suppression. Now, this group becomes important because there is an evidence, significant evidence, especially in the current times, that there is adverse sequel of atrial fibrillation, especially cardiovascular and osteoporosis, if TSH remains suppressed in the long term, especially in women, postmenopausal women, and older than 65 years of age. Most patients more than 60. Here, this is an important set. And there is emerging evidence that individuals will have greater morbidity in the longer term. So however, having said this, that there is an increased morbidity, cardiovascular as well as other all-cause morbidity, increased chances of heart failure. Many a times, these subnormal TSH values tend to return back to normal on follow-up without intervention. So we should keep this in mind. And the non-thyroidal illness, another important entity, again leads to similar picture, which resolves on its own. So we should not go by a single TSH report, but we should try to have a confirmation which will give us more idea whether we should start management or not. TSH being low or normal and the thyroid hormones being low, this is simple. This is occurring in central hypothyroidism, non-thyroid illness, TSH deficiency, SA interference. So this is the usual cause of secondary or tertiary hypothyroidism. Now, having seen these basic TFT patterns, let's see some specific considerations. Now, this becomes important because when we are assessing the thyroid status, we should remember that the thyroid function test should confirm one's clinical suspicion. We should not look at the test individually. However, they should be helping us, aiding us in our clinical scenario. So if it is discordant with our clinical status, a reassessment if unexpected TFT result is there. Another important thing is when the patient is on levothyroxine therapy. When the patient is on levothyroxine therapy, anomalous or discordant TFTs are not infrequently seen in patients with levothyroxine therapy due to several causes. Some of the causes which I have mentioned here are very important, and very commonly we see that we are giving a good amount of levothyroxine, still the thyroid function has not come under control. And we keep on increasing the dose, and that probably does more harm because we have to rule out the various factors which could have been responsible for this factor. One is a normal variant, and normally many people, it happens that the TSH remains normal for whatever amount of levothyroxine that we are giving. The TSH is okay, but the thyroid hormones remains a little on the higher side. But the patient feels comfortable and the patient is clinically good. So we have to see the clinical status of the patient. If that is so, this is a normal variant, let the thyroxine dose be the same. Another is inappropriate administration. When we say that the patient does not take properly on an empty stomach, takes concurrent medications, probably this comes under the picture that the TSH persistently remains high. Malabsorption, another very important problem where the patient is taking a good amount, high dose you are giving, and still the TSH is remaining high. Try to rule this out. Increased thyroid hormone metabolism excretion, probably not very common, again has a similar picture that we just mentioned. Increased thyroid hormone binding capacity, as I said, that in oral estrogen therapy, the lot of thyroxine gets bound. So we need to have the TSH persistently remains high. Change in thyroxine preparation. This is something very important because we change the preparation, the bioavailability varies, and then the thyroid function tests go haywire. SA interference, another very important factor to be kept in mind. And the second point, the most important factor I would say is the poor compliance. Patient takes regularly, then misses for 3-4 days. Again, the entire scenario goes haywire. And then what we get is we do not get a very good thyroid function test. And when we just apply increasing the dose, we increase the dose. After 3 months, what we see, the TSH is very low. And we don't realize why there are so many fluctuations. Probably this is the cause. Very unusually resistance to TSH, because resistance to the thyroid hormones, because at the level of the thyroid hormone receptor, beta gene, there is a mutation. This is a very unusual and rare condition. Many a times medications cause a lot of interferences in the measurement also, in the thyroid function also. This has to be kept in mind. Many a times we have to also consider the hypothalamic pituitary diseases. If we suspect a central cause for the hypothyroidism, then TSH should not be considered as a reliable marker, especially for secondary or tertiary hypothyroidism. It is the free thyroid hormones which should be used to guide our management. Non-thyroidal illness, sick thyroid syndrome, very important because intercurrent illness can, I'll just finish in 2 minutes. Intercurrent illness can affect thyroid function in several ways. So commonly TSH is low, normal or partially suppressed with low or normal free TSH. So we should try to avoid testing for thyroid hormones when the patient has other intercurrent illness or reconfirm after the patient recovers. What happens in sick thyroid syndrome? There is a decrease in the activity of D1, D2, which usually convert the T4 to T3 in the periphery, and then there's a conversion, there's an increase in the activity of D3 enzyme, which converts free T3 to reverse T3, leading to an increase in reverse T3, and that leads to a reduction in the TSH. So it leads to a variety of combinations, and these various patterns we can find out, which are very confusing. Avoid relying on them. Reconfirm when the patient is improved. Pregnancy alterations are very important. So trimester specific reference ranges should be used whenever possible. Assay interference is very important to be kept in mind. If the discordant TFTs are not explained by any of the factors that I just mentioned, we should remember there is something called assay interference, and that is important because simply sending a sample to another lab does not mean that you will get a better result, because different assay platforms also have similar interference. So we have to have a specialist advice and specialist lab where we have to discuss and accordingly try to see. Now I'll just review very rapidly about the other tests. The plasma thyroid hormone binding protein I just talked about, and the various conditions which increase or decrease the bindings can cause an alteration in the total and thyroid hormones. And so it's preferable in these conditions to go in for the free thyroid hormone levels. Serum thyroglobulin test usually used for follow-up of thyroid cancer patients. Thyroid autoantibodies, they are polyclonal antibodies, and they are increased in Hashimoto's thyroiditis and Graves' disease. And there are various tests for thyroid antibodies. Then there are tests for thyroid iodine metabolism tests, the radioactive iodine uptake, and the thyroid scans, which are the technetium scan being the most preferred because it takes much shorter time as the half-life being least. We use it for uptakes in patients where we consider where we're evaluating for masses, where we are evaluating for thyrotoxicosis. This is a hot nodule, as you can see. On one side, we have a normal scan. The other side, we see the hot nodule. Very importantly, we have to differentiate from subacute thyroiditis. You can see there is absolutely zero uptake in that. So I just put in a figure for that. Just a picture. Thyroid ultrasound is another
Madam,
very
can you
important.
conclude?
Yes, I'll conclude. Thyroid ultrasound is another important test, and so is thyroid FNAC, especially for masses. So summarizing, the results of thyroid function test must always be interpreted in the light of the clinical status of the patient. Awareness of the conditions or disorders that can be associated with different patterns guide further investigation and management. Confounding factors should always be kept into mind, like intercurrent non-thyroid illness or medications, before we just go in for barge in for a long list of biochemical, radiological, or genetic testings. And screening of thyroid for interference in thyroid hormone assays should also be kept in mind, and referral to specialists and endocrine service required whenever we have discordant TFTs. Concluding, a structured approach, careful clinical assessment, judicious use of TFTs, knowledge of the conditions disorders that are associated with different TFT patterns enables most TFTs to be reliably interpreted with avoidance of inappropriate investigations and treatment. Thank you.
Thank you, madam, for a wonderful interpretation how so various factors will play a factor, and particularly pregnancy is a challenging for interpretation of thyroid function. Thank you for the lack of time.
Yeah, in the interest of time, probably we'll conclude the session, and I will humbly request the questioners, if suppose they are there, to directly interact with Dr. Swati. Thank you so much.
Thank you. Thank you so much.
Thank you so much, Dr. Swati Srivastava, for this wonderful talk. I also extend my thanks to the chairpersons, Dr. Mukhya Pran Prabhu and Dr. Mukulesh Gupta. Let's proceed to the next talk. The presenter is Dr. Purvi Chawla, and the chairperson for her talk will be Dr. Meenal Mohit and Dr. S.S. Daria. I request the chairpersons to please come upon the stage and take their seat. I request Dr. Purvi Chawla to please come up and take the podium.
Good afternoon, everyone. We begin the next session, and I invite Dr. Purvi Chawla, a very close friend, a very good orator, and a very sweet person. I think we don't need more introduction, do we? We all know Dr. Purvi, and she's a wonderful speaker. I invite Dr. Purvi to talk on refractory hypoglycemia.
Thank you. Thank you so much. Always a pleasure and a double-edged sword when you have Jess as your chairperson. There's a huge risk of being dragged. Anyways, without much ado, I want to at the outset thank ACT India chapter team to have invited me here. And in particular, Dr. Anuj Maheshwari sir, Dr. Jayant Panda sir, Dr. Srinivas Murthy, Dr. Supratik, and Dr. Naik, who's also here. So thank you very much. Goa is a dream come true, and VC Roy room is another dream come true. Not all of us can get that award. So when it's difficult to treat, I'm going to give you a quick overview on the refractory hypoglycemia aspects today. So what exactly is refractory hypoglycemia? Well, definitions are not exactly clear, but it has been described as either prolonged duration of hypoglycemia that's lasting from hours to days, need for high dose of dextrose, more than 30 grams of glucose to normalize the glucose levels, or prolonged infusion of glucose to maintain euglycemia. So this is how it has been described. Very quickly revising the physiology, well, the brain cannot make glucose, cannot even store glycogen, or cannot use alternative sources of energy. So it depends solely on glucose for the energy, and that is completely dependent on the blood to brain glucose transport maintenance. And hence, the blood glucose levels are always maintained so that the brain can get the nutrition it requires. There are counter-regulatory mechanisms, as we all know, that effectively prevent the hypoglycemic events from occurring. And these critical physiological defenses include decrease in insulin secretion itself as the glucose levels decline within the physiological range, increase in glucose secretion simultaneously, and then increase in epinephrine secretion also as the glucose levels are declining further. Increased cortisol and growth hormone secretion also help in maintaining this defense against prolonged hypoglycemia, and they prompt symptoms which increases the food intake or food ingestion behavior. So when all these defenses fail, there is a plasma glucose level lower than 70 milligrams per DL or lower than 55 milligrams. That's when the neuroglycopenia starts. And at this point, insulin secretion is suppressed virtually completely. Plasma insulin levels are less than 3 units per ml. C-peptide levels are less than 0.6 nanograms per ml. And pro-insulin levels are less than 5 picomoles per liter. Because of the capacity to increase endogenous glucose production substantially, hypoglycemia is the result of absolutely low rates of glucose production or rates of glucose production that are low relative to high rates of glucose utilization. So this is when hypoglycemia occurs. Symptoms, I don't need to elaborate, but we all know neuroglycopenic symptoms are the worst, and that's what we want to prevent. Neurogenic, autonomic are basically the perceptions that are created so that we can prevent further declining of the sugar levels. And these symptoms, the symptoms are largely sympathetic neural rather than adrenomedullary in origin. And sometimes the the neurological symptoms actually take time to recover even though the glucose has been corrected. And in the worst case scenario, there has been even brain death reported. What are the causes? Now, the commonest causes, and I'm giving you this preview so that we can dive deeper into what causes refractory hypoglycemia. So the commonest are probably iatrogenic causes, mainly insulin and insulin secretagogues and even alcohol. Other drugs include, the whole list is out here, but importantly, certain quinolones, quinine, chloroquine, beta blockers, even ACE inhibitors, etc. The other systemic causes include renal failure, where there may be decreased gluconeogenesis and decreased clearance of renally excreted drugs, causing an enhanced level in the blood. Hepatic failure, again, decreased glycogenolysis and also decreased gluconeogenesis. And of course, the compromise on the functional reserve, even genetic defects, and even compromised drug metabolism. Cardiac failures, again, associated with hypoglycemia, sepsis, including malaria, and inanition. I also learned this new word today. This means lifeless or dull. So causes, again, important ones include hormonal deficiency like cortisol, glucagon, and epinephrine, and neoplasms. These are also very important causes of hypoglycemia and usually lead to refractory hypoglycemia. So whether it's non-islet cell tumors or mesenchymal tumors, hepatocellular carcinoma, adenocortical tumors, carcinoid tumors, leukemia, lymphoma, all these should be suspect when we see cases of hypoglycemia that are not really occurring in patients of diabetes or are refractory in nature. Well, if we have to relook at that in a different way, in a seemingly well individual, endogenous hyperinsulinism may be due to an insulinoma, functional beta cell disorders, and that includes nesidioblastosis, or non-insulinoma pancreatogenous hypoglycemia, or even post-gastric bypass hypoglycemia. Insulin autoimmune hypoglycemia, where there are antibodies to the insulin or the insulin receptor itself, where this antibody actually stimulates the insulin secretion endogenously. And of course, overdose of insulin secretagogues. Again, accidental, surreptitious, or malicious hypoglycemia is also one way to look at it. Endocrinopathies, which I just described to you, and poisoning. Ethanol poisoning is probably one of the most commonest reasons for hypoglycemia. So this traditional classification where we look at hypoglycemia, whether it was fasting or post-meal or postprandial reactive hypoglycemia, has long been challenged. Persons with an insulinoma, which we would expect will only experience fasting hypoglycemia, often tend to experience postprandial hypoglycemia as well. And those like the post-gastric bypass patients who we expect will experience post-meal hypoglycemia may have symptoms in the fasting state as well. So again, with all this clinical heterogeneity, it has been reclassified and it is clinically recommended to just see whether the patient is seemingly well or is under the burden of hypoglycemia that is occurring. And of course, with respect to somebody who is burdened with the occurrence of hypoglycemia, one should mediate with medications. So how do we go about evaluating or work up a patient of hypoglycemia, especially a person without diabetes? In diabetes, we all are experts, so to speak. We all know how to treat that. But this is where the problem lies, because this is a refractory hypoglycemia, which is not amenable to the usual dietary or even the glucose that we give IV. So hypoglycemia is rare in people who do not have drug-treated diabetes. Confirmation of the Whipple's triad is a very important step before we elaborate on investigations for the patient. And even this is just clinically, even an SMBG confirmation of hypoglycemia for Whipple's triad confirmation is more than enough at times, although most guidelines say that do a plasma glucose level at that point. So documenting this Whipple's triad is extremely important because we may subject the patient unnecessarily to a lot of investigations when we may not have even proven that what the patient has experienced is hypoglycemia per se. So symptoms of hypoglycemia, again, we have already gone through that. And Whipple's triad is nothing but hypoglycemia that is presenting with symptoms, signs, or both consistent with hypoglycemia, a low plasma glucose concentration at the same time, and resolution of these symptoms after the plasma glucose has been corrected. So this is the triad, and this confirmation is extremely important before we go about investigating the causes further. Well, we always start with a very thorough and good history taking, including looking for specific symptoms, timing and duration of the episode, aggravating and relieving factors, a physical examination and laboratory tests to rule out other illnesses, hormone deficiencies, or even neoplasms. Whipple's triad, like I said, should be confirmed. With no evident cause in a seemingly well individual, we must measure plasma glucose, insulin, C-peptide, proinsulin, and beta-hydroxybutyrate concentrations, and screen for oral hypoglycemic agents as well during an episode of spontaneous hypoglycemia, and observe the plasma glucose response to IV injection of 1 milligram glucagon in order to distinguish between the causes of hypoglycemia and the mechanisms underlying that. We must also look at the insulin antibody levels, if any. So now this is a tough scenario clinically, and which is not always possible, or maybe not possible at all, because the patient may be, in any situation when experiencing hypoglycemia, and we may not be able to subject the patient to this kind of an evaluation. So because of that, there is a wonderful protocol that has been developed, which is called the 72-hour fast, which must be conducted. So there are several protocols like this that exist from different groups or experts who have worked in this field in particular. However, this is from the Endocrine Society internationally, and this is how the test is conducted. And best to conduct this in a hospital setting. You may ask the patient to start fasting at home, but then later get admitted in the hospital. Because usually patients with Whipple's triad confirmed will not be able to complete the 72-hour fast, and that will be abandoned much earlier. 2/3 of the patient complete the test in 24 hours, 24 to 36 hours, and the remaining at 48 hours. So here what we do is discontinue all the non-essential medications. No food or drink is allowed except non-caloric beverages. And in 6 hours, we collect the samples of all the parameters that I mentioned to you. If the plasma glucose is above 60 milligrams per DL, then we continue the fast and we collect the samples every 2 hours or so. If there is a hypoglycemia, meanwhile, then we increase the frequency of sampling, and further when the glucose drops below 45 milligrams per DL with signs and symptoms, we collect the samples and send them for analysis. We also screen for oral hypoglycemic agents at this point and rescue the patient from this hypoglycemia. And the same is done even if the glucose is less than 55 milligrams per DL with a previous episode of hypoglycemia that's been documented. So in a patient with documented fasting or postprandial endogenous hyperinsulinemic hypoglycemia, a negative screen for oral hypoglycemic agent, and no circulating insulin antibodies, we conduct sophisticated procedures like the radiographic, or the CT, MRI, which have 70 to 85% sensitivity to pick up the tumors, transabdominal and endoscopic sonography, and if necessary, the selective pancreatic arterial calcium injections with measurements of the hepatic venous insulin levels. These are almost very important to diagnose a case of insulinoma. And management of the specific hypoglycemic disorder should be planned with due consideration to what the patient really wants. Now, I just want you to focus on insulinomas because they are the commonest causes of hyperinsulinemic hypoglycemia in adults, clinically characterized by, say, neuroglycemia, although it can present in many other ways. And particularly this is experienced in the fasting state, but we cannot rule out postprandially also. It affects 1 in 2,500 patient years. All ethnic groups may be equally vulnerable to it, and at any age and slightly more predominant in women. Malignant insulinomas are less common and only present in less than 10% of the patients, and they present with multiple tumors or have the multiple endocrine neoplasia type 1 or the MEN1 syndrome with a high recurrence rate. Early recurrence also means that it was not enucleated properly in the first place, and long-term survival is completely dependent on the complete removal of the tumor. The first case of hyperinsulinemic hypoglycemia due to insulinoma was successfully treated as early as 1929. So people have known about this and have been treating it for a long time. Well, the key features include that there is a complete failure of insulin secretion to fall to very low rates, even as the plasma glucose concentrations fall below the hypoglycemic thresholds, indicating that hypoglycemia is due to low production rather than high rate of glucose utilization. The levels of the different parameters are given here. Most patients fulfill these criteria within 24 to 48 hours of the 72-hour fast, and Whipple's tried inappropriately elevated elevated plasma insulin, C-peptide and proinsulin levels, and no detectable oral hypoglycemic agent levels during fasting hypoglycemia, and no circulating antibodies to insulin are all indicative of insulinoma. Amongst all the investigations I just told you, and the differential diagnosis commonest is NIPHS. I'll just go through that in a minute, and mesidioblastoma. Well, surgical resection is a very well accepted mode of therapy for insulinomas. Now, what is NIPHS? Which is non-insulinoma pancreatogenous hypoglycemia syndrome, again characterized by spells of neuroglycopenia and less common than insulinoma, but predominantly seen in men. It differs from insulinoma by the timing of hypoglycemia occurrence. This is usually postprandial or reactive in nature, and this consists of diffuse pancreatic abnormality with islet involvement with mesidoblastosis. And because radiological investigations may not always help us, the most recommended test for NIPHS is the selective pancreatic arterial calcium injections. I'm not going to go through the details for want of time. And again, there's no recommended path for NIPHS treatment. Partial pancreatectomy has helped, but at the same time, even it can be managed medically if the patient is in a good general condition. Again, for postprandial or the gastric bypass related hypoglycemia and other such, I'll take 15 minutes more. So, and other such hypoglycemia events, they have a mixed meal diagnostic test, which is sort of similar to the 72-hour fasting test. And this has, again, different protocols being used by different experts and groups. The differential diagnosis, again, this has been quite beautifully described in this paper by Cryer P.E. et al. And this is from the Endocrine Society Clinical Practice Guideline, where different levels of the different hormones has been given and what it really indicates. Because the differential diagnosis of hyperinsulinemic hypoglycemia and the absence of diabetes can be quite a confusing clinical picture. Again, the entire table is out here, and on the right side, you can see the diagnostic interpretation. So it's a lovely paper if you want to go through that, if you have a case like that. And very quickly, I want to tell you that even last year, they presented this poster where they described a sitagliptin-induced refractory hypoglycemia in a patient of diabetic kidney disease. The patient was dialyzed, and they did not realize, the internist did not realize that the patient was on sitagliptin full dose, and the patient had prolonged and profound hypoglycemia, making it a case of refractory hypoglycemia. And they eventually treated it with IV dextrose and other supportive treatment. The patient recovered, and that's why they presented this, that all hospital internists should know what all can cause this kind of hypoglycemia. Again, neonatal refractory hypoglycemia is also a common entity, although not as common as the adult one. And several causes are given here, which we have gone through earlier as well. Diagnostic approaches are available all over, especially from the Mayo Clinic or the Endocrine Society practice guideline. And again, it's the same thing that I've described, that we start with confirmation of the Whipple's triad, go through the 72-hour fasting test, look at all the levels of the hormones, and then decide one by one what it narrows down to. Management, well, it can be managed medically with how we manage iatrogenic hypoglycemia, and in special cases we need dextrose. Again, we are all familiar with this, so I will not go through the details of this, but I want to talk to you about, again, glucagon is also an important aspect that our patients should know, although it's a very expensive treatment at the moment. We also have nasal sprays of glucagon available, and patients should be taught, especially type 1 diabetes patients and those of refractory hypoglycemia, because they seem to be responding well to glucagon. Several papers have been published in this with this experience, and glucagon remains an important aspect of therapy. Octreotide, on the other hand, is a known management line for those suffering from sulfonylurea-induced hypoglycemia in particular. And let me tell you how it works. It's an analog of somatostatin and used for patients with refractory hypoglycemia, and a potent inhibitor. If you look at this diagram, you can see that this is the somatostatin 2 receptor, where it binds octreotide, and it inhibits this is on the pancreatic beta cell surface, and it blocks the calcium influx which is required for insulin secretion. So this is how it blocks the sulfonylurea receptor and brings about the restoration of glucose levels. Steroids cannot be used in that aspect, because steroids, even though are used widely in other forms of hypoglycemia, rescue, but they will not help us with sulfonylurea-induced hypoglycemia. Again, steroids.
Sorry to interrupt you, ma'am.
Yeah, I'm
Please
just
kindly continue.
completing. Again, low-dose steroids also can be used in these patients of refractory hypoglycemia, especially where diagnosis has been a challenge. Most of them respond well, and adrenocortical insufficiency also should be ruled out as one of the diagnostic measures. These are again two agents commonly used in cancer therapy, sirolimus and tacrolimus, but they have been tried with varying degree of success in refractory hypoglycemia as well. The most important aspect is maybe localizing the tumor and surgically resecting the same. So thank you to all of you, but in particular, this is my brainstorming team for refractory hypoglycemia. I've had a couple of difficult cases, and I've shared experiences with them all who hold special interest in this field. So again, thank you very much for this patient hearing and this wonderful opportunity.
Thank you so much, ma'am, and congratulations for a wonderful deliberation. As we all know, we are agree that 80% patients are heterogenic of hypoglycemia, but 20% who are refractory hypoglycemia, and this is a need of our, because of the hypoglycemia, patients are landing with the hypoglycemic induced hypoxic encephalopathy, and this is very cumbersome for the patient. And thank you so much, ma'am, for your excellent deliberation.
Do we have any query from the house? Yes, quinolone-induced hypo is a very common entity, and there's definitely, congratulations, Dr. Purvi, you've covered it vastly and widely. One important aspect that we all have seen during COVID is sepsis-induced hypoglycemia, and that is a very bad hypoglycemia and directly proportional to the outcome. The worse is the hypo, the bad is the outcome. So that is very important. Secondly, if we talk of non-diabetic population facing refractory hypoglycemia, then factitious hypoglycemia is very important to remember. So you always have to check a C-peptide value. Recurrent hypoglycemia, as you rightly mentioned, can be because of hepatic failure, kidney failure, or pituitary failure, most importantly. So you have to remember that very importantly that we are missing on central hypothyroid pituitary or secondary hypothyroidism or pituitary failure or even adrenal failure cases.
Thank you so much.
Thank you so much, Dr. Puri, for the wonderful talk. I also thank the chairpersons, Dr. Meenal Mohit and Dr. S.S. Daria, for coordinating this talk. Let's move to the next talk by Dr. Brajesh Kumar. The chairperson for this talk will be Dr. Rajiv Avasthi and Dr. Supratik Bhattacharya. I request the chairpersons to please come upon the stage and take their seats. I request Dr. Brajesh Kumar to please come upon the podium.
Hello. So we are very warm welcome to all the audience, both physically present here and online. And this is a very interesting session which is going to take place. Fusion medicine and engineering. And we are trying to find our own alternative use of artificial intelligence in the medical diagnosis. And I request my co-chair to introduce the speaker.
Thank you. It's my pleasure to introduce Dr. Brajesh Kumar, who is the head of the Department of General Medicine, Government Medical College, Azamgarh, and is also the Associate Professor of Medicine at KPS Postgraduate Institute of Medicine. So I am sure there are many more, but unfortunately, I think the slide says a lot less than what there should be. So again, a pleasure and honor to have you on board.
First of all, I would like to thank our ACP India chapter governor, Dr. Anuj Maheshwari sir, for giving me such a wonderful opportunity as a speaker in this scientific test, that is 6th annual hybrid meeting of the ACP India 2021. Good afternoon, everyone. My topic is medical engineering fusion, artificial intelligence in medical diagnosis and treatment. Introduction. The revolutionary invention of artificial intelligence solutions are used in the diagnosis and treatment of diseases with improving diagnosis, patient monitoring, disease risk stratification, identification of risk factors, and treatment of patients effectively, efficiently.
Dr. Brajesh, could you please move a little closer to the microphone and speak, because
efficiently and promptly at low cost. Medical engineering fusion. What is medical engineering fusion? The applications of engineering technology to the field of medicine and the goals of to improve healthcare by the infusion of medical innovations such as pacemakers, artificial hips, surgical robots, artificial organs, or to generate medical equipment or devices or diagnostic tools which having medical significance. Now, what is artificial intelligence? Artificial intelligence is artificially created intelligence by human to perform human activities, and when it incorporated with computer system to create artificial intelligence system. Artificial intelligence system has goals like reasoning, learning, planning, programming, problem solving, etc. Artificial intelligence system having a subset of artificial
intel intelligence, machine learning, deep learning, data analytics for making intelligent decisions when it added to data. Machine learning and deep learning is important as far as predictive properties uh, is concerned. For disease, deep learning is a new concept with advances of artificial intelligence, next generation level. Now, machine learning is a modern data analysis and a unique ability to learn and improve performance with human instruction. On the other way, machine that respond to stimulations consistent with traditional response for a human, given a human capacity of contemplation, judgment, and intention. Now, deep learning, what is deep learning? It is a field of science and engineering concerned with computational understanding of what is commonly called intelligent behavior and with the creation of artifacts that exhibit such behavior. Next generation machine algorithm using multiple layer and another artificial neural network, which is equivalent to brain, which is equivalent to neuron in the brain, different layer approximate theory of human brain. Now, what is the role, what is the importance or applications of artificial intelligence in medical diagnosis and treatment? There are a lot of diseases of cancer which are responsible for major concern of infirmity globally. In such type of situations, AI play important role for as far as identifying risk factor, identifying diagnosis and treatment of in such type of circumstances. So here I am taking a common or important chronic condition, chronic disease, hypertension. So role of so role of artificial intelligence in the diagnosis and treatment of hypertension. One of the most essential application of artificial intelligence in healthcare system is the identification and diagnosis of diseases. Machine learning algorithms that are being used to identify or diagnose or predict hypertension. Identification and diagnosis of hypertension in early stage is being required to prevent cardiovascular, cerebrovascular, and renovascular outcomes. In the field of medical image analysis, many variables such as many disease lesions are difficult to diagnose, but after AI applications, it becomes easier to diagnose and find variables. Smart EHR, that is electronic health record, when it incorporated with AI-based applications, are important tasks for diagnosis and treatment of hypertension. Electronic health record with artificial intelligence used to help in making diagnosis and clinical decisions. Artificial intelligence and blood pressure measurement. As we know that elevated blood pressure is early and important risk factor for development of cardiovascular, cerebrovascular, and renal results, and the use of artificial intelligence with reduced disease outcome. Machine learning algorithms used in blood pressure measurement are photoplethysmography, balastocardiography, electrobioimpedance, and STM superior vector machine by using pulse wave velocity, pulse transit time, pulse wave analysis method. Now, artificial intelligence hypertension detection. Machine learning algorithms such as support vector method and artificial neural network have been used to predict hypertension. Predicting model using machine learning and electronic health record data effectively predict those as risk for hypertension, along with improving care quality and reduce healthcare costs. Now, how to predict risk for hypertension? So this is the model, predictive analysis model using machine learning and electronic health record on hypertension risk reduction. So these are the factors from 1 to 5. Age is an important factor as far as risk developing in patients of hypertension. Comorbid condition also, clinical utilization cost, economic status of the patient, that is low to middle income group patients is more prone to develop as compared to high income group. Communal areas, people live in common sharing area are prone to develop risk for hypertension. Proximity to fast food and bakery chains are also linked. The study details this were taken from many hospital US. It includes still at 81,544 patients of low risk category, out of which 1.19% develop hypertension in first year. And second category, that is high risk category, in which 41,329 patients were taken, and 50% develop hypertension in 1 year. So as compared to low risk, so in this category is more chance to develop hypertension, and 65 patients have established hypertension, while 98.44% with very high risk had a chronic disease. Now, machine learning on cardiorespiratory system data for hypertension prediction. HIT project comprising 6 algorithms of machine learning. 6 algorithms like SP, LV, LVW, RTF, random forest, superior vector machine, and artificial network. So these are the 6 algorithms of machine learning. In this fitness data, including 23,095 patients from which they were taken from 1991 to 2001 with 10-year follow-up. Data include 41 attributes. 13 were selected, while 55% male and 45% female. 50% had a history of coronary artery disease during 10-year follow-up, and 30% has hypertension. So we conclude that age is the most important factor as far as reduction and risk for hypertension is concerned, followed by resting systolic cholesterol, blood pressure, and history of hypertension and coronary artery. Now come to challenges. What are the challenges during the management of hypertension? Pathophysiology of hypertension is heterogeneous. Model fails to capture heterogeneity of the patient, especially poorly controlled hypertension. No integration of genetics, environmental factors in clinical trial, and methodology to deal with medication is non-adherent and ineffective. All guidelines recommend salt restriction. Best dietary approach to stop hypertension is smoking cessation and reduction in alcohol consumption, but none incorporate personalized treatment and behavior modification factors. Important one. Factors which are responsible for poorly controlled blood pressure are genetic predisposition, epigenetic, salt sensitivity, sleep apnea, psychological stress, microbial community, and environmental factors are not well defined. Single trial guided by AI seems promising. Lack of update of practices, absence of proper data sets, and model fails are some of the drawbacks. And limited work on artificial intelligence at the current stage in the context of hypertension. Because of limitation of quality of data, computational work, presence of control and uncontrolled factors. Now come to improving hypertension treatment. How to improve hypertension in patients suffering from increased blood pressure? If it requires important points like digital transformation, data science transformation, biotech, biomedical transformation, healthcare delivery transformation, and population science transformation. So Digital transformation is an important one as far as treatment is concerned. Apps and internet-based tools. So home blood pressure monitoring, app-based lifestyle and non-invasive BP monitoring, such as smart watches and bands. Data science transformation and artificial intelligence, like precision medicine, data revolution, also important. Biotech in this novel RNA, DNA, cell-based therapy. So these are all important as far as data is concerned, data collection application is concerned. In our day-to-day practice, we are far from harnessing the innovative tool artificial intelligence. Although the evidence of artificial intelligence being useful for diagnosis, predicting risk factor for hypertension, and its treatment. Machine learning rapidly assists multiple texts, social media, vital signs, ECG, echo, data capturing by wearable techniques, and deep learning has emerged in image recognition, research, as well as speech research recognition. Capturing data from hypertension, which is likely to be improved with wearables or implantable for machine learning deep learning purposes. Personal data from patients can be added to big data, which can optimize hypertension treatment in individuals. Now, the artificial intelligence as far as future perspectives is concerned, to achieve artificial intelligence research in medicine, multiple sources of data are required. Omics, there are many types of omics, a combination of genomics, metabolomics, metagenomics, whole genome sequencing, and genome-wide association study. Input from social media, wearable technologies are required for machine learning algorithms. In future, increased use of devices, mobile apps can provide data which can help research and development, treatment, and also reducing over the healthcare costs. Now, conclusion. Hypertension is extremely challenging public health problem globally. Challenging because of increasing population, increasing age, increasing obesity, increasing weight, and also because of diagnostic concern, because there is no alarming sign and symptom still now in especially initial stage of hypertensive patient. And once patient diagnosed as a hypertension, it's remain treated lifelong. So there is a follow-up issue. Besides this, the mechanism of or pathophysiology of hypertension is still now is not clear. Essential for genetics of systemic hypertension is not clear. So these are the challenges during the management of hypertension. Artificial intelligence has a tremendous scope in the diagnosis and treatment of hypertension. With the use of artificial intelligence, we can easily, early predict or diagnose or identify risk factor regarding hypertension, early diagnosis of the hypertension, disease risk stratifications. So these are as compared to normal traditional diagnosis criteria. So with the help of artificial intelligence, we can easily accurate, appropriate, timely, we can diagnose hypertension and treatment of patients effectively, efficiently, promptly with low cost or cost effective. So artificial has a tremendous scope in the diagnosis and treatment of hypertension, and artificial intelligence definitely will be an important tool in future perspective, because the we all know that still now there is no blockbuster drug for the hypertension treatment. And there are a lot of disparity as far as treatment guideline or protocol concerned from international or different societies worldwide. Beside this, there is uh, despite this, so in such type of scenario, artificial intelligence play important role. We, on the other way, we can say at such type of circumstances, we have much needed artificial intelligence as far as treatment diagnosis of hypertension or other chronic diseases or cancers or different types of diseases is concerned, because there is lot of pressure on healthcare industry or healthcare professionals or paramedics as working with the use of artificial intelligence. Such type of problem easily resolved with continuous availability, that is 24/7 hours, and there is no discomfort or fatigue problem with the use of artificial intelligence. That's all.
Thank you, Dr. Rajesh, for introducing us to artificial intelligence use in the management of hypertension. So because of the paucity of time, we will move on to the next session. Thank you very much.
So for our next session, we have as our chairpersons, Dr. Srinivas Murthy, sir, and Dr. Vipul Chawla, sir. Kindly come on.
So good afternoon, and it's our privilege, honor to introduce our Kamalakar Tripathi sir, who's spent hours together in the airport just to deliver this lecture. We are honored to have you, sir, and we appreciate your patience in the airport to deliver this lecture. I request Vipul to introduce Tripathi.
Thank you. You can cut short this introduction. You heard this artificial intelligence before. And thanks to Dr. Srinivas Murthy, Dr. Maheshwari, Dr. Panda for accommodating me. Can you take this? Thank you. We'll be talking on salvaging the kidney. How do I do it? And right, sure. You will do it? During COVID season, इसको include मत करिएगा time में हमारे. During COVID season, many people lost their smell. So badly, somebody was looking, भाई हमारी नाक कहाँ चली गई? किसने कहा भाई साहब वो आपके आँख के नीचे है. So यह प्रतिष्ठा की अनोखी धाक है. यह नहीं तो जिंदगी फुटपाक है. कोई पीछे से न इसको काट ले, इसलिए आंखों के नीचे नाक. That's the rationality what we have learned with IIT's people teaching us about the COVID. IIT Kanpur, IIT Kharagpur, as if we have become only licensed medical prescription writer. And that's why we have lost many opportunity to innovate in medicine, and things are going beyond clinician, going to the diagnostic houses. So we'll be talking on how to salvage the kidney, and we could start at the primary prevention where we would, and Dr. Makkad would remember that Yusuf Salim, about 25 years back, gave the concept of putting 4 pills in one capsule. The RAS inhibitor, the statin, antihypertensive together with aspirin, hoping that even the individual at a very high risk would take this and would get prevention from the hypertension, thereby the CKD. Then we could look at some of the conditions like those which are the aflatoxins, the aminoglycoside, the interstitial nephritis, which we can prevent the CKD. Then we could look at the secondary prevention, and we all have learned now diabetes, hypertension are the two diseases which we require to understand, and from there we move onward. Then looking at the proteinuria, looking at the dysglycemia, and then looking at the tertiary prevention. I'll take this slide, Dr. Mani, whom we respect more than any professor of medicine. He never had been to any academic institution, but he is now 90 plus, very renowned, revered nephrologist to all of us. And he published this article 25 years back, wrote in Kidney International, which is a very high impact journal like New England Journal of Medicine, or for that purpose, Lancet having such a high impact value. And look at the blue yellow line with the simple treatment of Adolphin acid drugs, reserpine. We all wrote dozens of prescriptions. Dr. Makar must have written during his residency. We wrote a lot during our time. And Downhill, glibenclamide, very potent anti-glycemic drug. You take this morning, 500 sugar will be half by the next, within 2 days. He could reduce the incidence of chronic kidney disease significantly by 6 per thousand in population, not hospital basis, not tertiary care referrals. And you can understand the importance. And therefore, the one of the important, and this came to only 6 pence per individual at the total expenditure. 25 years back, that time gliptin was not there. Gliflozins were not there. We do not have the costly GLP-RA at that time present. And still the incidence of chronic kidney disease would be reduced. HbA1c was brought down 70%. Look at here, this particular incidence. 70% people could get HbA1c less than 7%. So therefore, to prevent then salvage kidney, we have to look at the glomerulonephritis, the primary condition, looking at the prevention, which is possible, looking at the immune-mediated diseases, immune complex disease, stop infection, take care of the simple physical presence like headache, blood pressure, facial, periorbital edema, letharginess, low-grade fever, weight. Therefore, one can halt at the level of acute glomerulonephritis, acute kidney injury, all prevention. Can also look at the preventing the progression from acute to chronic glomerulonephritis. Serum creatinine may not be true estimate. Look at the young boy, serum creatinine could be 1.2. A middle-aged man, 48, 50, 60, it could be again 1.2. And 80-year-old lady, 1.2. But look at the EGFR, it could be anything from 98 to 49, almost stage 3. And therefore, EGFR remains the prime and most important parameter at this stage 1, looking at the action plan, do diagnosis, treatment, following the progression. Stage 2, estimating the progression. Stage 3, evaluating the treating the complication, and then looking at the renal replacement therapy at the last stage 5. 1 in 3 approximately adults with the diabetes and 1 in 5 adults with high blood pressure may have chronic kidney disease, and therefore you have to estimate the both EGFR, the proteinuria, and drugs have to be appropriately chosen for them. The proteinuria would be reduced on you. I'm starting from very simple. I'm starting from the diet first now. And if you reduce the dietetic intake of the protein from 1.02 gram per kg per day to 0.89, one can reduce the CKD incidence 90% on ACE inhibitor, no difference on albuminuria, and independent risk factor. So there could be significant reduction of CKD in the terms of 4 to 5 year follow-up. When we reduce the protein intake from 0.84 to 0.4, I'll come in a moment exactly what it is. Then you reduce the reduction of EGFR from 5 ml to 1 ml. If it is 1 ml drop per year, and you strictly adhere to the reduction in the protein diet, that is 0.4 gram per kg body weight, then you attain the 90 percentile advantage of 5 ml. This is the protection what you get at the end of the 1 year. If EGFR is more than 60, you remain on the normal diet, protein diet.
If it is less than 60, then the start protein restriction right from there. If it is less than 30, low protein diet. The moment patient goes to hemodialysis and transplant program, you can liberalize protein intake. Look at the yellow at the bottom, it is 0.4 gram per body weight. So the normal RDN difference between the patient on the prevention, you can start 0.8 gram and you can reduce up to 0.6 gram. Salt can be 2.3 to 1.3. Potassium 3.5 to 2. Phosphorus should be, and it's the fish. Fish contain very high phosphorus. It's with the sea fishes, and you have to be very, very cautious of it. And then look at the fat and the cholesterol. I'll show you some of the evidences for this statin. Therefore, to combine the two, the keto analog diet, reduction in the protein, reduction in the salt intake, high potassium, less phosphorus, would improve on the bone mineralization, improve on the insulin resistance of the skeletal muscle tissue, take care of the sarcopenia, one of the very important factor in the type 2 diabetes, making insulin resistance very strong. So sarcopenia will be reduced, as well as the catabolism. Erythropoietin sensitivity improve, insulin sensitivity to improve at the adipose site, and also CKD progression will be reduced. This is the keto analog diet on chronic kidney disease, which is the meta-analysis 2019 publication. Look at the bottom. When you change the diet pattern and at keto analog, then eGFR improves tremendously. And the patient with on the CKD, MBD in patient with eGFR as 18 ml per minute can improve from. This is the statin. And the pleiotropic effect I was talking about before would decrease the monocyte macrophage infiltration, very important histological changes into the renal parenchyma, decrease mesangial proliferation responsible for the sclerosis, decrease accumulation of extracellular matrix, and also take care of the eNOS. And therefore, these effects could lead to improvement in the progression of kidney disease. Which is statin? Jupiter study have taught us at 1 year, eGFR had declined 0.5 to 7. So the difference of 0.5 ml per year per minute, those patients who took rosuvastatin, then the placebo. For a stat, with 0.34 to 0.41 ml, so close to 0.7 ml per minute per year. And the pravastatin we do not use very much, but it has a tremendous potential, 8% improvement. Atorvastatin stands better than the placebo, and this is the slide where atorvastatin 80 milligram have an advantage in reducing, in decreasing the progression of the eGFR, and eGFR would improve. This is the slide over the 1994 to 2015, the MDRD trial, which was primarily diet-based study in the patient who has eGFR between significant reduction, 13 to 65 ml. Look at the GFR value, and a still reduction of the blood pressure, systolic blood pressure from 107 to 92 milligram, could protect the kidney. Renin, which was primarily the ramipril-based study, did not have any change on the progression. So this study shows that angiotensin converting enzyme inhibitor would retard proteinuria, but would not retard the progression of chronic kidney disease. A SPRINT, which was a primarily blood pressure trial, have showed reduction between 140 to 120. Even the patient with eGFR of 20 ml, if you control strictly blood pressure, they would decrease the incidence of the chronic CVD and death from the renal failure. Asked which amlodipine was used as antihypertensive, when you significantly decrease the blood pressure, even patient with eGFR between 20 to 65 ml per minute, you could improve upon the total progression and deterioration of the renal function, and occurred, did not improve on the total cardiovascular, but improve on the. If you look at the simple control of blood pressure, even amlodipine, any antihypertensive for that purpose, if it is controlled, that would prevent the decrease of the eGFR, and this could start from 11.5 on the my right side up to the bottom at 1.3. All patient would decrease, but when the patient is controlled with the blood pressure, then there is less deterioration of the renal function. You might need 2, 3, 4, 5 drug. Nephrologists use some 5, 6 drugs. Central blocker, alpha blocker, beta blocker. Don't criticize the prescription. Otherwise, even systolic blood pressure doesn't touch down because there's severe glomerular sclerosis. Total architecture is lost. So all autoregulation fail. And therefore, what we have to decide is how many drugs can control the blood pressure. Blood pressure has to be brought down anyway up to 128 to 138. Look at the all alhat, amlodipine, IDNT, irbesartan, renal, revaprin, eucalyptus, APCT, we all understand. And ASK is the last one with amlodipine. So the recommendation comes from the KDIGO that patient who have got without proteinuria, you could be little liberal in controlling blood pressure up to 140/90, but with proteinuria, you have to be 130/80. That's the message, final message. No story would be complete without gliflozin because gliflozin has such a pleiotropic effect. Net effect, it improves on the renal plasma flow, filtration fraction becomes better, single nephron GFR becomes better, intraglomerular pressure is resumed back, postglomerular arterial resistance becomes better, preglomerular arterial resistance also improves, prostaglandin release, plasma nitric oxide decreases, angiotensin 2 improves, and aldosterone improves. So there are so many pleiotropic action of gliflozin. But gliflozin is not the answer for everything. That's not the last drug. And I have a slide, I don't show it, but I have a slide where the gliflozin have showed the potential to decrease HbA1c within the 5 years, ever since the first gliflozin came, is now coming slowly down. It's getting the same result what we had with sulfonylurea. They're different stories. But why it is so? Because SGLT inhibitors have not yet been established role on endothelial dysfunction, mitochondrial injury, tubular hypertrophy, and growth factor in autophagy. They have not responded. This is all credence DAPA-CKD trial, which have all shown, and they have worked, even prescribed even those patients whose eGFR was less than 30 ml, 30 to 60 ml. DAPA-CKD between the 25 to 75, so huge range of variation. And EMPA kidney, we are still waiting 2022 result might be out. But all studies have said at this particular level, when eGFR is so low, glucose lowering property has nothing to do with it. It is all other property which are helping the kidney. And what are those? With GLPRA, it is the inflammatory cytokine NF-κB, which goes down. Sodium hydrogen on exchanger NH3 and ANP improves. The renal fibrosis decreases, the podocyte loss improves, mesangial dysfunction improves, endothelial dysfunction improves, and oxidative stress improves. This is the molecular area which somebody was referring before, the mitochondrial cytopathy and mitochondrial distress. ER stress improves, apoptosis becomes better, slit diagram between the two podocytes becomes better, the fibrosis becomes less, the migration, this is called mesangial transformation between the tight junction becomes better. There's improved autophagy with mTOR-based action and fibrocin proliferation. So the combination of GLPRA and gliflozin becomes a better answer for prevention of it. This already have been talked. Empiric Canvas leader all have shown values something like 0.39% to 27% to 22% and ultimately 56% improvement. So the semaglutide sustained 6 and leader, when you add it with any one of the gliflozin, they had a better chances of improving the renal function. This is the randomized trial, again based on the maintenance on the newer immunosuppressive drugs. So the primary glomerular, I was talking, the combination of the calcineurin inhibitors, cyclophosphamide, as well as the azathioprine, they all together with referring at the primary glomerular disease to decrease the incidence. This is the phospholipid A2R antibody now being used in the nephrotic syndrome membranous nephropathy. Last 2 slides. This is the abatacept in glomerular disease, which is a new era of intelligent immunosuppression, and this is the one which we are looking for. So this is the summary of the presentation. ultimately, what important issue is, doesn't matter what medicine you use, but if you can control meticulous blood pressure by using any simpler drug, you can control blood sugar, bring HbA1c below 7, take care of the primary glomerular disease. For the secondary glomerular disease, we now understand the specific immunosuppressive therapy and the combination of GLP-RA with SGLT2 inhibitors would be a long way to solve it. Thank you.
Thank you so much, sir, for enlightening us with your expert knowledge. Kidney is always very important organ, and we must try to salvage the progression of the kidney and salvage the kidney. If there is no question from the audience, let's move for the next talk.
Thank you.
Thank you, respected speaker, sir, and the chairpersons. We now move on to the next session, which will be chaired by Dr. Anubhav Srivastava and Dr. Surshendu Pal, sir.
Good afternoon, welcome you all. Now we are moving on to a very important session, and this is being delivered by none other than one of the luminaries of diabetes, Dr. B.M. Makka. He actually needs no introduction. We all know he is one of the highest portfolio members of API, RSSDI, and we are honored to have him here amongst us to deliver a very important session. He is the director of Dr. Makka's Diabetes and Obesity Center, New Delhi. He is the honorary secretary of RSSDI 2017-19. He was a member of AACE International Committee. And he is, of course, has a number of publications, has international work exposure as well as the UCCF San Francisco Cleveland Clinic, John Hopkins, Oxford Diabetes Centers, all the stars of diabetes in the world today. So after you, sir, for a great presentation.
Thank you, sir, for those very kind words. At the outset, I would like to thank Team ACP, especially my friends, Dr. Narsingh Verma, Dr. Anuj, Dr. Srinivas, for this great opportunity. And I'm going to speak on a little unconventional topic, which I think is very relevant in clinical practice. So I'm going to speak on, do we really need to test the fasting blood sample for working up our patients in clinical practice? I don't have any disclosure for this presentation. So let us start with this slide. This is the latest ADA guidelines on evaluation of patients for type 2 diabetes, which is one of the commonest situations that we face in clinical practice. And for the lab evaluation, it is recommended that we should perform every year a lipid profile which includes total cholesterol, LDL, HDL, and triglycerides, liver function, spot urinary albumin to creatinine ratio, creatinine, and EGFR, which is kidney function, thyroid hormones, especially in type 1 diabetes. Now we do in type 2 also, because there are almost a third of patients who have some degree of hypothyroid and maybe having an impact on dyslipidemia. Measurement of vitamin B12 is commonly required in patients who are on metformin, and especially we have vegetarian population, so there is B12 deficiency in number of patients, and serum potassium levels, because we have a lot of patients on ACE inhibitors now. So most of these tests are actually what we require in any chronic disease management, routinely seen in clinical practice. If we look at these tests, fasting actually has very low effect or low impact on most of these tests. Fasting does not influence the kidney function, liver function, thyroid function, or the routine blood count. Now, but every time you will see a patient walking into clinic, tests are, it is taken for granted that tests are to be done in the fasting state, overnight fasting. So fasting is usually required if you have to see the fasting blood glucose level from the lab value. Otherwise, it can be simply done by a glucometer at home. And the triglycerides, which is part of the lipid profile for accuracy of results. And usually for fasting blood glucose, we need fasting for 8 hours. And for lipids, it is recommended 10 to 12 hours or overnight fasting. If you look at the thyroid function, sample can be taken anytime. This is the, these are the general guidelines given at various top line centers. This is from Cleveland Clinic, you see at Mayo Clinic. They will give guidelines how to prepare patient for sampling. And they clearly mention that it can be taken any time of the day without fasting. Now, major issue is always talking of lipids. That can we do a fasting or do we need a fasting sample or can we do a non-fasting sample? And there are reasons. Lipid parameters are very important for evaluation of cardiovascular risk. And we need 4 different parameters, as I mentioned: total, LDL, HDL, and triglycerides. And usually sample has been done conventionally in the fasting state. Fasting is 10, 12 hours overnight, and reason has been 2 major reasons. One, the postprandial triglycerides can remain elevated for many hours. And second, LDL is also calculated by triglycerides using a Friedwald equation. So triglycerides are usually measured after fasting, since the concentration of particles can remain elevated in bloodstream for many hours after a meal. And normal healthy range of triglyceride is less than 150, we know that, which is after 10 to 12 hours of fasting. Getting accurate EG is also important to get an accurate level of calculated LDL. Now, non-fasting before a standard lipid level actually throws off both the values, triglyceride and LDL. We are going by this hypothesis. And if you look at the total cholesterol and HDL, they are not affected by eating. They remain stable. Now, what are the important considerations why we are looking at a non-fasting sample? So the reason has been that most of the individuals who consume, if you look at the people, the daily eating pattern, most of the individuals consume several meals during the daytime. So perpetually they are in the postprandial state over 24 hours time. And if we are doing just a fasting lipid profile, which may show lower values of triglyceride or LDL, actually may be underestimating the risk. Because during the 24 hours time, individuals are exposed to a much higher level of triglyceride and LDL throughout the day. Other thing has been that, if you look at the triglyceride levels, the concern has been because we measure triglyceride after a fat tolerance test. But if you compare the triglycerides measured after a fat tolerance test, the triglyceride levels after a routine meal do not go up so high as go up after a fat tolerance test. And actually, it does not really make much difference in that. So this was one very large study done in Canada, in Calgary. The objective was to investigate association between fasting times and lipid profiles, and this was cross-sectional examination of lab data, including fasting duration, which varied from 1 hour to 16 hours after the last meal. And this was done over 6 months period, involved more than 2 lakh patients. And mean levels of total cholesterol, HDL were measured, and they were correlated with different fasting times. And the study showed that the maximum difference that happened in LDL levels was only 10%, and maximum difference that happened in EG levels was only about 20%. And this is the result ranging from, if you see here, onto your left, this is the levels after 1 hour, and this is the levels going up to 16 hours. And if you see, there is no change in HDL, there is no change in total cholesterol. LDL largely remains more or less within 5-10% variation range. Only change happens in triglyceride levels, which decline. This is the data in men between 1 hour and 16 hours. You can see the differences, and this is in. So there is not much change happening in the levels of triglycerides and LDLs also. So fasting, the study concluded that fasting time showed little association with lipid subclass levels in community-based population in Calgary, which suggests that fasting for routine lipid levels is largely unnecessary. This is a study done in children. Again, looked at the changes in levels of subclasses of lipids between 1 hour and 16 hours of eating. This is from US. based on the National Health Survey in children, involved more than 12,000 patients, again showed not much difference happens in the levels of various lipids. This study also correlated the levels of estimated LDL levels versus the direct estimated levels with the calculated LDL levels, and showed there was a strong correlation. There was no difference even if you are using estimated LDL levels, the calculated levels across the normal range of LDL levels in these patients. And this is the data in different ranges of triglycerides and LDL, comparing the measured levels versus the calculated levels. And the change, if you see, happens largely in triglyceride levels when it goes in the higher range. In the normal range of say we take as cutoff of 150 or around 200, there is not much difference in TGs as well as LDL. Another study from Denmark, Copenhagen General Population Study, looked at the differences between various subclasses of lipids within 1 to 6 hours of eating post testing, within 1 to 6 hours of last meal, and again showed that there was no significant difference whether you are measuring after 2 hours or 1 hour or 6 hours compared to fasting. It does not make much difference. If you look at various risk estimation scores, the commonly used scores have been Framingham, ACC-AHA, ASCVD score, Reynolds score, Uris score, or the SCORE. SCORE is the systematic coronary risk estimation. All these scores only use two parameters, total and HDL cholesterol. They don't use HDL or TGs for measuring risk. So you don't really need a fasting lipid profile for estimation of risk also. And look at the various studies that have been done till now. Most of these studies have taken non-fasting samples. Most of the studies that we have done with lipids, including large studies like Interheart study, Copenhagen General Population Study, Nurses Health Study, Physician Health Study, all these had non-fasting samples. No, they didn't have the fasting samples. So based on these data, Denmark 2009 laboratories started using non-fasting sample, and only if the TG was more than 350, the patient was called back to do a fasting sample. Between 2011-15, they did 60,000 plus TG measurements, and they only needed 10% of the patients to come back to measure fasting sample. And this was to rule out, severe hypertriglyceridemia or genetic dyslipidemia or, other reasons for hypertriglyceridemia. So ACC-AHA guidelines way back in 2013 mentioned that you don't need to do a fasting sample to measure the ASCVD risk. It is recommended to do fasting sample only if you are calculating LDL before statin initiation. This is, I am talking of 2013. I will show you current also. And if the non-HDL is more than 220 or TG is more than 500, or you are suspecting genetic dyslipidemia. 2014, NICE guidelines mentioned you don't need non-fasting lipid levels. Do a non-fasting, and if you look at the bottom, even in patients who are on statin, to review statin therapy, again, you don't need a fasting sample. You do a non-fasting sample, look at non-HDL levels, and review the statin therapy. Now, what is the new use? Non-fasting lipids can be used to assess risk. Non-fasting total cholesterol, HDL, have no change in any case. LDL can now be directly measured. Most of the labs are doing direct LDL measurement. So again, it is not dependent on TG. Food intake changes the levels only by maximum 5% in LDL, which does not make much difference. And food intake can increase TG levels by 15%. So if you are doing fasting samples, there are a lot of issues. It can complicate blood testing because accurate to say 10 hours of fasting or 12 hours of fasting is very difficult to do. Then patient inconvenience is there. Patient has to specially visit the lab for a specially fasting sample. Now labs are overburdened because every patient will come in the fasting. So morning hours there is a rush in the lab to get the samples. Evening hours, all the reports are dispatched to physician. Physician has to review. You have to review all the patients in the evening only. So this causes a lot of problems. This is a guideline which was issued by European Atherosclerosis Society and European Federation of Clinical Chemistry and Laboratory Medicine way back for about 4 years back only, and clearly mentioned that fasting is not required routinely for assessing plasma lipid profile. When the PG level is more than 5 millimole or 440 milligrams per deciliter, a repeat fasting sample should be done. And labs can accordingly flag the abnormal value and refer these patients to lipid clinic. So non-fasting sample is adequate for most patients who are being subjected to initial lipid profile testing, who are being evaluated for CVD risk assessment or follow-up of statin therapy in children, in any patient who prefers to be non-fasting, diabetic patients. If you have to keep them fasting in the morning, you are increasing the risk of hypoglycemia. Elderly patients, you can't keep them fasting for long hours, or make them get into the risk of dehydration. So fasting is required only if the non-fasting PG is more than 400, 440, or you are following high triglyceride in the lipid clearance. Only thing is you have to change the cutoff. So fasting PG should be less than 150 to be labeled as normal. Non-fasting sample, it should be less than 175. So about 20% higher than the normal cutoff. And similarly, non-HDL cholesterol, which should be, fasting should be less than 145, non-fasting should be less than 150. This is the current guideline from Endocrine Society, lipid management guideline. It clearly states that in adults with endocrine disorders, we recommend a lipid profile for assessment of PG levels and LDL concentrations. Non-fasting lipid panels are acceptable for initial screening. If PG levels are elevated, or if you suspect genetic dyslipidemia, repeat a fasting panel. If you are measuring lipoprotein little a, you can take fasting or non-fasting again. So to conclude my presentation, fasting blood samples are not required in routine clinical settings for most of our patients. You need to do fasting glucose if you have a confusion about diagnosis of diabetes. You have to do glucose tolerance test, or you are defining pre-diabetes. Otherwise, you don't need a fasting sample. And second situation, if lipid profile shows PG level of more than 400, 450, you need to do a fasting sample. With this, I end my presentation. Thank you so much. I hope I finished in time.
Thank you, sir, for a very lucid presentation. I think it's very clear. Fasting is not required. And at least we should make it clearer to our pathology colleagues, because in the hospital, in the college, they are not ready to take thyroid samples. So we need to advocate this.
We have made it clear to all our labs that when we are sending patients,
You have to
don't
take.
ask this question.
Yes. Thank you, sir.
And especially fasting causes problems. Fasting samples, especially in primary care. People coming from distant villages is a big problem. So it's a very good issue that sir has talked upon. And we are closing the session in the interest of time.
Anytime. Unless you have some specific hormone, you are measuring ACTH level, you are doing some stimulation test.
Cortisol stimulation test. Yeah.
Otherwise, you don't need to do everything.
Actually, because of a long-standing habit of fasting test, lot of trouble at the end of labs, at the end of physicians, and also patients. Yeah. So that's why in primary care setting, the message should go clear. And I'm sure many are watching virtually. Message should go clear that unless you have a specific indication, that most of the tests don't require.
So in our setting, in my own setup, when patient comes for the first time and is very patient has to pay out of pocket. So in the first setting only, we do complete evaluation, including all blood samples, lab tests, and everything. And second consultation, patient is on close by, wants to come physically, it's fine. Otherwise, we can manage them on remote mode. So this is where technology should help patients and physicians both. It is good if you are using a standardized machine with standardized certifications. It is used good. You can use do a spot lipid for re-evaluation. Somebody is on statin therapy, has come for follow-up after 2 months. You want to do a spot lipid, do spot lipid. Spot A1C, spot lipid. Now we are getting equipment to do spot creatinine and eGFR also. So we can write to them actually. This is a good suggestion. Yeah.
So it has been a splendid talk. In the interest of time, I'm closing the session. Give me a big hand, please.
Thank you so much, Makkar sir and the chairpersons. Anubha ma'am, we request you to stay on stage, please, for the next session. And for the next session, we have our chairperson, Dr. Vijayan Das sir. I kindly invite him on stage.
For the next session, I would invite Dr. Digamba Naik sir for his talk on relevance of echocardiography in primary healthcare. I'd like sir to introduce.
Naik sir doesn't need any introduction actually. Is a very senior person for us, and I just we are saving the time. I'd like to request to proceed with the presentation.
Thank you so much, sir, and good afternoon, everybody. I know we are all a little bit sleepy, those who have had their lunch and those who didn't have a little bit hungry. Yeah, that's a lovely time to think of something like this. Okay, now my purpose today is very simple. I'm not going to teach you echocardiography in the next 20 minutes. I'm just going to impress upon you why this investigation is one of the most vital investigation for us in any practice at any level. I remember in 1990s, early 90s and all, when I used to give an opinion on ECG, many times I failed a person from joining his job, or I have failed, I postponed surgeries unnecessarily, which I realized the moment I purchased my ultrasound unit and started using it myself. This is how I developed my ultrasound, and then things went on. Okay? And now, recently in COVID, I've been doing an echo on every COVID patient, and I'm surprised to look at the incidence of myocarditis. Okay? If any person who does not feel good, I get myocarditis in him. And the talk of long COVID, I don't think it exists. All my patients, once I know the condition, I treat them with good level of vitamin C and something for the heart, and they just recover in 3 or 4 days' time, who have been suffering from months together. So, my friends, this is the importance of echocardiography. I know I've got very little time, so I'll cut short as fast as possible. Can I have the video on? I've just created a small. I can.
Good day, my friends. This is your Dr. Digamba Naik. Well, today I do want to say something about echo or echocardiography. As a cardiologist, I've been doing a lot of echoes, and that fascinates me because just by putting a probe on your heart, I tell the patient practically what is happening inside his body the whole day. Today morning, one young man comes to me, 32-year-old, for a routine echo, for a fitness. I do an echo and I tell him, my boy, you are hypertensive, you have a high blood pressure. He says, no doctor, I've never been a high blood pressure. I don't have it, I don't feel anything and all that sort of thing. So I checked his whole thing. He had all the signs that the blood pressure causes on the heart. Your pressure is a pressure inside the heart. So what happens? Heart is the first organ which gets damaged because of blood pressure and the arteries, and then the damage goes on. After I finished my echo, I recorded his blood pressure 3 times for him to be convinced, and it was high as expected. So friends, this is echo, wherein you use ultrasound to look at your heart, and you can look at so many things. You can look at the walls of the heart, you can look at the valves of the heart, you can look at various chambers, you can see how the blood flows through various chambers. You know if particular area of the heart is getting less blood supply, you know if there are blockages, you know if there are impending blockages coming tomorrow. You can know if your heart is failed, you can know if the heart is about to fail, or you can know what various problems which can come into the heart even tomorrow. You can actually look at that echo and predict, okay, well, you can live long, or you have a short life. So much information is available today with the types of echo studies that we do. In any condition, say you want to be made fit for anesthesia, you need an echo. You want to be made fit for your job, you need an echo. You want to be fit for sports, you need an echo. In fact, in sportsmen, echo is a must. That's one investigation which will give the sportsman his complete life. There are problems sometimes inside the heart. If they are not checked by an echo, you do find these young sportsmen scoring a goal and dropping down dead. These problems could be identified. Look at the lung. Looking at the echo of the heart, you can see the condition of the lung, because the heart and the lung are interconnected. The science of echo is so well developed today that it has become subspecialties. Like you have a transthoracic echo, you have a transesophageal echo, you have a contrast echo, you have a 3D echo, you have a 4D echo, you have a spectral tracing, and you have a strain rate as separate branches of echo. Especially cancer, when you are taking chemotherapy or radiation in cancer, what happens is these drugs do affect the heart, and your echo can tell you that they are harming your heart, and they can help you to time these drugs very well so that these drugs tomorrow will not have an effect on your heart. On a plain echo, I can know the biochemical changes inside the body. Like you have a low sodium, you have a high potassium, you have a kidney failure, you have a stroke, and so many things inside your body. Friends, with echo, you can see your heart yourself. If I show you exactly what is wrong with a particular valve or particular point inside your heart, don't you think you will be in a much better condition to understand that problem and to take care of it perfectly? Friends, echo is so easy to do. No side effect. You can keep on doing it a number of times. You can keep on repeating it with better expert. You can send the CD that you have done it to any expert in the world, and you can get a much better opinion on that if you want. So friends, what you should do before any major procedure on your heart, see that your doctor does an echo on you and gives you the condition as to where you stand. And taking use of echo, you will be able to be.
So I think I have just summarized, okay? And now let me go a little bit into detail now that I have time. Let me mark my time, okay? Because this is a huge presentation. You will start loving when you see the videos, okay? Now, all of us are managing our heart patients. All of you have to treat your heart patients. How do you treat them? Take a history, good clinical examination, do a few blood tests, do an ECG, and you know how effective or non-effective or confusing your ECG is. Echo, my friends, is the best investigation in your hands as on now, especially with the new normals that we are doing, okay? We are looking at speckle tracking as a routine thing today, and your diagnosis comes to you immediately. Your patient can be shown his own heart. Okay? Now this has been today also used as point of care ultrasound. Now, ultrasound has been a common tool for anybody and everybody who manages the patient. In your ER room, you need ultrasound. In your casualty department, you need ultrasound. In your operation theater, you need ultrasound. In your ultrasound unit room, definitely you have your ultrasound, okay? But these are all the places where it is being used today. Why do you need ultrasound? First is immediate diagnosis. Your diagnosis is in your hand. Immediate direction for a proper patient management as well as for follow-up of your patient. Intensivists use it. Your anesthetists use it. A casualty doctor, this is a big tool in his hands. In everybody who doing a peripheral practice as a general physician, you must try to have this echo machine with you. And and now there are emergency medicine specialists. You have a DM after MD in emergency medicine. Why do we need it? Okay, just basically to need the case fully. Yes, you need to take a little bit of effort to acquire the skills in imaging, and ultrasound gives you the diagnosis as well as direction in the management of the patient, especially in critical care. Focus on cardiac and thoracic, pleura and lung. You have your diagnosis today. Ultrasound is used for a lovely diagnosis on lung. We don't need an X-ray chest. Okay? Vascular, DVT, peripheral arterial disease, abdominal screening is so simple. There was a time when I was practicing, abdomen was called a magic box. And they should put cases, okay? Open, they didn't know what was diagnosis, and it was always labeled as open and close, open and proceed. Today you have an ultrasound and there's nothing called a difficult case, abdominal case today. And all procedural guidance can be done under this and for serial assessment. Now this echocardiography is now become a specialty or super specialty by itself. There are people who are only adult echocardiographer. There are people who are only pediatric echocardiographer or stress echo. You have transthoracic echo, you have transesophageal echo. You have a special branch of echo in cancer patients. Especially in US, every person, any drug used in cancer or your radiation is going to harm heart. And echo can tell you whether it is really harming the heart, and you can time your chemotherapy according to and look at the safety of the patient. Critical care sonography in your critical care room, it is a must. Interventional echo. For all interventional procedures, we put a probe directly inside the heart and monitor it. And therapeutic echo, yes, a time will come where the high intensity ultrasound will be used to open up the clots into your coronary arteries. So let's try and become a part of that. Emergency department, all critical care patients should have a sonography. Maybe abdominal, testicular, early obstetric, musculoskeletal, rupture of a tendon can be identified the best on an ultrasound. Ocular, you have a B scan for your eyes, okay? And in any time, this is what I'm talking about, a physician doing it, a simple MBBS doctor doing it. And in all cases, you can always give a call to an expert sonographer. Okay, life-threatening cases like cardiogenic shock, congestive cardiac failure, pericardial tamponade, severe reduction in systolic function, massive pulmonary embolus, pneumothorax. We knew how much trouble we used to get to make the right diagnosis. Today, it has been that simple. I've got a lot of videos. I don't think I'll go through all of them. Let me quickly leave them off. because I do have a message to be. This is an abdominal this is your chest ultrasound showing a pneumothorax. Patient in failure, patient with low systolic function, fibrillating patients, pericardial tamponades. It's so, you're looking at this pericardial effusion. You know, this tuberculosis is the cause of this effusion, okay? Look at the septa into the pericardial, okay? So simple. I will go through them because I don't think I just got 5 minutes more. Use in your cardiac arrest. We have a cardiac arrest and many times we struggle there. This is one place where we can make a good use of echo. Emergency should have an ultrasound machine, okay? And thoracic lung ultrasound today is beautifully done. We have understood. And initially we used to say the air is an enemy of ultrasound and we could not do the ultrasound in air. Now what we use is a contrast effect. We use the same effect where the ultrasound is not able to pass to make all these diagnoses today. And it's so easy. Little bit of fusion, pneumothorax, take cardiogenic shock. DVT and P. This is one diagnosis we remember initially we used to always miss. S1, Q1, Q3 and T3 was our only diagnosis. But by the time this diagnosis comes, patient is already halfway off. Okay. Now this can be, now you can make a DVT or a P in the diagnosis just at any level and end up in saving that patient pretty early. Okay. Your abdominal ultrasound, all these diagnoses are so simple to make. You don't need a radiologist to give you a diagnosis of on an ultrasound. See, making a diagnosis on an ultrasound has been pretty easy with us physicians because you make a clinical diagnosis and then just you put your ultrasound there and you are able to spot it out. Ultrasound in trauma. Ultrasound can be used for diagnosis of or helping all these procedures, whether it's thoracocentesis, paracentesis, regional anesthesia, lumbar puncture, central venous catheter, arterial puncture, your abscess drainage, arthrocentesis, airway management, ectopic pregnancy. So simple, ovarian cyst. Both can mimic similar. You can see a bleeding due to an ectopic pregnancy. Testicular sonography. Soft tissue and musculoskeletal sonography. The rupture of your rotator cuff, rupture of these tendons in sportsmen. Okay. The best way to diagnose is an ultrasound. You can diagnose even a fracture on an ultrasound today. Even when the X-ray is not showing. Today, yes, for all fracture, we send them for CT scan because that's the way we look at it. But ultrasound can be used with the same effect, the rupture of a tendon, okay? Ocular sonography, okay? Rupture, global rupture of foreign bodies, retinal detachment, lens dislocation, vitreous hemorrhage, evaluation, and intracranial pressure. Now, all ophthalmologists have started having their own ultrasound machine for doing the B scan. This is abdomen, distended colon. So it has been that simple to make it. All that initially you need is a little bit of effort, a little bit of learning to, okay? I'm just going through this. Now what has happened, okay? Now, many times people get scared to give an opinion on echo because it is a little bit difficult, okay? Now you have an echo report being done online. All that you can do is get your machine, get a technician, train him to take echo videos of the patient, send these videos across, and I will give you the complete report signed by a cardiologist. Okay, so this is easily happening so that at all peripheral levels where you are not able to get a cardiologist, you can have a very well developed echo being given to the patient. Just a minute, I'm just going through a minute. Okay, so this is distant tele-echo medicine that we have it. You get a report signed by a cardiologist. These are all the details of it. I won't, can't go through it. And on top of it now, today, we can manage a full-fledged cardiac clinic at peripheral level where the cardiologist is not available. You have a distant ECG, you can report a distant echo, a distant TMT, Holter monitor distantly, sleep study, you can do it online, full clinical history and advice, and a video conferencing with a cardiologist. You do not, at the peripheral level in our country, you do not need a cardiologist to run a complete, full-fledged distant cardiac clinic. So thank you, friends. Thank you so much. So my effort was, because I've been doing a lot of work in spreading the knowledge of echo, making people aware. Please start doing an echo on your patients, okay, where you can manage them in the most efficient way. And this is the most effective way of looking at it. This is the investigation which is cheap. Echo can be given, some hospitals are giving echo for even 500 rupees. And all that tests, some of them are charging up to 2,000. So with that little money, you can get much more investigation, and that too quickly. And this can be serially followed. Okay, thank you so much.
Thank you, sir, for your insightful and beautiful presentation. I think we are running behind the schedule, so we'll close up this session.
Thank you. Thank you so much. Yeah.
If for the next person, I would like to request Vijay Patni sir and Dr. Ashish Saxena sir to kindly join us as chairpersons.
Okay, the session would be on postprandial glucose and the role of premix insulin. Already Dr. Makar has emphasized this particular factor of postprandial status or state in most of the patients rather. So it becomes very important. We need to look at the premix insulin as a modality on managing the postprandial control. And we have none other than Dr. Srinivas Murthy, the organizing secretary for this meet. No need of an introduction. As rightly said yesterday, a personality in himself. So it's all yours. Thank you.
Thank you, sir. Thanks for your kind words. We've intentionally kept this after the lunch hour, so postprandial. So the relevance of PPG and role of premix insulin is going to be the title of the topic, and this is going to be the flow of contents. And I'll be little rushing to cover up the time. The unique characteristics of Indian phenotypes, again, risk associated with the uncontrolled PPG, insulin in the context of our country, and a last case-based discussion. So we know this START study back in 2014 has clearly shown across India, the carbohydrate consumption is more than 60%. That's the first take-home message in this slide. There's a clear non-adherence to dietary advice by the diabetic patients. This is another biggest problem we encounter in our practice. So the key realities in our country is we have high carbs, high PPG levels, and uncontrolled patients, most of them who visit us with multiple OADs, and we need a simple and convenient treatment. So can OD basal insulin can take about all this is a big question. So we need a specific therapeutics for Indian diabetics, wherein the diet modifications most of the times will not work in spite of a repeated advice on the diet and exercise. And most of us don't emphasize or spend enough time to counsel our patients on the diet and exercise, which can bring down A1C up to tune of 2%. And no drug except insulin and GLP-1s can bring down 2%, but we don't spend enough time to emphasize on the diet and exercise. So ultimately, all of us switch over to the drugs, multiple OADs and insulins eventually. And this just to show you that the 7-point blood glucose profile in different populations and Indians, as seen in the mark, they show higher blood glucose after each meal compared to other regions, which compared with the West Asia, Africans, Canadians, etc. And this is again showing our own study, the relative contribution of PPG to A1C, Indians versus Caucasians. Again, we see the A1C increases with the PPG contribution in Indian context. So what are the risks with uncontrolled PPG? There are enough studies to show that the PPG and the 2-hour postprandial hyperglycemia are associated with the CVD mortality risk than FPS in Asian quads. And that's very, very important. Most of these studies, the famous study is the DECODA study. And of course, Chinese studies are enough to prove that the postprandial hyperglycemia is directly associated with the CVD mortality versus the fasting sugar in the Asian quad. That's something to be very, very important to understand. And this is, again, the postprandial hyperglycemia, the independent risk factors for microvascular, macrovascular complications. Again, the DECODA and Honolulu studies are the famous ones. Just for want of time, we'll not get into these. So these hyperglycemic spikes following every meal, and most of us spend 70% in this hyperglycemic time, and they are associated with the hypercoagulability, plaque stability is reduced, fibrinolysis. You can see the N number of complications with just hyperglycemia. And of course, the carotid intima media thickness, which is one of the surrogate markers, is very clearly shown direct correlation with the postprandial hyperglycemia. And look at this study, which again clearly shows the PPG is an independent marker of mortality when you compare with the fasting glucose. And more patients achieve the target of A1C when you adhere to the PPG targets than the FBS target. This is again evidence. You can see 94% versus 64%. When they adhere to the PPG target, they can well achieve the A1C. So the control of fasting sugars is necessary, but usually it is insufficient to achieve the goal of A1C, and the PPG control essential for achieving the recommended HbA1c goal in Indian context. So insulin in Indian context, of course, these are the barriers which all of us face, and most of the patients disappear when you say you need to go on to insulins, and you need to start priming them from day one when you start them as a simple metformin or a baseline drug, or even in a pre-diabetic stage, that eventually in your lifetime, you are going to be an insulin. And when you start repeatedly priming your patients during each OPD visit, it's very easy to initiate insulins for them eventually. And which most of us don't do. We use it as a threat that, okay, 3 OHS, next time you come back, your A1C is 8.5, I'm going to start an insulin. So please do not use it as a threat. And the knowledge and education, what you have regarding insulins, you need to impart and transfer that to our patients in every visit so that it's very easy to initiate. So intensive treatment with OADs over a certain period of time is clearly shown, but eventually the glucose levels continue to steadily rise as the diabetes is a progressive disease. And in India, insulin therapy is initiated only when the A1C levels have deteriorated around 9%. Look at that. The normal target, what we say above 8.5%, above that individual target A1C, you need to initiate an insulin. But we do it around 9% in Indian context. And this insulin initiation inertia from the physicians, according to me, is more than with the patients. Because you don't educate the patients properly, obviously they have all kinds of phobias towards the insulin pricks. So this delay will eventually put our patients into all these complications. So timely initiation of insulin becomes a very, very important task in our routine clinical practice. Just to show you, 1 in 5 Indian patients in diabetes achieve A1C less than 7% with insulin therapy, which is supposed to be the gold standard eventually. 2 out of 5 patients with diabetes reduce their insulin dosage after a minor episode of hypoglycemia. Very important point. We don't again educate about hypoglycemia when we initiate insulins. We blindly initiate and send them, and no enough education again pushes them into hypoglycemia. And even 1 episode of minor hypoglycemia will make 2 out of 5 patients to withdraw from insulin. And look at the last number, 77% of the patients who experience hypoglycemia in 6 months, when you, whatever. 77% of the patients who experience hypoglycemia in 6 months of their insulin initiation will discontinue within 1 year. And the onus is on you. So we need to be very, very cautious when we initiate and educate our patients. So look at the discontinuation rates impact. Hypoglycemia and fear of hypoglycemia will be the highest ones, which makes patients to discontinue. And this is again another study called IMPROVE. The Indian data at the time of insulin initiation, which I was alluding earlier, it takes 9% of A1C of our patients to initiate insulins in our practice. So the key realities, can a basal insulin can be suitable for all these high carb diet, and does it take care of PPG, be suitable in case of delayed insulin therapy, and offer convenience at insulin initiation with a direct total control of both FBS and PPG. Can a basal insulin do this? But this is what the recommendation says. You can say ADA, AS, IDF, etc. We'll talk about basal insulin to initiate. And then NICE guidelines talk about the premix insulin apart from basal insulin. Of course, RSSDA again talks about premix insulin also as one of the initiation choices for initiation of insulin. So I'll end with a small case, role of premix insulin in uncontrolled OADs. You can see typically 12-year-old diabetic duration, BMI of 26. Parameters are okay, except the A1C is 9.3. FBS, PPBS, you can see 146, 255 respectively, and he's got a diabetic dyslipidemia. LFTs are okay. Blood glucose is not controlled. Look at the medications: glimepiride, sita, metformin, atorvastatin, losar. And the more number of days, in fact, there is a study which shows after 3 drugs, the adherence drops to 70%. After third drug, if you add a 4th drug, adherence, forget the efficacy, because no drug will bring down A1C of 2% or 1%, OHS, when we say. So please do not up titrate to the maximum and try to waste time to initiate insulin. So when do you choose this premix insulin versus the basal, what most of the bodies recommend? So the glycemic factors is if the PPBS increment is above 54, if the FPAG and HbA1c ratio is below 20, and if the difference between bedtime and morning blood glucose value is more than 55. Very simple things in your routine practice. Even in the busy practice, you just have to calculate this and then take a call to initiate a premix. Of course, psychosocial factors, patient has got limited literacy, and simple and easy to understand regimen is needed for initiation, because you need to up titrate, because no basal insulin with 10 units, most of our patients will not be under control. So if you choose a premix insulin where easy titration, makes start at the once and then probably you can up titrate it to twice a day. And adults at early or progress stage of disease and elderly patients in need of simple therapy. And of course, Indian realities, limited resources, simple and easy to explain insulin therapy is needed for both initiation and intensification, because we're not going to end. Again, we have an inertia in up titration of the dosage. You start with 10 or 14 units, and that guy keeps on taking it for years together, only 14 units, because it was prescribed by his physician 10 years back, 5 years back. This is what the story we again hesitate. We have inertia to intensify that. And of course, being India, as I showed you one of the slides, the START study, which says 64% of the patients have hyperglycemia, I mean carbs in their diet. So premix insulins definitely will provide control of both FBS and PPBS and convenient for initiation, up titration, and intensification as well. Just to show you some evidence versus glargine, you can see better reduction of A1C and of course attaining target. The overall hypoglycemia, nocturnal hypoglycemia, again, something which we always ponder upon. So the overall hypoglycemia was also low in both groups. Nocturnal hypoglycemia was also similar in both the groups. Premix versus glargine, what we are talking about. And of course, this patient was started with 10 units before breakfast. Try to find out which is the heavy meal and try to initiate those just before that. And after 4 weeks, and another good point, what we mentioned here, glimepiride, just try to withdraw, but up titrate metformin to 1000 mg BD, most of the patients will tolerate well, and that will also negate the so-called weight gain because of insulin. So to summarize, significant contribution from PPG, even at a higher A1C in Indian population as compared to Caucasians is seen. Premix insulins are simple to start, single injection with effective A1C control covering both FBS and PPBS. Patients uncontrolled on 2 or more OADs with flexible lifestyle can be started on premix insulins, and those can be titrated on a weekly basis. Again, we need to educate our patients to self-titrate. SMBG is one of the easiest ones to do and the very important in our routine clinical practice. Premix insulins provide convenience, simplicity for both initiation, intensification, and premix insulins provide both convenience and efficaciousness, as we saw, and it has got almost equal hypoglycemic episodes versus GLARG. Thank you very much for patient care.
Thank you. There's one point which I'll say as a take-home message. What you said, that adherence drops after we add the 3 drugs, that most of the physicians and clinicians and diabetologists forget. Now, another thing which I'll just like to ask you, what is your say on basal insulin with short acting, which is now coming up into the market?
Yes, sir. That's a very good one. We have enough choices, but cost constraint is something where we have to think about in those molecules. But that's one of the best ones to initiate. The premix, which has got a short acting and analog. That's a wonderful combination in our routine clinical practice. Again, of course, cost is another point, but
now I think so that they're reducing the cost and things will be more amicable because it's coming into the pen fills. So
yes,
maybe
comparatively it is ready. Agree. But still, when you compare to your human, these are all
because
definitely
looking to the carbohydrate diet, what our population is taking, looking to the pear shape obesity.
Because
this-
basal insulin, what I've seen people after 40 units, they split and put it in a BD dosage. Still the sugars and the A1C is not under control. Doesn't make sense at all. Once somebody crosses about average 30 units, I don't think it's worthwhile containing basal. But yes, it is a good thing. I'm not saying we should never use basal, but Indian context, the premix to counter the PPG excursion will be the ideal.
So the take home will be the basal should not go beyond 30. If it is, then we have to switch. And the best thing is that inertia, which has to be gone, and the adherence has to be taken
And try to initiate the premix
at
from
an
day
early
one.
stage. Yeah. Thank you. Thank you very much. Any
Thank you,
other
sir.
questions? Thank you for this presentation. I think so. We'll go ahead with the others.
Dr. LSM.
Thank you so much, sir. Thank you so much for our respected chairpersons to agree to chair this session. And for the next session, we have as our chairpersons, Dr. Prahlad Chawla, sir, and Dr. Chandrasekhar, sir. I request you to kindly come on stage, please.
Good afternoon. Lunch is going on, and that is why only few people, but probably online there will be more and more people will be attached with us. So Dr. Narsingh Verma is very much familiar to this audience as well as all the associations, and he is a professor in KGMU, and he is associated with all the associations and remains a president for whether it is UPDA, RSSDI in Uttar Pradesh, and president of Association of Physicians of India, definitely. So, and recently he has conducted president Asia Pacific Society of Hypertension in Delhi. So I request Dr. Narsingh Verma to start his deliberation on home blood pressure monitoring.
Thank you, respected chairperson. I will be talking about the home monitoring, and my topic is that whether it is really a new normal in these days. And before that, two, three slides regarding the hypertension. And I would like to emphasize that hypertension is more common. In my country, around 39% prevalence rate of hypertension. But it is not so attended by the physicians. And still, we have a lot of hypertensive who are not receiving any treatment. And we have to make more emphasis on the diagnosis of hypertension That is why I have chosen this topic. And you know that all vascular diseases, which we say because of the hypertension, ranging from heart failure to peripheral vascular disease, large number of diseases are attributed to hypertension. If we talk about heart failure, burden in India is very high, but 50% of the hypertensive develop heart failure. So such is the importance. Still, hypertension is not gaining that much importance because of certain reasons, and challenges to hypertension management are many. If we talk about public perception, this particular slide, which I'm taken from the Canadian Journal of Cardiology, this says that 80% of the people were unaware of the association between hypertension and cardiovascular disease. They think that hypertension is not very common and not very dangerous, and it is just a disease, and we can take a pill and everything will become normal. And 63% believed that hypertension was not a serious condition, and 38% of people thought they could control high blood pressure without the help of any health professional, and they don't think that it requires a continuous monitoring. When the monitoring comes in our mind, this statement of the Norman Kaplan is very, very important. The measurement of blood pressure is the clinical procedure of greatest importance. But that clinical procedure, which is of greatest importance, is being performed in a very, very sloppy manner. And hardly anybody thinks on that. One famous study, I don't remember the quote, was done by the Mehdi Hassan. He was an anatomist, and he did that study in which he found that, I'm talking about 20 years back when the only mercury manometer was there. He found that around 43% MD doctors and 39% MBBS doctors and 32% nurses were not able to measure blood pressure correctly. And it was delighting to see that the nurses were more accurate than the MD doctors because they were not having that importance to the measurement of blood pressure. So we have the cardiologist, nephrologist, and plenty of specialists who can talk that which drug to be given and what combination to be given and what combination not to be given. But about the measurement, nobody talks. So recording can be done direct methods, which are only for experimental purpose. They are not required and they are not used in the clinical setting. Indirect one is used, and we know that indirect methods have the sphygmomanometry, and we know classically we are taught palpatory one, auscultatory one, but most important, the oscillatory one, which is not being regularly taught in most of the medical schools. And the manual versus automated instrument is another issue. And most of the time, perceived thing is that manuals are more correct, but it is opposite. The automated one are having more accuracy. When we talk about this recording, there can be office recording, home recording, or the ambulatory blood pressure monitoring. Types of reading. When we take blood pressure or measure blood pressure, there can be a casual blood pressure measurement in which a measurement taken without the required 5-minute rest period, then it is called casual, and this casual blood pressure measurement cannot be taken as for the diagnosis purpose. Resting blood pressure is the seated resting blood pressure used to determine and monitor treatment decisions and also the making diagnosis. Standing blood pressure is used to test for postural hypotension, which may modify treatment if present. And we had a very good lecture in the morning session on postural hypotension and importance of that particular disease. So which blood pressure to be chosen, office, home, or ambulatory? This is the question. Regarding office measurement, it will remain, it is there, and it will remain. But only statement is that office measurement alone may not suffice. Sometimes we have to use the home monitoring and the ambulatory one if they're required. Only office measurement may not be correct most of the time. So why? Because circadian rhythm of blood pressure is not same. It keeps on changing, and according to the 24-hour rhythm, we can have the tipping pattern, and those who have dipping of 10 to 15 millimeter of mercury during night time, they are said to be dippers. And those who do not have tipping pattern, they are called as non-dippers. Why we want to know dippers and non-dippers? Just because the dippers are having more risk of developing cardiovascular disease, while the non-dippers, in the comparison of non-dippers. Not only that, we can have reverse dippers. During night time, the blood pressure rises. In the cases of DKD and CKD, we can found all these changes which are attributed to autonomic dysfunction, and we can have an extreme dippers. During night time, blood pressure fall is more, and all of these conditions are not good. Then coming to the oscillometric method, which I was talking about, the oscillometric method is a better one. Why? Because in the oscillometric devices, the blood pressure measurement is done by, and here the mean arterial pressure is detected, not the systolic and diastolic. And then we can find out systolic and diastolic, which is opposite to the methodology of the palpatory and auscultatory one, where we can find out the systolic and diastolic, and then we can calculate the mean arterial pressure. We all know that the mean arterial pressure is a major parameter which is required. In oscillatory method, these are the oscillations which decide, and the oscillations are recorded, and by that we can find out the blood pressure. So patient preparation is the first thing. It has to be done whether we are talking about oscillometric or any other method. These things are the requirement, and they had to be done. Without them, if the blood pressure is taken, this will not be a correct one. And that is the major problem we are facing, because most of the time our patient, even when they are using home monitoring, they phone us that my blood pressure has gone up to this level. And then we have to educate them that no, you have to measure your blood pressure only in the morning hours and in the evening hours, not any time. And especially when you are having some problem, that is not the correct time to measure blood pressure, because at that time the blood pressure will be different, and you cannot say that it is the same blood pressure which you are talking about. So the posture is very important. The posture, patient sitting calmly, seated for 5 minutes, which is very, very difficult. In most of the office setting, it becomes very difficult because usually the physicians do not have that much time so that they can allow the patient to sit calmly for 5 minutes. It does not mean that patient is waiting outside your chamber. That is not correct, because at that time he's not calm. He's aware and he's waiting, and he's trying very hard to get early into your chamber. And you know that sometimes he used so many ways to enter you to your chamber. And the second thing is that patient had to sit on a seat which has a backrest and back well supported, which is not the case. Most of the time what happens that doctor is sitting on the chair and patient is sitting on the stool. And on the stool, there is no backrest, so it is not possible. That's the situation most of the time. Arms should be relaxed and supported at heart level, and legs uncrossed legs and feet flat on the floor. That is another important thing. And not only that, the bladder and bowel had to be evacuated before measuring the blood pressure. These are the requirements, whether we are using the other methods or using the monitor. Office technique, I have already talked about. 2 readings had to be taken. And if the readings are different by more than 5 millimeters of mercury, the reading should be repeated until 2 consecutive readings are comparable. That is very, very important. And standing blood pressure at 1 to 3 minutes, at 0 hour, and then 1 minute and 3 minutes to diagnose postural hypertension, which we had a lecture in the morning hours. And at that time, again, I want to repeat that postural hypertension can only be recorded by office measurement. We don't have any other method. By the ABPM, we cannot record the postural method with the postural hypertension. So why I'm talking about more about home monitoring, because by home monitoring alone, we will be able to find out true hypertensives, and also we have to be able to find out the white coat hypertension and the masked hypertension. Masked hypertension is not rare. It is very common. We are not diagnosing the masked hypertension. That is the problem we are facing. And why? Because most of the time we overlook the problem of the masked hypertension, and we have seen that the prognosis of masked hypertension, prevalence of masked hypertension is approximately 10% in the general population. 10%, quite high, almost similar to the prevalence rate of diabetes. So it is again higher in diabetic individuals. So those who are practicing diabetes, they must look for the masked hypertension. Then we know that the home monitoring and the office blood pressure monitoring and the ambulatory monitoring, they all have different values. And the description is that for the blood pressure monitoring by home method, 135/85 is the limit. And then the daytime average ambulatory blood pressure should be 135/85 and 24-hour average of ambulatory blood pressure should be 130/80. These are the norms when we are using ABPM and the home monitoring rather than going for the office measurement. Patient instructions are very important. All methods, they should be there using a validated monitor. That is very much required. Most of the time monitors are plenty, but they are not validated one. And you know that in my country, there was no agency available which can monitor that whether the monitors which are being used are of the good quality are validated one. But now the government has passed one rule that no monitor can be sold without having that particular validation. Correct cuff size is second thing, which is very, very important because usually the physicians have only one cuff size with them. We have to ask our patient that please come with your cuff size because every size of patients are coming to you and it's impossible a physician to have different cuff size. And accurate resting technique, which I have already talked about, and patient technique should be reviewed regularly. Duplicate measurements and 7 days after any treatment change, when the treatment change has been done, then definitely we have to go for the home monitoring and ask our patient to monitor their blood pressure morning and evening daily for at least 7 days to find out whether the treatment change has been effective or requires more modification. And I said in the beginning, the 2 readings are required in the early in the morning, just after 30 minutes, within 30 minutes after getting up, but the bladder has to be emptied, bladder bowel both have to be emptied, and before taking any drug and before taking anything in meal. And similarly, 2 hours after dinner, before half an hour before going for the bed, the best time to monitor blood pressure. By that, you will be able to find out the difference in the daytime and nighttime blood pressure. And then even home monitoring will be as good as the ambulatory blood pressure monitoring. What are the benefits of automated devices? They are better than the devices which we were using earlier because of so many things. They are standardized BP readings from one operator to the next operator, because in the previous one, whether we are using LED one or the Mercury one, the operator, they were operator dependent. If the operator is different, then different readings are there. That removes many of the errors which are associated with the manual readings. They're accurate, reliable, and reproducible readings, multiple readings with everything, and opportunistic screening can be done by using them because there's no effort involved and you can use the machinery, and they have been checked for several readings. Automatically zeros with each impression, which we have to do a lot of exercise when we're using the Mercury one or LED one. Then we have to press it and evacuate, and we're very sure that whether it has been zeroed or not. And they also perform full system check, which is important. But the only thing is that we have to choose a validated blood pressure measurement device. And for that, the, the validated one, we have certain guidelines, and the good guidelines, which I have found is the BHS guideline, British Hypertension Society guideline, which is good to guide us that what monitor should be used. Support is required, and measurements taken by patient at home are often lower than readings taken in the office and closer to the average blood pressure recorded by 24-hour ambulatory blood pressure monitoring. So home monitoring readings are almost close to the ambulatory one. And when the in the Gallup poll in 2005, it was found that 35% of hypertensive patients now check their blood pressure at least once per week. And this thing has improved in my country as well. And latest one survey was done in the whole Asia, and I was also part of that survey that revealed that during these 2-3 years, a lot of doctors are inclined using the monitors, and even patients are buying them. But I think they should buy, every patient should buy like a thermometer, like a glucometer. They should have a blood pressure monitor at their home. The office BP measurement is associated with several disadvantages, which I have already talked about, and large variability in office BP readings have been reported both in clinical trials and in the primary care settings. So that is why it is preferred to use the home monitoring one. A study in which repeated BP measurements were made over a 2-week period under research study condition found variation of as much as 30 millimeter of mercury with no treatment change. So that is why they are not reliable one. We require home monitoring. This is the accuracy of home blood pressure monitors in the measurement of systolic blood pressure, and you see a very good accuracy there, and readings are almost similar, only few readings were apart. Advantages and limitation of home blood pressure monitoring. Advantages are so many, like can take multiple readings over an extended period of time and effortless reading recording. Avoid white coat reaction to the BP measurement, reproducible, predicts CV morbidity and mortality better than office one. And most of the readings say, and most of the research also points out to that, allows patient to better understanding of the hypertension management. Even patient knows that his blood pressure requires drug, and the patient compliance also improves, and the BP variability can also be known daytime and nighttime measurement. Limitations are also there. Some devices have been found to be inaccurate, and in my country, the 70% of devices used by the patients are inaccurate. And cuff placement can affect accuracy, may induce anxiety and excessive monitoring, which is the case. And we physicians receive so many calls, sir, my blood pressure has gone up to this. And that is one problem we are facing, that once they have monitor, then they have only one job, monitor it every 1 hour. That had to be discouraged, and we have to educate them that only 2 readings are required, one in the morning, one in the evening, not at any time. And when you are feeling a lot of problems, anxiety, depression, or any other physical problem, please don't monitor your blood pressure. Lack of nocturnal recording is there, but up to some extent it can be done. And these are some limitations to the home monitoring. So potential indications for the use of ambulatory, where the ambulatory one is required, the list is exhaustive, but some of them can use the home monitoring as well. Value of home blood pressure monitoring is very high, and I'm putting some data. 5 prospective studies have compared home and office BP for predicting cardiovascular outcome, and all 5 found that home BP is significant predictor, and 4 out of 5 found that it's stronger than office BP. So more data in favor of home monitoring rather than office one. Other studies have shown that home BP predicts target organ damage better than the office one. And patients who monitor their home BP may be more likely to take their medication regularly, because they are not in that dilemma that whether they should take drug or not, because they're monitoring blood pressure themselves. So the compliance increases. The recommendations are plenty of recommendations. Most of the guidelines and most of the advocacies are done, including National Institute for Clinical Excellence guideline, NICE guidelines. They also favor it. For each BP recording, 2 consecutive measurements are taken. All these things are in the NICE guidelines. They also favor home monitoring. European Society of Hypertension Working Group on Blood Pressure Monitoring has produced a detailed consensus document in 2010, published in Journal of Human Hypertension, and it recommends semi-automated or automated one. So I will finish very quickly. So a lot of advantages of using home monitoring, and especially in these population, we can use the home monitoring. Thank you. I think I will say in the last that today the time has come that the home monitoring become new normal for nowadays. Thank you. Thank you.
So thank you, sir. It's a very wonderful lecture, sir. So as you said, we are agreeing that, sir, hypertension is a bigger problem than the diabetes. For the diabetes, it is a SMBG, which is went into the even general public, but HMBP is not went into, sir. And it is the only method to unmask the masked hypertension. But one problem, sir, so because in the even office BP also measuring, we need to check for the feet position and that backrest position. But in the home BP, so as you said, the many number of the times they will be taking irrespective of time and all, their mood and all. So that one problem, apart from the defective cuffs and what is called these cuffs and machines, but this posture and part need to be taken care, sir. So
We
one
require
comment.
more education.
Yes,
We
sir.
have to educate
Yes.
our patient. Just buying a monitor will not suffice.
Yes, sir. Yes. Sir.
Thank you.
Thank you, Doctor.
Thank you, Verma sir. Thank you, chairpersons. And may I please request Dr. Rajiv Avasthi to chair our next session and Dr. Narsingh Verma also to chair our next session.
So, good evening, everyone. Now we have another powerful lecture lined for today's evening program, Evolving Evidence for Newer Molecules in Type 2 Diabetes, and it will be delivered by Dr. Manoj Chawla. I'll request Dr. Narsingh Verma to please introduce Dr. Manoj Chawla.
Dr. Manoj Chawla needs no introduction. He's has been involved in the diabetes, hypertension, every fora, and I think just to save time, I will just say that Dr. Manoj Chawla, the stage is yours.
Thank you. Thank you, Chairperson, sir, and thank you, ACP, for having me here. There are slides. Guys, IT team, can I have the slides? Thank you. So I'm going to be speaking on evolving evidence for the newer molecules in type 2 diabetes with focus on evogliptin. It's been a decade and a little more for DPP4s, and we've been using them. But it's time that we understood a little more about this wonderful molecule, evogliptin. Right, okay. So the current place of therapy for the gliptins, most will agree, favorable clinical and predictable efficacy, low risk of hypoglycemia. I think that's the biggest advantage of gliptins today when we use it amongst the safest drugs. Extremely low risk of hypoglycemia, weight neutral, rare chance of side effects. And again, that's what gives advantage that you use this drug. You know, it's a headache-free drug. You give it to the patient, the chances of patient coming back with a hypoglycemia, with weight gain, with a genitourinary infection, these problems are not going to happen, and hence rare chance of side effects. And backed by extensive scientific evidence, the entire group DPP4 inhibitors. Now, these are some of the gliptins that we have, the ones which are available in India now. You have Sita, Vilda, Saxa, Lina, Alogliptin also, Teneli, of course, and then evogliptin, which is known as Suganon internationally, and it's a product from Korea approved in 2014. A little more about evogliptin. It's selective, potent, and reversible inhibitor of DPP4s, extensively studied for its efficacy and safety, and I'll be sharing some of the data today. Approved in South Korea in 2015, Azerbaijan, Russia in 19, Bolivia, and then later in India by 2018. For treatment of type 2 diabetes as an adjunct to diet and exercise to improve glycemic control when used either as monotherapy or in combination with metformin. Standard single dose 5 milligram once a day, does not require any dose adjustment in the elderly or for renal or hepatic impairment. And I'll be showing some data there as well. Now, the question is, in this number of gliptins that we have, is there really a difference? Why do we choose one gliptin over the other? Are all DPP4 inhibitors the same? And that's when we need to deep dive a little and understand that DPP4 enzymes with their binding site. So you actually have the S1, S2, S1 dash, S2 dash, and the X2 extensive DPP4 enzyme binding sites. Of this, for you to achieve any significant DPP4 inhibition, it's the S1, S2 site which all these drugs predominantly work on. Where else they work, what other inhibition they cause is going to decide their efficacy in terms of how efficacious they are, and also their selectivity for DPP4 inhibition over the other DPP enzymes. So binding with S1 and S2 is considered as fundamental. Binding to additional will give them the additional inhibition of DPP4. So let's see, when we look at the class 1 type of DPP4s. You have vildagliptin and saxagliptin. And this is, they're going to be on S1, X2. Predominantly, that's where they work, nothing else. You look at class 2, which is where you get in alogliptin and linagliptin. They work on the entire S series. So you have S1, S2, S1 dash, S2 dash inhibition is what alogliptin and linagliptin cause. And then you have the class 3, where you have sitagliptin, keneligliptin, and evogliptin, which work on S2 extensive along with S1, S2, causing the predominant DPP4 inhibition that they cause. So evogliptin binds to S1, S2, and S2 extensive binding sites, non-covalent binding, as I said, reversible binding. And this is what gives it this specific nature. So when you talk about the DPP4 inhibition, the means of figuring out the DPP4 inhibition is through the IC50 activity. And for that, there's an inversely proportional ratio. So the lower the IC50 activity, higher the efficacy of the drug or its selective inhibition of the enzyme. So evogliptin is right up there in terms of being extremely efficacious. Then you start looking at that, yes, I want this drug to inhibit DPP4, but I do not want its effect on DPP8 and 9. So I don't want any cutaneous side effects. I don't want any other side effects, any respiratory side effects, wherever the other DPP enzymes may be. And then you start seeing the selectivity. So evogliptin, when it comes for DPP8, DPP4 selectivity over DPP8 is more than 6,000 times. And similarly, the selectivity for DPP4 over DPP9 is 6,000 times. And as you'll see in the table there, that this is, it's as good as many other drugs. There are some other agents which would be more selective in that, but evogliptin with its low IC and this selectivity gives it the unique advantage. So the pharmacokinetics of evogliptin, absolute bioavailability is about 50%, reaches its plasma concentration in 3 to 5.5 hours. Plasma DPP4 inhibition rapidly surpasses the 80% mark in less than an hour. And most of you who've been listening to gliptin talks realize that 80% DPP4 inhibition is what is critical for us to get good sustained effect. Importantly, the terminal half-life of this drug is about 32 to 35 hours. So it's truly once daily a drug because of its prolonged half-life. Reaches a steady state concentration within 3 days. According to its in vitro studies, evogliptin is not an inducer of the cytochrome P450 3A4 series, nor an inhibitor of the other cytochrome P enzymes. Although its metabolism is primarily mediated by cytochrome P3A4. So minimal inhibition from the hepatic pathway. The renal clearance and fraction are excreted unchanged in urine. So no dose adjustment required because of these aspects of the drug. Dosage and administration adjustment is not needed. So we know that for sitagliptin and some of the other gliptins, you will have to bring down the dose as the GFR is coming down, or if you're using them in mild to moderate hepatic insufficiency. No such concerns here. So favorable pharmacokinetics, and if we put all these gliptins into perspective, you start seeing in terms of half-life. As I said, evogliptin, the longest half-life. You use sitagliptin as once daily, you use teneligliptin as once daily, and you'll appreciate the half-life of evogliptin being much higher than any of these, and hence once daily dosing. Excretion, hepatic, and to some extent by renal, but largely unchanged in the urine. Increase the postprandial. So what does it really do? This increases the postprandial GLP-1 levels by 1.5 to 2.54 fold, decreases the postprandial levels by 20 to 35%. The DPP4 inhibition increases in a dose-dependent manner and remained over 80% after 24 hours period. And those are the characteristics that you require actually in a good DPP4 inhibitor. What about its clinical study landscape? Very good developmental program that it's had. And in fact, more and more evidence being generated even in countries where it's being used, including India. So right from its phase 1 program to phase 2 and then phase 3 studies in different scenarios, that's the entire landscape of evogliptin developmental program as you can. And I'll be focusing on some of these studies today. Clinical evidence with evogliptin. So these are some of the important studies. Efficacy and safety of evo monotherapy in patients with type 2 diabetes and moderately elevated HbA1c levels after diet and exercise, published in 2017. Efficacy and safety of adding evogliptin versus sitagliptin for metformin treated patients. Efficacy and safety of evogliptin versus sitagliptin as add-on in Indian patients. That's an Indian study. Then a randomized double-blind active control phase 3 clinical trial to investigate the efficacy and safety of evogliptin when added to ongoing metformin monotherapy. Then there is a Brazilian study and then the Evergreen study. So let's have a look at some of these studies. So this is the phase 3 study, evogliptin monotherapy in patients with type 2 diabetes, randomized double-blind placebo control, multi-center 160 patients, evogliptin or placebo for 2 weeks. And you were able to see the mean HbA1c significantly decreased from 7.2 to baseline of 6.97. Now, when you look at the A1C reduction here, sometimes someone wonders it's only 0.23%. You know, what is 0.23% today when we have drugs? But every time you are shown data for A1C reduction, start looking at the baseline. So this is a scenario where it's used as monotherapy. Your baseline HbA1c is here 7.2 average. So from 7.2, if you're getting your patients to 7.9, 7.95, as long as you're getting them to below 7, that is the target. Now, this is the study in the Brazilian population, a randomized bridging study. So again, here, patients, type 2 diabetic patients between 20 and 75 with inadequate glycemic control. These were treatment naive patients again. And they've been randomized to evogliptin 2.5 milligram, 5 milligram, 10 milligram, or sitagliptin. And you start seeing the results. So the efficacy of evogliptin 5 milligram was found to be comparable to sitagliptin, which is considered very often as the standard comparator in the DPP4 scenario, that you're getting an A1C reduction of 1.3% as compared to sitagliptin. The Evergreen study, again, this was presented at ADA 2019, which was done to evaluate the efficacy and safety of Evo versus linagliptin. Now, when I say in terms of the gold standard for DPP4s, a lot of us would say sitagliptin. When you talk about DPP4, which has proven safety, whether it's again renal, hepatic, no dose adjustment, it comes to be linagliptin. So fair to see a study against linagliptin. How did it score? And this was also a CGM study to look at the reduction in glycemic variability. So a single blind study, placebo run-in period, and then patients were randomized 1:1. A CGM done in between. They would be either on evogliptin 5 mg or linagliptin 5 mg. You start seeing the primary efficacy endpoint, again do a CGM, have another 12 weeks duration period, and followed by the other CGM. What was found in terms of changes in HbA1c from baseline to week 12, as between these drugs, for evogliptin from a reduction total of about 0.85%, and you see for linagliptin 0.75. So comparable in terms of efficacy, you're getting the A1C reduction. What about the markers for glycemic variability? You're looking at MAGE. Again, you see better reductions of mean amplitude of glycemic excursion, which is one of the standard means of glycemic variability metric. You see better results for evogliptin there. In terms of standard deviation, again, evogliptin doing better than linagliptin. So nowadays we tend to look more at Kaimin range, but prior in the earlier CGM studies, it was essentially SD and MAGE, which was looked as markers of glycemic variability. You also see further the change in HbA1c from baseline to week 24, and you see a further reduction in the HbA1c, taking the patients on evogliptin down to 6.58. And this is a typical CGM profile of patients who are on evogliptin. You're seeing the baseline. You can still see the peaks, which you're able to appreciate on the left. You see at the end of 24 weeks of evogliptin therapy, and you see all these peaks flattening out and patients looking at spending more time in range. So what they saw at that time was proportion of time in glucose range. This wasn't exactly the standard TIR that we talk about today. And also, if you can appreciate the appropriate time in range there during this study was 70 to 140. Today, we have the international recommendations for time in range, and we look at 70 to 180. But even if you looked at 70 to 140, you could see that between baseline and week 24, patients on evogliptin improved from 40% time in range to 59, which is 60% time in range. This was 70 to 140. If this was done for 70 to 180, you probably would have seen things closer to 75, 80%, and anything above 70% is the recommendation. So the conclusion of this study was that when evogliptin was orally administered for 12 weeks, its effect on the change in A1C was proved to be non-inferior to linagliptin. In 24-week study, evogliptin is considered as a safe and effective anti-diabetic treatment for type 2 patients. Evogliptin administration also resulted in improved glycemic variability. Now, some study in renal dysfunction. So this was essentially to evaluate the pharmacokinetic and tolerability of Evo in subjects with renal impairment by comparing in those with subjects with normal renal function. Small study, 32 subjects. What they found in this study was concentration was found to be safe in phase 1 multiple dose study. Dosage adjustment of Evo was not required in patients with renal dysfunction. The drug was found safe in all grades of renal dysfunction, and I think has an approval to be used even up to 15 ml per minute GFR. Pharmacokinetics and safety in patients with hepatic impairment. This study looked at trying to evaluate the patients in mild to moderate hepatic impairment. You had patients with both mild hepatic impairment, moderate hepatic impairment, as you can appreciate down, with the healthy controls for both these groups used. And they found that, again, even though in the moderate hepatic impairment, that was the only group they actually found certain impairment in the absorption of evogliptin, but not causing any clinical significant issues in the patient's efficacy. So although the evogliptin exposure was increased in the moderate ones, did not have a problem, and hence never recommended to have adjustments in patients with mild to moderate. We do understand when we talk about more than moderate hepatic insufficiency, most would argue about the usage of oral drugs there and would prefer to use insulin in those scenarios. Now, this is a cardiovascular risk evaluation. I must say this is not a cardiovascular outcome trial, but this is one of the largest studies that they had for cardiovascular risk evaluation for evogliptin. Now, this is from a database where they looked at comparison between glimepiride as a standard, and they looked at all the gliptins and SGLT2 inhibitors as a comparator when they were used in the patient databases. So this was a study design. You had a large number of patients which are evaluated here. So you're talking about almost 23 lakh, 18,000 patients, or rather more, who were evaluated, and this was the number which was excluded. You had patients who were on metformin monotherapy users, and then wherever other drugs were used, so this could be either glimepiride, it could be gliptins, or as I said, any of the SGLT2. So these were the three class of drugs which were used, and the division of this, they found in the database that about 3% patients that there was usage of evogliptin as well. What did we find here? So when we talk about the cardiovascular disease risk, when you look at the DPP4 inhibitors compared to glimepiride, DPP4 inhibitor users, which included evogliptin. So this is not completely exclusive for evogliptin. This was entire gliptins, including evogliptin. It was associated with a decreased cardiovascular disease risk. And this you can appreciate with a hazard ratio of 0.87, where the 95% of confidence interval did not cross unity. You see the data in this retrospective database analysis. For SGLT2 inhibitors, we would have expected a better result. Somehow, in that statistical analysis, you find the 95% confidence interval crossing unity and hence not getting statistical significance the way they found for the gliptin class in this particular study. So when they looked at even separate events, whether it was MI, heart failure, cerebrovascular disease, and angina, they largely found the DPP4 inhibitors to be having statistical significance in reduction of cardiovascular disease as compared to glimepiride. Now, I guess that kind of discussion is sulfonylurea safe, are DPP4 more cardiovascular safe, will continue as the studies continue to evolve. So the conclusion from that study largely was that use of evogliptin either decreased the risk of CVD or had no association with it compared to other ingredients of DPP4s or SGLT2s. Now, we move from evogliptin to see what has taken this drug ahead, and that is the wonderful combination of evogliptin and metformin. So various countries is where this combination is now approved. South Korea, China, South Africa, Russia, Ukraine, Kazakhstan, and of course, India. And different pharma companies are marketing this drug in different products. We talk about the clinical evidence. Earlier, I showed a list of clinical evidence for only Evo. This is the list of different studies done for evogliptin and metformin. Now, this is a Korean study where they again looked at the efficacy and safety of adding evogliptin versus sita for metformin 1000 treated patients. So those patients who are on baseline metformin 1000 milligram, not at target control, you are adding either sitagliptin or moving to this combination. In change in A1C, you're seeing for evogliptin 0.59, for sitagliptin 0.65. So considered to be comparable there again between sitagliptin and evogliptin. A specific Indian population study, again, almost similar, the evolution study where patients on background metformin are again either given evogliptin or given sitagliptin, and you see the reduction in A1C from 0.55% in the evogliptin metformin group and 0.48 in the sitagliptin group. Again, I wouldn't say one was better than the other, but both of these showed comparable reduction in A1C. Evogliptin phase 3 study, again, which looked at using evogliptin, comparing it again. This was a double-blind study, so you had the placebo controls also. Again, evogliptin versus sitagliptin. You had two countries here. The earlier ones we showed was individual country data. This was for both Korea and Russia. What did this study show here? Again, for the Evomet as compared to sitagliptin metformin, you're getting a 0.6% reduction and similar 0.63 in the sitagliptin group as well. So all of this showing good efficacy in both these groups. So when added to metformin more than 1,000, evogliptin demonstrated non-inferiority compared to sitagliptin. Okay. And there has been some recent data which I would like to conclude with. This was a retrospective observational study on usage of Evo, which was presented at RSSDI 2020. Again, the study aimed to assess the effectiveness and safety of evogliptin, who were prescribed either evogliptin alone or along with other oral hypoglycemic agents. And I'll jump to the conclusion, which found evogliptin was found to be effective when added to the patients who were uncontrolled on even 2 or 3 drugs. So even on the baseline other drugs, somebody who's on sulfonylurea metformin, you start adding evogliptin, they found further reduction. So in this study, from a baseline of 8.4 for patients on 2 drugs already, sulfonylurea metformin, it came down to 7.2, and that was the strength of the study. We have multiple more studies which to talk about its comparative analysis. In the interest of time, I will jump to conclude my conversation that evogliptin, truly once a day due to its longest half-life of 32 hours, established renal, hepatic, and cardiovascular safety. Again, yes, a disclaimer would be we don't have a cardiovascular outcome trial, but whatever analysis of large patients, it seemed to be, the pointers have all been towards cardiovascular safety. As per the Evergreen study, which was comparison versus linagliptin, evogliptin showed highest reduction in glycemic variability, so that's an added benefit. Besides the HbA1c reduction to be non-inferior. With 3 head-to-head studies against sitagliptin, evogliptin is also proven to be non-inferior versus the comparator, gold standard comparator, whatever we may say, which is sitagliptin, and one of which is an Indian study itself called the Evolution India study. Finally, evogliptin metformin, and the advantage there is a genuine sustained release metformin preparation. I, for one, love to use this because it gives you the once daily benefit, whether you're using the 5x500 or 5x1000, because it is amongst the better extended release metformin preparations that you have. So this Evo metformin FDC formulation provides better compliance and of course helps patient to adhere to the therapy because of a single pill treatment that they get. With this, let me thank you all again for the patient hearing.
Thank you, Dr. Manoj. Thank you for revisiting us to the gliptins. And are there any queries? If there are no, then we'll move on to next session. Thank you, Dr. Manoj.
Thank you.
Thank you, chairpersons. Thank you, Manoj Chawla, sir. With this, we proceed to the next session, which will be chaired by Dr. Shirsendu Pal, sir, and Dr. Brijesh Kumar, sir.
So we move on to the next session. That's on COVID-induced coagulopathy, workup and management. And it shall be delivered by none other than Dr. Mangesh Tiwashkar. He needs no introduction at this part, but still I'll request my co-chairperson to introduce him.
Good afternoon, everyone. Dr. Mangesh.
That's okay. Yes. That's okay. Thank you. ना देखो मनोज सामने है तो मैं बाकी मेरे बारे में कुछ बोलने की जरूरत नहीं. Anyway, thank you very much. Good afternoon, everybody. And it's like, walking directly from airport to here. And thank you, Jayanto. Thank you, Srini. Of course, Dr. Muruganathan, Anuj, Narsingh, where are you? Okay, everybody, thank you very much for this beautiful opportunity. Now, before I do that, I would request all of you, please stand up a bit. Let us pay our respect to the fellow who we lost unfortunately. Pride of India we lost. In memory of our CDS General Bipin Rawat and entire 13 people, those who have lost their life. Thank you very much. I appreciate it. So friends, I'm going to talk to you about COVID-induced coagulopathy. A story which starts here and Agam will really talk about, because Agam recently has published along with Dr. Chopra and team a beautiful paper in JAPI. In this JAPI, Agam published a paper on COVID-induced or COVID-associated coagulopathy, a story which starts actually as a story of inflammation. And we all know that this blizzard of inflammation really triggers and is responsible for most of the challenges that people of COVID will have. But one such outcome of COVID is an immune outrage, which actually impacts the immediate and the long-term morbidity as well as mortality, is what is called as a COVID-associated coagulopathy or COVID-induced coagulopathy. So let's discuss this in next 15 minutes or so. I am Dr. Mangesh Tivaskar. There are some important disclosures that I have, that we all are aware that the knowledge of COVID is still evolving and we are still learning. Every day we spend during this COVID times, we are getting some new information. Believe me, there are more than 52 studies which are already published on the COVID and associated coagulopathies. So my discussions are going to be entirely upon the guidelines which are published by various organizations, including the Thrombosis Society of America. And along with that, the scientific peer-reviewed literature. And I'll just give you the bird's eye view. I'm not going to talk to you in details about the management strategies, the different drugs, the mechanism of actions of the drugs. But there are a few new terminologies that you will surely know. Few of them, those who have worked in COVID, are aware about these terminologies. But I don't know how many of you are aware that there is a role, what is called as a netosis. How many of you have heard this term? I'm not sure about it. The presentations of COVID-associated coagulopathy, we are all aware about. Primarily present to you with the venous thromboembolic phenomena. It can happen in pulmonary circulation. It can happen in general venous circulation. It can present as microangiopathies, and that was a feature of most of the postmortem lungs that people have explored. And of course, there are a few other macroangiopathies like myocardial infarctions, increasing the risk of strokes, DVT, probably sometimes the peripheral vascular disease acceleration was also noted. And the incidence anywhere ranges between 15 to 53%. In fact, one of the latest French studies have actually showed that the incidence of COVID-associated coagulopathy was to a tune of around 90%. Now that was what. And thanks to Agam again being, one of the co-faculties for this paper, which was published in JACC. This was presented as a paper in the American Heart Association National International Congress during the ACC 2021, but also has got a place in JACC in May 11th edition of this. And we talked about thromboprophylaxis in improving the outcomes in COVID-19. So the story dawns here in alveoli, and it starts by COVID virus attacking the type 2 nematocytes. But apart from the inflammatory response, there are some COVID or COVID-associated coagulation challenges. And the challenges are usually very high levels of soluble thrombin levels, very high levels of von Willebrand factor. That actually leads to formation of microthrombi, and ultimately, along with netosis, basically because of the excessive recruitment of neutrophils at the site, will cause coagulopathy. So let's have an overview of a coagulopathy. We all are aware that hemostasis has three different components. No matter it could be an extrinsic injury or an intrinsic injury. Extrinsic, external injury, it's a very quick response of the body. And that is the reason why it's a very short pathway. But whenever you talk about intrinsic, that means body wants to stop coagulation as a response to a small intrinsic triggers. So it requires a long clearance pathways. And that is the reason why intrinsic pathways are always long time taking pathways. Extrinsic response is extremely quick, where there is initial immediate vasoconstriction along with the platelet plug formation, and then a vasculation or the coagulation cascade kicks off. And then naturally, once the entire, I would say, thrombus is formed, then if at all there is an intravascular coagulation happening, then the antithrombus or antithrombus mechanisms are kicked off. So coagulation cascade, which is classically also initiated by what we call it as proenzymes, or also called as zymogens, are actually the glycoproteins which are present, which are responsible for the sequence of the events to give you ultimately a clot formation, and then you do have a natural fibrinolysis. Now, these are different clotting factors, and these are the two different mechanisms. I'm not going to the details about it, but you can see clearly that extrinsic mechanism or the extrinsic clot formation trigger is extremely fast and very, very sharp, whereas intrinsic mechanism takes a long time. I could not stop myself in telling you about the menomic, how I remembered these clotting factors. And this term, this sentence has made my life really easy. Few people try climbing long slopes after Christmas. Some people have fallen. Now, this was the simple menomic that I remembered when I remembered the menomic. Presentation is don't worry about it. So it's a sort of I would say association of different factors which actually causes that Virchow's triad challenge, where you have got a hypercoagulable state, where of course we do have got a hypercoagulable state where there is an excessive thrombin burst, and that can be easily formed on what we call it as the thrombus elastography. And then of course there is a short K that tells you about the thrombin generation, and also there is a clot strength which is very, very strong, and this is primarily because of one area, it is netosis. Now I'm repeating this term netosis again and again, because once you understand what this netosis is, you will realize that why these clots, which are usually formed because of the COVID-associated coagulopathy, are so resistant for fibrinolytic therapy, where that is the place where your fibrinolysis or the lytic therapies, they don't work. So the best way to do and to try and avoid this is usually a good anticoagulation. And along with this, there is an endothelial injury. And of course, stasis, because of the long-term immobilization, is going to add to it. You would be wondering, what is the picture and what this exactly is? What is this picture? This is the longest, the largest endocrine organ of the body. Surface area is very, very high, and the tissue immediately below this. This I am talking about endothelium. So a normal endothelium has got an absolute phenomenal ability to stop getting natural coagulation in the flowing blood. And especially this endothelial matrix that I am talking about has got natural heparin inhibiting factors. There are nitrous oxide stopping factors. There are prostaglandins. There are thrombomodulators which are there, but which will stop the blood coagulating inside. But what happens in COVID? The immunopathogenesis, the systemic inflammation. Apart from that, the cytokine bursts. All this will cause endothelial dysfunction. And one of the prominent mechanisms of endothelial dysfunction is excessive RAS. Now, why you get an excessive RAS activity? It's a direct effect of SARS-CoV virus on the angiotensin 1. But more interestingly, as we all are aware, that these spike proteins of SARS, they bind to ACE2 receptors. Now, ACE2 receptors are phenomenal. Remember them. ACE2 receptors are mandatory to stop the progression of the inhibited progression of the angiotensin mechanism. Remember that ACE2 degrades angiotensin 2. We all know angiotensin is usually stimulated whenever there is a hypotension. The renal perfusion goes down, the peripheral perfusion is poor, and there is an excessive angiotensin mechanisms trigger. These are all natural triggering mechanisms. But this angiotensin, which has got a tremendous vasoconstrictive properties, needs to be stopped. It cannot continue. Otherwise, the patient can have a real genuine challenge of perfusion. So this angiotensinogen 2 is neutralized with the help of ACE. Now it are these ACE2 which are usually taken up by the SARS-CoV, and that is the reason why there is an uninhibited action of angiotensin. So there is an extravagant stimulation of angiotensinogen 2, which will ultimately cause peripheral vasoconstriction, stasis, stagnation. Along with that, it will cause increase in the local reactive oxygen species release, will trigger the I would say cytokines, and not only that, it will reduce the natural vasodilation happening because of the nitrous oxide. And along with the cytokine challenges, it will cause a severe endothelial dysfunction, which leads to this challenge. So on one side, you have got a beautiful endothelium, which has got all the protective properties, but the moment the trigger of SARS-CoV happens, this endothelium starts becoming porous, and which is anti-inflammatory becomes pro-inflammatory, which has got an anticoagulant properties, starts becoming hypercoagulable. And then you get excessive recruitment of lymphocytes and neutrophils along with the cytokine challenges to add to the complement story to the whole system. And that will worsen the challenge. Why? Because the complements coming into the scenario will cause excessive recruitment of polymorphonucleosides, and which will lead to what is called as netosis. So I'll spend a couple of minutes on what are these nets: neutrophil extracellular taps. Beautiful mechanism. I was not aware before I really prepared for this talk that neutrophils, they have got such a tremendous potential. And what does they do? Actually, in response to the insult, we all know that polymorphonucleosides, which are the part of the innate immunity, innate, inborn, we are born with it, right? And they respond. They respond by recognizing what we call it as DAMs and PAMs, damage-associated molecular proteins, or the pathogen-associated molecular proteins. They'll sense it. And what happens is that not only they degranulate, but the chromatin, the nucleus chromatin, is thrown as a fisherman's net. Now we are in Goa, so who better than fisher people here will realize the importance of fisherman net. So there is an excessively recruited neutrophils showing an aggressive net formation. And these nets have got the toxic compounds like histones or myeloperoxidase or proteinase 3, which has got a tremendous capacity to stimulate the cytokine response. And they disrupt not only the alveolar epithelium, but also vascular endothelium. Actually, they do have got a capacity to trap the microorganisms. And that is the reason why these are the webs of the DNA, which consist histones, microbiocidal proteins, and oxidant enzymes that are released in response to the pathogens. Now that is our defense mechanism. Now this is a beautiful video that you can see where these excessive neutrophils are getting recruited, and you can see in yellow and green, so much of nets are thrown. Now this is an electron microscopic film of the neutrophil elastase release and the chromatin release. And you can clearly see the amount of the chromatin material getting degenerated. And look at the beautiful colorized scan picture. Now, even though this is not SARS-CoV, but this is in response to Helicobacter. But look at the way these webs of, and what happens is this, that because there is an excessive recruitment of neutrophil, there are so many neutrophils throwing up these webs. So what happens is that there is an aggregation of these nets, and these are called as agnets. And that starts, with the triggering of coagulation cascade. That is the reason why these nets are not responsive to lytic therapies, because there is no blood more involved here. It is more of a chromatin material. So a cascade, a myriad, I would say a crosstalk of immune pathogenesis along with the netosis actually is a basis of COVID-associated coagulopathy. There is also something called as pyroptosis, and which is actually responsible for excessive stimulation of tissue factors, which is also responsible for the excessive coagulation. And then to add to it, naturally, the platelets get activated. And we all know platelets are another beautiful organs. A simple, small, discoid looking platelet, the moment there is a trigger, changes itself to a completely sticky with multiple phylopodal extensions coming out, and they start becoming sticky, and they'll start, getting stuck to RBCs, to WBCs everywhere. And these platelets, along with the whole coagulation, will lead to immunoinflammatory endotheliitis. So this is, in short, what you generally get in immunoendotheliitis. But remember that one very important thing is this coagulopathy is not a consumptive coagulopathy. We have to remember that. There is no, I would say deficiency or deprivement of the coagulation factors. The coagulation factors are not consumed. So this is not a consumptive coagulopathy. And hence, why it is important to understand, because what are the lab markers that you will ask for? Primarily, you ask for the inflammatory markers, especially CRPs, we ask for ESR, ferritin levels, and in very rare situations, we ask for PCT levels. Then we ask for the coagulation markers like D-dimer. The commonly asked investigation during the COVID time was D-dimers. And then, of course, in few select cases, we asked for the platelet activation. So look at the whole, I would say, tabulation of the various laboratory coagulation parameters that you can ask for. But out of these 7 or 8, there on table. The commonly asked are usually D-dimer, sometimes prothrombin time, very rarely fibrinogen, and also simultaneously, sometimes you may ask for a platelet count. Some select situation, you ask for a PTINR. Why? Because PTINR is a direct representation of the extrinsic and the common pathway of the coagulation. And the normal PTINR, you all are aware that it is between 11 to 14 seconds. And in the situation where you want to know about the intrinsic pathway, you will ask for activated prothrombin time. And that is APTT, which is around 25 to 40. And you know that, it is a little longer time. It is similar to PT, but it is different because it judges the intrinsic factors. And of course, D-dimers, we all are aware about it. They are the fibrin degradation product. They represent the degradation of the fibrin. Now, why D-dimers rise? Because there is an excessive fibrin formation. And as these fibrins are lysed by the natural mechanisms, you get this divalent dimer protein which released in the blood, and that causes the rise in the D-dimers. Lastly, a beautiful comparison between 4 types of coagulopathies and how do you differentiate between them. And during COVID times, especially in ICCU, me and Agam managed, I don't know how many patients together, and we definitely saw these coagulopathies: sepsis-induced coagulopathy, DIC, and the COVID-associated hematological abnormalities, or CAHA, or COVID-induced coagulopathy. You don't have to ask for all these myriad. Just whenever you want to differentiate between a sepsis-induced coagulopathy and a COVID-associated coagulopathy, only 5 investigations. You don't require anything else. Prothrombin time, rarely activated prothrombin time, D-dimer level. Simply to differentiate between the sepsis-induced coagulopathy and a COVID-associated coagulopathy, there is a challenge. Ask for only 1 investigation, D-dimer. I'll be finishing in next 2 minutes, sir. D-dimers are extremely high, usually in COVID-associated coagulopathies. Where in sepsis-induced coagulopathy, you will not get D-dimers. Similarly, if you want to differentiate between a DIC and a CAC, what you will do is, again, you will ask there probably for platelet count, which is the simplest, cheapest, and easily available investigation. It will clearly tell you a difference between a DIC and a COVID-associated coagulopathy. This is an overall bird's eye view of the different typical coagulation profiles of pregnancy. I have included here primarily because there are many pregnant patients, those who face this challenge. So a Virchow's triad of COVID-associated coagulopathy, where there was on one side virus responsible for the trigger, on the other side you have got the coagulation dysfunction, and on the third side there was a stasis because of the prolonged hospitalization, leads to the COVID-associated coagulopathy. Last 2 minutes, I'll be talking about management. Quickly, few pointers. Remember that pharmacological VTE prophylaxis, that is venous thromboembolism prophylaxis, for all the hospitalized non-pregnant patients with confirmed or highly suspected COVID-19, regardless of the VTE risk score. It's very important for you to understand this. But if the patient is pregnant, then it is always advisable to follow some guidance which has been issued by the Obstetrics and Gynecological Society. If there are contraindications for VTE, pharmacological VTE, you may consider the mechanical VTE, especially in the ICU patients. And in the critically ill patients, you may think about giving them both. There are almost nearly 53, 54 studies which have been already published. Prominent are being there on your screen. What they have come out with is that especially in the moderately ill patients, it has been proved that therapeutic anticoagulation is superior. But in the critical patients, those are very sick, on probably gadgets, on ECMOs, on ventilators, probably you don't have, I would say, this choice of therapeutic anticoagulation. Now, lastly, pharmacology, we all know, scoring systems, we all know. These are all the pharmacological agents that we used. Commonly used are enoxaparin. We used also sometimes unfractionated heparin. DOACs, absolutely champions and proved champions. Either they may be direct thrombin inhibitors, or they can be a factor 10A inhibitors. So to conclude, key points: SARS-CoV predisposes people for a COVID-associated coagulopathy. There are current guidelines which suggest that all the patients, those who are moderate to severely sick, must be given COVID VTE-related prophylaxis. And most importantly, the duration of the prophylaxis depends on the severity of the illness, the duration of the hospitalization, and the pulmonary involvement. And that's what the BTS guidelines have said. So lastly, to conclude, I'll end up my talk by saying a great teaching by Stephen Hawking and our late President, Dr. APJ Abdul Kalam, is the greatest reason for failure is not ignorance. It is the illusion of knowledge. But if I have to dare and add one more line to this, now during COVID era, it is the resistance to change can be the greatest reason for the failure. Vaccination, as Agam loves about it, is the only way to prevent probably the COVID onslaught that we have. Rest all is history. Thank you very much. I'm sorry for
Thank
exceeding
you.
time.
Thank you, sir, for wonderful presentation. And now house is open for discussion. Any question regarding this talk?
Not in mild COVID patients. Usually mild patients, they do not require any anticoagulation requirement. But moderate to severe, yes, all of them should be there.
Thank you, sir, for your very lucid.
High risk factors, only with high risk, suppose. Yes. Oral, all oral, mostly oral.
So,
yeah.
One more question, if you don't.
Usually the recommendation for moderate to severe is around 6 weeks to 3 months of time. Most of the guidelines will suggest you to give around 3 months of time. That is an ideal time that is been expected to be, anti-therapeutic anticoagulation may not be completely, but at least, the VTE prophylaxis can be extended up to 6 weeks to 3 months.
So sometimes we get the D-dimer prolonged beyond 3 months also.
Yes.
So, and
So that is the
also.
reason why D-dimer is not the only criteria for the even the continuation of the anticoagulation. Remember that, or the thromboprophylaxis. There the patient's clinical scenario really takes a score over it. So if the patient is clinically doing well, sometimes, because see, and most importantly, D-dimers are again the non-specific indicators. They are not genuinely the markers of hypercoagulability. And there are so many other reasons where D-dimers can be. So you need not be really following or chasing D-dimers. That will they only have got a prognostic values, not the therapeutic or diagnostic values.
Yes, and sometimes sepsis may coexist with COVID.
Sometimes, yes. Then
Yes.
that is the reason why I showed those all 5 or 6 parameters where, if suppose the situation is this, that D-dimers are also very high, but also that the platelets are low, or probably the activated prothrombin time is also high, which is not seen. Activated prothrombin time may not be very high in the COVID patients, but this is usually seen in the sepsis-related coagulopathy. Sepsis-related coagulopathy usually associated with CAC. The one simple investigation that you can actually call for is procalcitonin levels.
Yeah.
And not only one procalcitonin level, but the rising procalcitonin titers will surely tell you that the patient is in sepsis, and maybe possibly that this fellow also has got a sepsis-associated problem.
So also some people suggest that you can add antiplatelets. Just
Good question, sir. Antiplatelets have no role in
Yes.
COVID antibodies. In fact, we have probably, messed out, because it is not platelets that we are treating. It's not the platelet dysfunction which we are treating. It's a coagulation problem. So you are not dealing the platelet problem. You are dealing with the coagulation problem. So you use aspirin as a preventive measure. That is an error. And sometimes it can really turn up extremely bad, because these patients can, develop gastrointestinal bleedings and all that. So they're very bad. They are already sick patients, already stressed out. They bleed profusely.
thank you, sir. Thank you for such a lucid deliberation on such a complex topic. Oh, any more?
Yeah, now good question again. If the patient is already on with, see, the patient already has got an established cardiovascular disease for which the patient is already on with the secondary prevention. If the patient is on with secondary prevention of aspirin, you cannot stop it. You will need to continue that. Okay. But if the patient is probably on with clopidogrel as a primary prevention, and you have got COVID in these patients, you may shift these patients from clopidogrel to either enoxaparin or the combination of enoxaparin plus the newer oral anticoagulants.
Right.
But in the secondary prevention, you are not supposed to stop aspirin at any cost.
So we close the sessions, yes, with our memento to our famed speaker.
So for our next session, I would again request Dr. Brijesh Kumar sir to kindly join us as chairpersons, and also Jalise Fatima ma'am to kindly join us as a chairperson.
So for the next session, the next lecture is also a very important lecture by a very eminent speaker. And the topic is very interesting, second generation basal redefining glycemic control. And it will be delivered by Dr. Mukulesh Gupta, who is MD, Fellow of RSSDI, FISH, FACP, Director, Consultant Diabetologist, Udyan Healthcare, Lucknow. He's an internal medicine specialist, and I know him personally. He's a very good orator and a very learned person. Looking forward to your talk, sir.
Thank you so much. Can I have my slides? So after chairing multiple sessions, now it's my turn to speak. So first of all, at the very outset, I would like to thank ACP India chapter, Dr. Narsingh Verma, Dr. Anuj Maheshwari, Dr. Panda, having given me this opportunity to speak on this subject. And thanks not only because I have given this opportunity, but because this forum basically is addressing to primary health care. And as Dr. Muruganathan yesterday mentioned, that Christian Barnard, and he quoted him that he focused that if suppose he could have focused on primary prevention or the primary health care, he would have saved millions of lives. Similarly, if you have heard Dr. Anuj Maheshwari talking about the theme of this particular conference, he talked about that primary healthcare, if suppose we nip the bud right in the beginning, probably it will save many complications and many patients requiring tertiary care. And therefore, this is important that we focus on some messages which have to be given to the primary care physicians. And as the Dean ICP has mentioned, that we need to be building bridges between the primary healthcare and the second and the tertiary healthcare. We need to be developing. Having said that, we know that making a change is something which is important. And personally, I feel and I relate to this message because out of 30 years of my practice, 20 years I've devoted to rural areas. And this is why I think that this is something which is really important that we are talking about primary health care and delivering some messages. This is not an emotional statement, but it is basically something which is pretext to my talk. turn off. Maybe. Okay. So the talk given to me is basically talking about the second generation basal insulins. Now, once we are talking of this, we know that the moment we talk about insulin initiation in our patients, there is a lot of resistance that comes in various ways. And the fact remains that the HbA1c goal is far-fetched. Hardly 24 to 28% patients, they are on goal. And if we talk of insulin initiation, then we wait for HbA1c of nearly 9.1 before we really think of initiating insulin. So these are the factors. Why this happens? Because this happens the moment we start talking about injectable insulin with our patients, a lot of myths around insulins, lot of problems, maybe interference in their lifestyle, wrong notions about insulin, maybe that they think that is end of the road. This is the last thing which probably they will like to have in their life. If we talk of physicians, then there are certain barriers, hypoglycemia on the top, whether we talk of primary care physicians or diabetologists, everyone is worried about hypoglycemia, and rightly so, because hypoglycemia is sitting in the driver's seat as far as the cardiovascular outcomes are concerned. At the same time, it is also responsible for converting a good patient into a bad patient. So that's why we don't want this to happen to our patients whenever we are talking of intensifying our treatment in diabetic subject. So why this is happening? Can we do something, or has the science done something to the type of insulins now we are having with us in addressing to these problems? And this is precisely what I will be talking about. So we have seen a lot of technological changes happening in insulin, NPH, GLA-100, then the degludec, and in 2011, we had GLA-300. What difference is that made? So has this solved certain problems? And probably we have reached to a near ideal basal insulin. Why so? Because this is having near physiological basal profile. It is practically peakless. It is truly once a day. The incidence of hypoglycemia is really, really low, especially the nocturnal one. The titration with them and the intensification with them is pretty easy. The timing, which is normally bound with the meals, is something which is not there with this generation 2 insulins. The glycemic variability, which we now talk of time in range and others, so we need less of glycemic variability that is also positively affected with generation 2 basal insulins. And then a special variety of patients, like patients with DKD or patients, those who are elderly, wherein we are really finding difficult to manage hyperglycemia, therein certainly this has a role to play. Then coming to the newer devices which has come to our hand, and that is alleviating the injection pain and some complexities which happen with the usage of pens that are also taken care of. And then COVID has given us insight as far as the telemedicine is concerned, the usage is concerned. More of us are using it nowadays, and that is something, because of the simplistic algorithms, they can be now instituted even using telemedicine. And if we talk of monitoring, then monitoring, very less monitoring is required with these long-acting basal insulins. And these are the 2 articles which are published. And we have just heard Dr. Manoj Chawla, and the expert group wherein I was also part has focused that yes, during these difficult COVID times, basal insulin initiation was something which was very handy, and that change gradually happened during these COVID times as well. So that brings me to the overview of my presentation. I'll be talking about what basal second generation insulins we are exposed to, and then a comparison between the options which are available to us, and then finally the innovative pen which is available. Now, if we talk of the changes which has happened over a period of time, we can see that the basal insulin initiation is now unanimously recommended by all organizations. And therefore, it has become a rule of thumb now practically that we have to initiate insulin with basal insulin. So premixes, probably they are sitting at the back seat, excepting for some specific indications wherein obviously we can use that. Now, what are these second generation insulin? If we talk of GLA 300 or the Glargine 300, it is just not a concentrated insulin. It is just not like any other U200 of concentrated plain insulin. It is having a different PK and PD profile. It acquires a smaller volume in the subcutaneous tissue, and then there is a slower release, and it makes the PK/PD different from its counterpart U100. And here is a difficult to perform clamp study, which talks of the differentiating points between the PK/PD profile, and you can clearly see that U300 is performing better, longer, with lesser variability using this PK/PD profile. This point has been clearly established. Coming on to the HbA1c reduction, then GLA 300 demonstrates better HbA1c reduction as compared to GLA 100 at the end of maybe 12 weeks. And therefore, achieving to target becomes easier with the use of GLA 300. So the advantages, what we have with generation 2 basal insulin over generation 1 is that it is having a stable and prolonged action more than 24 hours. It's having less glycemic variability. It is effective and sustained glycemic control, less overall and nocturnal hypoglycemia, safer during titration and maintenance phase. I'll come to this point later on. Minimal weight gain and flexibility of dosing. It is free of that mealtime association. So these are the advantages which we get with generation 2 insulins. Now, what are we having in terms of generation 2? That is degludec and U300 Glargine. So once we have these two options, we have to see what these two formulations or the compounds they actually do. The addition trial that basically compared the GLA 300 with GLA 100, and the program BEGIN compared the IDEG versus GLA 100. And in both the situations, you can see that GLA 300 had lower rate of anytime and nocturnal hypoglycemia, while the IDEG, it had lower rate of nocturnal hypoglycemia only. So there are certain subtle differences, but overall, generation 2, in terms of hypoglycemia, they are better as compared to generation 1. Now, there are certain differences if we talk of the methodology in which these insulins, they work. If we talk of GLA 300, once they are injected, it goes into alkaline pH, and therein it precipitates, and then the active metabolite gradually release from the subcutaneous milieu into the circulation. While in case of IDEG, the moment you inject, it forms multi-hexamers, and then gradually the monomers, they are released. And herein, it is 99% bound with albumin. So there are differences as far as the mechanism of release is concerned, and that makes some difference. If suppose the person is having low albumin, then certainly IDEG will have a different PK/PD. This was the first trial which compared head-on the GLA 300 versus the degludec 100. This was a multicentric, open-label, randomized, active control 2-arm trial. And in one arm, it was GLA 300 in the dose of 0.2 units per kg as per label. And in the second arm, it was IDEG 100 once daily as per label. And then it was followed up and the results, because it was to meet HbA1c target. So in both the arms, the HbA1c target was met. But what happened during this course is revealed here. During the titration phase, what is titration phase? The titration phase basically when we are trying to intensify our dosages so as to achieve HbA1c target. And here during this titration phase, which is very important, because during this titration phase, if suppose your patient develops hypoglycemia, then probably he will stop titrating. He'll become a bad patient. He will probably be gulping carbohydrates. He will not be following your advice. So if suppose that happens during this titration phase, then it really leads to not achieving HbA1c target. And if we see the head-to-head comparison, then GLA 300 performed significantly better in terms of hypoglycemia during this period, whether it is incidence or the event rates, using both the cutoffs, whether it is less than 70 or less than 54 mg/%. This sub-analysis gave us further insight, the bright renal. It gave us further insight that in compromised EGFR patients, where the EGFR was less than 60, therein more number of patients, they achieved their HbA1c target, and that too without getting hypoglycemia. So along with safety, you get a better HbA1c profile even in the renally compromised patient. And this was a good thing which happened with U300. Coming to glycemic variability, which we talk of nowadays, because if there is lesser glycemic variability, there are more chances that the person will spend time within that range. So the lower variability was seen in this CLAMP study against IDEC 100. I take this study with a pinch of salt because there is another CLAMP study which talks otherwise. But if we talk of the time in range and head-to-head comparison using CGM, then we can see that the time in range with both the options, IDEC 100 and GLA 300, that is okay. But if we talk of time below range, then we can clearly see that there is less chance of going below range with the use of GLA 300, meaning whereby that the patient will have lesser chances of hypoglycemia. Once again, it will safeguard the intensification process, which we really want in our patients. Now, these randomized controlled trials should also be replicating themselves in the real world situation. So this is OneCare randomized the real world trial using in the adult type 1 diabetic patients. And herein we can see that the time in range is practically the same. But if we are talking specifically of the range between 70 to 140 and 70 to 180, then you can see that the green bar in the lower chart is taller as compared to the pink one. And that denotes basically more number of patients, those who have attained that target. So if we talk of the number of patients achieving target without getting hypoglycemia, whether nocturnal or anytime hypoglycemia, more chances of getting to the goal with the use of GLA 300 as against IDEC 100. Another real world trial that was done in insulin naive type 2 diabetic patients. And this is the ATOS real world evidence, wherein 1/3 of the patients, they came from India. And therefore that is reflecting our type of population here also. So 1/3 patients here in India. And once again, initiation of GLA 300 in people with type 2 diabetes uncontrolled on OADs resulted in improved glycemic control with low rates of hypoglycemia and minimum weight change. This was a replication of the randomized control trial. Now, the subgroup analysis of this ATOS, which was published or presented in ADA 2021. And here, once again, this subgroup analysis is talking of the high-risk population or the critical population, that is elderly. And once again, it has shown that it is safer to use this in elderly population. At the same time, another subgroup analysis talking of the renally impaired patients, wherein once again, it is found to be better in terms of getting hypoglycemia in that sort of situation. So overall, what are the advantages of GLA 300 over IDEC 100? These are the two long-acting basal insulins we are having. So lesser glycemic variability with GLA 300, lesser anytime hypoglycemia during titration phase, lesser nocturnal hypoglycemia during titration, and lesser risk of hypoglycemia when albumin levels are low, and better time in range profiles, lesser weight gain with the use of U300. Then coming to how do we give this using devices? And when we are using various types of pens, we know that there are at times situations when the patient fumbles with different type of cartridge, different type of pen. Whenever we are trying to change the type of insulin, that leads to some problems with the usage of pen. And this is something which happens. And it's a practical problem. And therefore, there are errors in insulinization, which can happen, mismatch of cartridge and pen, which can happen, mistaking rapid-acting insulin with basal, which can be dangerous. And therefore, we need a more patient-friendly device. And herein, this is innovation, that this middle portion is basically the cartridge, which is the part of the pen as such. And therefore, it is a dedicated part of that pen. So there are no chances of mixing or maybe error once we are using this particular device. It has got certain extra benefits. It's very light. It needs very less pressure. The overall period of time is just 5 seconds required to inject the insulin. It is containing 450 units of insulin. At the same time, the pricing has also gone down, which is very important in Indian scenario. And therefore, this device has made the application or injection in a very simplistic manner, in a more aesthetic manner, in a more durable manner, and in a more functional manner. So in summary, the message is that we know that initiation of insulin is really a challenge. We need to spend nearly 20 to 30 minutes before we can really convince the person and bring him out of his all sorts of myths as far as the insulin initiation is concerned. And unless and until we initiate insulin in time, at the optimal time rather, we will not be able to achieve targets in more number of patients. And therefore the message here is that you now have a very long basal insulin, which can be really instituted without significant hypoglycemia risk in a very simplistic manner. If suppose the person can afford, this can be a very safe option. Even using telemedication, this is something which can be used, and we have been using it very successfully. So this is the message for all primary care physicians as such, that they should now try to use, at least get the taste of long-acting basal insulins and get more number of patients to their goal. Thank you so much for your patient hearing.
Thank you, sir, for wonderful presentation. Now, house is open for discussion.
Yeah.
Actually, according to pharmacokinetics, there's a little bit of difference. Since it's a depot formulation, Glargine 300, initially the biological availability differs. And so in some of the studies, it's shown that the dosage is increased if you switch from Glargine 100 to Glargine 300. Maybe after some days, it may equalize, but it may be so that initially the dose should be increased. What's your view on this?
Absolutely, because if suppose anyone is using Glargine, he will certainly come to this question. Because the moment you are trying to shift U100 to U300 dose to dose, then probably you are not going to get the same response. It is not because of the equivalence. It is because of the PK/PD profile. It acts slowly. It's a very subtly increasing sort of insulin. And therefore, it is advocated, even the literature mentions, that you can increase the dose of the initial dose of insulin by 15 to 20%. Because it is safe there, and it is going to give you that equivalence of the blood sugar reduction in the equivalence of safety profile. So it's not because of that it's lesser or acting or it's a less potent sort of option, but it is because it's a very subtly increasing and very slowly acting drug. That is the difference. And the 15 to 20% is the literature. But practically, if anyone here will be with me, then probably even if you increase the initial dose by maybe 30%, it is still safe. Anyone who is using will certainly be with my opinion here.
Thank you again, sir, for nice answering.
Thank you so much.
Thank you, respected speaker, sir, and chairperson, sir, and ma'am. We proceed now to the next session, and for that, I would like to call on stage Dr. Padma Shri Gulati, ma'am, and Dr. Vinod Mittal, sir, as chairpersons.
So now we are going to have a presentation on preventing a crisis, how to avoid glucocorticoid-induced osteoporosis by Dr. Meenal Mohit. She is consultant and head Department of Endocrinology, Manipal Hospital, Jaipur, and she's the director of Sashakt Thyroid Endocrine Diabetes Center. She has many publications and presentations to her credit. Dr. Meenal, please.
Thank you, ma'am. Good afternoon, everyone. Before I begin, I must thank Dr. Anuj Maheshwari, sir, Dr. Narsingh Verma, sir, the entire ACP team for inviting me here. Dr. Jain Panda, sir, has chosen a very interesting topic for me, osteoporosis, steroid-induced osteoporosis, and how to prevent it. Dr. Srinivasan, he has been a wonderful organizing secretary, and I must thank the entire team for inviting me here. And Dr. Mangesh is sitting right in front for my talk. Thank you, sir. Thank you, audience, for being here. So we are going to talk on steroid-induced osteoporosis, how to prevent. I think the more interesting question that is intriguing your brain right now is, can we prevent it? So, can we prevent it? Yes. Now, this is a case in 2003 where the T-score was normal, started on steroids, 1 year down the line. We did not prevent it. So there's a hunchback. What about the non-vertebral fracture incidences? Men versus women. Men is no exception. Osteoporosis is common to all. Though we do talk of women being more prone to osteoporosis, but we do have the data in men as well. So this was a study by Wenstar in more than 2.5 million patients and with matched controls. And can you see the incidence of non-vertebral fractures at hip, vertebrae? Can you see the lines? And it is entirely and clearly dose dependent. So higher dose, lower dose, and the controls. You can see men versus women, the incidence over time. What about the fracture and steroid dose? Similar data, same study. You will find that as the dose of steroids is increasing, so it is dose dependent, it is duration dependent. What about the steroid used fractures at lower BMD? You will find that as the BMD starts dipping, the fracture incidence starts increasing. You will find that the steroid exposed bones break at a lower BMD or at a lower T-score. So that is what the steroids do. This was a study in men, specifically in men, just a number of 9 people. And just can you look at the beginning dot? And over the period of time, the TA scores, the final measurements dropping at all the points. The total body score, the femoral neck, the trochanter, lumbar spine, the Watts triangle at every point. What about the role of the parathyroid hormones or the bone markers, the bone formation markers, the osteocalcin? Parathyroid hormones initially drop and then with time they start increasing. So there is a preventive or a defense mechanism by the body, but ultimately it fails. The bone markers, the bone formation stops. We are under a wrong impression that these steroids, they eat away the bones. So there is increased osteoclast or the osteoclast activity. Actually, there is initially the inhibition of bone formation. The bone turnover stops. What about the Cushing syndrome, where there is high endogenous steroids? Again, you will find that the BMD is low at all points. What are the predisposing factors? So it is the steroid dose, it is the steroid duration, it is the individual, the BMI, the family history, the genes also maybe. So you look at the graph, you will find in postmenopausal women, the fracture incidences begin at a much less BMD, at much less T-scores. Just to give you a background, how does the entire thing happens? Just we go back to our pathology classes a little. So we begin with the hematopoietic cells. These are the osteoclasts, and this is the group of osteoblasts. And we know that there's a beautiful balance, intricate balance between a bone turnover. Bone is a dynamic tissue, it's always in turnover. And we know that there's a balance between the osteoclastic activity and the osteoblastic activity. So what happens when we add steroids to it that we need to see? So normally, the osteoclasts, they reabsorb the bone. There is transforming growth factor beta. They actually stimulate the osteoblasts in turn, and that becomes the WNT pathway. And the WNT signaling pathway, the most important signaling pathway, which goes and secondary signals are there. A lot of secondary signals are there. Some of them are stimulating, some of them are inhibiting. So whenever the WNT signaling pathway is in the inhibition mode, we get a bone formation decreased. Whenever the WNT signaling pathway is in the activation mode, we get the increased bone synthesis. So that is how this WNT pathway plays the entire role. And there is something called autophagy. This autophagy you pronounce, or autophagy. This autophagy is actually the need of the nature to keep the damage under control. So whenever there are reactive oxygen species formed because of oxidative stress, the role of autophagy is to prevent the bone damage, to prevent the bone entire tissues, not only bone tissue, because autophagy plays a role everywhere. But whenever the reactive oxygen species or the oxidative stress, it overcomes the preventive mechanism of the body, the autophagy fails, and there begins the apoptosis. So whenever the autophagy mechanism fails, we'll end up with apoptosis. So now what happens? Here we add the steroids, that is dexamethasone, and the reactive oxygen species or the oxidative stress, it supersedes this defense mechanism of the body, and the bone starts damaging. The rank ligand, the receptor activated kappa beta ligand, we all know the rank ligand, that has an important role, and we have the therapies based on rank ligands. So that all defense mechanism fails, and finally the bone goes into a state of apoptosis. So now when we give high doses of glucocorticoids, the bone leads to apoptosis. When we are still dealing with low doses of glucocorticoids, the autophagy manages it. Then comes another antibody, that is the sclerostin antibody. This sclerostin antibody again plays a role in bone formation. And whenever we have sclerostin antibodies defeated by steroids, again the bone goes into a phase of stopped or a blocked bone formation. So that is how the bone faces osteoporosis under the influence of steroids. So this is the summary of the entire things that we've been talking, that this is glucocorticoids. They first lead to decreased bone formation. And after the decreased bone formation, there starts the bone resorption or bone damage. But that all does not alone lead to fractures. So we have to assess the FRAX score. So we also have to understand that we need to fall to break. So the role of muscles, we also need to have a good muscular strength. So we need to also prevent fall, right? So glucocorticoids also have a role in muscle damage. We are not sparing the muscles at all. There is a loss of muscle mass with a long glucocorticoid usage. So we have the inhibition of osteoblasts, we have stimulation of osteoclasts, we have bone loss, we have mass loss, we have muscle loss, and also probably the weak attitude or the fragile attitude of the patient because of the underlying disease for which the steroids were given. That leads to fall and fractures. Now, this understanding came to us not today, that this understanding came to us way back in 2001. So way back in 2001, we had international societies laying down different norms, different interventions, and different therapeutic measures. So the American Society gives us certain protocols that every time you are using steroids more than 5 milligrams for more than 3 months, think of prevention. Primary prevention. Primary prevention means don't allow the bones to go into osteoporosis. So start the primary prevention for all patients. Secondary prevention, only when the T-score is below -1. Calcium and vitamin D supplementation for all patients. We must remember that steroid is the leading cause of secondary osteoporosis. So we are dealing here with secondary osteoporosis. Now the UK bodies are a little liberal. They say we only give steroid, we only give calcium and vitamin D when needed. We start the secondary prevention a little later at 1.5 T-score. We give the primary prevention only above 65. So there is a little controversy between American and the UK bodies, as always. Now the role of bisphosphonates, the most easily available pocket-friendly molecule, which we should be using a little more. And the role of bisphosphonates stands in prevention as well as in treatment. So right from primary prevention, no, only calcium and vitamin D for primary prevention. But for secondary prevention, bisphosphonates definitely stand. Again, For non-vertebral fractures, with meta-analysis of a lot of studies, prevention as well as treatment, bisphosphonates do have a role. And we have once a year therapy, we have IV bisphosphonates, we have oral bisphosphonates once a week, once a month, once in a quarter, once in a year. We have all preparations, and zoledronate has a very significant role, as the literature proves. Now coming to the most controversial topic, should bisphosphonates be used for long-term glucocorticoid-induced osteoporosis prevention or treatment? So as I just told you, not for primary prevention, but for secondary prevention. So long back, because the concept or the misconcept that osteoporosis happens because of steroids causing activation of osteoclasts, the bisphosphonates had a place. But later on, it was found that the role of steroids is not to stimulate the osteoclasts, but to inhibit the osteoblasts. So it is the bone formation that is stopped first. And that is why bisphosphonates do not have a role in primary prevention. Rather, a long-term use of bisphosphonates along with steroids can lead to more complications at times. And this was one study which has shown there was some bone beaking, and that happens with the long-standing usage of bisphosphonates along with steroids. So which are the approved bisphosphonates? We know alendronate, etidronate, rezidronate, zoledronate. We have been using all of them. But out of all these molecules, one name that is osteoanabolic is only teriparatide. We have the new molecules coming up. That is, as I talked, the sclerostin antibody. The sclerostin antibody molecules are still in pipeline. We are still using in India teriparatide, that is 1:34 amino acid PTH hormone. We are not using the entire PTH. So what is the status of bisphosphonates versus the osteoanabolic molecules? Let us have a look. There are a lot of studies comparing teriparatide with the bisphosphonates, and all the studies have proved that obviously the osteoanabolic hormone or the teriparatide definitely has an edge over the bisphosphonates in the vertebral as well as the non-vertebral bone strengthening. So even if we go beyond, because Dr. Narsingh Verma is not here because he was asking me what beyond BMD. So we have the bone markers, we have the bone formation markers, we have the bone absorption markers. Though these markers are not yet in our clinical practice very valid, and they have not been validated actually, and they're not easily available in all the labs also, and they're pretty costly also. But we do have, for the research and the studies and the academics purposes, we do have the bone markers available, beginning from the PINP, the CTX, and all these bone formation markers, they dip down with the addition of steroids. And also, just to add to your information, all these changes happen very rapidly over the first 3 months, and then they settle down. So all the damage happens in the early period. So whenever you think of adding a steroid, counsel your patient to be on optimal doses of vitamin D and calcium. Which vitamin D and which calcium? That is another interesting topic to discuss. So now we have the studies comparing teriparatide and alendronate in the glucocorticoid-induced osteoporosis fractures. In terms of fractures, again, the preventive role has been in favor of teriparatides. Teriparatide versus risodronate, changes in the spine BMD. Again, the studies are in favor of teriparatide because we know that is the only osteoanabolic molecule we have so far. So calcium and vitamin D. One word here only because it's a different lecture altogether. The active form of vitamin D whenever you're using a steroid, not the cholecalciferol, but rather the calcitriol. So calcium and vitamin D, never too late to start, never too early to start, right from day one until the last. The newer molecules, that is the sclerostin antibody, that is the tocilizumab. We have another one also in the pipeline. This molecule is still not out, but this molecule acts via the sclerostin antibody. And again, this is the osteoanabolic molecule. So this will be the second osteoanabolic molecule for our usage after the teriparatide. Now, another molecule, that is beta-ecdysone. This is a steroid again, but this is a plant steroid. And this plant steroid has been taken from the plants, as you can see, the Ecthyranthus, and they are again in the research status so far. So the management algorithm actually goes that any patient to be planned or starting on steroids should be given a primary prevention. And when I talk of primary prevention, not only calcium and vitamin D, but we have to talk about the lifestyle also. The bone strengthening begins with your physical activity. And once you think of secondary prevention, then of course you have to assess for all your patients for a BMD, that is bone mineral density. Going beyond bone BMD, you can also assess the FRAX scoring. And depending upon your BMD, you have to give the patient the benefit of primary prevention or the secondary prevention. Bisphosphonates need to be added. And besides bisphosphonates, you can also think of teriparatides if you're thinking of T-score below -2.5 or you're having a doubt of fragility fractures. So I think that is all. My entire skeleton says thank you so much for being here this evening.
I would just like to make one.
Please, sir,
You
please.
mentioned,
Sir? Yeah, when we are talking of primary prevention and specifically keeping very much in focus the topic that is steroid-induced osteoporosis. The moment you introduce steroids to your patient, dosage may be anything, but specifically if you're adding more than 2.5 milligram per day, then let all of them have the benefit of calcium. The preparation can be by calcium carbonate or calcium, any other form of calcium preparation, going to the elemental calcium of at least 500 milligram twice a day. And vitamin D, specifically as recommended, the active forms of vitamin D, that is calcitriol, preferably we give 0.5 micrograms per day, 0.5 to 1. So that is the recommendations as per the American Rheumatology Associations and as per the UK Association. So calcium, vitamin D as a primary prevention should be given to all, and bisphosphonates as secondary prevention, and teriparatide, yes, that goes beyond that, depending upon the BMD scoring. Yes.
So that also.
Correct. Yes. So the lifestyle goes without saying. Specifically, if we consider that, but because we are getting biased here, we are thinking of the general population. We are not thinking of the general population. First, we have to see what are the reasons why steroid was prescribed. So definitely the patient is already facing some challenges, maybe a rheumatic disorder, maybe some other inflammatory disease which is undergoing, which is already damaging the musculoskeletal system. So the steroid is being added for some underlying disease. So the disease is affecting the patient, then the steroids are affecting the patient. So lifestyle goes without saying. The muscle strengthening has to be there right from day one. And of course, the primary prevention benefits of calcium and vitamin D that should be extended to almost all our patients. Please, sir. Bisphosphonates leading to fractures is depending upon the dosage and the length of usage and your justified usage. Otherwise, bisphosphonates are a molecule which are known to prevent osteoporosis, and we are using them to prevent osteoporosis, especially in proven BMD cases with T-scores below 2, -2 or to -2.5, and to a period of say 2 years or maybe up to, even they have been recommended up to 10 years. Teriparatides, we go up to 2 years, and bisphosphonates, we are giving up to 10 years also. And the zoledronic acid specifically has been documented as on an annual dose basis that yes, it's safe and it prevents, it does not rebuild the bone. It's not an osteoanabolic molecule, but it just helps to prevent the further loss of bones. Yeah, but that is when we are talking of the weekly dosing or the monthly dosing. When we're talking of the annual dosing, yeah, monthly dosing, then you can give a drug holiday. So there is, again, there's a bone mineral dynamics that changes. So there's a balance, the disturbed balance between the osteoclast and osteoblast, the bone formation changes, the bone, actually the bone mineral density changes. As there were studies showing there's a bone beaking is there. the stress fractures can happen.
Okay, any other comment?
The thiazolidine-diones, the glitazone-induced fractures you are talking of, sir. Yeah, the same mechanism, same pathology, because even they are causing a decrease in bone mineral density. So the glitazones can be combined with a preventive strategy of calcium and vitamin D. And also they can be combined with bisphosphonates depending upon your BMD scoring. You have to assess the BMD score. Thank you so much, everyone. Right.
With this, we move on to the next session. And for that, let us have as our chairpersons, Dr. Minakshi Bhattacharya ma'am and Dr. L. Srinivas Murthy sir.
Thank you. Good evening, everybody, and trust me, today's program is really very special to me. I'm at Goa. For the first time, I'm on the ACP's platform. I have my mentor and my close friend right in front of me. I have another close friend of mine who's introducing me, and there cannot be any better combination. The topic that is given to me of crippling illness, ILD. Is it preventable? And my talk is not going to be as impressive as my previous speaker's talk, where she spoke about preventing osteoporosis. No, I cannot prevent interstitial lung disease. Interstitial lung disease people who suffer, we can try to improve their quality of life to some extent. And the program has got just another flavor, as another close friend and mentor is here, Dr. Andip Guleri. My sincere thanks to my teacher, Professor Director Dr. K.C. Mohanty, Jayanta, Srini, of course, Dr. Muruganathan, Mangesh, all of you, educational partners to today's program, and of course, Dr. Anuj Maheshwari, team, and all my patients who gave me chance to learn respiratory medicine and probably be here in front of you. This technology is ILD, a death sentence once upon a time. When I was a student 22 years ago, a death sentence. Patients do not improve. They are put on steroids, and what was discussed in the previous talk, they have all possible complications because of steroids. They either die of their disease, illness, crippling respiratory failure, or die of drug-induced complications. And it makes me talk to you about this
do not take life too seriously. You will never get out of it alive. But do to take your ILD seriously. You will not get out of here for sure, but not only you, your entire family, all close relatives, dependent people suffer because of it. And I was talking to Dr. Muruganathan, sir, how do I explain the importance of this crippling disease? You know, people are paying more attention to diabetes. They're more worried about hypertension. They're more worried about heart diseases. But somehow,
जा सिमरन जा जी ले अपनी जिंदगी
कल की ट्रेन से आती हूँ।
And while coming from the airport, you know, there was a radio ad and they were talking about, she was so breathless, the interstitial lung disease, you know, that is what patients suffer. You send it to me, sir. And so you can't really enjoy your life to your full extent. The simple pleasures of life, like running away with somebody, you have to do it on the next day. There was one ad on the radio while I was coming from airport to the hotel. And it was about some news channel, you know, and they was talking about conquering the world. They said, India ko jeetna hai to pehle India ko samajh lo, you know. If you want to conquer the country or world, whatever, you need to understand the world. And I was just relating it in my mind. If we really want to prevent interstitial lung disease, first, we have to understand interstitial lung disease. And that's what I'm going to do for next 15 or 20 minutes. I'm going to be talking about interstitial lung disease. So it refers to a diffuse parenchymal lung disease, and it is a group of about 150 different type of disease. A distinct clinical presentation, as well as a radiological and pathological finding, may help you characterize each interstitial lung disease. There are various key differences between clinical presentation and more frequent COPD diagnosis. So whenever a patient come to you, you may end up, you may end up misdiagnosing them as interstitial lung disease. And a term, interstitial, is misnomer, since it not only affects the interstitium, it also involves the cellular and the interstitial components of alveolar wall, including the alveolar spaces. And hence it is more appropriate. Nowadays, we're not labeling it as interstitial lung disease, we are calling it as diffuse parenchymal lung disease, or something called as DPLD. So I was just preparing while preparing for this small talk, I was looking at my data and what kind of patients are referred to me as COPD. And when I looked at it, out of 100 patients who were referred to me as COPD, as a chest physician from my colleagues, only 45 were actual COPD and 23 had interstitial lung disease. 7 had uncontrolled asthma. There were few patients who had GERD, few patients who have occupational lung disease, even one had bronchiectasis. When I looked at what kind of interstitial lung disease I am seeing, I'm in Bombay, out of last 48 ILDs that I had, the majority of chunk was IPF. IPF is idiopathic pulmonary fibrosis. I had sarcoid, vasculitis, cryptogenic organizing pneumonias, and a significant proportion of patients would remain unclassified in spite of doing whatever limited workup that we can do in our practice. And now in COVID times, you're seeing a lot of organizing pneumonias also presenting as interstitial lung disease. This is how we look at interstitial lung disease spectrum now. We're looking at interstitial lung disease of known causes. Say you have a particular collagen vascular disease, something that you physicians manage far better than what we do. You have drug-induced lung disease. You have granulomatous ILDs. Look at the third column, like sarcoidosis, like tuberculosis. You have certain uncommon unique entities like lymphangioliomyomatosis. You have eosinophilic pneumonias, etc. And comes a bigger chunk of what is there in blue, idiopathic interstitial pneumonias. And out of the idiopathic interstitial pneumonia, the major chunk is with idiopathic pulmonary fibrosis. And then you have various other diseases in that. You have even the cryptogenic organizing pneumonia, or something what we saw now with COVID, the kind of organizing pneumonias. And when you take evaluation, when you take clues from their presentation, you get to narrow down your differentials. So whenever there is rapidly worsening, rapid onset disease, you're talking about probably post-infectious, something we saw in this viral infections, or you could see it with variety of viral infections as well. It could be acute hypersensitivity pneumonia. You could see with smoking, RBILD, DIP. You could see occupational pneumoconiosis, or you may have even drug-induced interstitial lung disease in that appropriate setting. When you have patient presenting to you with hemoptysis, and when there is a suspicion of interstitial lung disease, you're talking about probably a alveolar hemorrhagic syndrome. You're talking about lymphangioliomyomatosis. You may be talking about superimposed infections. If patient has got pleurisy, it may be connective tissue disorder related interstitial lung disease. If they have ocular symptoms, again, vasculitis, again, rashes would mean a connective tissue disorder. Exposure to organic antigen would clinch diagnosis of hypersensitivity pneumonitis. If there is dryness of eyes, dryness of mouth, you know you're talking about probably Sjogren syndrome. Myalgia, muscle weakness would point to various connective tissue disorders. There are various presentation also would give you idea about etiology, like anybody presenting in 5th or 6th decade, you know, generally it is idiopathic pulmonary fibrosis. Male patients, chances of idiopathic pulmonary fibrosis are higher compared to women. And when it is relatively younger age, you're talking about connective tissue disorders or sarcoidosis, etc. This is a classical radiological finding of idiopathic pulmonary fibrosis. Radiology have really changed the way we look at interstitial lung disease. And to my mind, IPF diagnosis is must, because idiopathic pulmonary fibrosis is a different treatment. Rest all ILDs will require steroids. But in idiopathic pulmonary fibrosis, steroid is not at all useful. In fact, it is more detrimental. It does more harm to your patient. And CT scan, HRCTs done properly could clinch diagnosis in most of these cases. So you have idiopathic pulmonary fibrosis pattern where there is no mediastinal involvement, when there is no pleural involvement, it's purely a parenchymal involvement. It is mainly, there is a apices and the basal involvement. You have stakes of bronchiectasis. There are piles of bronchiectasis, one after the other bronchiectasis, layers of bronchiectasis you see in periphery, and there is not much of mosaic pattern. There is not much of ground glasses. There is not much of air trapping is the classical feature of idiopathic pulmonary fibrosis. You see this picture, and this is the picture of NSIP. You see more of consolidation. You see more of air bronchograms, and you see this picture. This was the case of actually a Sjogren syndrome. This is what I was talking about, a classical, you see multiple layers of bronchiectasis at the periphery and no air trapping, no ground glassing. This is a classical case of idiopathic pulmonary fibrosis. This is what we see in COVID. You see a peripheral line. You see a peripheral sparing. You see a dark line at the periphery. This would go against idiopathic pulmonary fibrosis. This is a feature of organizing pneumonia or hypersensitivity pneumonitis. And the next slide is showing IPF to give you a comparison idea. This is the ground glassing. Whenever you have ground glassing, you take deep inspiratory and expiratory cut. Many a times even mosaic pattern or air trapping would present with ground glassing. Once you have ruled out that, this would mean hypersensitivity pneumonitis, PCP, NSIP, even fluid there, even bleeding there in the lungs would present like this. But this is not a feature of IPF. The whole idea is to differentiate IPF from non-IPF radiology. Pleural involvement will give you different set of differentials. Associated adenopathies and the curly B lines will help you narrow down your differentials of interstitial lung disease. Coming down to IPF, it is defined as specific form of chronic fibrosing interstitial pneumonia, which are limited to lungs. COPD is a systemic disease. You have variety of system getting involved in COPD, but in IPF, it is only lungs which are involved, with histopathology of UIP pattern on surgical biopsies. It is very important to understand when I say UIP, pneumonia does not mean infection. It is only inflammation. And when I say usual, it means that most commonly the histopathological feature that you see on slides starts little late, 5th decades onwards, rarely seen in 4th decade. General survival is poor, untreated, life expectancy only 2 to 3 years. And it is associated with a classical sign of UIP on radiology. Initially, we used to believe we don't see many cases of IPF in India, but we have enough studies which has come from country all over and believe that, yes, we also have decent cases of IPF. And in fact, a lot of us believe that after viral infections, like what happened in COVID, a small subset of patients may behave like idiopathic pulmonary fibrosis and may have disproportionate fibrosis going on in them. Risk factors: male, old age, smoking, certain infections, GERD, associated genetic link between diabetes and other metabolic disorders. Environmental factors also play important role. Very gradual to begin with. Patient have cough. Breathlessness comes up little later. Digital clubbing is seen in significant proportion of those patients. And the disease eventually progresses the entire lung, have respiratory failure. Patient eventually may develop pulmonary hypertension. If patient is a smoker, you may have a combined feature. So they may have emphysema because of smoking, and you have something called a CPFE, combined pulmonary fibrosis and emphysema kind of presentation. So you will make diagnosis of IPF if patient is has cough and unexplained breathlessness, where you have ruled out other causes of diffuse parenchymal lung disease, like, patient is not on any treatment, there are no genetic disease, patient does not have connective tissue disorders, and you will do their lab investigation, you will do their spirometry, you will do that CT scan, and would give you diagnosis. In a doubtful situation, you may have to subject them to biopsies, that is open lung biopsy. Earlier, we used to believe that there is some insult, chronic inflammation, and fibrosis. Now we believe it is the repeated inflammation, repeated injuries, which leads to aberrant wound healing, and that results into pulmonary fibrosis. Histopathology is not done by and large nowadays. Currently, the idea is to do a multi-speciality joint consultation for doubtful cases. If everybody does not agree on the same page and there are doubt for this, especially when patient is younger patient, you may subject them to biopsies. Otherwise, in situation, CT scans, clinical evaluation, ruling out other disease would clinch diagnosis of idiopathic pulmonary fibrosis. If you do that lung biopsy, there are various patterns which talks about UIP pattern, probable pattern, possible UIP pattern, or the features which are not suggestive of UIP. When you don't do surgical biopsy, if you have excluded other causes, if classical radiology features are there, and if patient has got bibasilar Krebs, you do their spirometry, which is restrictive, you can safely make the diagnosis of idiopathic pulmonary fibrosis. HRCTs, there are different patterns. That is UIP pattern. The classical pattern is subpleural disease distribution, basal predominance, reticular abnormality, honeycombing with or without traction bronchiectasis. So whenever you have this kind of distribution, without any pulmonary, without any pleural involvement, without any lymph node involvement, you can be certain that this is idiopathic pulmonary fibrosis. This is the same thing. You can see these arrows which are shown. You have a peripheral distribution with stakes of bronchiectatic reticular shadows. So whenever you have suspected interstitial lung disease of IPF variety, if there are no other connective tissue causes, no drugs, no exposure responsible, you can get CT scan done. CT will give you UIP pattern, and your diagnosis of idiopathic pulmonary fibrosis is made. If there are other treatable causes, other identifiable causes, there is a lymph node there is a distribution which is a perivascular, they are talking about sarcoidosis, if there are lymph nodes, etc., fungal infections, etc., etc. It is non-IPF and you would treat them accordingly. If there is any doubtful area, you may subject them to investigations like open lung biopsy. Management, luckily 2014, 2015 has been game changer, and whatever treatment we tried earlier had failed, and it was concluded that there are only 2 drugs which has shown some improvement in patients of pulmonary fibrosis, idiopathic pulmonary fibrosis, and that is nintedanib and pirfenidone. And we have a negative recommendation for all other drugs, including sildenafil, macitentan, bocetan, anticoagulation. There was a very popular treatment of prednisolone, azathioprine, and acetylcysteine. All these studies were proved useless, and there was some evidence for nintedanib and pirfenidone. I would just show you the comparison between these 2 drugs. This is a tyrosine kinase inhibitor, whereas pirfenidone is inhibitor of TGF-beta. Both have shown good efficacy of slowing FVC decline. You know that it is not a reversible condition. Once you have IPF, it is not going to revert. It can only progress. And when you do this intervention, probably the rate at which they are worsening can be reduced. And that is what is demonstrated in nintedanib, shows FVC decline by 50%, and so was seen in pirfenidone. By and large, both drugs are good. And unluckily, we don't have head-to-head comparison between these two. We don't have a data where we have combined both drugs. So we are going to learn more in time to come. Yes, lung transplantation is possibility, and there are various centers in India also. We have started lung transplant. In fact, there were a couple of 2 doctors who underwent lung transplant. IPF patient must be picked up early for lung transplantation if situation permits. So if you have a patient whose fairly decent lung functions maintained, does not have any other comorbidities, can be considered for lung transplantation. There are some important facts which I thought I would bring it to your notice. That majority of the patient should not receive mechanical ventilation. You know, by and large, once this patient have got decline in their IPF status, that means it is not infection related, it is not complication related, it is not pneumothorax that patient has got. And if this patient requires ventilation, most of them will not do well. You may not be able to save them. A minority of them may. Majority of patient of IPF should be treated for pulmonary rehabilitation. You know, pulmonary rehabilitation, though, is very well studied for COPD patients, but even in IPF patient, they would do well. In certain patient, it may not be reasonable. Majority of the patient should be treated with corticosteroids when they have exacerbation. But in small proportion of patient, it may do more harm. Pulmonary hypertension, by and large, in IPF should not be treated because it is due to hypoxia and it is generally a secondary one. You don't really need to treat it. But in some patient, when there is disproportionate pulmonary hypertension, it may be reasonable to treat. And asymptomatic GRD may also require attention in few. Palliative treatment, yes, we need to pay attention to that. We need to look after a lot of other needs of the patients. And like you see in asthma, like you see in COPD, even idiopathic pulmonary fibrosis patients also has got multiple phenotypes. You have a rapid worsening patient of pulmonary fibrosis. You have patient of pulmonary fibrosis who get frequent exacerbations. You have IPF patient who has a very slow decline in their lung functions. You may have IPF patient who's got associated air trapping, who may have associated COPD, and you may have IPF patient with pulmonary hypertension. Yes, future is very interesting. We may be doing genomic study. We may be identifying this patient. We may have certain tests helping you. One more minute. Future is very bright. There are a lot of studies in various phases of studies. You have at least 10 or 12 different molecules would be available at the end of next 5 years. I would end my presentation by saying that prognosis in idiopathic pulmonary fibrosis is unpredictable, it being a progressive disease. Early diagnosis, appropriate management is vital to maintain quality of life and slow down the disease progress. Disease management is crucial and includes anti-fibrotic therapy, rehabilitation, management of comorbidities, supplementation of oxygen, social psychological support, lung transplantation in selected patients, and one must enroll them into clinical trial as and when possible. I would thank you by saying that though IPF cannot be prevented, so most of the ILDs, but we have a few options that can help improve the quality of life of our ILD patients. Thank you very much for your patient hearing.
Thank you, sir. That was really very clear and nicely explained talk, and with all of practical tips. Sir, you have any question? Okay. Sir, you can discuss on the tea time, sir, tea break. Yeah. So we all are running. Sir, we are running short of time. So we will discuss and we won't leave him like that. We'll discuss. Thank you so much, sir.
Thank you, sir. We will now proceed. Let us now proceed to the next session. It will be chaired by Dr. M. Shanmugvelu, who will be joining us virtually. And it will be chaired by Dr. Mangesh Devaskar, sir, and Dr. Anuj Maheshwari, sir, on the dais.
Dr. Shanmugavalu.
Yes, sir. Good afternoon. Very good afternoon. Nice to meet you all. Yes, sir.
Welcome you virtually.
Yes, sir.
So,
Thank you so much.
Would be very happy if you like to introduce the topic, or we can expect some comments from you at the end.
Yes, sir.
So before that, I'm just introducing Bansi. Or would you like to introduce Bansi? I think.
Sir, you can introduce Bansi. I'll give a few introductory notes on the topic. Yes, sir.
So Dr. Bansi Sabu is a personality. I don't think any introduction he needs, at least across the world. So everyone knows him very well in the world of medicine, diabetes across the world. He is the chief diabetologist and chairman of Diabetes Care Hormone Clinic at Ahmedabad. He has been president, one of the most prolific and dynamic president of the RSSDI. Just finished his term, and now he is the immediate past president of RSSDI, and leaving so many good and wonderful legacy for others to follow it, and of course wonderful memories of his tenure. So not wasting much time, over to Dr. Bansi for his topic, that is vitamin D.
Let me take a few introductory. Yes.
Would you like to say something?
Yes, sir. Yes, sir. Yes, sir. Respected chairpersons, learned viewers and listeners of this program, I thank the organizing committee members, Dr. Anuj Maheshwari, Dr. Srinivasamurthy, and Magesh Chivashkar for their kind invitation. And I also feel extremely happy and honored for their kind invitation. Of course, rickets, scurvy, beriberi, and other such diseases were known for centuries. The cause of them remained elusive until the 20th century. We have today Dr. Bansi Sabu with us, who will take us through his presentation covering the timeline, which shows the chain of research and events that led to an understanding of vitamin D in biological system and to the development of some of the medical uses. Over to Bansi ji.
Thank you. Thank you, Dr. Shamangvelu, for kind introduction. Thanks, Dr. Anuj, Dr. Mangesh, for kind introduction and kind invitation also to ACP. Thanks, Dr. Srinivas Murthy. I acknowledge presence of RSSDA President, Dr. Vasant Kumar sir here, President-elect, and Sanjay also. And my immediate past president before me is Dr. Rajiv. So the topic given to me is vitamin D discovery of the century, that I will be trying to complete it in next 20 minutes. Before the 20th century, it was not possible to describe the essential of diet that support life, growth, and reproduction of higher animals. Discovery of vitamin A by McCollum and Davis in 1913 ushered an era of accessory food substances, culminating in achievement of that goal. It included the discovery of vitamin D and its production in skin caused by ultraviolet light. Although rickets, scurvy, beriberi, and other such diseases were known for centuries, the cause of them remained elusive until 20th century. Sir Edward Melviny in Great Britain has been very concerned with the extremely high incidence of rickets in United Kingdom, especially in Scotland. In fact, disease became known as an English disease at that point of time. And following the introduction of, vitamin D, when it was given, rickets almost disappeared as a major medical problem in 1935, and then it remained in a quiescent state. So, we started in early 19th century, and within 30, 35 years, 40 years, they thought that vitamin D is primarily for preventing the rickets, and then rickets had gone. And now then everything had reappeared. And so the topic which is given to me is that vitamin D is a molecule of the century, which started in 19th century as a molecule of anti-rickets, and the deficiency was leading with a calcium problem and all bone problems. And now we know that a lot of data of vitamin D with NCD and with cardiovascular disease also. What we know that it is a hormone precursor that is present in two forms, ergocalciferol and cholecalciferol, which is ergo is present in plant and some fishes. Cholecalciferol or vitamin D3 is synthesized in skin by sunlight. Vitamin D3 is a fat soluble vitamin that I'm sure everyone of us knows about it. It regulates secretion of insulin, which controls the blood sugar. So this is something also that other than that, what we know about it, it also has some effect on diabetes too, because it has effect on pancreas too. It is essential for normal activities of heart, brain, blood vessels, and kidney. So vitamin D is not only a hormone or not only a vitamin which is only related or regulating the bony system, but it is also essential for heart, brain, and blood vessels and kidney. It also have an effect on normal growth of hair and skin. It regulates immune system and defense mechanism against microorganisms. The sources are from sunlight, and from intestinal absorption is only 15%. So directly whatever which we are eating through the food, only 15% can be absorbed through that also. The foods containing milk is for the vegetarian, the mushroom and yogurt, and cod liver oil, salmon, fish, cheese, and egg yolk is also for the rich sources of vitamin D. The physiology is at the skin with the ultraviolet rays, pro D3 in change in pre D3. Then it is in active vitamin D3, vitamin D3 in the liver with 25 hydroxylase vitamin D, and then at kidney it has 1 and 25, which has become very active, and that acts one at side intestine to increase the calcium and phosphorus absorption, and other side it acts at bone also to mobilize the calcium store. And that's how it maintains the calcium and phosphorus that is required for bone health, required for neuromuscular function, and also for metabolic function, where we are more interested. The oral vitamin D supplementation in some of the gastric condition or GI disorder, where it has to be given lifelong in a higher dose, which are cystic fibrosis, Crohn's disease, celiac, chronic pancreatitis, and short bowel syndrome. Vitamin D suppresses renin production through nuclear receptors. So this is something at the level of kidney, how it acts at and suppress the plasma renin activity, which is responsible. Increasing plasma renin activity is more for the renovascular disease or nephropathy, or more chances of hypertension. So vitamin D have an effect at the renal level also by decreasing the renin production and suppress the RAS activity. So vitamin D deficiency increases the renin activity. It increases angiotensin converting enzyme activity. It increases angiotensin 2. It decreases ACE2, and it decreases angio from 1 to 7 also. Angiotensin 1 to 7. And that's how it increases the parathyroid hormone PTH and decrease in calcium. So then there are multiple effects of vitamin D which are seen. It is not only the cardiovascular, where smooth muscle calcification and cardiovascular disease gets increased. It also have effect on vascular system, where increasing the hypertension, but it also have the effects on lung. So it is increasing the lung injury and susceptible to infection. I will show some newer data related to vitamin D deficiency and COVID. It has got effect on pancreatic system, where increasing the insulin resistance, decreasing insulin sensitivity, and increasing the beta cell apoptosis, where it increases also the incidence of metabolic syndrome and diabetes too. The prevalence of vitamin D deficiency in our country is almost 80 to 90% of general population. Children, young, middle-aged, elderly, all are at higher risk of vitamin D deficiency and insufficiency all over the world. So even they may not be significantly deficient, but insufficient are many. The status of vitamin D, it is deficient when we call it less than 30, insufficient between 31 to 39, and sufficient when it is more than 40 nanogram per ml. Signs of vitamin D deficiency is like any other non-communicable disease which does not have any symptoms, but some of the patients who may have some problem like bony pain may be there, or some of the comorbid condition like obesity, psoriatic patients, high blood pressure, these are the patients, they may have significant vitamin D deficiency also. The role of vitamin D deficiency in diabetes, I can say both the conditions are like everyone is vitamin D deficiency. Simultaneously, we are seeing a lot of diabetic patients also. But vitamin D improves the body sensitivity to insulin, the hormone which is responsible for regulating blood sugar levels. So vitamin D, improving vitamin D status, probably we are decreasing the insulin resistance. Also, vitamin D helps to regulate the production of insulin in the pancreas. This is the one paper which is published in 2019 in Indian Journal of Diabetes and Endocrinology to see the prevalence and clinical epidemiology of vitamin D deficiency in patients with type 2 and with hypertension. This is a cross-sectional observational pan-India study, and which has talked about 1,599.5% patients who completed the study. Out of them, 500 were type 2 diabetes, almost similar number were having hypertension, and few patients, 500 patients around diabetes and hypertension both. overall prevalence of low vitamin D deficiency was seen in 83.7%. So I mean, and out of them, 82% of the patients were newly diagnosed. So in newly diagnosed patients it was found to have more prevalence of low vitamin D amongst patients with type 2 diabetes was 84.2, hypertensive patient was 82.6, and those in combination of hypertension and diabetes, it was almost like 84.5% respectively. So it is prevalence of vitamin D deficiency is very high in the patients who have diabetes, those who have diabetes and hypertension. What's the potential mechanism in modulation of diabetes? Vitamin D and insulin sensitivity. There are direct actions. It stimulates expression of insulin receptor. It activates PPR alpha gamma with transcription factor implicated in fatty acid metabolism, skeletal muscle and adipose tissue. It regulates extracellular calcium influx through cells. It has got anti-apoptotic effect, and it is also having the effect through RAS mechanism also. This is a one paper which is talking of low baseline vitamin D were independent predictor of increase in HOMA-IR and decrease in ISCI comp in subjects who develop hyperglycemia, including pre-diabetes and diabetes. So these are multiple papers which is talking about this is a prospective study which shows an independent association between vitamin D level and onset of hyperglycemia. So not only it increases metabolic syndrome, pre-diabetes, as well as incidence of diabetes too. Does we have the effect on other side that by supplementing vitamin D, does it improve the glycemic control or decrease the insulin resistance in a pre-diabetes population? In a meta-analysis with a controlled clinical trial that assess glycemic outcome measures among adults at risk of type 2 diabetes, including pre-diabetes, overweight or obese. And this is the paper which is talking that the significant effect of vitamin D on A1C also. So one side, when we were talking that vitamin D deficient people have higher incidence of diabetes, pre-diabetes or metabolic syndrome, but does we have the effect of by adding the vitamin D? Is there an effect? Yes, there is an effect that by adding the vitamin D to the people with the diabetes, there was a decrease in A1C level also. So the vitamin D deficiency in type 2 diabetes are escalating health problems worldwide. The results suggest that vitamin D supplementation improves glycemic control and attenuates insulin resistance in pre-diabetes or individuals who are at the risk of developing diabetes. And vitamin D supplementation may offer an affordable, safe, and accessible preventive measures. I mean, this is one of the easiest way by which we can give. Higher vitamin D level increases the survival rate. And this is one paper which is talking that, but it's not like by giving them vitamin D that increases the survival rate, but it is those who have good vitamin D, sufficient vitamin D, they found to have better survival in compared to those who are deficient. There is a link between vitamin D deficiency and coronary artery disease and cardiovascular disease. Inverse association with vitamin D level and risk of acute myocardial infarction. Coronary artery disease attributable to inverse relationship, and which is a marker of MMP9, a marker of myocardial remodeling after acute myocardial infarction. Those with vitamin D deficiency but not having prior cardiovascular disease has twofold increased risk of first cardiovascular event in 5 to 7 year follow-ups. I mean, you can see that it is almost like those patients who have diabetes and having heart disease, the similar way vitamin D deficient people are also at the higher risk of developing coronary artery disease. Vitamin D levels predict the risk of adverse events after acute myocardial infarction also, and with cardiac surgery with 40% risk reduction with the level who have more than 7.3 nanogram per ml. In over 3,000 subjects who are undergoing angiography, severely deficient individuals, it means less than 10 nanogram per ml, had 3 to 5 times higher risk of dying from sudden cardiac death and heart failure, and 50% increased risk of fatal stroke over 7-year follow-up period. This is one paper which is level of vitamin D and cardiometabolic disorder. It is a systemic review and meta-analysis which is talking of overall high level of vitamin D are associated with 43% risk reduction in cardiometabolic disorder. This is one paper which is talking of increasing vitamin D level, decrease the relative risk of cardiovascular disease. This is the data from meta-analysis of several prospective study which is indicating there is an inverse relationship between vitamin D and relative risk of cardiovascular disease. So vitamin D and heart, it is like almost lower vitamin D mean higher risk of cardiovascular disease. And can we consider is a vitamin D in new therapeutic options for prevention of coronary artery disease also. But at this point of time, we don't have sufficient data that by giving or supplementing vitamin D, will it decrease significantly the coronary artery disease. But there is a direct relationship. It is shown that lower the vitamin D, higher the risk of developing the coronary artery disease, acute myocardial infarction, as well as sudden cardiac death also. So what's the directly, it has actually low vitamin D have effect on higher blood pressure, more metabolic syndrome, more pre-diabetes, more diabetes, more atherosclerosis, more inflammation, more heart failure, and they all increase the cardiovascular disease. This is a paper which is talking of observational study have shown that low vitamin D are associated with adverse cardiovascular risk profile and significantly increased risk of cardiovascular events also. There are immune effects of vitamin D also. So, I mean, we talked about the metabolic syndrome, we talked about the cardiovascular disease, we talked about the vitamin D association with diabetes, and we had shown also that how supplementing vitamin D actually decrease A1C level also. But immune effects of vitamin D is a multiple effect of immune problems occurs with the patients who have vitamin D deficiency, and this has been seen in evidence with COVID-19 also. Vitamin D deficiency may increase the chance of enveloped virus infection. Risk of enveloped virus infection is increased by 50%. So vitamin D deficiency were having more risk of COVID infection also. This is in paper which is published in American Journal of Respiratory and Critical Care Medicine just recently in 2020. Low vitamin D status occurs in 90% of the patient with ARDS, and it is associated with longer duration of mechanical ventilation. Retrospective analysis of this alveoli trial had shown 476 patients who were studied. 90% were meeting with IOM criteria, were deficient of vitamin D, and deficient patients have fewer days of mechanical ventilation than other patients. And there's a crude mortality was higher in deficient group in compared to other patients. And the results was showing those patients who survived and those patients who died. The patients who died were having actually very low vitamin D in compared to the patients who survived. There is a evidence for vitamin D deficiency in COVID-related deaths also. These are the patients who are not having any deficiency. You can see on the right side, the green, they were having not so serious COVID problem in compared to the patients who are critically ill and the severe COVID infection were there and they were hospitalized. 50% or more than 50% of them were actually significantly vitamin D deficient with less than 20, while almost 90% of them were having vitamin D deficiency, which is less than 30. So COVID-related death, COVID-related hospitalization, COVID-related severe infection was also found to have more with those who have vitamin D deficiency. Conclusion from this study had shown that maintaining high vitamin D is actually highly protective against COVID-19. There are studies which had shown that 6,000 to 10,000 unit or up to 250 microgram per day, up to 20 times the current recommendation is required for combination of sources to maintain blood glucose level of, blood vitamin D level of more than 40 nanogram per ml. This is one paper which is effect of calcifidol treatment and best available therapy versus best available therapy on intensive care unit admission and mortality among patients who are hospitalized again with COVID-19, a pilot randomized clinical study, and which is talking about high dose of calcifidol or vitamin D significantly reduce the need for ICU treatment of patients who are requiring hospitalization due to proven COVID-19. This vitamin D seems to able to reduce the severity of the disease, but larger trials with groups properly measured will be required to show a definitive answer. Vitamin D sufficiency, which is at least 30 nanogram per ml, reduce the risk of adverse clinical outcome in patients with COVID-19 infection. And this is a data of 235 patients who are with COVID-19. It is reasonable to recommend vitamin D supplementation among the guidelines recommended by Endocrine Society to achieve a blood level of vitamin D at least 30 nanogram per ml to children as well as adults to potentially reduce the risk of requiring the infection for all COVID-19 patients, especially those being admitted into the hospital. So this is a recommendation by Endocrine Society, which is the largest society of US of endocrinologists. This is COVID infection positivity rates associated with circulating vitamin D, and it had shown that lesser the vitamin D, there is a higher the risk of COVID infectivity too. And this both the paper had shown that COVID positivity is strongly and inversely associated with circulating vitamin D level, a relationship that persists across latitude, races, ethnicity, sexes and age ranges. So across the world, anywhere in the world, it had shown that there is a direct linkage between the immune problems and more COVID infection in the patients who are having vitamin deficiency, vitamin D deficiency. This is also in paper which is talking about the statistical reduction in D dimer and ventilation requirement in vitamin D replete group. So those patients who are having less vitamin D have higher D dimer as well as they require more ventilation too. Last slide, the conclusion from this study had shown that vitamin D deficiency may be associated with worse outcome with COVID-19 infection, and short-term high dose of vitamin D supplementation had shown in a particular from India study had shown beneficial in the patients with the COVID-19 infection too. This is one paper which is an open randomized 10 weeks prospective study on the efficacy of vitamin D in vitamin D deficient patient, and it had shown the symptomatic relief earlier in compared to the patients who were not on vitamin D. This is an endocrinology and metabolic syndrome paper is talking about adults who are vitamin D deficiency may be treated with 60,000 units per week, and then they should be on maintenance dose of 1,000 international units per day. So the take-home points is vitamin D deficiency is associated with increasing risk of heart disease, diabetes, blood pressure, poor immune response to infection. Vitamin D plays a vital role in normal functioning of heart, brain, blood vessel, skin, hair, and regulation of insulin secretion by pancreas. Regular checking of vitamin D level is necessary in many of us, irrespective of comorbidities. Vitamin D daily supplementation, which is 1,000 to 2,000 international units per day, or monthly 60,000 60,000 international units per month is recommended. Recent studies on vitamin D suggest strong evidence between vitamin D level and COVID-19 outcome, irrespective of age, sex, and latitude. Optimal vitamin D level, which is more than 40, appeared to confer better immunoprotective response against COVID-19. An increase in morbidity and mortality in COVID-19 patients with severe vitamin D deficiency is also been found with this. Thank you. Once again, thanks to both the chairperson, and let's go outside to get some sunshine. Without any question. Thank you.
Thank you, Dr. Bansi. That was, as usual, a rocking presentation. And because of the shortage of time, we will not take any questions as per the instructions from the organizers. Okay. So let's move to the next session. Okay.
Thank you.
Over a small memento to Dr. Shabu. Very nice presentation. Actually, yeah. Dr. Shabu's presentation has proved that actually what has been opined by the whole world in the management of collagen vascular disease after the steroids, the greatest discovery is vitamin D. So in many fields it has come, and he has very rightly substantiated the use. We'll move on to the next station. Thank you, Dr. Samgovelu. Thank you, Professor Maheshwari and Dr. Mangesh.
With this, we move on to the next session, and for that, I would like to again invite Dr. Anuj Maheshwari sir on the stage as chairperson and Dr. Srinivas Murthy sir as chairperson.
So, welcome again. So next session is a very important and very good session. You are going to listen by a very learned foreign faculty is Dr. Sugiro Hamaguchi. Sugiro Hamaguchi is the ACP member from the Fukushima Medical University. He is working in the Department of General Internal Medicine. And the good thing is that Sugiro Hamaguchi is the scientific chair of American College of the Physician Japan chapter. So many a times when I visited Japan or when I spoken in the ACP Japan chapter, he was the person who has assigned a topic to me. And for the first time, I am getting an opportunity to invite him on ACP India chapter. And we are really very happy and lucky to have you, Dr. Sugiro, on our forum. Over to you for the very innovative and very good topic, that is approach to fever of unknown origin, which is very much required now. Over to Sugiro.
Thank you very much, Dr. Maheshwari, for inviting me as a presenter in this prestigious ACP India annual meeting 2021. And next year, I will be chair as well. So I would like to invite you as well again. So I will share the slide. Can you see my slide? Okay. Today I'm talking about an approach, fever of unknown origin. I hope that makes your FUO easy. So to think about FUO, the important question is coming to our mind. Is the FUO a true one or only yours? Approach to FUO has two things to do. Reducing no diagnosis for you, getting authentic FUO, then think about differential diagnosis. I will present one case. 71-year-old female who was previously healthy. 2 months before, she started having loss of appetite and fever, and 4-kilogram body weight loss for the past month. And she went to a nearby hospital where she was found to have anemia, but there was no abnormal findings in non-abdominal CT imaging. And she was referred for further evaluation to our hospital. She had no regular medication. She denied traveling and having pets. The body temperature was 37.7 degrees Celsius, and the remainder of the examination, physical examination, are unremarkable. In the laboratory studies results, she has anemia, hemoglobin level of 8.1 gram per deciliter, and there was a hypoalbuminemia, and inflammatory markers such as CRP and erythrocyte sedimentation rate were very, very high. But there was no autoimmune antibodies like ANA, rheumatoid factor, anti-cyclic strinate peptide antibody, and PR3 ANCA and MPO ANCA were all negative. And there was no abnormality in tumor markers and cortisol level, and upper and lower GI endoscopies didn't have any abnormalities. And transthoracic echocardiography has no abnormalities, and 3 sets of blood cultures were all negative. She was admitted for further evaluation to our hospital. What would you do next? Whole body CT with contrast material, 18 FDG positron emission tomography of CT, administering antibiotics, administering high dose corticosteroids, or do you have any other choices? So then we performed a whole body CT with contrast material, and there was a thrombus in right pulmonary artery. And we also checked lower extremities veins, and there was a thrombus in bilateral perineal veins and soleal veins as well. So we worry that the patient might have some cancer elsewhere. So we consulted OBGY doctors, but they didn't have any findings of malignancy in uterus or ovarian lesions. And there was no hypercoagulable causes like reduced protein S or C activity, and there was no lupus anticoagulant. And fondaparinux followed by warfarin were administered. But high-grade fever persisted. This blue line was body temperature. There was a spiking fever. 2 weeks after admission, she still had high CRP. How would you manage this patient? The definition of FUO was first made in 50 years ago in 1961 by Dr. Peter Dorff et al. There are 3 criteria. Number one, fever higher than 38.3 degrees Celsius on several occasions. Number 2, duration of fever for at least 3 weeks. And the third one is uncertain diagnosis after 1 week of study in the hospital. The number one criteria is to exclude habitual or functional hypothermia. In the literature, they investigated body temperatures in normal healthy persons and found that there was no person with body temperature higher than 38.3 degrees Celsius. Therefore, they put this result to this criteria. And the second one, duration of fever for at least 3 weeks, is because the most acute febrile illnesses show the whole picture within 3 weeks. So then the origin of fever will be identified within 3 weeks. So it doesn't become FUO. And also most self-limiting diseases such as viral infection will be resolved within 3 weeks. So then the fever will subside within 3 weeks. The third one, I don't like it. Uncertain diagnosis after 1 week of study in the hospital. So, but they didn't describe which type of hospital, what size of hospital, and where the hospital is located. Then, 30 years later, Dr. Dirac revised the definition. The first 2 criteria are the same, but the third one was changed to uncertain diagnosis after studies of 3 days hospitalization or 3 outpatient visits. So this is also kind of a very unclear, because hospitalization, what the hospitalization mean? So which type of the hospital is it? How large the hospital is? It depends on the hospital quality. But there is no such description. And Dr. Dirac also added the 3 other types: nosocomial FUO, neutropenic FUO, and HIV-associated FUO. This is, I think, very good. After more than 10 years, the third one was revised by Dr. Nokat. This is certain diagnosis after a list of investigations as follows. So XX. This is very good because regardless of the type of the hospital, size of the hospital, you need a list of investigations. So it's a kind of qualitative definition. Duration and frequencies are quantitative definition. So what does XX mean? They are comprehensive history and physical examination, routine blood test, microscopic urinalysis, cultures, blood, urine, other fluid, and chest radiograph, abdominal, US, and antibodies like ANA, ANCA, rheumatoid factor, tuberculin skin test, and serology detected by local epidemiological data, and also further evaluation detected by abnormalities detected by above test. HAV, cytomegalovirus, EV virus serology, and chest CT echocardiography. So it's a long list of examination. So I want to ask you, what has the highest proportion in FEO causes? Infection, neoplasm, non-infectious inflammatory disease, miscellaneous, or no diagnosis? So the answer is no diagnosis. So we are facing a challenging era for FEO diagnosis. Why is it no diagnosis? It's probably due to advancement of imaging studies. We have whole body CT, MRI, transthoracic echocardiography or transesophageal echocardiography. And we have a positron emission tomography. In one literature describes that you should first perform PET. So then you can diagnose 1/3 of patients with FUO. PET is very expensive examination, but if you do PET at first, and then you can diagnose the patient with FUO, and it doesn't cost less compared to starting many examinations before the PET. And also thanks to advancement of microbiological studies, we have automated blood culture system. So HACEC bacteria, which can cause negative bacterial culture negative in infective endocarditis. So many years ago, HACEC bacteria will grow only after 2 weeks. So it takes longer, but thanks to the advancement of culture technique, the HACEC bacteria can be detected within 1 week. And we have gene amplification techniques like PCR or LAMP. And also thanks to advancement of serological studies, we have useful serology techniques such as soluble IL-2 receptor or ANCA. So most fever would not be an FUO by those, but sometimes FUO, no diagnosis, is only for you. So why is no diagnosis is only for you? So how do you assess exam results? Do you think negative ANCA means no vasculitis? Do you think negative transthoracic echocardiography means no infective endocarditis, etc.? So how do you assess opinions of specialists, especially pathologists? They sometimes say it's possible to be lymphoma. We cannot exclude the possibility of lymphoma. So it's not incompatible with lymphoma. It's not incompatible, blah, blah. So sometimes you are taking a plunge. You cannot wait until you get a proper diagnosis. So if the antibiotic is effective, so you think it's as infection, and if the steroid is effective, you think it as a steroid responsive disease. So you cannot reach the conclusion, but cannot wait until getting the diagnosis and use antibiotics or steroids. So I would say how to reduce no diagnosis for you. The first one is connecting the dots. That means super review of clinical causes of the patient. And the second one is trusting yourself. That is to assessing the test results or opinions from specialists in line with your super review. The first one. What does connecting the dots means? So the informations, the many pieces of information are scattered in different sites or different places. So you should get all information together to create a complete review record. And sometimes you should ask previous doctors if needed, and you should review all medication used and review all laboratory and imaging results and review all culture results and timing of antibiotics. So this is an example of a super review medical record. This is written in Japanese. To create, make this review, it's very hard. But after this is made, it becomes easier to manage the patient. The second one is trusting yourself. So do you remember the case I presented? The female, 51-year-old female who has fever, weight loss, anemia. So pathologists didn't describe any other abnormalities rather than thrombus. But we reviewed the clinical picture, an elderly female with 2 months history of loss of appetite, weight loss, fever, anemia, high inflammatory markers, but no specific findings for original fever. So this picture is very likely to be giant cell arthritis. So we checked aortic wall in the CT scan again. So look at this. What do you think about it? I think we thought that this is a little bit thick. So then a literature says that the aortic wall thickening in CT can increase the diagnostic accuracy of giant cell arthritis. So we gave a high dose steroid to this patient, and she got better, and she's fine now. So the third one, qualitative definition is, I think, very important. So I would say an authentic FUO is fever higher than 38.3 degrees Celsius, duration of fever at least 3 weeks, and then an absence of no diagnosis for you using super review. And the last one is diseases slipping through a filter of XX, panel of investigations. Infectious diseases slipping through a filter of XX. For example, infectious endocarditis, especially antibiotics are already used. The blood culture will be negative. The osteomyelitis, especially vertebral osteomyelitis, didn't show any sign of abnormalities in the MRI or CT in early phases. And entrance and exit infection. So this means dental infection, perianal abscess. So you would not be checked. Neoplasm, malignant lymphoma, especially intravascular biopsy specimen, sometimes did not contain any abnormal findings. And prostate cancer also is not easy to detect in imaging. And tumor fever, especially after chemotherapy. Inflammatory diseases, giant cell arteritis has negative anchor. Polyarteritis nodosa has also negative anchor. And polymyalgia rheumatica is a diagnosis of clinical diagnosis and exclusion others. And adult onset still disease is a disease of clinical diagnosis. And there are some other list of miscellaneous diseases. For further tests, biopsy, including bone marrow, and we have the word of wisdom, tissue is the issue. So repeat it if necessary. PET scan Gallium is to look for a biopsy site. Try questioning if the patient have periodic fever to detect familial Mediterranean fever, and stop suspicious medications to detect drug fever. And patient with no diagnosis still, so you do not worry about it. It's possible self-limiting diseases, and they have favorable prognosis. As a take-home message, connecting the dots, trusting yourself, getting authentic, if you will, thinking disease is slipping through WX, and tissue is the issue. Thank you very much for your attention.
Thank you, Dr. Suga Ihiro Amagochu. And any questions from the delegates, experts?
Thank you, Dr. Sugiro Hamaguchi.
Thank you very much.
Talk, and it has been really wonderful case series what you have presented, and we really liked it and loved it. So from all of the audience and all ACP members of India chapter, thank you very much, and congratulations for the wonderful presentations what you did here.
Thank you very much.
With the permission of the chairperson, we'll move on to the next session. And for that, I would like to invite Dr. K.K. Parikh and Dr. Minal Mohit as chairpersons for our next session.
Good evening, friends. Now we move on to a very important topic. Love thyself, to be given by none other than Dr. A. Muruganathan. I invite Dr. A. Muruganathan on the stage. It's my proud privilege to introduce my friend Dr. A. Muruganathan, who had been leader of API, Hypertensive Society of India, American College of Physicians, and his role in taking American College of Physicians to a great heights. And today it is one of the biggest association in disseminating the knowledge. The most important activity and he has utilized adversities of pandemic into an opportunity of disseminating the knowledge to our clinicians and physicians throughout last 1.5 years. So, and he had been so regular in this holding the CME programs on different subjects which are common to every physician. So I think he is one of the person who is also taking awareness, increasing awareness about hypertension, BP monitor, home BP monitoring, hypertension, and hypertension clinics. So he is the right person to speak on this subject, because we physicians and doctors do not care ourselves, and we always care for other patients and other persons, but we don't care, and the mortality because of the diseases like coronary artery disease, diabetes, and other comorbid conditions are very high in doctors and medical fraternity. So I think it's a very right topic to be discussed among us. So over to Dr. Muruganathan.
Thank you, Dr. Parikh, for that wonderful introduction. And I'm very happy, Chairperson Dr. Parikh, Dr. Minal Mohit, my brother Anuj, Srinivas Murthy, Jain Panda. And I'm very happy to
topic, theme as primary care. That is objective, but subjectively, what is primary care? Even primordial care is the care for ourselves. That is what love thyself, love yourself. Not moving. And you may wonder why we have chosen this topic. In fact, when I wrote to all my good friends, especially international people, they want this topic to be given to them as a link because this is a hard time for them. So many people internationally also love this topic. Love yourself enough to create an environment in your life that is conducive to the nourishment of your personal growth. Allow yourself to let go the people, thoughts, and situations that poison your well-being. Cultivate a vibrant surrounding and commit yourself to making choices that will help you release the greatest expression of your unique beauty and purpose. Know thyself, accept thyself, love thyself, no matter what you have done, where you have been, know, accept, and love who you are. Loving yourself is the greatest revolution. Loving yourself isn't vanity, it is sanity. Self-love is not selfish. Self-service is not selfish. You cannot truly love another person until you know how to love yourself. When you love yourself, you glow from inside. You attract people who love, respect, and appreciate your energy. Even Mother Teresa, when she, goes all over, people, are attracted because, she knows how to attract people by doing selfless service. Everything starts with how you feel about yourself. Start feeling worthy, valuable, and deserving of receiving the best life has to offer. Be magnetic. I love me. Love yourself for who you are. And trust me, if you are happy within, you are the most beautiful person, and your smile is the best asset and best magnetic. Fall in love with taking care of yourself. Fall in love with the path deep healing. Fall in love with becoming the best version of yourself, but with patience, with compassion, and respect to your own journey. Love yourself when you are tired. Love yourself when you're weak. Love yourself when you're confused. Love yourself when you're broken. Love yourself when you are restored. If Anuj Maheshwari and Srinivasa Murthy has got confusion, if they start loving, the confusion will be cleared. When I loved myself enough, I began leaving whatever wasn't healthy. This meant people, jobs, my own beliefs and habits, anything that kept me small. My judgment called it disloyal, but now I see it is self-loving. Talk to yourself like someone you love. I don't know how many of you have seen this. When you see a peacock, especially put a peacock in the front of in the mirror, it will speak by, in the mirror. They start loving themselves. This we see every day in my garden. And my wife has taken a picture, but this is not my wife's picture, but it's somebody's picture. But we have the picture in my own house. This is what is happening every day. The peacock, when you put the mirror, it speaks to itself by putting in the mirror. People who love themselves don't hurt others. If you love yourself, you will not hurt others. The more we hate ourselves, the more we want to others to suffer. Eat like you love yourself. Drink like you love yourself. Because I'm seeing Anuj is drinking tea. So when you drink like you love yourself. Speak like you love yourself. Act like you love yourself. Love yourself. Even Buddha said, you yourself as much as anybody in this entire universe deserves your love and affection. To love oneself is the beginning of a lifelong journey, romance. Even before you do any romance, you must start love yourself. To fall in love with yourself is the first secret to happiness. You want to be happy? Start loving yourself. Love and embrace yourself. Find the love you seek by first finding the love within yourself. I don't see Amit Gupta here. This is the Ravi Shankar's message. Learn to rest in that place within you that is your true home. When you start taking care of yourself, you start feeling better, you start looking better, and you even start attracting better. It all starts with you. You see, every day we are going in flight. What do you hear? You help yourself before you help others. This is the message you get from the air hostess. How many of you realize that? In the people, in the practical life also, you must start helping yourself before you help others. Practicing self-care, self-love may be extravagant, especially when we feel like our jobs are beating us down. The pandemic is weighing heavily on us. We are not doing enough for the kids, for houses, and miss having a homeschool in some cases while juggling work. But as Meghan Markle once wrote, you need to know that you are enough. You are complete without a partner. You are enough just you are. Fall in love with taking care of yourself, mind, body, and spirit. What does self-care look like for us? Self-compassion, reframing, gratitude and appreciation, humor, financial goals, time for yourself. Important thing is sleep. Because most of us today is looking very tired because yesterday night we did not sleep, including Anuj, including I've seen so many people. Sleep, food, and aligning with your values. Recharge in real-time minds and journey. What are the recharging? Physically, mentally, sensory, creative, emotional, and social, and spiritual. We diagnose so many syndromes. If you ask Padma Gulati, she'll say so many syndromes. But we also have to talk about the diagnosing ourselves. What is our problem? That is where self-care starts by diagnosing ourselves. This is a very important message. Please learn to speak to your organs. You may wonder, how do I speak to my organs? See, Radim Claria says lungs is important. Cardiologist says heart is important. Gastroenterologist says stomach is important. When you abuse your organ by taking a substance which affects the stomach, which affects the heart, which affects the lungs, when you smoke, the lungs and the heart will kick you. God, you are torturing me. When you get emotion, anger, your heart beats more. Your heart tell you are unnecessarily torturing me. So give comfort to the organs like kidney, heart, by avoiding injuring abuse. They also work for you 24 hours. Avoid unnecessary emotional stress, overworking, and stress. So today, one message for all of you: go back. It may look silly or crazy or funny, but learn to love. Talk to yourself. Mittal now talks to his wife and says, "Let us practice." I think we'll start practicing now. Organ talk, all the ways to communicate, connect with community, communicate with us, and talk to your organs for self-healing, hands-on exercise to open the channels by which we receive. Everybody does not have to like you. That is not their job. Liking you is not anyone's purpose in life except yours. Start liking you. Be you, do you, love you, for you. Self-love. Why is self-love in this subject? It reduces the burnout. In the pandemic, we get lots of burnout. Physical, emotional, and mental exhaustion caused by long-term involvement in emotionally demanding situations and interpersonal workplace stresses. Burnout was originally coined by Herbert Freudenberg in 1974 to describe emotional fatigue due to the mismatch of resources to the needs of patients. Jayant Panda tells me he's in the COVID ward, he's in the dengue ward, he's overworking, burnout, he doesn't take care of himself. So self-love is the lesson for you. Emotional exhaustion, feeling low personal accomplishment, depersonalization of the patient, all these things cause apathy, irritability, loss of enjoyment, pessimism. You may wonder, what is burnout, what is stress, what is the difference? Stress is characterized by over-engagement, burnout is characterized by disengagement. Emotions are overreactive in stress, emotions are blunted in burnout. Produces urgency and hyperactivity in stress, produces helplessness and hopelessness, loss of energy in stress, loss of motivation, ideas, and hope. So you may think burnout and stress are same. No, burnout is different. So practicing well-being, and coming to the topic, well-being is a very important topic in ACP, American College of Physicians. In fact, first time I sent Anuj Mageshwari as a well-being champion. I sent Narsin Verma as another time as a well-being champion. I had been a well-being champion for 3 years. To practice well-being. What is well-being? Doing well, feeling good. And doing good, feeling well. Both are different. Doing well and feeling good, and doing good and feeling well. A common understanding of well-being is doing well and feeling good. Doing well indicates the material dimension of welfare, of standard of living, suggesting that is rooted in economic prosperity. It need not be limited to this. Feeling good is subjective dimension of personal perception. These are the three points of the doing well and feeling good. Day to day, some tips, micro level tips. mindfulness. Always you be mindfulness. You see, when you take a bath, you think about bath. You think about your webinar or think about the office. When you eat, you don't think about what you are eating. Sometimes you don't know whether you are eating sabji or kolambu or vegetarian or non-vegetarian. Provide a tool to navigate anxiety and certainty associated with COVID-19 pandemic. Self-connect, name it to tame it strategy. I'm stressing. Then wellness. What is wellness? Wellness is more being definite. It is not absence of illness. WHO says wellness is just about physical, mental well-being, social, emotional, spiritual, environmental, occupational, intellectual, and physical well-being. Then Hippocrates says it is body, mind, and balance. Your body speaks to your mind. Understand how your thoughts and emotions affect your health. 10 commandments of physician's wellness. Welcome, Narasimha Verma. It's for you. 10 commandments for physician wellness. Thou shalt not expect someone else to reduce your stress. So you will have to reduce your stress. Thou shalt not resist change. Thou shalt not take thyself in vain. Remember what is holy to thee. Honor thy limits. Thou shalt not work alone. Thou shalt not kill or take it out of others. Thou shalt not work harder. Seek to find joy and mastery in thy work. Thou shalt continue to learn. Thou shalt continue to learn. That's one of the physical wellness. So we are all learning. When we are happy, when we are in present, when we get what we want, when we have slept well, when we have eaten well, when we have manageable workload, when we have healthy connections, then we are kind, and many more reasons. 8 dimensions of wellness. I'll complete. First is emotional. Relax your mind every day. Do not chase numbers, targets. 10 crores achievement, 20 crores. No. Gratitude. You must be grateful to what you are getting. Be kind to everybody. Acceptance is another message I would like to give you, all of you. Acceptance is the key. Learn to accept. That will transform your life. I'll give you an example. Accept that you will never be perfect. Life will always have challenges, and other people will disappoint you sometimes. Acceptance is the first step towards peace. Suppose if you're coughing coat on your pants, every day it happens to me. When I wear a white coat, somebody comes and puts coffee on me. If my dear one, my wife or some dear one spill, I won't get angry. If the waiter comes and spills, I say, what is this? Bloody fool, nonsense. It's already spilled. What is the use of scolding? Gone. To accept it, it is right. It's dirty. You clean it. Anger is a negative emotion. Toleration is the positive emotion. If your colleague has a Benz car, other day Srinivasa Murthy was driving on BMW. Next day he was coming in Benz car. I cannot feel jealousy and think, okay, when Srinivasa Murthy can get 2 cars, I can get 3 cars. That's the inspiration you must get. Instead of getting anger, inspire positive emotion. Ego is negative. Humility is positive. If Indian cricket team loses against Pakistan, why do you worry? It's already over. You accept it. You have a defeat. If you start grooming, you will get peaceless night. First attempt in learning is accept mistake. This is very important. Change the changeable, accept the unchangeable, and remove yourself from the unacceptable. Very important quotation. Change the changeable, accept the unchangeable, and remove yourself from unchangeable. Accept yourself, love yourself, and keep moving forward. If you want to fly, you have to give up what weighs you down. Now comes the occupational. Pursue career passion. Do not pursue career of finance. Then setting measurable goals. Then opportunities. Explore parallel opportunities and career prospects. And then this is very important. Physicians should treat patients with detached attachment. Whenever you treat a patient, if you have an attachment to the patient, when you lose the patient, you feel very unhappy. So when you treat, you must treat without attachment. And there are people, I'm very happy and proud. My wife took care of my daughter's delivery. If you have attachment, you cannot conduct. So detached attachment is the key in our profession. Then comes the intellectual. Open-minded opportunities, research, engaging in research, habitual reading, active listening before coming to conclusion. Learn to listen, listen to learn, and learn to adapt. Learning newer dimensions in life. Practice cognitive exercise every day. Then only your memory power will be improving. Then the other one is environmental. Spend time outdoors with environment. Now Anuj has taken everybody in Goa, but he has not taken us in Goa beach. But we must have that's why I want to attract his attention. He's talking. But still, when I say Anuj also is not listening. You must take everybody to Goa beach also instead of the hall. spend time outdoors with environment. Walk or cycle for commuting, reduce the carbon footprint. Digital detoxification. Unplug from technology, spend quality time offline, avoid too much of WhatsApp, too much of social media, watch comedy programs in TV, attend useful webinars, listen to Sandeep Gloria's TV message, but not other messages. Because, it will be scary. Whenever you open the video, TV, COVID, now is, oh my Quran only. So now, financial, set budget goals and plan ahead. Social, participate in group discussions and active listening. So we have an advisory council meeting. So participate and listen. So Anuj is there, all my good friends are there. That's Emily from ACP. And join and interacting in social organizations. Join Rotary, join Alliance. See, the first step is, professional. The second is social, then divine. So when you go social, you join some Rotary or NGOs and enjoy yourself. Volunteering the community. You must volunteer whenever there is an opportunity. And physical exercise that increase the heart rate. And then this is another thing, and then healthy diet, enough of that was said by everybody. And practice sleep hygiene. One important thing, we must sleep at least 7 hours. If you sleep well, your immunity goes up, especially growth hormone, IL-12 increases when you sleep between 10 p.m. to 11 p.m. At least 7 hours of sleep, all of us should have, that will make you wellness. Then spiritual, traveling and exploring other cultures. Then only, you'll have comprehensive spiritual culture. You may go to mosque, you may go to church, you may go to temple, exploring the inner self, mindful practice. Our oath. This is not my oath. This is then 2017, Geneva. I will attend to my own health, well-being, and abilities in order to provide care of highest standard. So let us have a pledge now. Please put your hand. I will attend to my own health, well-being, and abilities in order to provide care of the highest standard. This is the revised declaration of Geneva. So this is the oath of self-care and well-being. There were 7 commandments. This is again in the 2020. So learn to love yourself, well-being, promote wellness centers, promote well-being champions. Because our aim, Anuj and we were talking about wellness modules. I think the module was stopped because we didn't have enough time. Now we are going to roll out. All of you, please start wellness clinics. Apart from your clinic, Galis Fatima, Meenakshi Bhattacharya, in your clinic, have one center for wellness where you can have comprehensive wellness center. So wellness center, well-being champions, you should do. This is the certificate I got because when I went twice, we had a thing. So wishing you all a wonderful, enriching, and successful adventure to self-love. I wish you all, and very good. Thank you very much. And I'm ending with a happy note. This is the Osler Cup we do. Even in the games, before you serve, you have love all. In the tennis, what is the comment? Love all before you serve. So before you serve, love all, particularly love yourself. Thank you very much.
Now that was really wonderful, sir. Thank you so much. And I think we all have got the take-home message for the entire conference. Selflessness was a virtue once we were all taught. We have all been brought up with that single message. Selflessness is a virtue. And self-love was always stated synonymous with being selfish. That is a vice. But I think sir has changed the concept. Self-love is not being selfish. Self-love is just all about me too. So I am also there. It's not that I am all alone there. I am also there. Thank you so much, sir.
Thank you very much. If there's any
Dr.
question, I'll
Muruganathan.
be very happy to answer. It's a philosophical webinar, an interesting topic. Suppose you ask some question, it may kindle my interest. Yes, Makar was, about to ask any question. Yes, Makar. Don't ask me to get down, but that is of course.
I'll ask you to get down because we'll have another session. So I conclude here. And thank you very much, Dr. Muruganathan. It is very important to learn to love and take care yourself.
I
But I think to follow your all advices will put another stress and strain on our mind.
No, no, you take it in a very lighter way. So don't take it. And thank you, Farid. He was there enjoying the beach. So he called me. So he wants to come to chat. Then I told Anuj and Jain Panda, try to delay. That's why we delayed 1 hour. That's why he come. Thank you very much.
Thank you, Chairperson. Thank you, Muruganathan, sir. We now proceed to the next session, and for that, I would again like to call Dr. A. Muruganathan on stage as chairperson and Dr. Jayan Panda to join him as chairperson.
So it's a pleasure chairing this prestigious oration. You heard Dr. Muruganathan. The message is very clear. Oh, doctor, heal thyself. We try to heal people day in and day out. And in the process, we have to remember in the process of healing others, at times we forget ourselves. And Dr. Muruganathan rightly reminded, it's part of our duty to heal ourselves also. I invite the present governor of ACP, Professor Anuj Maheshwari, to join us for this prestigious oration. Before that, I'll just take 1 minute to tell the context, because it's the first Muruganathan oration that we are going to host in ACP. You know, a man from Tirupur has created a wave across the country. He has been a born leader, led ACP, led API, led ICP, led IMA, and he has seen the glimpses of leadership, and still it's on. Just you heard him. And the ACP activities and the ACP participation has become so prominent. Every year, the awards for the India chapter, Osler Cup, and then the recognition globally of Indian physicians, mostly because of his contribution. Taking all into consideration, the advisory board introduced the A. Muruganathan oration, and this is the first oration it will be rolled onwards. So with this background, I request Anuj to tell the context, and will invite Dr. Randeep Guleria to deliver the first oration. Dr. Anuj.
Thank you, Dr. Panda, for very nice context setting. And when we were really thinking about the person who could be the best for this first oration of in the name of Dr. Muruganathan, who has really worked hard to make the ACP on this level in India, because ACP was not anywhere 8 or 10 years before in this country. Now it is so well known that most of the physician wants to become a part of the ACP. Already we have crossed the 3,100 number of the ACP members. So this is a very good number. And apart from that, when we were discussing with Dr. Muruganathan, myself and other advisory members who can be the best person, and we find that Dr. Randeep Guleria is the person. When so many Indians were not knowing him so well, he was not a television celebrity. Sometimes he blessed ACP since then. He was the person who has been invited in the ACP 2018, which we organized at Lucknow. And he was not only a speaker there, he has participated in panel discussion. And that was one of the biggest attraction of that ACP. And I still remember, and you can also go and see the pictures of that session. That was the session where many people were standing in the hall, although the hall was having the capacity of 500 people sitting. As people were standing there and they enjoyed that session. So then we thought that he is the person who has blessed for a long time. And of course, the 2 years of the COVID has also made him most relevant nowadays. And again, in last 15 days, when we are listening so much of the Omicron, then of course, he can be the best person to guide the members of the American College of Physicians on the way forward or how to move forward and what to do next. With this small words, I would like to ask in 2020 also, Dr. Muruganathan is saying in 2020, Dr. Guleria was the keynote speaker. So he has every year blessed the ACP in one way or another way. Now I will request the people to give the introduction on the Dr. Guleria on the screen before I ask him to come for the deliberation, and Dr. Panda will read it.
Yeah, actually, Dr. Guleria requests no introduction. I request our secretary, Narsingh Barmaji, to accompany sir. And the name which was discussed most during the, sir, please be here, sir. You will have a felicitation before the oration. Name which was discussed most during the COVID time. And you know, when initially we didn't know much about COVID, guidelines. Right for the medical and we try to because that I also request have to try the registration from
Thank you very much, and I'm truly humbled by being conferred this first Dr. Muruganathan oration. As has already been said, Dr. Muruganathan has this passion of doing things, and he is
the one who has driven ACP and so many other organizations because of his love for academic activities and teaching. And I think what we've achieved today as far as the ACP is concerned, or various other organizations, is predominantly because of his contribution to that. Therefore, it's truly humbling, and I know how much he's involved. We just had an excellent talk by him on the values of loving yourself and why it's important to really be happy and be proud of yourself. So I'm just going to be talking on briefly covering what India did as far as COVID was concerned and what the future lies. I'll give a broad overview of what we did as a country and then what we did at the All India Institute of Medical Sciences, the vaccine story a little bit, and then the future. So we all know that COVID-19 is the biggest pandemic of our lifetime. Never seen anything like this. And it started off with an outbreak which happened in Wuhan, in China in December 2019. At that point in time, no one really anticipated the magnitude of the problem. And now, 2 years down the line, we have 265 million people worldwide who have been infected, and 5.2 million people have died. A huge number, still much less than what we've seen in previous pandemics, but still a worrying number. And India, we all know, has suffered from 2 devastating waves of this pandemic. And there's always this apprehension of another wave. If you look at data, India has the second highest number of documented cases in the world at 3.46 crore. And we have the third highest number of documented deaths. But if you look at it in terms of cases or deaths per million population, we are much lower down, and we have actually done much better than many of the developed world in terms of cases or deaths per million population. So it's an important thing to keep in mind. The timeline that we have, 30th January 2020, first reported case of COVID-19 in India. This was 3 medical students who had come from China to Kerala, and they had taken multiple flights. And there was this huge issue of contact tracing that one had to do from various airports that they have been through. We had the first national lockdown on 25th of March 2020. Seems a long time ago, but it's not that long. September 2020, we had the first wave. And then, of course, vaccines got rolled out remarkably well. We never imagined that we'd be able to do it so early on 16th of January 2021. And we had 2 vaccines which got emergency use authorization. March to May were bad months for us this year. We had this huge second wave, which was caused initially by the Alpha variant and then taken over by the Delta variant. And we had more than 4 lakh cases per day. And now this month, on the 2nd of December, we have the reports of the first Omicron variant, and we have now almost 23 confirmed cases. So we had the first wave and the second wave. The second wave was huge not in terms of numbers, but in terms of the way it rose. The steepness of the second wave was what really hit the health infrastructure. Had it been as slow as the first wave was in terms of the rise, we probably would have done better. But it was so steep because the Delta variant was so infectious. It spread so rapidly that it caused almost the entire family to get infected rather than just a few people in a family. I had written this editorial in 2018, in March 2018, regarding pandemics, and I had said 100 years after the flu pandemic of 1918, we are still very vulnerable and we need to prepare for pandemics, because if you look at what has happened this century, in the last 20 years, there have been a large number of outbreaks. We've had H5N1, which is known as bird flu. We had SARS. We've had MERS coronavirus, which is still there in the Middle East. We've had Zika. We've had outbreaks of Ebola and others which have been there in different parts of the world. We've had one more previous pandemic, which was H1N1, also commonly known as swine flu. So enough indicators that there is something big going to happen, and we need to be ready for that. It's always, everyone feels that it's not going to happen, but it's always better to be prepared. So what were the strategies that we as a country adopted? Like I said, we had stringent lockdown, we had physical distancing, we were very aggressive in what we call COVID appropriate behavior, and there was widespread public education programs. Many of us took part in that. There was alignment of political will and public participation. And we really ramped up our testing strategies. I'll come to that. Zero survey was done repeatedly, and this gave us more and more confidence that people are having milder infection and coming out of it, and therefore we are having some degree of immunity in the population. Drugs were made freely available. There was shortage of drugs. We had this whole issue of shortage of remdesivir, tocilizumab, and then of course amphotericin. Health insurance was provided, and of course we had multiple vaccine trials, which are also coming. So we had proactive and unified response from the center and state. Remember, health is a state subject, and there has to be coordination between the center and the state. We had travel advisory as far back as 11th of January 2020. There were guidelines of how to send samples. Surveillance guidelines were put in place. There were, on the 11th of March, there was visa suspension and compulsory screening was done. And the Prime Minister's Citizen Assistance and Relief and Emergency Situation Fund was also created. In April 2020, the Cabinet approved a 15,000 crore package, which is known as the India COVID-19 Emergency Response and Health System Preparedness Package, which really helped in improving our infrastructure and, of course, improving our testing that we could do. So this key objectives of this package was to develop diagnostics, dedicated treatment facilities, and the whole concept of COVID care center, COVID hospital, COVID ICU started from there, centralized procurement of a large number of essential equipments. And then there was a large number of other activities like building up laboratories, boosting surveillance. And on the 14th of March, they were able to isolate the strain, which was, we were the 5th country to successfully obtain a pure sample of the virus. And I'll come to this also because we were involved in this. From a handful of labs, we have now more than 3,000 labs. And subsequently, of course, we had genomic surveillance also done. So on March 14, NIV Pune actually isolated the strain of the novel coronavirus. This was very important because this helped us in two ways. It helped us in developing some degree of our own indigenous kits as far as the RT-PCR test was concerned. And it also was one was able to do a tech transfer of the virus to industry, and this was to Bharat Biotech, to make the inactivated whole virion vaccine. So this helped in many ways, and this, I think, a big boost as far as the country was concerned. So like I said, we had very few labs, and now in December 2021, we have more than 3,000 labs which can do RT-PCR testing. We were involved aggressively in this, and I'll come to that. We have now a testing capacity of more than 2 lakh tests, 20 lakh tests a day, and we touched 30 lakh also in the past, in June, July. Currently, we are, if you look at current data on a daily basis, we are doing between around 11 to 13 lakh tests a day. As per WHO guideline, we should be doing at least 12 to 13 lakh tests a day. So we're a little below that in terms of our population. But I think this is very important because as the cases come down, testing should not come down because that will really help in being able to pick up a cluster or an increasing number of cases in any area of the country. Vaccine was something which is again a story which I'll come to because this really helped. And then there was, of course, the whole issue of getting PPE and equipment. And again, a lot of indigenous production started happening. And by May 2020, India began producing an average of 150,000 PPE kits per day. Before this, we were all importing PPEs from China. We were not making our own PPE. And we had this whole issue in our own institute of PPE shortage, N95 shortage, and what will we do? I think we really turned that around in a big manner. And then, of course, there was infrastructure and training. IEC dashboard was maintained by the Ministry of Health and Family Welfare, which looked at, and this dashboard is still very active. They have a war room also, and there was a proactive role played by the media itself. We also then, this is one of the big boosts that we had, that was we were able to push forward for teleconsultation. Now, it's not new. The teleconsultation was something we were already working on. I was a member of the Board of Governors of the MCI, and we had already made a draft, but there was a lot of reluctance by the government to push this forward, and there were a lot of medical legal issues. COVID-19 really pushed this very rapidly, and the government released the telemedicine guidelines in March 2020. Before this, there was this whole issue of the legality of giving a teleconsultation, because people said that it may be illegal and it may cause medical legal issues. This actually allowed us to really do two things. One is improve non-COVID care, because during the lockdown, a lot of patients were not willing to come to the hospital or not able to come to the hospital. With teleconsultation, we could reach out to them and provide care, and it could be for hypertension, it could be sugar control, it could be for our COPD patients where you just need to just a dose of their inhalers or start maybe a short course of steroids or bronchodilators. It also enabled us to start triaging patients with COVID-19 and home isolation became more popular, and you could monitor patients more closely and provide treatment because of the teleconsultation that one could give. So I think this has been a huge achievement, and I think this is one thing that will move forward when we look at how we can use technology to provide better care to patients in the periphery or in rural part of our country. I'll quickly shift gears and tell you what we did as an institute. Most institutes did the same thing. We were a little bit more active because we were an academic institute and we had other mandates also. But I think the first issue that we realized was protection of healthcare workers. And that is why very aggressively from day one, we started holding, we developed training modules, a hospital infection control team twice a day, 3-hour module in the morning, 3-hour module in the evening, would teach all healthcare workers, and this was across the board, of infection control practices. The other was motivation of healthcare workers. There was a lot of fear in the early days. Stigma was there. I still remember in the first few months trying to sort of talk to a nursing officer. She felt she had come in close contact with the COVID-19 patient, and she told me the virus is all over my body. I can't go home. My parents will get infected. It took a lot of counseling to really reassure her. Luckily, the patient turned out to be negative, but that was a type of panic, and you need to keep your healthcare workers motivated. And of course, there was a need to infuse infrastructure, training, mentoring, and generation of public awareness. So very quickly, we formed the COVID-19 task force. We, in the institute, had multiple committees because we need to have a smooth chain of supply chain of diagnostics, of drugs, of human resources, and of course, looking at the other issues in terms of how do we repurpose our resources. I would have daily meetings with the entire staff, that is the faculty, the residents, our nursing officers, our technicians, and other staff to really look at the challenges that we had. And we had, every day there used to be a challenge, sometimes a shortage of PPEs. Once the residents said our PPEs are our N95 is of poor quality, it's leaking from the side, we need to change it. So we went and did another local purchase. One time, one of our residents' wife who was pregnant turned out to be positive. So overnight, we had to make a COVID labor room. So those are the type of challenges that we had every day. And we did a little bit of work also on this. We published a research paper of how you could recycle PPEs because there was a shortage of PPE at that point in time. How could you take PPEs, wash them, hang them, use a fogging machine and make sure that they are sterilized, and then pack them and recycle them. We did that, and we had a huge sort of storage of almost 800 PPEs which we had recycled and kept. So a lot of things were done. First was infrastructure. We converted our National Cancer Institute, which is been inaugurated in 2019. It's a 700-bedded cancer hospital. It's currently we were at 250 capacity. We opened it all up. The Vishrant Sadam, which was basically a hostel at that point in time, was also converted into a COVID care center. Our trauma center, which is 250 bedded, 260 bedded, was also converted to a COVID hospital. And because of the lockdown, we were quickly able to move our trauma services to the main hospital and convert this trauma center into a COVID hospital. Thereby, we created more than 1,700 beds and subsequently more than 250 ICU beds. Challenge was not the infrastructure. The challenge was the human resources. You're not able to get more residents. You're not able to get more faculty. You're not able to get more nurses. So you have to repurpose them. You have to motivate them. And there were times when we had people from anatomy, people from physiology, being trained to manage patients and taking help of even undergraduate students. It was a challenging time. This is our National Cancer Institute, which is 700 bedded. You have a research block here, an academic section, an OPD, and an indoor ward. This is it from the ground level. The building that you see on the left was inaugurated 2 months ago. So this is an old picture by our Prime Minister. That is the Infosys with Vishram Sadan. Infosys donated money and made a Vishram Sadan, which is 800 bedded for the attendants and patients of cancer who are for chemotherapy or for daycare to stay in that center. This is the trauma center, which we also converted to a COVID hospital. And we started, like I said, use telemedicine for non-COVID patient care. And this is something that we did very, very aggressively. And of course, continue to manage non-COVID. Non-COVID care didn't go away. It came down because of fear, but there was a lot of non-COVID care which was required. And I think one of the collateral damage of the pandemic has been the non-COVID patients who suffered a lot of cancers, got to an advanced stage because it could not be diagnosed. A lot of people had various other exacerbation of the non-communicable diseases which we were not able to provide for. We treated more than 20,000 patients in our COVID centers, and these were all very sick patients. I mean, we were not really admitting mild patients, and they needed either high flow nasal cannula, non-invasive ventilation, or invasive ventilation. But I think the main issue was that we continued to train our staff. We had more than 50 webinars, online training modules, and we have a Saral platform which we use for undergraduate training. It's a module platform which is for training our undergraduate students using this Saral platform. This was also converted to converted to train doctors, interns, and nurses. And like I said, almost 33,000 of our employees were trained by our infection control team. We also had these mentorship programs, which our grand rounds were already mentioned by the chairperson. We also did a lot of other activities with the Ministry of Health. To begin with, we started enhancing the RT-PCR testing. This was a meeting I used to take once a week. We had 14 mentoring institutes, and we would then divide various areas of the country, and we then got after all the private and the government medical colleges to start an RT-PCR lab. In some colleges, there was not that much of a push. Luckily, at that time, I was still part of the board of governors, so we got the MCI to write a letter to them that the college would be de-recognized unless they set up and invested in an RT-PCR lab. And this was it. As you can see, we had a dashboard of all the labs. We got them all accredited. We got all of them, had a quality check done, and after that, they were then given approval to start RT-PCR testing. We had webinars. This is the early part of the pandemic in 2020, where we had 6 webinars for management and site preparedness. We had over 385,000 views, and this was put up on the YouTube platform. Currently, it has almost 56,000 subscribers. We also did webinars for nurses, and this was also done by the College of Nursing. And this also was very popular in terms of how, educating about nursing care during COVID-19. Then the obstetric care was also something that we were asked to do. So 10 modules of educative webinar series from May to June of 2020 were done for management of these patients. And this was also put up on the net and was also very well received. The Ministry of External Affairs then asked us to do some webinars for the SAARC countries as part of international outreach program. And so we did this webinar for SAARC countries, where we got a lot of good response from Maldives, Mauritius, and Nepal. And we did these webinars on management, infection control, and lab diagnosis. I'll just run through my slides. This is the national grand round that we started. And this actually started because when I used to do EICUs, I realized a lot of people who were managing COVID did not really have that much of background knowledge. I still remember one person who was from Gujarat, and he converted his nursing home into a COVID hospital. And he told me, and I'm an obstetrician. I've been managing only patients with obstetric care in the past. And now I'm admitting patients with COVID, and I have not much idea of how to manage them because I've never really managed anyone with respiratory failure. And I was really touched, and I thought that showed the spirit of the medical profession, that they were willing to take the pandemic head on and take this as a challenge. And I felt, and I then realized that we must have some case-based discussion, and that's what led to the National Grand Rounds, which began in July 20. There was a lot of support from Niti Aayog, and these were really very popular. The viewership was almost 3 lakhs, and we did that then subsequently with our international partners, because at that point in time, COVID was actually causing more of a problem in other countries. We had this outbreak in Europe, we had it in US, and we were trying to learn from them what are they doing. So this was with University College London, where we had an outbreak. We reached out to colleagues in New York also, because New York also was having a huge outbreak at that point in time. And their management strategies were what we tried to understand. Then at the request of the Ministry of Health and Family Welfare, we started an EICU program where we would interact with doctors in various COVID hospitals and discuss about treatment and management issues. And I myself probably interacted with more than 500 hospitals across the country. And again, like I told you, I realized the diversity of treatment. one center was giving methylene blue as a treatment strategy, and they said we are finding methylene blue to be very useful. The other doctor argued with me that I think all patients should be given remdesivir on day one. If you have to decrease viral replication, why don't you give it to asymptomatic patient on day one? That will take care of the viral replication and patients will be all right. And then, of course, there were cocktails of drugs, steroids, remdesivir, anticoagulants being all given on day one because of a little bit of a panic reaction. So this really helped in trying to have a proper program in terms of the management strategy. We also were asked by the ministry to start centers of excellence in July 20, and this was a hub and spoke model. In phase one, we had state center of excellence, and then we had regional centers of excellence. This was the phase one that we did as a center of excellence, supported by the Ministry of Health and Family Welfare. And this had over 1,25,000 viewers. And then in the second wave, we were again asked to start this program again, because this actually came down in January when we even thought COVID is over. And from April to May, we again had revived the Regional Center of Excellence. We did 10 webinars, and these were recorded, edited, and there were presentations were shared. And we were keen that these centers then disseminated in their areas as far as the training program is concerned. In phase three, also we interacted with the Indian Medical Association, and with IMA, we started another program of webinars which could be given both to doctors in the government sector and the private sector, and this was converted to online modules. At that point in time, we also focused on children because everyone said the third wave is going to hit children much more. There was a panic reaction, and the ministry said you must do webinars for children. So this was also done by the pediatrics department. And then we realized that we can also develop modules that people can go later on to train themselves as far as COVID is concerned. So a 4-module training program was developed, which is basic of COVID care for physicians and healthcare workers. This you could log on to this, you could do your modules, and you could answer the questions. And if you got your answers right, you could print a certificate, which would say that you have gone through this training program. So this was a skill e-learning sort of a training program, which was not like a webinar, but could be done by anyone by going onto the net. Coming to the vaccine challenge, I think this is another huge story because the pandemic is a huge challenge. Distributing the vaccine equitably to billions of people is also a challenge. And of course, there's the worry of immune escape mechanism and overcoming vaccine hesitancy. Now, when we look back, and I remember when we had the H1N1 pandemic in 2009 and 10, there was a huge issue that why is India not making its vaccine? We were manufacturing, but we were not doing research in vaccine. And at that time, for the monovalent H1N1 vaccine, we had to rely on donations from the WHO because we were not making our own vaccine. And I remember one girl died in Pune at that point in time in 2009. And this created a huge media uproar, and there were multiple meetings in the ministry. But India was not at that time involved in manufacturing vaccines. The other big issue is to have a good platform for distribution. That is the challenge Africa is facing. Billions of doses of vaccine is now being donated to Africa after Omicron, but they're being given as Pfizer vaccine. Pfizer needs to be kept as -80. Africa doesn't have the capacity to distribute these vaccines. They don't have that infrastructure available, which we were able to develop to be able to reach out and distribute it even to remote areas, maintaining the cold chain and having people trained to give the vaccine. This is something that we were able to do remarkably well. And in April 20, the NECVAC was formed. October 2020, there was states were asked to set up state level mechanisms for including cold chain. And then of course we had COVID Suraksha mission where money was given, and the budget allocation of 35,000 crore was also allocated. The important thing here was that at that point in time, people were working on maintaining the cold chain. There were meetings being held that we will need so many extra syringes, so many extra needles. So the manufacturers being asked to produce so many extra needles and syringes. And this was way back somewhere in September, October last year. So there was a lot of planning which went behind in trying to see that the vaccine rollout happened in a good manner. And I think it's remarkable. We have now vaccine of our own, Covishield, Covaxin, Sputnik has been approved, Johnson has been approved, and our own first in the world, a DNA plasma vaccine, ZyCoV-D, has also been given emergency authorization. So India is in a much better position in R&D in vaccine than ever before. And from what we had initially that we were not being able to do it, we are now looking at so many platforms. Besides this, Novavax is there, which Serum Institute is making. Biologically, with support from Department of Biotechnology, is making a protein antigen-based vaccine. An mRNA vaccine, which can be kept at 2 to 8 degrees centigrade, is being made by Genovia, and it is undergoing trials right
Good
now.
boy.
And Bharat Biotech is looking at a nasal vaccine. So we have a vaccine platform, which I think is remarkable for what we've done as far as vaccine is concerned. And of course, we have the whole issue of vaccine Maitri, that we are now giving vaccine to other parts of the world. This was stopped for some time during the second wave, but has again been started. This is a paper that we were involved in the first phase, looked at the safety immunogenicity of the Bharat Biotech vaccine in a double-blind randomized phase 1 clinical trial. This is the subsequent phase 3 trial, which showed that this vaccine, Covaxin, has an efficacy of 77.8% and was effective and well tolerated and without any safety concern. And we have now actually vaccinated or given doses to almost 1.2 or 1. We have crossed 1.3 billion people, which is a huge target. If someone had asked me or told me 2 years ago that we in less than 1 year we will vaccinate 1.3 or we'll give vaccine to or give 1.3 billion vaccine shots in our country, I would have said it's impossible. And yet we managed to do this in less than 1 year. So I think it's a remarkable feat that we have achieved, which is thanks to all our healthcare workers. The vaccine program really did very, very well. And I think it also shows that developing a vaccine is only half of the work done. Delivering it equitably is the most important step, and this has been shown very well in what is happening in Africa. Unless we have equitable distribution of the vaccine, the pandemic will continue and new variants will continue to emerge. And there are Western countries which have almost 6 to 7 doses of the vaccine pre-ordered per citizen, whereas there are countries in Africa where the vaccine is even less than 5% as far as availability for the population is concerned. So vaccine equity is very, very important. We've had multiple strains. We've had the Alpha, Delta, Beta, and the Delta strain also from India. And based on that, we had the development of what was known as the INSAGOG, which was started in January. Started off with 10 labs for genome sequences. Now it is more than 30 labs which are doing genome sequencing and building it up every day so that we are able to develop genome, do more and more genome sequencing. And INSAGOG actually was the one which reported then what it was called the double mutant, which was the B1617, and a variant belonging to this lineage, the B16172, became what is known as the Delta variant, which is now becoming the dominant variant. Even now, when we're talking of Omicron, we're seeing that more and more patients in Europe and in US are actually having infection with Delta, and hospitalization is more with Delta rather than with Omicron. This is a paper which we had published during the second peak and trying to look at the effectiveness of vaccine during the second week and second peak when the Delta strain was there. And this actually, based on the study that we did in our hospital, the efficacy of the vaccine was around 50%. Coming finally to Omicron, a lot of concern about it. We've had more than 50 countries which have reported it. The concern being that this virus has so many mutations, more than 50 mutations, 30 at the spike protein region. But we still, whatever data we have, I think is not sufficient to really come to any conclusion. It seems to be a mild infection, doesn't seem to cause very high mortality, but is more infectious. But if you look at India, wherever we've had now almost 23 to 24 confirmed cases of Omicron, and one it could have been a super spreading event in a marriage party. We've not seen any surge in that area in terms of cases. So if we look at how things are in India, I think it's slightly different from what we're seeing in the Western world, but we need more data right now. And tweaking the vaccine is something that we can always do, and this is something that is possible. We do it every year for the influenza vaccine. Every year we have a new influenza strain. We have a quadrivalent influenza vaccine now. So it's always possible to tweak vaccines to cover new strains. There's already research going on to develop new vaccines to cover the Delta variant. There's also a company which is making a bivalent vaccine to cover the Delta and the Beta variant, because that is one which they feel could be more having an immune escape phenomena. So we will have new generation vaccine in the coming year. Finally, in the last few minutes, the way forward. Can we have a third wave? I think this is a paper which was done by WHO, by ICMR as part of the mathematical modeling. And there they felt it was quite unlikely unless two things were there. You had a new variant which was really more transmissible and at the same time capable of significant immune escape mechanism. Unless you had that, unlikely that you will have a significant third wave. And of course, decrease in COVID appropriate behavior would also drive the third wave, and that is the other thing that we need to keep in mind. So combination of total lack of COVID appropriate behavior and the emergence of this new variant is the only way that one could have a third wave. So this is what I've already said, that this could be the likely causes. A new variant which has escape mechanism and is more infectious. And to protect it, again, COVID appropriate behavior, aggressive vaccination, and I think enhanced genome surveillance. We should not be caught off guard. We need to have more and more genome sequencing and limited lockdowns if wherever a cluster develops or we see a surge in the number of cases in terms of positivity rate or hospitalization. Does this work? This is data from the influenza pandemic, and it showed that those cities in US which followed appropriate behavior with lockdown and social distancing, they actually had a lower mortality and they were able to come back to manufacturing and employment faster than those which were more lenient. So it's a lesson that we should not forget, that good aggressive COVID appropriate behavior and limited lockdowns do help in the long run. Major challenges that we have are limited hospital beds, oxygen supply, and trained manpower. We need to really work aggressively on this, push for vaccination, and the gradual sense of complacency which is actually coming in. If there is a little bit of COVID fatigue, we have to admit that. The government itself gave another package, which was the Emergency Response and Health Preparedness Package Phase 2, which was given in July, 23,000 crore rupees, which was basically to look at various areas. It was to support more beds, increase genome sequencing, develop a hospital management information system even at a district hospital level, and focus a lot on teleconsultation. It also looked at pediatric units in all districts of our country and pediatric centers of excellence, 20,000 ICU beds, and of course, liquid oxygen and other supportive staff. So I think a lot of activity is being going on. But what I'd like to say is that as the pandemic changes, we need to evolve and we need to really be ahead. So what we learned last year may not be relevant now. We need to really see how things are and evolve accordingly. Therefore, to conclude, COVID-19 has caused considerable morbidity and mortality in our country over the last 2 years. We must not forget these lessons as we move forward in terms of preparedness, in terms of the importance of a robust health system. With the emergence of new variants, COVID-19 is here to stay, and occurrence of further waves is possible. Another important thing to remember, COVID-19 is not going to disappear. It is going to become endemic. And we will have, like we have in influenza, cases which may come and go. We will have some people who will become very sick and go into the ICU, as we see with influenza, with a viral pneumonia and having ARDS. But by and large, it will become endemic. India has responded by upgrading public health infrastructure, adopting telemedicine, and investing in universal vaccination. But I think a lot more needs to be done in terms of public health infrastructure. And we need to see how we can push the frontiers as far as telemedicine is concerned. It could also be looking at things like eICUs and other things. And we need to be prepared. We may not have a third wave, but that doesn't mean that we should not be prepared for any eventuality. Thank you very much.
Thank you, sir, for enlightening us with the experiences and ideas, as well as giving the guidelines for the future. And of course, we know that COVID-19 and Omicron is still mysterious, and many things are weird with that. But a person like you, when guides us, then it really makes the difference for the attitude of the clinicians, people, those who are listening this conference, not only in India, but outside India also. They may be more vigilant and more learned and more appropriately behaving towards the COVID-19. With this message, we can conclude this session. Before we move forward, we would like to give a token of appreciation from American College of Physicians to speak in this oration.
We now proceed to the next session, which is 100 Years of Insulin Symposia. And for that, I again call upon Dr. Jayant Panda and Dr. Anush Maheshwari, sir, to kindly act as chairpersons.
Good evening, everyone. Thank you, ACP India, for inviting me for this talk on 100 years of insulin. Before the technical glitch is controlled, I would like to introduce that since the time immemorial, the treatment of diabetes, especially when we are talking about diabetes per se, it's type 2 diabetes. And the so many oral treatment available, ultimately every type 2 diabetes has to take the help of insulin in the course of the entire illness. So when we talk about the insulin, when we start thinking about 12 minutes, right? So I've been instructed to complete in the 12 minutes. So total control is the right aim when we dwell upon deciding about the use of insulin. So these are my financial disclosures that have been supported by Novo Nordisk for this promotional meeting. If you don't treat a disease properly, then you are ready to face the complication. And we know that the type 2 diabetes, the basic complication arise because of the endothelial dysfunction, which lead to micro and macrovascular complications. And they become ultimately the cause for the death in diabetes. There are some non-classical complications like cognitive impairment, depression, NAFLD, NASH, etc. Insulin offers the maximum glycemic efficacy in the armamentarium of type 2 diabetes. And there are basal, premix, prandial, basal, bolus. What to choose? There are need for a specific therapy for Indian people because not all the patients across the world are same. We as an Indian, there is a need to address this high carbohydrate meal either through the diet modification, which becomes a very difficult part, come what may, whether whatsoever education you may impart to your patient, but the diet control becomes a very difficult proposition. So is there any therapeutic intervention which can control this prandial rise of the glucose? And what are the impact for uncontrolled postprandial strike? It causes oxidative stress, which leads to endothelial dysfunctions. And this endothelial dysfunction is responsible for various complications in type 2 diabetes. Even in the impaired glucose tolerant stage, the endothelial dysfunction starts taking place. And we know that the prandial rise in the glucose is the first derangement which occurs in type 2 diabetes. So we have to address this issue. Unlike Western population, DPG is contributing across all the HbA1c level as compared to Caucasian, whether it is less than 7.1 or it is between the range of 8.8 to 12.7. We have got a greater contribution from the prandial rise as compared to Caucasians. Despite similar fasting plasma glucose reduction with the basal insulin, which most of the associations are offering, and there is absolutely no doubt that the initiation of insulin is the best with the basal insulin. But can we tweak it a little bit? Can we have an option which is not only giving a good basal control as other basal insulin, but also trying to control the major meal prandial excursions? So this is the study that the Asian patient achieving HbA1c target as compared to the patient level pooled analysis of 16 randomized control trial. So they said the total control matters. Prandial component needs to be addressed in all Asians. So do we have 2-in-1 solution? Yes, IDEG Aspart, a 2-in-1 solution suited to Indian realities. In the diabetes management, it has got IDEG dihexamer along with Indian insulin aspart hexamers. The dihexamers, they are injected in a subcutaneous space and they combine to make a long multi-hexamer. Insulin aspart released immediately, and this multi-hexamer is with the zinc, it diffuses slowly, causing slow basal secretions of basal level of insulin. The distinct prandial and basal glucose lowering effect of IDEG Aspart at steady level can be seen in this diagram. You have a good rise in the immediate insulin secretion and then the steady basal insulin secretion. So pharmacological properties make IDEG Aspart the prudent choice for once a day initiation and subsequent intensification with twice a day insulin. So aiming for total control, fasting, HbA1c and PP control, IDEG Aspart provide total control of PPG and fasting plasma glucose. In turn, effective HbA1c control, RSSDI, ESI clinical practice recommendations, they have also approved that insulin therapy should be considered in all patients failing to achieve glycemic target with the 3 oral agents. These are some of the trials which are taking place. IDEG Aspart phase 3 clinical program, in which the insulin detimer by Aspart 30, insulin glargine U100, basal insulin plus insulin Aspart with meal, and the IDEG Aspart has been being tried in the various levels. So here the insulin initiation and intensification were IDEG Aspart. What are the results which we can see here? If you look at it, the IDEG Aspart dosing once a day, 26-week trial, HbA1c superior control as compared to the basal plus bolus. Fasting plasma glucose similarly contained, and PPG increment 57 milligram better control as compared to basal only. Confirmed hypo 27% less, and the nocturnal hypo 25% less. Switch from basal plus bolus. Again, what is the difference? You have 45% less nocturnal hypos and 12% less insulin dose. So this combination works really well. There are various studies, real world evidences which are available. both Indian and the outside trials. We will give, this is trial by Chaudhary et al. What they have shown that the IDAG-Aspart caused statistically significant greater reduction in HbA1c as compared to IGLAR U100 and IGLAR 300 in their study. They have shown that the significant better fasting plasma glucose reduction was seen with IDAG-Aspart, IDAG U100 compared to IGLAR 300. And they have also shown that the significantly better PPG reduction with IDAG-Aspart as compared to IGLAR 100 or IGLAR 300. And significant increase in insulin dose requirement as compared to IDAG plus Aspart. If you compare it with IGLAR U100 arm, non-significant increase with IGLAR 300 arm and IDAG-Aspart arm. No significant difference in hypoglycemia occurrence between the group. Then there comes a question of how to choose, initiate and titrate IDAG-Aspart. If you have the difference between the fasting PP more than 54, then it favors IDAG-Aspart. Is the patient likely to manage basal only therapy when intensification is needed? If the answer is no, then it favors IDAG-Aspart. Is there a large carbohydrate intake at 1 or 2 meals? If the answer is yes, then IDAG-Aspart is the favorable drug. Is the patient lifestyle predictable? Eating pattern and working hours unpredictable? Then of course this IDAG-Aspart makes a choice. There are practical recommendations. Initiate with 10 units of IDAG-Aspart once a day, the most carbohydrate heavy meal of the day. And then you can up titrate the drug with twice a day. Practical recommendation for weekly titration using simple algorithm. If fasting is above the target range, then increase by 2 units. If the fasting plasma glucose is at the target, maintain the dose. If below the fasting plasma glucose target, then you reduce it by the 2 units. Identify your patient's fasting plasma glucose target as per that. This is the design of FlexiPen, which they have launched. And they only pre-filled insulin pen with no push button extension, easy touch button with low injection force, easy to read scale, and end of the dose confirmation in the patients improves the confidence. So to summarize, the Indian realities of diabetes management demands total control at initiation of insulin therapy. IDAG-Aspart is a simple and judicious choice with proven safety and efficacy as shown through the multiple randomized clinical control trials. And the real world evidence with IDAG-Aspart has also shown significantly better control for HbA1c and prandial plasma glucose as compared to IGLAR U100 and 300 both. Thank you very much. I hope I have completed in time.
So thank you so much, Professor Dr. Anuj Maheshwari, Professor Panda, for this opportunity, and thank you, Chair, for the kind introduction. And I'll take from where Dr. Awasthi has left. I'll just wait for the slides to appear. Hopefully I can move the slides from here. So this is my disclosure. I had been contracted by Novo Nordisk for this session. And what we'll try to understand is when you take the IDAG-Asp into the real world, what exactly happens? And ARISE is a prospective real world study of IDAG-Asp. So the analogy I give usually is if you have a Ferrari and you're driving it in the F1 circuit, it's an entirely different scenario. Everything is in a controlled environment. If you take your Ferrari and take it out in the city traffic, that is what real world studies are like. So my in-clinic experiences that I'll share in the form of a study. So this is the ARISE study that was presented at the Australasian Diabetes Congress. And this was about the improved glycemic control in people with type 2 diabetes. And they were initiated or switched to IDAG-Asp
from any anti-hyperglycemic treatment or even from insulins like basal insulins. And this was done across 6 countries. This was the basic design of the study. About 1,112 adults with type 2 diabetes were recruited for this study. And as you can see, it was non-interventional, multi-center, prospective primary data collection and visit frequency according to local standard of care. And 6 countries like Australia, India, Malaysia, Philippines, Saudi Arabia, and South Africa were involved in this particular study. An observation period of about 26 to 36 weeks. So the primary endpoints that we were looking into was the change in the HbA1c from the baseline, and the secondary outcomes that we were looking into were the number which achieved a HbA1c of 7% or less, which is considered a good glycemic control. HbA1c less than the predefined target, change in the fasting glucose from the baseline, at the same time, change in the insulin dose in terms of units, and change in the body weight from the baseline, number of hypoglycemic events, and a treatment discontinuation. The exploratory endpoints were resource utilization and HbA1c less than 7% without any incidences of hypoglycemia. So overall subject disposition, and what we want to emphasize is 92% of the patients actually completed the study. This was the baseline characteristics. The mean age was about 58.6. Male to female ratio was 53 to 46. Body weight, mean body weight was about 79.5. Duration of diabetes was 13.3 years, and mean BMI was about 29.2. Fasting at baseline, mean was about 198, and baseline HbA1c mean was 9.8. So these were the baseline anti-diabetic agents that they were on when they were initiated on IDEC-ASP. OADs only was 35%, basal only was 21%, GLP 8%, basal bolus was 13%, and premix 21.9%. What were the reasons that were considered by the physicians a reasonable cause for starting IDEC-ASP treatment? And majority of them thought that the reason was to control the glycemia better. A handful of them also thought that lowering the hypoglycemia was the reason why they should be starting them on IDEC-ASP. Flexibility of the dosing regime, fewer injections, all of these were the considerations they had in mind while switching them to IDEC-ASP. What was the percentage that were using once versus twice IDEC-ASP? So about 52% was using it once daily versus about 47.6% to using it twice daily. These were the changes in HbA1c from the baseline. You see the overall change was about 1.4%. If you look at Australia, it was about 0.8%. In India, it was close to 1.6%. The maximum was at Saudi Arabia, where there was a drop in HbA1c of about 2%. So significant reduction was seen in the mean HbA1c from the baseline, and this was consistent across the countries. Again, if you look, there was significant reduction across all subgroups, depending, it didn't matter what they were using at baseline, whether they were on OADs or whether they were on basal insulin, GLP-1 receptor analogs. Even when they were taking basal bolus or premix, there was a significant drop in the HbA1c from the baseline. But the highest was in those who were taking about 3 or more OADs and still uncontrolled. There was a drop in about 2% from the baseline. Similar change in the fasting glucose was there from the baseline. And we saw that there was a drop in almost 52 milligrams per deciliter in Indian circumstances. Also, the non-severe hypoglycemic events, we were comparing at the start of the treatment and at the end of the treatment. And we see that no matter what they were using at the baseline, whether they were on OADs, basal, GLP-1 receptor analogs, there was a significant drop in the number of non-severe hypoglycemic events with the introduction of IDEC-ASP. Similarly, if you're considering severe hypoglycemic events, and you look at the start of the treatment and at the end of the treatment, again, there was a significant drop in the number of severe hypoglycemic events with the introduction of IDEC ASP across the board. So resource utilization, and if you talk about the self-reported outpatient visits or self-reported emergency room visits or self-reported work days missed, again, there was a significant decrease. You saw a 61% decrease in the resource utilization in terms of visiting the OPDs. And also there was a 90% drop in the self-reported work days missed with the introduction of IDEC ASP. So the conclusions from this study was that IDEC ASP, so whenever you're switching to IDEC ASP, there was an effective drop in the HbA1c, effective drop in the fasting, improved safety outcomes, and better resource utilization with the introduction of IDEC ASP. So ARISE complements available evidences to consider IDEC ASP and patients failing to achieve glycemic control, those with postprandial glucose spikes, as happens in Indian circumstances because of a higher representation of the carbohydrates in our meals, patients at an increased risk of hypoglycemic events or nocturnal hypoglycemia. And nocturnal hypoglycemia is always a challenge because, you know, that's the time when the patients are most vulnerable and least likely to seek help. So patients who benefit also are those who have reduced injection burden and less complex regimen, and patients requiring flexibility in timing. So you can conveniently place it once daily to initiate with the biggest meal of the day, for example. So now with the co-formulation in place, we have changes in the practice recommendations as comes from the RSSDI 2020. And now RSSDI recommends that in Indian circumstances, you should be considering a co-formulation like IDEC ASP to begin with, and insulin therapy should be considered for all patients failing to achieve glycemic targets on at least 3 OHCs. So ARISE was the real world evidence that I showed you, and I'll talk about my experience. And this was presented at ADA this year. And we were talking about the efficacy and safety of once daily fixed ratio co-formulation of degludec aspart plus Empalina in post-discharge COVID-19 pneumonitis type 2 diabetic patients who were treated with dexamethasone during the inpatient stay. So these were patients who were treated with dexamethasone. They were stable while they were discharged, but they were discharged on a full-on basal bolus regimen. So what we did see was the new patients who were insulin naive to begin with, they did not do too well with the 4 injections of 4 pricks a day. So frequently they discontinued the insulin, and many times we saw that they were only taking the basal insulin, and of course they were not reaching the glycemia that was desired for them. So this was a single-center study, and the data was collected from 1st June to 31st December. And these were those individuals who were non-compliant with the basal bolus regime after discharge from the hospital. So total number was about 67, and the mean age was about 60. The BMI was 26. So after 14 days of discharge, what was seen was that 88% of the patients were non-compliant with the basal bolus therapy, and 100% of them failed to achieve the glycemic goals that was desired of them. So these patients non-compliant with basal bolus, when they were switched to a convenient once daily IDEC ASP with introduction of metformin and Empalina combination, they did really well in terms of compliance. And we also did see that there was a massive drop in the postprandial glucose to the tune of about 155 milligrams per deciliter. The fasting came down by about 118.7 at the end of the study. HbA1c drop was also very significant, and you can see it dropped down from initial about 10.7 mean to about 6.85, which was desired. And also the insulin dose, although was higher to begin with, so they were either on once daily Ryzodec, or those who were not controlled were considered for twice daily. And the mean units at the beginning of the study was about 37.8. And when the study was over, it was about 17 units. And there was 100% compliance to this regime with 0 episodes of severe hypoglycemia and nocturnal hypoglycemia. So significant reduction in the glycemic parameters with better compliance and improved safety with this particular combination. So in conclusion, what we can say is that switching to IDEG as plus OADs is an efficacious and safe alternative to basal bolus regime. Post-discharge patients of COVID-19 who were treated with dexamethasone. So these were moderate to severe patients who needed ICU or HDU care. And I know that you'd be treating similar patients in your day-to-day practice. And so this might be sort of an experience that I wanted to share with you, which you can use in your clinical practice as well. So with this, thank you so much for your kind patient hearing. And I invite the next.
Good evening, folks. Thank you, Dr. Panda and Dr. Maheshwari. You have really successfully pulled off this meeting amidst the petering of Delta and the rising of Omicron. So it's hats off to that. I'm going to take you straight to managing hyperglycemia when stakes are high. The intricacies in inpatient hyperglycemia management. Center. Okay. So these are my financial disclosures. The agenda is going to be guidance for optimal management of hyperglycemia in non-critical care, benefits of the newer analogs, and my clinical experience. Let's look at the guidance for optimal management of hyperglycemia in non-critical care. Hyperglycemia and mortality in non-critical care. I think the graph speaks it all. Patients with normoglycemia, patients with known diabetes, and newly discovered hyperglycemia. So hyperglycemia is generally associated with an increased risk of mortality. And how are you going to manage this hyperglycemia in the hospital setting? And the therapy is divided into insulin, which is the recommended, and OADs, which are usually not recommended. You can have insulin, which is intravenous in the critically ill patients in ICU, and subcute insulin in the non-critically ill patients. We all know that the sliding scale is slowly sliding out because it is non-physiological with retrospective reaction to blood glucose levels, poorer glycemic control and increased risks of hypoglycemia. It promotes the glucose roller coaster and cannot predict insulin dosage requirements. It is not individualized, and it's a reactive approach practice. See and react. And you can see the roller coaster wonderfully drawn with the red graph. The basal bolus regimen has superior efficacy compared to the short-acting subcutaneous insulins. It's a physiological way of glycemic control, and ADA recommends the use of basal bolus regimen in inpatient settings. It addresses three components. It addresses the fasting state insulin requirement, bolus, the mealtime insulin requirement, and correctional. This is important. Unexpected glucose elevations or dispose of elevated hyperglycemia. Basal, bolus, and what is not known is the correctional phase. So implementing this basal bolus therapy to manage inpatient hyperglycemia in non-critically ill patients will improve glycemic control. There'll be fewer hyperglycemic and definitely hypoglycemic episodes. If you look at the dosing, in the basal bolus in non-critical care, you calculate the total daily dose. Divide this equally between basal 50% and bolus 50% insulin. Bolus insulin is divided equally or depending on the meal, usually equally between the 3 major meals. And you measure blood glucose 4 times, 3 pre-meals and 1 at bedtime. You measure the insulin sensitivity. And based on the blood glucose measurement and insulin sensitivity, you add correctional insulin to the bolus dose. And based on fasting sugar, titrate the basal insulin. The total daily dose, of course, in ideal body weight is 0.4 to 0.5 units per kilo. In obese, it is 0.5 to 0.6. And in the lean and renally compromised, it's 0.3 to 0.4. This is the correctional insulin protocol, where depending on the sensitivity, either in the usual or in the insulin resistant, you have an add-on to the bolus. You have to go for the gaps. The gaps in treatment are extremely important. In the basal bolus regimen, in-hospital requirements, ease of titration, effective glycemic control, lower risk of hypoglycemia, flexible and simple dosing, and usage in a wide range of populations. Now let's look at the benefits of newer analog insulins in inpatient care. I know Dr. Supratik and the others have given you a snapshot, but the real-world trials and real-world evidences have shown consistent efficacy and hypoglycemia benefits with degludec in outpatients with type 2 diabetes. And if you look at all the trials, Begin, Switch, Devote, and Conclude, which were random control trials, and Real World, which is EU Treat, Confirm, and Reflect, they measured A1C, FPG, doses, hypoglycemia, and had a comparator with them, Glargine U100 in most of them. In Conclude, they had Glargine U300, and in Confirm, they had Glargine U300. And it was very clear here that the arrow of reduction was to the left when you used degludec. Let's see. The important metrics of basal insulins to be clarified in inpatient care. Degludec reaches a steady state in 2 to 3 days. Glargine 300 in 3 to 4 days. And Glargine 100 in 2 to 4 days. The onset of action is within half to 1.5 hours with degludec. With Glargine 300 goes up to 2 to 6 and Glargine 100, 2 to 4. So the rapid onset of action with degludec, which attains steady state in a similar fashion compared to other basal insulin analogs, makes it very useful. The rapid attainment of glycemic control with insulin degludec in hospitalized patients, where you see that degludec was titrated daily in both medical and surgical hospitalized patients. The mean blood glucose level on day 1 was within the ADA recommended targets with degludec 180. And if you see, there was no episode of severe hypoglycemia, no hypoglycemia of severe nature, and the mean blood glucose levels were about 185. See this paper by Simeoni et al., where there was lower hypoglycemia with degludec. Only one nocturnal hypoglycemic episode occurred in this study, where the efficacy and safety of degludec for hyperglycemia management in non-critically ill hospitalized patients was seen. 48% of the population, mind you, was more than 75. And CKD was seen in 35% and PVD in 23%. So this demonstrated efficacy with very low risk of hypoglycemia. The IDEO study again confirmed the lower hypoglycemia with degludec. You see the subjects with percent of hypoglycemia when you see degludec and glargine in the no episode, in the diurnal episode, and in the nocturnal episode. And if you see in the pre-switch, see what happens where you get much better results with Declofenac. So again, demonstration of hypoglycemic efficacy, very low risk. What about glycemic variability? Today, insulin is looked at with glycemic variability, and control is looked at with glycemic variability. Because you can have people with normal fasting post-lunch, but high A1Cs because of wide swings in GV. If you look at Degludec in the graph, which is compared with Glargine 100 and with Glargine 300, you see the lower glycemic variability. Treating diabetes and insulins is a delicate path. You have to tread carefully. Just because you have potent, nice insulins with you, you can't keep shooting in the dark. So the choice of mealtime insulin is extremely important. Effective glycemic control with faster aspart. Faster aspart given 20 minutes post-meal provides similar A1C control versus insulin aspart given before meals. So aspart before meals and faster aspart up to 20 minutes after meal, similar A1C as you can see in the graph. There is lower risk of hypoglycemia with the faster aspart. And you can see overall, daytime and nocturnal when you compare faster aspart in the deep blue and insulin aspart in the gray. So significant lower risk of overall and nocturnal with fast-acting insulin aspart. What is the flexibility of faster aspart? More convenient in daily life, allows for more precise calculation of dose based on carbohydrates consumed, reduces the risk for hypoglycemia should a meal be delayed, particularly useful for elderly patients with cognitive impairment and or irregular eating habits, and also useful in those whose eating behavior is known to vary considerably. See the clock before start of a meal on the left and up to 20 minutes after the meal on the right. What is my clinical experience with the newer insulins and hospital hyperglycemia? This patient admitted for the management of an acute viral illness. These days, all illnesses are viral, remember that. Or everything else has gone under the carpet. 40-year-old male admitted with PUO, 3 months duration, known case of diabetes, past 8 years. Metformin, Sita, Telma, that's what he's on. He's well built, 80 kilos, BMI 25 roughly. His random sugar on admission 150, A1C 7.5. Now what happens? See, no insulin given, and when you start with the pre-meal, and especially when you're looking at how the scale is written there, -4, -2, same, +2, and what happens with faster aspart? With faster aspart, breakfast, lunch, and dinner, see what happens to the blood glucose reading. Day 1, day 2, and you can see how wonderfully, with proper titration, day 3 results are 130, 180, 150, 180. So the case continues on day 5, 24 hours blood glucose monitoring was done. This is another thing. Insulin is no longer FPG, PPG, and A1C. It is CGM, glycemic variability, amount of hypoglycemia. Glucometers sooner than later. Everybody goes to Dubai for the Pfizer, but when he comes back, he has the CGM machine, which he says, "Abhi mujhe kiski zarurat nahi." He moves it over his shoulder and he says, "See, my sugar is 180." So today CGMs are in vogue and they would stay. And on day 5, 24 hours blood glucose value by glucometer, as you can read, all under 150. The summary was inpatient hyperglycemia in newer insulins, Basal bolus regimen is preferred to sliding scale. Degludec is effective, safe, and can be titrated daily. Evidence has shown that Degludec cohort maintained a mean blood glucose which was within the ADA recommended targets of 140 to 180. And faster aspart is effective, safe, and offers post-meal flexibility. With these newer insulin, you have a winning edge. Maybe when we meet next year, when Omicron is behind us, and we'll have a larger meeting, probably no hybrid meeting, but a full virgin meeting of only physical. We'll probably have some other gimmick, another insulin, because every step that we take is for the benefit of our patients. Every diagnostic aid is for the benefit of the doctors and the patient. Thank you for your patient attention.
Thank you very much, Anuj. I think we'll stop there and start my talk. Thank you very much, Anuj, for this very nice introduction. First of all, congratulations on such a successful meeting. And I'm sure there'll be a lot of take-home messages from this meeting for a lot of doctors. So congratulations to you for this. And I'd like to thank Novo for giving me this opportunity to speak over here on this subject, which is of quite importance as of now, because we're looking at new metrics for glucose monitoring. And conventionally, we know that we have been talking about point of care testing, then we moved on to HbA1c. And now, of course, we're talking more about time and range as our metric for, for assessing good glycemic control. And perhaps one doesn't replace the other, and we need to see in totality how all these three metrics complement each other. What we're really looking today in my lecture is basically how does insulin play a role in getting patients to better goals in terms of time and range. How do I change my slide, please? On the screen. Cursor. Okay. Okay, thank you. So these are the financial disclosures, and I'm going to start my talk about a little bit of introduction of time and range and its implication. Here, you have two patients, both of them with identical HbA1c, but the difference between the two groups is what you look at is the variation of glucose control in both of them. So if you look at the upper graph, this patient has got a lot of glycemic variability and yet an A1C of 8%, whereas the second patient has got a lower glycemic variability and yet has an A1C of 8%. But what matters is basically the patient who's up swings between hyper and hypoglycemia. And here in the second patient, you find that these episodes are lower. We know now that one of the reasons for all complications of diabetes is glycemic variability. And if you can minimize this glycemic variability, then obviously our patients are going to do much better. All right. So what do we really mean by time and range? It refers to the idea that what is the percentage of time in a day a patient is between the range of 70 to 180. And that is basically what we call as a good time and range. And majority of our patients should be within that range. And if you want to look at tight glycemic control, then the patients between 70 to 140 is the target, that how much time they spend in this range. We also talk about time above range and below range to indicate hyper and hypoglycemia. And time in range may be more appropriate endpoint for clinical research as a measure of glycemic control in patients with diabetes. There's now, of course, a lot of emerging evidence that time in range is inversely correlated to risk of developing micro and macrovascular complications. And I will just present some of the data in some of the coming slides on this. All right. So there was just recently published in 2019, the International Consensus Report on continuous glucose monitoring and the concept of time in range. And the purpose was basically to give a unified guideline on and recommendations for clinicians, researchers, and patients with diabetes on the use, interpretation, and how to make decisions based on CGM data for effective diabetes management. And this was, of course, based on the fact that in 2012, there were the first recommendations by the expert panel on standardization of CGM metrics. And in 2017, there were various publications in CGM metrics and data to evaluate, but there was no formal adoption by professional organizations and applications in clinical practice. So finally, in 2019, the international consensus at ATT to develop CGM targets based on currently agreed upon CGM metrics. All right. Now, what it really points out in this graph is basically most of our patients should be within the range of 70 to 180 majority of the time. So more than 70% of the time, 16 hours and 48 minutes is basically what they really actually quantified. And the time that somebody can spend below and above range has also been specified. So above 180 and 250, how much is allowable time in a day, and below range, of course. Our endeavor should always be to see that we should try and keep majority of the time on majority of the patients within the target goals of 70 to 180. Based on the various studies, it has been shown that each incremental 5% increase in TIR is associated with clinically significant benefits for type 1 and type 2 individuals. And we'll see that in the coming data. Now, there have been also sort of, categories of patients where we may need to make some adjustments. So in the older patients, you want to see that patients are lesser sort of tightly controlled for the risk of hypoglycemia. So you shift this time in range to see that majority of the time the patient could be between 140 to 180 rather than go down all the way up to 70. So then you make these adjustments to see that the patient's goals are a little more relaxed and to avoid hypoglycemia. Whereas in pregnancy, you want to have more tighter controls for the benefits on the fetus. So you want to see that majority of the patients are in tight glycemic control so that you can achieve an A1C target, which is recommended for GDM and pregnancy. There is a correlation between A1C and percentage of time in range. And this has been quantified that if you look at the right side of the table, you see that 10%, 20%, 30% is the equivalent of what you see in A1Cs. So this is very similar to what we call about estimated average glucose, where you equate the HbA1c to estimated average glucose. And here you've got time in range, which has been equated to HbA1c. But what is important is to understand for every absolute 10% change in percentage of time in range, there was approximately 0.8% reduction in the A1C values. So here you can see the correlation between time in range and microvascular complications. And clearly you can see from this bar diagram that for every 10% less in time in range, the retinopathy progression increased by 64%. And very similarly, you see the progression even in microalbuminuria, that 10% less TIR causes a progression to be increased by 40%. So there is a very good correlation. And here you find there's a correlation between the carotid intermedia thickness and for significant association in TIR and CIMT, which could become a predictor for future cardiovascular events. So for every 10% increase in TIR, there was a 6.4% lower risk of abnormal CIMT. And here they've sort of shown the association between time in range and MACE events. And here you can see that they've tried to see above 70% versus below 70%. So all those, this is from the derived time in range. This is from the SMBG. Basically, they do a derived time in range. And you find that if you can keep your derived time in range more than 70%, there is a 27% reduction in the risk for MACE. And if you compare derived time in range more than 70% versus less than or equal to 50%, there is yet a 31% reduction in MACE. And when compared between 50 to 70 versus less than or equal to 50%, there is a 9% reduction in the occurrences of MACE. And this basically was maintained when analysis was adjusted for all the baseline characteristics. Here you can see basically a 10-year cumulative incidence of developing diabetes-related complications after improving time in range. And here they've looked at sort of 3 targets, 58% TIR, 70% and 80%, both for type 1 and type 2. And you look at the endpoints, whether it's myocardial infarction, end-stage renal disease, severe vision loss, or amputation. You find that when the patient is 58% in TIR, and compare that against 70% TIR, you find a very significant reduction. But when you go from 70 to 80, there's not much of a significant change that you really see. So there is that's why the cutoff point of 70% that you really see, and whether you see in type 1 or type 2, and across all the endpoints of occurrences, whether you look at all the, myocardial infarction or ESRD or vision or amputation. All right. My second point is, of course, how do you really visualize the benefits of neuroanalogs through time and range? And this is basically the timeline of action of Degludec. You can clearly see this has been compared again U100 glargine. The mean half-life for Degludec, irrespective of the dose that you use, whether it's 0.4, 0.6, or 0.8 units per kilogram, the half-life, mean half-life is about 25 hours. Whereas when you look at U100, whether it's 0.4, 0.6, or 0.8, the mean half-life is 12 hours. And if you look at the right side of the graphs, you see that there is a flat action curve that you see over here with no peaking effect. So that proves that there is a good uniform glucose lowering effect that is present throughout the day. All right. And this actually happens with very minimal or no glycemic variability. So here they've compared Degludec versus U100 and U300. And you can see here that there is there's no peaking effect of Degludec, and there is no variability that you can see in action between the Degludec and U100 or U300. And here, through RCTs and real-world evidences, they've shown a consistent efficacy in hypoglycemia, the comparator being Degludec versus U100 or U300. And if you look at the RCTs, whether Begin, Switch, or Devote, these were non-inferiority trials, and you can see that A1C was comparable, but the reduction in fasting plasma glucose and the dose required for achieving targets was much lower with Degludec when compared against U100. And the rates of hypoglycemia or severe or nocturnal hypoglycemia were much lower with Degludec when compared with glargine. And then if you look at the real world evidence, you find that there's a clear benefit with Degludec when compared against U100, Detamir, or NPH in the different studies. And even when you switched insulins from one to the other, and the patients who were switched from glargine to Degludec, you found that the benefit continued to improve when patients were put on Degludec. But this is a very important study, the Switch Pro RCT, and there they compared Degludec versus U100. There was an initial screening period, run-in period, and then the patients were put on flash glucose monitoring for 2 weeks. That was the baseline flash glucose monitoring data. And the randomization happened between 2 groups. That's Degludec once a day with the baseline oral agents versus glargine U100 once a day at the background of oral agents. And then after 16 weeks, they were again put on flash glucose monitoring. And at the end of 2 weeks of flash glucose monitoring data, they were then interchanged. So the patients who were on glargine were switched to Degludec, and the patients who were on Degludec were switched to glargine. And then they had another 16 weeks followed by 2 weeks of flash glucose monitoring data. So here you find that they were trying to see the benefit between one against the other. And when they were shifted from the interchange, did the benefit continue or what happened to the benefits? And here you can clearly see that the time in range where Degludec was, when it was compared against U100, there was an estimated treatment difference of about 1.43%, or almost 20 minutes of the patients in the day were more in time in range when the patients were on Degludec against U100. Similarly, if you see here the overall tight glycemic range that's the between 70 to 140, you found that patients were almost about 22 minutes of the day more in time and range between 70 to 140 when patients were put on degludec against U100. Here you're looking at basically more when you compare degludec versus glargine, what were the improvements in time and range? And you can see clearly that almost 37% improvement with degludec as compared to glargine that was seen when patients were put on more tight glycemic control. What about patients below time and range? So time below range, you found that there was a lesser number of patients or lesser time that the patients were in time below range when the patients were on degludec when compared against U100. So I'm going to end my talk here, and I hope I've kept to my time limit, that in summary, time and range provides a complete visualization of the patient's glycemic status and aids in better glycemic control. Increasing time and range has shown to reduce microvascular and macrovascular complications in people with diabetes. And when you compare degludec versus U100 glargine, there is an improved time and range. Superiority is confirmed. There's an improved height time and range that's between 70 to 140. There's a lower time below range, level 1 and level 2. And there are more patients who achieved clinically significant improvement in time and range. So I'll thank you for listening very patiently, and thank the organizers for inviting me here today. Thank you very much.
Thank you, Dr. Sanjay Agarwal. Please be seated. I invite all the panelists.
All the speakers, please join us on the dais.
Dr. Hemant Thakur, Dr. Rajiv Awasthi, Dr. Supratik Bhattacharya over here.
I think Dr. Rajiv Awasthi is not there. The picture.
Yeah.
The picture what you are seeing repeatedly on your speaker, that is our last oration. Dr. Rebecca Andrews. So that's why we are flashing that you please stay with us, because it's still, pardon? Yeah, no, oration is coming. That is the biggest attraction of the conference. So she's the oration, ACP India oration by Rebecca Andrews. She's the Board of Governors chair of the Board of Governors. So, but before that, we'll be having a talk of the Rajiv Koval. But quick question answer session.
To start with Dr. Supratik, you have rightly mentioned the details of the ARISE study, and also spoke the clinical trials and the real world evidence. So for primary care physician in this context, what message you want to give? Because you see, most of the hospitals don't have analog supply in the remote peripheries. And what we have found that the dose required for a person for the control of the blood glucose is almost equal, whether it's a human insulin or the analog insulin or the different preparations available. So those who can afford, for them, we can have a better option. And keeping everything in view, what in the 100th year of insulin discovery, what message we can give to the people practicing in a rural setup?
Thank you, Professor Panda, for this question. I think it's a very pertinent question. So the first clarification is insulin. So it will do its job of getting the glycemia to target. It only differs in how it does it. So the newer insulins that you get, they will get the glycemia to target with lesser number of hypoglycemic events, especially the nocturnal hypoglycemia that we want to avoid. Now, if you are educating the masses well, if you're teaching them how to use the insulin, whatever it is, even if it's human insulin, if you're teaching them how to take it, then there are very less chances that they will end up in hypoglycemia and they will get to the targets safely. Now, obviously, it all depends on, if I don't have the capacity to buy a Ferrari, I have to do with Maruti or whatever I can do. And the whole idea is to get to here. From here to, I have to get to my destination. So I can go in a Ferrari, I can go in my Maruti. It doesn't make a difference at all. So for a primary care physician, what you have to understand is you have to make the best utilization of what you have in hand. So But at the same time, what we want to emphasize is, I hope the government intervenes and makes this analog insulins available because of the safety issues. And, like even a single episode of hypoglycemia might land the patient in the hospital, which will add to the cost burden. So if you calculate the risk-benefit ratio, I think it'd be prudent to actually audit and try to understand whether there is a necessity to bring in insulins like IDEC Aspart on board, even for the primary physicians' use as well.
Next question to Dr. Hemant Thakkar. I really appreciate that view of Dr. Supratik Bhattacharya that every villager should be in the Ferrari. And as it is looks like whether how much it is realistic, the same way I can say low risk of hypoglycemia with insulin. Using insulin, still there is no hypoglycemia, low risk of the hypoglycemia. How much this statement looks realistic, and how can we promote it to the primary care people that insulin लगाओगे तभी भी hypoglycemia नहीं होगा? So how will it work?
So, Dr. Maheshwari, from Firangi to Ferrari, you've asked a lot of questions. You began. So we'll now talk about this low risk. No insulin has no risk of hypoglycemia. If there is insulin, there has to be hypoglycemia. Yes. So when you have a choice that all the desserts are sweet, you look for the least sweet dessert. You look for that insulin which shows in the studies, devote switch, falana, that the hypoglycemia, the overall and the nocturnal is least. That gives more liberty to the hands of the prescribing physician and more confidence to the hands of the injecting patient, that his likelihood, his chances, this does not take away from your titration or from your clinical judgment, which you have to indulge in. But if you have a choice between the two, one which has documentary evidence of low hypoglycemia, not no, but low hypoglycemia, that's what these studies depict. Thank you.
Dr. Sanjay Agarwal, I have a patient which is coming from the village background and he is using the conventional insulin, premix insulin, and he's very happy with that. He never had any hypoglycemia. How should I convince him to use this better quality of the insulin, which may keep him better, more time with the TIR, which may keep with the least glycemic variability? How can I say, when I say that you will not be having hypoglycemia, saying I'm already not having any hypoglycemia, why do you say I should take this more expensive one?
So I think number one, what is important is choose your patients well for choosing insulin. That's the first thing, because not everybody is a candidate for your regular insulins, and not everybody is a candidate for analog insulins either. Because cost remains an important concern where we are concerned. Because if you have patients whom you're putting on analogs and they can't afford it, they're not going to sustain and take it. And you'll end up giving the patient hyperglycemia because he's not going to take those insulins. So at the end of the day, if you look at the comparative data of all the insulins, when you look at A1C reductions, all are comparable. What matters at the end of the day is the percentage of hypoglycemia that you get. If you're using lower doses of insulin and where you feel that the risk of hypoglycemia is very low, I think you're good enough to continue even with NPH. So NPH as a basal still continues to be used in our populations, in large number of populations. When it comes to using higher doses, where the requirement is very high, there is always a peaking effect that happens. And the higher the dose, the higher the chances of hypoglycemia. That's where perhaps analogs have got an edge over your regular insulins. So I think choose your patients. Again, if you're looking at populations who have got, let's say, a kidney failure or a liver failure, where you feel that there is a risk of or elderly patients, where you feel that there is a higher risk for hypoglycemia, that's where perhaps the analogs have got an edge over regular insulins. So I think if your patient is doing well and is managing very well on regular insulins, why not just continue with it? I mean, he's doing a fairly good job. He's happy with it. His glycemic goals are met and he's got no hypoglycemia. I would not consider him shifting to an analog insulin at all.
The same thing happened. The fourth question I'm asking from the share of Dr. Rajiv Awasthi, although he's not there, any one of you can give the answer. What you are saying, that is exactly very right. And the same thing has happened in my state, Uttar Pradesh, from which I am coming. The government, when changed, and it has made available all these kinds of the insulin at primary health centers. After 6 months or 1 year, we could know that no one is using them. People are still using the old conventional one, and they say that when we are getting the appropriate result from that, and why should we start using this one? And they are just going unused and maybe expired after some time. So this is the change. This is a requirement of the change of concept. How should we develop this kind of the concept that people should start using in Ferrari if it is available, instead of still using the Belgadi or bullock cart what they were using?
So, the thing is, even if you're using a Ferrari, you still need to be trained enough that you don't hit it somewhere. And you need to be on an express highway to enjoy the speed of the Ferrari. Yes. Otherwise, your Maruti is good enough also.
So coming back to the science in your question.
Yes.
Like I said in my lecture, today diabetes is not measured by the FPG, PPG, A1C. There is CGM, there is time in range, and there is glycemic variability. So to all those people in Uttar Pradesh who see it on the shelf but don't reach out, if you preach this concept that you can have good A1C but still have a lot of complications because of glycemic variability, that you need to have time in range for every section of your patients: regular, pregnancy, elderly, geriatric, and time in range is important. And like I said, everybody who comes back from Dubai with his Pfizer, if he's diabetic, he comes with his CGM. So the CGM is extremely important, especially if you are doing basal bolus monitoring. So if you brought these new concepts into the awareness field of those physicians, I'm sure they'll adopt it. Because finally, you have to tread into those areas which you are shy and don't want to jump in. You think your world is happy and good until COVID hits. So you have to be agile and aware.
Quick concluding remarks. So I think CMEs like this with focus on primary physicians is very, very important, because many a times in my clinical practice, when this co-formulation was launched, the physicians at the primary level didn't know what Rhizotec was. And I've seen many a times the prescriptions, I usually send them back when they're well controlled to their physicians, and the insulin was getting replaced because they had no idea how to use this. So I think this kind of CMEs are very important to percolate that knowledge. Doing small workshops with them is very good, very essential to percolate that knowledge. And going back to the analogy, so the car is, say Ferrari is costlier for a reason. It's not only the outside, how it looks, but the safety features that are added to it. So it depends on how bumpy is the ride. So, like you can get to the destination without any safety hassles, with a better safety profile. And that's exactly what these analogs do. Thank you.
Thank you. Thank you.
All the speakers. We had a very interactive symposium on 100 years of insulin discovery. And the message is we have to keep the choice for every group of, every group of people. We should have bullock cart and also Ferrari. So in the era of technology, there should be options for everyone. Thank you. Thank you all. Please.
Thank you so much, sirs. And with this, we proceed to the next session. And for that, I would like to call Dr. Purvi Chawla and Dr. Hemant Mitra as our chairpersons for the next session.
Good evening, everyone. So thank you, Dr. Maheshwari, Dr. Panda, Dr. Narsingh Verma, Dr. Supratik, Dr. Srinivas Murthy, and Dr. Nayak for having us all here and congratulations on such a successful meeting. Well, I think as they say, the rise of an orthopedic surgeon depends on the fall of his patient, and the success of a cardiologist's practice depends on the failure of the heart of his patient. But given the burden of heart failure in our country, and especially in patients of diabetes, who better than a diabetologist to talk to us about empowering the spectrum of heart failure care? With that, it's my pleasure to invite Dr. Rajiv Koval. As you all know, he's a physician diabetologist from Mumbai at Dr. Koval's diabetes clinic, and also attached to Nanavati Super Specialty and Raheja hospitals, besides other hospitals, and speaker on many international as well as national forums. Without much ado, Rajiv, please take.
Thank you so much. Two jitters, few things in the stomach, standing on a podium, hearing Supratik talk about Meri Dad Ki Ferrari. You know, we should all change to Calcutta now. So I'm going to talk about Emperor program and implications of it in heart failure care. If I see. Okay. So heart failure, a few years back when we had hosted an international speaker for Declare Timmy, and we asked the audience that how many of you all treat heart failure? And out of a crowd of almost 100 people, where 30 were cardiologists, only 1 or 2 put up their hand and said, we treat heart failure. So heart failure from then, 5 years back to now, has actually been hitting us, grabbing all the eyeballs. Unfortunately, we missed the diagnosis. And that's why there was a need to come for a uniform diagnosis and definition of heart failure, where there are symptoms of heart failure with structural or functional abnormality, but mainly it's a clinical diagnosis. You endorse it with certain peptides and evidence of pulmonary congestion. And we all know that there are a lot of abnormalities in patients with type 2 diabetes, which drives all kinds of cardiovascular events, whether it's AFib, coronary artery disease, and heart failure. And I was speaking to a friend from the UK, and majority of their heart failure clinics has got Indians, and foot clinics have got Caucasians, you know. So there is a problem, and a lot of data has also suggested that the association between complications and diabetes, heart failure comes second to only peripheral neuropathy. Again, if you look at this, we give a lot of importance to atherosclerotic cardiovascular disease, but the annual event rate is around 5 to 7%. Heart failure's event rate is 10 to 15%. We see it, we miss it. Patient goes to a cardiologist and is lost to follow-up. So there are a lot of times we actually don't recognize heart failure. We push it as bronchitis, LRTI, and all those kinds of things. So if you look at empagliflozin, it's the whole continuum of heart disease, right from atherosclerotic cardiovascular disease to HFrEF to HFpEF, and also to acute congested heart failure with the EMPULSE study, which came at the AHA. It has actually set its foot right in all the complications or cardiovascular events in patients with diabetes. And again, this fairy tale of the EMPA-REG, which came almost 6 years back, where there was a 38% reduction in cardiovascular death. And in the subgroups of us, the Asian Indian, there was a 56% reduction in cardiovascular death. This is extremely important because statins are the foundation of preventive cardiology, but all statin studies have shown around 15% reduction in cardiovascular death. And here you have a drug which is an anti-diabetic. That's why we all become diabetocardiologists, which was giving almost 40% reduction in cardiovascular death. And that changed the paradigm of all of us who are treating diabetes. Again, if you look at it, that the death due to worsening of heart failure, so a lot of adverse cardiovascular events occur in patients with heart failure. It could be sudden cardiac death, cardiogenic shock, or sudden cardiac death. All this were reduced in the EMPA-REG, which is a sub-analysis. And we are still scratching our brains at how does SGLT2 work, whether it's the reduction, whether it's a natriuresis, diuresis, oxidative stress, that we can keep scratching. But it has actually put its foot in all kinds of cardiovascular complications. Emperor Reduce is a very, very good trial. It comes after the DAPA-HF study. And again, it's a phase 3 randomized double-blind placebo-controlled study where we are adding empagliflozin to patients with an LVF of less than 40%. What was different as compared to DAPA-HF, that here you had the EF was much, much lower than patients in the DAPA-HF. You had almost a median EF of 27%, which was very similar to the paradigm study. Again, if you look at the primary outcome, it's cardiovascular death or HHF. The key secondary outcome is the total hospitalization to heart failure, and also to look at how these drugs are affecting the kidneys. And again, if you look at it, the composite of CV death or HHF, EMPA versus placebo on standard of care in patients with reduced ejection fraction, you have a 25% reduction with a very significant p-value. And if you look at baseline characteristics here, whether the patient is old, young, importantly, whether patient is on an MRA. We all know that MRAs today have established their role in heart failure with reduced ejection fraction and also with ARNI. If you look at the last point, whether if the patient is on ARNI, you have a synergistic advantage. You have a 36% reduction in the primary endpoint when you use SGLT2 with an ARNI. And again, with an MRA. So there is a new data which talks about MRA as well as SGLT2 inhibitor should come much, much higher rather than an ARNI, which is used in HFrEF as such. And again, if you look at the worsening of heart failure or reduction in mortality, it comes very, very early, as we had seen in the EMPA-REG around the 29th day. And here in Emperor Reduce, close to 12th day, you're getting significant benefit as such. Emperor Preserve study. Now, HFpEF has always been something which we have again scratched our mind. A lot of people believe that it's a myth. There's nothing like HFpEF. HFpEF is HFrEF patients who have got better. And there is another school of thought which says that the heart failure with medium ejection fraction is again reduced ejection fraction patients who have got better. That's why there was a consensus that you have HFrEF, you have HFpEF and HFmEF also, where HFmEF is between 40 to 50 and HFpEF is purely above 40. That's why when you look at the Paragon HF, which is the study with ARNI, majority of benefits was seen in the 40 to 50% LVEF as compared to this particular study where majority of benefit is seen above 50%, where we're actually talking about HFpEF. And if you go back to any of the studies of SGLT2, it has actually reduced the hospitalization due to new onset heart failure. And majority of these patients were HFpEF. And if you go back in history to proactive study also, most of the patients who went into the ICU with heart failure were patients who had HFpEF. So with that scenario, Emperor Preserved and HFpEF is more common in our patients with type 2 diabetes than HFrEF because most of them go back to cardiologists itself. And again, if you see, there's a good 21% reduction in these patients with heart failure with preserved ejection fraction. And if you slice them down into 41 to 49 and more than 50%, which is true HFpEF, there's a significant reduction in the individual components of CV death or HHF or first hospitalization for heart failure. Again, these benefits, as we saw in the HFrEF study also, is across the range. So whether there's no gender difference, there's no baseline difference, whether patient has diabetes or no diabetes, whether the EGFR, majority of the patient, almost 60% had an EGFR below 60. Again, AFib or atrial flutter also did not change anything. Again, if you look at the secondary endpoint, which was progression in GFR, we have good studies. We have the DAPA-CKD, but again, this is a secondary pre-specified endpoint, which looks at the 50% reduction in the progression of reduction of EGFR in the HFrEF as well as the HFpEF study. Again, empagliflozin does not worsen overall safety in patients with HFrEF with or without diabetes. So whether the patient has diabetes, has metabolic syndrome, doesn't matter. These patients do benefit with this. Again, it's not associated with electrolyte disturbances. This paper came in June, which spoke about hyperkalemia and how hyperkalemia risk goes down. And when we are using an MRA on top of SGLT2, that's a huge serious risk. And that's what the paper suggested in the post hoc analysis, that when we use an SGLT2 with an MRA, also the hyperkalemia does not increase as such. Again, if you look at it, it's regardless of the use of ERNI, there is advantage much higher in the HFrEF as compared to the HFpEF. So again, as I spoke about hyperkalemia, again, the incidence of hyperkalemia goes down when we use an SGLT2, whether the patient has MRA use or no MRA use. Again, there's a 22% lower risk of discontinuation in MRA therapy in patients who are using an SGLT2. So this is very important because when we use many other drugs, the patients, we withdraw an MRA because of hyperkalemia. And what we see is that when we use an SGLT2, the chances of hyperkalemia goes down and the durability of a treatment of an MRA plus an SGLT2, which later may be followed by an ERNI, goes much, much higher. So the ACC pathway reinforces the simplicity of use. Again, single dose, once daily, no titration. Again, it's an early, meaningful efficacy, ease of use, consistent benefits across subgroups, and again, an overall safety benefit and kidney safety. Thank you all for the patient care.
Well, that was a beautiful talk, sir, and you explained it all. The only concern here in the diabetic patient is that you've all heard about the 4 pillars and used in the treatment of heart failure, namely ACE/ARB or ARNI, beta blocker, MRAs.
Go ahead because these guys will kill me.
Okay.
And there is a pretty lady sitting behind. But yes, you are right. This is the 4 pillars which I didn't go into. That this is the 4 pillars that one should look at, and fantastic data which suggests that this is the rapid sequencing which we should do in patients with heart failure. Rather than apna ADA ESD where we want one drug to fail, then add another drug, you get complications in between. You need to go like cowboys in heart failure. And this is the rapid sequencing, beta blocker plus SGLT2, then an ARNI and then an MRA.
So what precaution will you take in a diabetic patient specifically on insulins while using the beta blockers?
So whether you look at any beta blocker today, whether it's a carvedilol or a bisoprolol or a metoprolol, in all its heart failure studies, with MERIT-HF, Copernicus, there has been no increase in the incidence of type 2 diabetes. So these are very beta-1 selective blockers. So we don't see a lot of incidence of diabetes coming in, if that is what your question is all about. But, and even if there is, rosuvastatin had raised some eyebrow. Even if there is a mild increase, if you look at the advantages of a beta blocker in heart failure, you still use
it. Thank you so much for that wonderful talk and crunched so well.
Thank you.
With that, we move on to the next.
Thank you, chairpersons, and thank you, speaker, sir. We now proceed to the very prestigious ACP India oration by Rebecca Andrews. And for that, I would like to call our Governor, Dr. Anuj Maheshwari, and Dr. Padma Shri Gulati ma'am on the stage as chairpersons, please.
Thank you for good that we are reaching to the last part of the program of the day, and that is very much important. Our honor lecture of this conference, that is ACP India oration. Again, like Dr. Muruganathan oration, this oration is being started for the first time from this conference. So this ACP India oration is being first time in our ACP annual conference, ACP India chapter annual conference is being delivered by our chair of the board of governors, American College of the Physicians, Dr. Rebecca Andrews. She is professor of the medicine at University College of the School of Medicine. She is associate program director in internal medicine residency program, and she is presently working for the ACP as well as having a major achievement physicians with the physician lead primary care medical home. And with these words, I won't waste much of the time. because we would love to listen her instead of her CV. So over to Dr. Rebecca Andrews for your deliberation, which we are waiting since morning. Okay.
Thank you so much for having me today. I'm going to share my screen so I can start the talk. I want you to know that I've been listening this morning, and this was a great conference that I've been at so far. I have learned a lot and I've really enjoyed it. So I really want to thank you for inviting me and giving me a link to join early. Just some few disclosures before I start. I do work at the University of Connecticut Health Center. I am also the ACP chair for the Board of Governors, and I do some medical legal consulting work as an expert witness. I have 4 objectives today. I'd really like to go over the purpose of primary care and then review some high functioning primary care systems. Then I wanted to review some cancer screening guidelines, as well as look at what disease-driven guideline care is for some chronic diseases that help us make sure we're giving the very best care we can for our patients in primary care. So let's start with the purpose of primary care. The WHO has recognized the importance of primary care for decades. There are 8 elements to primary health care. They stem from education to access to such things as water, sanitation, good food, appropriate medical treatments, as well as drug therapy, and then education and health prevention such as maternal and child health, immunizations, and then prevention of diseases. Primary care sits in the middle between public health with primary prevention and secondary prevention, where's the bulk of our work. We do treat chronic diseases, and then we cross over a little bit into tertiary prevention as well. It's interesting though, 80% of our patients' health is determined by things that are outside of traditional healthcare. It is health behaviors, but also socio and economic factors such as education and physical environments such as air and water quality, which we really have a lot of limitations to control.
Dr. Rebecca, did you share your slides or you have not shared?
I did.
Yet?
Can you not see them?
No, not yet. They are not shared yet. Yes, now it is.
You can see them now?
Yeah, now it is there. Please make it full screen.
Let me see. Can you see?
Yes.
Can you see it now?
Yes. Now
it's on the first page.
Yes. That's great.
So thank you very much for interrupting me. I'll just walk through. These are just the slides that I touched on already with public health and primary care. This is where we are with health behaviors, socioeconomic factors, and then the physical environment of our patients that we have limited control over. This slide indicates the social determinants of health. Again, these are probably the most important aspects of our patients' care, but we also have the least ability to control them, such as I mentioned, education and the communities that they live in. In the United States, primary care is made up of family medicine, internal medicine, and pediatric physicians. I'm going to harp on now where the US falls short. I am a primary care physician and I do love practicing in the United States, but we do not do all of primary care well. In fact, we spend twice as much as other countries on our healthcare per person. And our outcomes for that amount of money that we spend really aren't that great. If you look here, you can see over the last 4 decades, we are increasing our spending faster than any other countries. And when you look where we spend our money, you can see that we spend less on social service spending. The mean is located here in the center of this slide, with red representing social services spending and the blue healthcare spending. So we avoid spending money on some of those most important aspects. So where does the money go? It certainly doesn't go to primary care. In the United States, the majority of our money that is spent on healthcare goes to prescription medications and other medical equipment, with less than 8% being spent on primary care, which is really unfortunate considering that more than half of our office visits are to primary care physicians. And for all that money that we spend, what do we get? Well, we have the highest rate of avoidable deaths, unfortunately. We have a low life expectancy when compared to other countries. And we have more adults with multiple chronic conditions than other countries. We also spend more on testing as far as imaging, and some of this in the United States is driven by patient preference. Now, there are some good things about the United States healthcare and primary care system. We do have lower hospitalization rates. We have pretty high vaccination rates for flu and other immunizations, and we have high cancer screening rates, especially with breast cancer. So how do you make a high functioning primary care system? If I had all the power to change my healthcare system, what would I do? Well, primary care should be integrated. It needs to be accessible. We have to be able to treat the majority of the health needs of our patients, and we need these sustained patient-physician relationships that are built up and maintained over time. Since 1978, the WHO has said that we should be the first contact for each new patient need that we have, and we should have person-focused care, not disease-focused care in the primary care world. We need to provide comprehensive health and then coordinate our care with specialists when it is needed. In order to make big changes, you need your organization, your government on board. There has to be a push. It has to be recognized as an important need, and it has to be recognized that good primary care actually improves the health care of everyone. But there also has to be a mechanism of action, a way to have governmental policies that can increase the quality of primary care. The ACP has a new vision of healthcare. They published 4 papers in the Annals of Internal Medicine, and these were written to serve as sort of a blueprint for the United States government to rectify some of the areas where we fall short in the United States. Not long after that, about a year, this report was followed by NASM, which is focuses on engineering, medicine, and all the sciences. And they actually claim that primary care is a common good, equating it with such things as public safety and public education, that it is that important. There are many more than 100 studies that have shown that nations that have a larger primary care workforce have better outcomes. Now, this does not mean we can practice without our specialists. It's really about the ratio of primary care to specialist care. And there are statistics that say when you have a higher specialist to population rate versus a higher primary care to specialist rate, to population rate, you have higher mortality and higher cost. Whereas if you can increase the supply of your primary care physicians, you will have lower total and heart disease mortality rates. So when we look at primary care spending with avoidable, like what it can give for you, it can give you decreased hospitalizations, decreased cost, decreased emergency room visits, less fragmented care, less use of specialists when they are not necessary, and more coordinated care when they are. There was a study in 2015 that looked at primary care physicians. We are not all the same. Some practice more comprehensive medicine, and some refer to specialists on a frequent basis. But when the physician is more comprehensive, we lower cost and we lower hospitalization. When looking at our most complex patients in primary care or across the health system, we see that it is the primary care physicians who are seeing 90% of the patients that have 4 or more diseases. They're there to balance those challenges. Like in the last talk we just heard, if you have a patient with heart failure who's on a beta blocker and you have to worry about hypoglycemia, the primary care physician can balance those competing needs. Sweden has a great primary care system. When comparing their outcomes to other countries in the European Union, we see greater life expectancy, reduced lifestyle risky behavior. However, to get there, they're in the top 3 countries of public spending on healthcare. But they're able to avoid hospitalizations for chronic conditions in comparison. They are not perfect. They have relatively low colorectal cancer screening rates, and there are some ideas as to why. But even in this system that is high functioning with a lot of support and spending in primary care, they have a hard time with primary care recruitment and retention. So I hope before I go into the next portion of my talk, I have laid the groundwork that primary care in high numbers can really produce a high quality level of health for all of our patients, regardless of our specialty of practice. As I mentioned, primary care physicians are responsible for screening and prevention, as well as chronic disease care. Just a few reminders. So screening tests really have to have a benefit that outweighs a risk. They have to be able to detect disease early, be cost effective, and not cause more harm. Whereas clinical guidelines help ensure that the standard of care is happening. They're recommendations, they are not hard and fast rules, and you have to weigh, these guidelines are based on the science that weigh the risks and benefits and come up with updates, typically from a committee that is composed of specialists. There are a host of guidelines, and the CDC website usually will collate a few of these together to show you best practices. As an internist, I follow the ACP and the United States Preventative Service Task Force. I'm going to start with breast cancer, and not for all of the cancers, but for this one, I'm going to go into just a smidge of the details in the research that's out there to give you an idea of how much work goes into these guidelines. Breast cancer is probably our most controversial cancer screening in the United States. There's controversy over when to start, when to stop, interval between screenings, and what method is best. And it's important because breast cancer is the most common cancer in women. We diagnose 1 million cases every year. And really what we're looking for is something that is an effective screening before a mass is even palpable. We have seen decreased mortality, but there is some concern that there is overdiagnosis and overtreatment that has significant harm. We know that there are both hormone-related and non-hormone-related breast cancer risk factors for our women. Today, we're going to talk about only the women who are at average risk. If you want to know, what makes someone high risk, you can read the categories here, but there are actually online risk assessments, most notably the GALE model or the National Cancer Institute model, that will help you figure out if you're dealing with a woman that has above average risk. So when looking at breast cancer screening, we have 3 options: mammography, clinical breast exam, and self-breast exam. However, self-breast exam is no longer recommended by any agency. So for clinical breast exam, ACOG, which is our GYN group, like our ACP home, they recommend that clinical breast exams should still be done, and they recommend them starting at the age 25. This actually differs from all the other recommendations, and the American Cancer Society just updated theirs this year that they are no longer recommended. So let's talk about the first controversy, mammograms in the 40s. The ACP and the U.S. Preventative Service Task Force has recognized that there's significant harm that can come with screening women in their 40s. And so they've said, really, this should not be routine screening. There may be women who are high enough risk that the harm that could come is worth the benefit of screening. That differs from ACOG, who says we should screen every 1 to 2 years starting at 40. And the American Cancer Society just increased the age to start from 40 to 45, making their recommendation more in line with the USPSTF and the ACP. Why is there a controversy? I only put one trial up here. There are so many more. There are trials that you really have to delve into the details. 2 Swedish trials did show a 31% reduction in mortality. However, they grouped all women 40 to 74 together, and they did not separate women in the 4th decade. The age trial showed that with mammogram, there is a lower sensitivity rate in women and high positive, false positive rates, which led to unnecessary biopsies. And when looking at some of the Mayo Clinic records, they did a review of 70 years of breast cancer and found for really young women, those cancers were aggressive, genetic based, and there was no indication that screening would have helped them. So while early screening is great to catch and treat cancer, we really have to note that there's adverse risks of overtreatment and too aggressive treatment, as well as anxiety for warning a woman that she may have an abnormality that ends up being benign. And this is an example of the numbers. A 42-year-old woman who has never had children, we can reduce her relative risk by 15% with mammogram, but she will be called back for more imaging 40% of the time, and then she will have an unnecessary biopsy 3% of the time, which makes future mammograms more difficult to read. If you're interested in reading more about screening effectiveness and overdiagnosis, there is a great article in the New England Journal of Medicine from 2016 on this in breast cancer. The next controversy was, should we ever stop screening? So the ACP and the USPSTF are really in line. At 74, you have to consider stopping. If you do choose to screen later, then you have to have a good indication why, and you would stop if there's a 10-year, less than a 10-year life expectancy. This differs markedly from ACOG and the American Cancer Society, who both say, as long as your female patients are in good health and have a 10-year life expectancy, you can continue to screen them. So where do we all agree? Pretty much 50 to 74 years of age, there is a mortality benefit to mammogram screening for breast cancer. We disagree a little bit on how often we should screen. USPSTF and ACP think every 2 years, whereas ACOG will say screen them annually, but you can do every 2 years as an option. And the American Cancer Society, which is more in line with the ACP, says do every 2 years, but you can do it every year if the patient asks. That is a lot on breast cancer alone. I promise the other screening guidelines won't take too long, but again, I did want to highlight just how long it takes to go through all the evidence so that we can make sure that we are on top of the very best care for our patients. For cervical cancer, there's a lot more consensus. Women under the age of 30 have screening with only cytology every 3 years. Women over the age of 30, until we stop screening, have 3 options: cytology every 3 years, cytology with HPV every 5, or the new high-risk HPV testing done alone without cytology every 5 years, caveat that that is not available everywhere. We're in pretty good agreement that we can stop screening at age 65 as long as there has been adequate negative testing in the previous 10 years, or if the woman has had a hysterectomy for benign causes. We do disagree on when to start. Some guidelines say 21 and some guidelines say 25. It is all about HPV exposure because HPV is known to cause between 95 and 100% of cervical cancer. This just shows that the American Cancer Society is the one group that has increased the age to 25 to start screening. I do think all of the other organizations are going to move to this in the next few years. Colon cancer screening also has a lot of consensus. Screening between 45 and 75 years of age with whatever mode your patient is comfortable with that you also have available. So if your patient wants a colonoscopy and it's a 3-year wait, you need to choose another option. There's some controversy, I will say, especially in the United States. Colonoscopy has been overused. There are significant health disparities in the types of screening, and then there's significant costs associated with a colonoscopy. Regardless, you have 2 options for colon cancer screening. There are those options that screen through direct visualization and those that screen through stool-based testing. The United States Preventive Service Task Force just reduced the age of starting screening to 45, and this is a B recommendation, meaning it should happen. Their recommendations are to use stool-based testing every year. Unless you're doing stool DNA, you can do that every 1 to 3 years, colonoscopy every 10 years, or virtual colonoscopy or flex sigmoidoscopy can be done every 5. Again, for your patients, the most important thing is using a validated test that your patient is willing to do and you have access to. So in the United States, in the middle of our country, we have very rural areas that have no access to colonoscopy. The ACP has not updated their recent colon cancer screening guideline since the United States Preventive Service Task Force dropped the age to 45. Theirs still reads 50 to 75, but they have commented that they're in agreement with the US Preventive Service Task Force. The ACP supports testing with either FIT, which is a stool test, high sensitive fecal occult testing every 2 years versus every year, colonoscopy every 10 years, and flex sigmoidoscopy with FIT testing in between done every 10. They do not support fecal DNA. as of yet, and they do not support screening over 85. This is just a slide to show that the benefit per 100,000 screened was not overwhelming for the US Preventive Service Task Force to change their recommendation. It was 1 life saved, 3 cancers found, and 25 life years per 1,000 screened. Lung cancer screening also has a lot of consensus. The US PSTF says that any patient 50 to 80 years who have a 20-pack year history of smoking or currently smoke or have quit but only within the last 15 years should get an annual low-dose CT lung scan. You will stop screening if the person is unwilling to have treatment for that cancer, they have health problems that will limit their life expectancy, or they have not smoked for 15 years or more. Prostate cancer is a discussion-based screening for men aged 55 to 69. In summary, for prostate cancer screening, there were significant harms. Many men were having false positive results, then getting a biopsy, some of whom then had treatment for cancers or mild abnormalities that were not going to turn into cancers and affect their mortality. And the overdiagnosis and treatment led to significant side effects, including erectile dysfunction and urinary incontinence. Making men aware of the limitations of this test to detect cancer and the false positive rate needs to occur, and you should only screen men who are then willing to proceed. There are so many recommendations I'm not going to be able to touch on today because of the limited time, and that includes diabetes screening, osteoporosis screening, and many more. But just to give you an example of some non-cancer screening guidelines we have, all men who have ever smoked, age 65 to 75, should get a one-time abdominal aortic aneurysm screen with an abdominal ultrasound. All adults ages 18 to 79 have a one-time screening for hepatitis C. All adults age 15 to 65 get at least one HIV test, and then annually or as needed, depending on risk. We should be screening adults and adolescents for depression, especially if we have resources available to treat them. And there are so many more. I will say the biggest challenge with screening tests is staying up on all of the changes as new evidence becomes available, including the most recent information that aspirin did not produce a difference in death or cardiovascular death when used for primary prevention. So now let's look at when disease versus the patient drives our care guidelines. I'm only going to touch on 3 because, again, there's limited time, but I wanted to give you an example of how this works. So for asthma, our goal is to prevent exacerbations now that we know that a patient's lung function might not return to baseline after an exacerbation. We have a recent change that all adults and adolescents with asthma should have an inhaled corticosteroid as control or treatment to reduce their risk of exacerbation and control their symptoms. And this includes all adults with all types and levels of asthma. We should also be seeing patients a few times in the office each year to measure their asthma control when they're not having an asthma exacerbation. And we can use validated testing like the asthma control test to determine if we need to increase their treatment. Every asthma patient should have an action plan so they know what to do when they're healthy, when they're sick. They should have a flu vaccination annually, a pneumococcal vaccination, and be seen in the office on a regular basis. So for our patients with diabetes, they also have their own core measures, including such things as a goal for blood pressure, some annual exams such as ophthalmology and a complete foot exam. They should be seen in the office on a regular basis. We have medications for prevention, including what we just spoke about, which is some of the SGLT2 inhibitors, vaccinations such as pneumonia, hepatitis B, and flu, and then even screening intervals for their labs. I put this up here just to show there are additional things we should be doing for our patients with diabetes, including weight management. And there are medications that fall to all diabetics, including statins and either an ACE inhibitor or an ARB. But now we don't just treat to A1C, we treat to disease. So if they have a comorbid disease, such as renal disease or heart disease, then we should be employing SGLT2 inhibitors and GLP-1 analogs. For hypertension, I would just highlight that there is a change in diagnostic criteria. And so although we diagnose hypertension now at a lower level, the time to start medication is when they hit 140/90. This change was really to highlight the goal and the role of healthy lifestyle to treatment. And I like this slide because it breaks down different levels of hypertension and what your next step should be when to institute drug therapy. Just a reminder that if someone has a comorbid disease such as diabetes, there are guidelines out there which will lead you to what the best treatment is for their hypertension so that you're getting 2 for 1. You're treating their blood pressure and their comorbid diseases. We do have hypertension disease-driven guidelines such as exercise, flu vaccination, seeing an eye doctor, tobacco smoking, low-salt diet, and aiming to get weight loss. And then for wellness visits, that is when we put it all together. So for an example, a woman who's 50 to 59, she should be having her pap smears for cervical cancer screening. We need to check to make sure that she has had HIV and Hep C testing, looking at her lipid panel, colon cancer screening, breast cancer screening, checking to see if she ever smoked and needs lung cancer screening, and then a host of vaccines such as flu, shingles, hepatitis B, regular tetanus every 10 years, and looking to see if she needs a pneumovax. Again, this is preventative medicine and screening, so it's directed towards the patient and their characteristics, such as gender and age and race. In contrast, when you're looking at disease-driven care, you have all of those items for health maintenance that will fall on the left-hand side, but we add in disease-driven guidelines, such as for this gentleman who was a previous smoker and diabetes, we now know he needs lung cancer screening, microalbumin, blood pressure, foot exam, retinal exam, etc. I'm going to end there and thank you again for having me. Doctors Darylyn Moyer and Ann Greiner gave me some slides for the content that had all the statistics in them, which I appreciate, and I will stop sharing my screen. There we go.
Thank you, Dr. Rebecca, for a wonderful oration. And since we don't have any question answer session.
Yeah. Thanks, Rebecca, for the nice deliberations. We all enjoyed it here as it is an honor lecture. So we usually don't have a customary to ask any question for this lecture, but we really enjoyed this lecture. If you could have been here, then probably we would have honored you with the medal and trophy. But somehow we will be trying to send a certificate to you, as well as we'll try to the things to honor you by courier. So thank you very much for spending time with us, and would be very happy sometimes if you visit India, and we shall be having a lecture live here. Thanks.
I will
thanks a
look
lot.
forward to that. Thank you for having me.
So with this, today's scientific part is being closed. And now I'll request our Master of Ceremonies to take us to the next part of the program of the day. That is the felicitation part, in which we shall be felicitating the people, those who have earned the fellowship of ACP, and they will be going to get this fellowship Chicago this year, and in April 28 to 30. And then we shall be announcing the ACP India Awards, and will be requesting the people, those who are getting that, they must be here. So I shall like that first we should give the ACP India Awards the people, those who are online. Dr. V. Mohan are with us online. Dr. C.L. Naval is online. Dr. Raj Shekhar is online. So would like to felicitate the all the awardees who are with us online, and then we shall be then we shall be inviting the people, those who are sitting in the hall. So First of all, I shall be having a very pride and privilege, Doctor, announcing the Lifetime Achievement Award of ACP India chapter for Dr. V. Mohan. What are you showing here? Yes. Yes. And Dr. V. Mohan is a personality whom no introduction is needed to the people, those who are in medicine world in this country at least, and out of the country also, and the people, those who are working in the field of diabetes, is very well known for this name. And Dr. V. Mohan is has been the only MACP a year before in India. This year, Dr. Muruganathan has also been awarded with the Master of American College of Physicians, but before that, he was the only Master of American College of Physicians from our India. And Dr. V. Mohan has worked very hard in the field of diabetes, and he has given a lot of knowledge he has added to us for his wonderful work across the life, what he has done. We are feeling very happy to honor him for this with this award of the Lifetime Achievement Award. And he has been the person who was behind the inspiration of the COVID Diabetes Month as well as COVID Diabetes study, what we could do. And yesterday it has been presented before the ACP president also. So now I shall request Dr. V. Mohan, although you are not here, if you would have been here, we would be more happy to honor you physically. But from the distance, we can simply show a certificate of honor here. So over to Dr. Mohan for a few words.
Yeah. Thank you, Dr. Anuj Maheshwari. I'm very grateful to you for this huge honor of conferring the Lifetime Achievement Award on me. The American College of Physicians in general and the India chapter in particular has been doing yeoman service, and I've been associated with the ACP India chapter as well as with ACP in the US also for many years now. I'm very grateful that they had also made me a master, my MACP a few years ago. This meeting is particularly very good. I've been attending some of the sessions and they are simply outstanding. They represent the cream de la cream of Indian physicians and the work which is being done in India. I'm very grateful that the ACP is also taking active part in this. I'm sure the India chapter is one of their best chapters, and I'm sure that a lot of work can be done together. To you personally, Anuj, I always admire your energy and your enthusiasm in organizing meeting after meeting, and that too now in face-to-face mode. I can imagine how much more challenging it is to do it during these COVID times, yet you have done it and you have pulled it off very successfully. I am sorry I'm not able to be there in person. I still have not started traveling to conferences physically. So it's a great honor for me. With all humility, I accept this honor and wish ACP India chapter all the very best. Tomorrow I have a talk in the morning and I look forward to being with you in the scientific sessions. Congratulations to you and to all the organizers for this massive effort. Once again, thank you very much. I'm humbled and deeply honored to accept this on behalf of all my colleagues at the Madras Diabetes Research Foundation and Dr. Mohan's Diabetes Specialty Center. Thank you once again.
Thank you, sir. Thank you. Then I shall be very happy to, if you can show the certificate of the people, those who have won the Osler Cup for our country. Very few people may be knowing that what is the Osler Cup and how was this story is there. Maybe you listening this name for last 2-3 days, that something is Osler Cup like. William Osler, you know, is a clinician of the great repute across the world who has initiated the medicine, modern medicine, what we talk about. He was from Canada. And he has been very much respected in American College of the Physicians across the world. In the name of the William Osler, there is a quiz which is being participated by all chapters of the American College of the Physicians. American College of Physicians is having 185 chapters across the world as well as in US. Out of those 185 chapters, our Indian lads has won this cup for India. So this is really not less than a win of the World Cup win. This was just equal to the World Cup, and you can compare it with the 1983 World Cup or any other World Cup. So in fact, on the day when this competition was going on, I was watching this online, and nobody was expecting that India will win. The team, the people, those who were of the board of governors, they were talking about their team. This team has gone up, this team, and I was just kept silent and without speaking, I was just watching that. As a dark horse, the India has won last, and it was really a proud moment. And I can simply compare this with the 1983 World Cup win, what the India has done. So these three lads has done the great job, in which I would like to have, there is one person, Siddharth. Siddharth is here. Siddharth, please come on the dais, and so the people may know you. Apart from that, there were three more persons were there. So there, in this team, we have selected 3 persons, and 1 person was in the waiting list. But the person who was in the waiting list, in fact, as a 4th player, we kept. Suppose if one of the 3 player is not available for the competition, then we can ask the 4th one to take. So we cannot undermine the contribution of the 4th one who has done. So, Siddharth was one of those. Apart from that, there were 2 more persons who has competed with him. One was the Ashwini Parchani and another is the Mayank Agrawal. Mayank Agrawal and Ashwin Parchani both are busy in their MD exams, so that's why they could not come. Otherwise, they would have also been joined here. And the 4th one was the Anand Thomas from Kerala. He was the 4th person who remained in the waiting list. But these three students has done the miraculous job. And Siddharth is exceptional out of those, because Siddharth's mother was admitted with the COVID on that day, and she was serving her mother, and he participated in the quiz from the hospital bed and won. So this is a thing which is really admirable, and we can definitely, it is a matter of the felicitation for the people, and Dr. Mohan is also praising for you. So for that reason, for this, we have given the Resident of the Year award to all the 4 the doctors, those who has participated. But Siddharth has been given the Resident Recognition Award for the leadership. So if it is there, it is not. Yes. Yes. Dr. Vasant Kumar is here, or yes, please join us here to felicitate this illuminating students of the country. There is only one more. Yes. Yes, sir. You announced it. So next, would like to request people, those who are on the this will be announced in the late. First, so first we will finish this list as we have already told. Please run that certificate what you were showing there. Certificates what you were showing there. For all the 3 students, those who has participated and has been given the Resident of the Year award, Ashish Ashwin Parchani, this is the memento what we are giving to them from the American College of the Physician for as a sort of felicitation, and that is the certificate which we are being given for which they are being given for the Resident of the Year award. I think these people are not being able to show that. No problem. So we can move on for the Resident of the Year award for Mayank Agarwal, Resident of the Year Agarwal Anand Thomas, and Resident of the Year Agarwal. We'll come it again. Anand Thomas, Mayank Agarwal, and Ashwin Parchani. And Mayank Agarwal belongs to Lucknow. His father is one of the good friend of mine, although he has won his award himself. We could never help him, but he is from Lucknow. That is just a matter of chance. He is from my city. And now we shall be, please next. Now we shall be announcing another award for, that is the Chapter Advocacy Award. Chapter Advocacy Award for this year is being given to Dr. Mangesh Tivaskar. Dr. Mangesh Tivaskar, if he is available on online, then I will request that he should be there. So he has advocated our chapters, ACP chapter of India, in multiple ways and multiple forums. So that's why he has been chosen for this award. Next, please. Next, please. Dr. J.K. Sharma. Dr. J.K. Sharma has been chosen for the All India Chapter Clinical Practice Award. If he is available online, I will request him to, he can show his presence. I don't think he is here. Then Dr. R.R. Singh, again, he has been chosen for the Clinical Practice Award of the ACP India chapter. Then Dr. C.L. Nawal, who is here already. Dr. C.L. Nawal is the another recipient of the, he is the recipient of the ACP India Educator Award. So Educator Award is usually given to the teachers, those who are active in the undergraduate as well as the postgraduate teaching, and they are supposed to be very good teacher. This award is usually being given on the opinion of their students. So on the basis of this award is being given to Dr. C.L. Nawal. Dr. C.L. Nawal, if you want to say a few words, you can.
Yes, sir. Thank you, sir. So very good evening to everyone. My sincere thanks to entire committee of the American College of Physicians India chapter, and special thanks to our honorary governor Anuj Maheshwari sir and Dr. Jayant Panda sir for considering my name nominations for this prestigious award of this very prestigious conference, of this prestigious chapter of the India chapter of the ACP conference, sir. I feel humbled and honored by getting this award. Really, under your guidance, sir, this chapter is growing like anything. I have attended almost all academics of the Anuj Maheshwari sir under your guidance from last almost a year, 1 year. So you are the real wonderful teachers, wonderful academicians, wonderful management. So under your guidance and leadership, I hope that this chapter will grow like anything. So my best wishes for this conference, a grand success. And thank you very much, sir. Thank you. Again. Am I audible, sir? Hello? Am I audible, sir?
Yes, yes, we heard you.
Yes, thank you, sir. Thank you very much, sir. Thank you, sir. Anuj Maheshwari, sir. Hello. Hello. Respect to Maheshwari, sir.
It's not audible.
Nice.
You are correct. Naval.
Thank you, sir. Thank you. Very good evening, sir. How are you?
Fine, fine.
Seeing after many times, sir. Thank you, sir. Thank you very much. I think connectivity is very poor from this.
Yeah, the technical team.
This morning we are technical problems there, sir.
Technical team is not being able to show the soft copy, but I can simply show the hard copy of this certificate, which will be sent to him through courier. So, Dr. Rajshekhar, we appreciate your efforts and we felicitate the work what you have done.
Thank you. Thank you.
So I think
congratulations, sir.
All the peoples has been covered up, those who had to be felicitated online. But I will request all of you to keep joining because many people are here whom we are going to felicitate for their wonderful work here. So before I move forward for the ACP awards which have been left, I shall like to announce the recipient of the fellowship. FACP is a very graceful thing, and most of the people need to earn it after a good work, after a wonderful CV they may be having, then it is usually granted to the people. There are the two categories of the FACP. One is that for that people apply and it is earned by them. Another is that it is granted and it is automatically taken cognition by the ACP and ACP grants it. But both the things are on the basis of their CV. So I shall be announcing the name of both the categories of the fellowship recipient. So first I shall like to announce the name of the people, those who have been recipient of the invited fellowship. So if they are here, I will request that they should come on the dais so that we can felicitate. I know Dr. Kamlesh Tiwari is not here. Dr. Kamlesh Tiwari is the API president. He has been invited fellowship this year. He has earned the invited fellowship this year. So, of course, the appreciation is there. I think on behalf of him is there. If there is anyone who can take, I think someone has come from the Kamlesh Tiwari's place, Dr. Kamlesh Tiwari's place. If he can come and he can take the award on his behalf.
Dr. Amit Das.
Amit Das. Amit Das is here. He can take. Okay. Whenever he joins, then we can ask him. Then another is Dr. Kamlakar Tripathi. Dr. Kamlakar Tripathi has also earned the fellowship. He has also been the recipient of the invited fellowship. Dr. Tripathi is also not there. I think nobody has called up him. है नहीं वो यहाँ पे. Then the very important, our own Dr. L. Srinivasa Murthy. So at least I can get a chance to felicitate him. So I will request Dr. K.K. Parikh to please join us here and felicitate him. हाँ बिल्कुल. And now I will request the very good friend of mine, Dr. Sanjay Agarwal, who is the boss of RSSDI. And of course, you are doing a lot of good work for the RSSDI. And sir. Dr. K.K. Parikh is a invited member of our advisory council, and as well as he is chair of the award committee. Thank you. Thank you, boss. Thank you, boss. Next one is Dr. Bijay Patni, if he is here. Dr. Bijay Patni is a very prominent physician of the Calcutta, although he remains always on the lower profile, but he organizes very good meetings in the Calcutta, and he is known for his academic credentials in the Calcutta. Thank you. Thank you. Doctor, so sometimes we should follow scientific chairs. Very much reported. So another person is in this list who deserves this applaud and for the invited fellowship is Dr. Mukulesh Gupta from my own city, Lucknow. Dr. Mukulesh Gupta is the person who works very silently, and very few people know about his work, and he never tells to anybody. When he told me, and I have written to the RSSDI, and he has earned the RSSDI fellowship also this year. And he is the person who has earned, I think, 4 fellowship in 1 year: FACP, RSSDI fellowship, fellowship of the Indian Society of Hypertension. Only 3 or 4? Okay. So this is a record of the year. So now I will request another one who has been invited fellow, who has been awarded with the invited fellowship, Dr. Sharad Joshi. Dr. Sharad Joshi is the clinician in Max Hospital, Vaishali, and he has worked very hard with the COVID patient, and for his service which he has done with the COVID patient, he has been awarded with this fellowship. Dr. Ashish Kumar. Dr. Ashish Kumar is the gastroenterologist from Gangaram Hospital, and although he is alumni of the King George Medical University, he has done the post-graduation from the KGMU, MBBS from the GSVM Kanpur, and he has done the DM in gastroenterology, and has also been appointed as an invited member of the advisory council of the ACP. Sajid Ansari. Dr. Sajid Ansari is the cardiologist. He is also one of those who has earned the 3 fellowships in a year: fellowship of the CSI, fellowship of the Indian Society of Hypertension, and FACP. Dr. Mukesh Sarna. Dr. Mukesh Sarna is from Jaipur. And Dr. K.K. Parikh is felicitating him what to say more. He is the person of the repute from the Jaipur SMS Medical College. So he has made the record, 4th fellowship he has earned in a year. So great. Then Dr. Dhruvi Hasnani. Dhruvi Hasnani is well known from Dr. Bansi Sabu, and I think very few people be there who may not be knowing him and knowing only Bansi Sabu. So whosoever is knowing Dr. Bansi Sabu, he is supposed to be knowing Dhruvi Hasnani also. So there are 4 persons, those who have earned their fellowship. Dr. Divendu Bhushan from the AIMS Patna. He is here, please join us. Actually, list is so long, so I am not going in the very much details of the people. But you can understand those who have earned the fellowship of American College of Physicians, definitely they must be having a backup of the very strong CV. So he is from AIMS Patna. Dr. Padma Shri Gulati, who has shared the session with me of the Rebecca Andrews. Dr. Padma Shri Gulati, her name is already included Padma Shri, so she doesn't need any other accolades to be given. Dr. P.S. Singh. Dr. P.S. Singh is a very senior physician, and he has retired last year and has also suffered a COVID after the retirement. But this is your 6th fellowship in a year. So he is another record maker. And after the retirement, he has earned 6 fellowships in a year. So you can always understand he was so much busy in the serving their patient that he could not apply and earn the fellowship. So by this, we are completing the list of fellowship. Now I shall be coming to the list of awards. The people, those who have been left off, those who have been felicitated online, the people, those who have been not felicitated at that time, and we decided that we shall be felicitating them here in the hall. So first I would like to announce one award from the ACP for one of our advisory council members who works very silently but very strongly. His impact is one of the strongest impact, and he is Dr. Bansi Sabu. Dr. Bansi Sabu is being awarded by ACP, ACP India Excellence Award. So I will request Dr. Vasant Kumar join here. because you are the president RSSDI and Bansi Sabu was the president RSSDI. It's needless to say what the Bansi Sabu has done. It is just showing a light to sun. If I try to say anything, what the Bansi Sabu has done. Should I come? So when we were thinking of that, so I thought there is only one person in India whom I can say that he deserves for the Excellence Award, because he has done excellence in every field, may it be teaching, may it be advocacy, may it be anything, in practice, clinical practice, being an internist, being a diabetologist, anything if you, and research, of course, research also. So we cannot restrict him for one thing like Researcher of the Year Award, Teacher of the Year Award, yeah, Clinical Practice Award, yeah, Internist Award. We cannot restrict him like that. So Excellence Award is a word which accommodates everything. Then I would like to announce another very important award, that is the Hospitalist of the Year Award. And Hospitalist of the Year Award is for this award our award committee has chosen Dr. Jalis Fatima. If she is here, she can come. I don't think she is here, but no problem. Dr. Jalis Fatima, I would like to share for her one thing, that she is the head of department in ERAS Lucknow Medical College of Medicine. In the COVID time, she was suffering with the COVID. She has herself been admitted in the COVID ward, and still, while being suffering with the COVID, having the low SpO2, she was daily taking once or twice round to the patient, those who have been admitted there and suffering with the COVID. So this kind of the service feeling and service zeal is very rarely is being seen. And most of the patients, those who have been admitted there, they recovered well also from that place. So next is she's so large-hearted, even she did not come to take this award. All these award has been informed to all the awardees before that, and it has also been told to them that we shall be doing it at 7:30 to 8:30 here. Another is again a very interesting award. It was very difficult to decide who can be the best candidate for that. That is the Humanitarian of the Year Award. So Humanitarian of the Year Award, it was really tough to say, because humanitarianism is a part which should remain in all the doctors. And we expect that everyone should be a humanitarian, a good humanitarian. But very few persons are there who can show this quality to the people. We all are having this quality. Sometimes we are able to show, sometimes we are not. Dr. Ashish from Sultanpur has been chosen for this award. This is the humanitarian award, and you must have listened to him yesterday. He is a very good singer, fan of Kishore Kumar, and all patient loves him very well. Then is again very important award, that is the Early Career Physician Award. Early Career Physician. Early Career Physician Award. For this award, another I can say that a pupil of Dr. Bansi Sabu has been chosen. Although never asked by Dr. Bansi Sabu, but these people has made their reflections by themselves so much. Dr. Vipul Chawla. Dr. Vipul Chawla is the person who has contributed maximum number of the patients in COVID diabetes study. I think Dr. Mugunathan has taken the entry very right time. Yeah. His timing is always perfect. So before I move forward, and I must announce the very important award for Dr. Mugunathan also. At least he has served the ACP for so long and has made a lot of sacrifices and contributions in the progress of the ACP. So ACP has one of its awards that is called as Chapter Leader Award. So for that award, we all decided, all the advisory council members decided that nobody else can be more deserving person than Dr. Muruganathan. So we'll request Dr. Muruganathan sir to please join us on the dais for the Chapter Leader Award. Now I'll request the next few of the awards. I'll request Dr. Girish Mathur to come on the dais and felicitate our other people, those who have been left. So there is an important award that has been already announced for the Dr. Rajshekhar, that is ACP India Internist Award. And it has been thought by many people that why only male are the internists, good internists, why can't be the female good internist? And for this lady doctor, a female doctor who always fights in the country and does a lot of work for the rights of the female doctors, and that is none other than Dr. Divya Saxena. Dr. Divya Saxena is my senior of the MBBS days. Dr. Divya Saxena and her husband, Dr. Akhil Saxena, both has been my senior in my MBBS days in Allahabad. At that time, it was called Allahabad. Now it is called Prayagraj. Then it was very difficult to decide whom to give this Researcher of the Year award. So Researcher of the Year award, a number of people are there who are doing the research and they claims that they are the researcher, and of course they are really too, but they may be fitting in other things also. But if we really look for the excellence in research, so excellence in research, I could see the only person who can be chosen for this award, that is, and he is Dr. Srinivas Murthy, who is the organizing secretary of this conference also. He is the person who runs a center of excellence in research, which has been accredited by the US FDA. A center in India, US FDA accredited, is a very big thing. Then the another prestigious is the Teacher of the Year award. So Teacher of the Year award, always it remains a lot of contestants there. So one teacher who was working very hard with the American College of the Physicians has been chosen, and very hard for this conference also. He worked day and night, and not only for this conference, he has worked a similar kind of the work for so many conferences. And he is none other than Dr. Jayant Panda. Dr. Jayant Panda was looking at who can be there. He was seeing here, there, here, there. He was never thinking that he can be himself. So for this Teacher of the Year award, we have chosen the two person. The another person is again a very hardworking person. And sometimes I call him as a born teacher. And he keeps on his spirit of teacher all the time. Either he walks like teacher, he talks like teacher, he eats like teacher, he sleeps like teacher, and he is Dr. Narsingh Verma. Then again, another very important part of the physician's professional life, that is a community teaching. Without community teaching, we are nowhere. William Osler has said the good physician is not that who treats, but good physician is that who teaches the population how can he be saved from diseases and how can they may not be fall for the diseases. So keeping this spirit in mind, the ACP has started this ACP Community Teaching Award, and that is being given this year for the three people: Dr. Amit Gupta from Gautam Budh Nagar, and nobody will be having any doubt for the choice of this award regarding Amit Gupta, because Amit Gupta is a person who has done the tremendous work for the Defeat Diabetes, for all the campaigns of the RSSDI. And not only RSSDI, but also ACP also. He has done equally contributed in RSSDI and ACP. On one leg, he was serving for RSSDI, from another leg, he was serving for the ACP. I don't know if he was working for some other organization. Yes, he was working for the third organization also. He was organizing secretary of the Asia Pacific Congress of the Hypertension also at Delhi. So he is again a very multitasking person. So